tick-tock, squeeze, release.
Yeah, completely in the background.
Right. It's this masterpiece of biological engineering, and it quietly does its job without you ever having to think about it.
And we take that predictable rhythm entirely for granted. I mean, the moment you start actually feeling every single heartbeat, something has fundamentally changed.
Exactly. But imagine that metronome suddenly shatters. It just breaks and turns into this chaotic, quivering storm. It starts firing completely out of sync, totally unpredictable. That is atrial fibrillation.
Or what you'll usually hear called a fib.
Yes, a fib, which is what we're diving into today.
It's the absolute definition of electrical chaos inside the human body.
It really is. AFib completely rewrites the rules of how the heart is supposed to function, changing it from this organized pump into an erratic, trembling muscle. And so today, we are exploring the clinical and historical notes on a fib, specifically focusing on the nursing and medical angle. We're calling this deep dive the irregular rhythm that throws clots.
I like that title. Very accurate.
Thanks. We're going to unpack what it is, why it quintuples your risk of a stroke quintuples, and how the medical understanding of this condition has flipped like multiple times over the decades.
And understanding this is so crucial for you listening because AFib is not some rare medical anomaly. It is one of the most common sustained arrhythmias on the planet.
Yeah, it's everywhere now.
It really is. Our global population is aging, which means prevalence is just skyrocketing. I mean, millions of people now have smartwatches buzzing on their wrist with these irregular rhythm alerts.
Which is terrifying to wake up to, I'm sure.
Oh, absolutely. So whether you're a nursing student cramming for the NCLEX or a medical professional or just, someone trying to track your own heart health, a fib is something you will inevitably encounter.
And it's wild to think we're now getting wrist alerts for something doctors spent literally centuries trying to decipher just by touching a patient's wrist.
Right. The history here is fascinating.
The historical notes show physicians were noticing these highly irregular pulses long before they had any clue about the underlying mechanism.
Yeah, you can actually trace it back to 1749.
1749, that's what, George Washington was a teenager?
Basically, yeah. There was this French physician named Jean-Baptiste de Sénac. He was feeling the pulses of patients with severe mitral valve disease and documenting this highly irregular, rapid pattern.
Just by touch.
Just by touch. But the terminology really became evocative, I'd say, in 1876. That's when a clinician named Carl Wilhelm Hermann Nothnagel described the phenomenon simply by feeling it at the bedside.
And he gave it a great name.
He did. He coined the term delirium cordis.
Delirium of the heart.
Exactly.
That is just an incredibly vivid way to describe a pulse, but purely descriptive, right? I mean, they had absolutely no mechanistic explanation for why the heart was delirious.
Isn't it all? To move from feeling a delirious pulse to actually mapping an electrical storm, that required a massive technological leap.
Enter the early 1900s.
Yes. A Dutch physiologist named Willem Einthoven invented the string galvanometer.
Which sounds like a steampunk instrument.
It kind of was. This was the first real electrocardiogram, the ECG, and it actually won him the 1924 Nobel Prize.
I always wonder how they actually pulled that off before modern computers. Like, how do you visualize human electricity in the early 1900s?
Well, it was a brilliant piece of analog engineering. Einthoven suspended this microscopic silver-coated quartz string.
Wait, an actual physical string?
The physical microscopic string. He suspended it between two powerful electromagnets. And when the tiny, almost imperceptible electrical currents from a patient's heart passed through that string, the magnetic field caused it to twitch and move.
That is unbelievable.
Right. And he shined a bright light on it, so the moving string cast a shadow onto a scrolling roll of photographic paper.
So the shadow of this twitching string physically drew the electrical waves of the heart.
You got it. The very first ECG tracings. Einthoven captured these early recordings showing a chaotic, undulating baseline where the normal, organized electrical wave, what we now call the P wave, was just entirely missing.
Just gone.
But it was British cardiologist Sir Thomas Lewis who put the puzzle together around 1909. He connected Einthoven's visual tracings to that delirium cordis that clinicians had been feeling for, 150 years.
And he coined the modern term, right?
Close. He coined the term auricular fibrillation.
Oh, because atria were called auricles back then.
Exactly. But he proved that the irregular pulse was the surface signature of disorganized electrical activity.
So let's talk about that disorganization, because under normal conditions, you have the SA node, the sinoatrial node, that's your heart's natural pacemaker. It sends one clean, sweeping electrical wave down through the upper chambers, the atria, to trigger a coordinated squeeze.
One clean wave.
But in a fib, that clean wave is completely hijacked.
It is. Instead of one wave, you have 400 to 600 disorganized microwavelets firing simultaneously every single minute.
400 to 600 impulses a minute is terrifying.
It's pure static.
If those all went through, the heart would just vibrate itself to death, wouldn't it?
It would be entirely unsurvivable, which is why the AV node, the atrioventricular node, is so critical here.
The biological gatekeeper.
Right. It sits between the upper and lower chambers. The AV node gets bombarded by these 600 impulses, but it just refuses to let them all pass.
Yeah.
It only lets an irregular, unpredictable subset of them through to the ventricles.
Which is why the hallmark physical finding of a fib is that irregular pulse. There's no repeating pattern in timing or strength.
None.
It makes me think of a frantic bouncer at a nightclub.
Oh, I like that analogy.
Yeah, so you have this unruly mob of 600 people outside the doors just pushing and shoving, and the bouncer is totally overwhelmed. He's just randomly grabbing people. You can go, you stay, you go, you go, you stay. He's only letting a random few through the door at a time. And the result on the dance floor, the ventricles, is completely unpredictable.
That is perfectly put. The ventricles are only responding to whichever impulses the AV node lets pass the velvet rope.
But diagnosing this isn't just about feeling the chaos anymore.
No, to formally diagnose this chaos, the American Heart Association, the Heart Rhythm Society, and the European Society of Cardiology all require a very specific threshold. You need to see this chaotic activity on an ECG for at least 30 seconds to officially call it a fib.
Wait, why 30 seconds?
Good question.
Like, what if my heart quivers for 28 seconds? Is 30 just a neat round number someone made up to make medical textbooks look organized?
It sounds arbitrary, I know, but shorter runs of atrial irregularity are actually quite common in human beings, and they're usually clinically insignificant.
Oh, really?
Yeah. The 30-second cutoff was specifically chosen because that's the threshold where the finding becomes highly reproducible on clinical monitoring and, more importantly, clinically actionable.
Meaning that's the point where a patient's risk profile demonstrably starts to shift.
Exactly.
And that risk shift is huge because if the heart is just quivering and not doing that nice clean metronome squeeze, the blood itself is not moving properly.
No, it's not.
And that mechanical failure leads directly to the deadliest consequence of a fib.
The clot.
The clot. To understand this clot risk, the notes bring up a 19th century concept called Virchow's triad.
Yes, Rudolf Virchow. He outlined the 3 perfect conditions for thrombosis or blood clotting: stasis, endothelial injury, and hypercoagulability.
And all 3 of these play out with devastating precision inside a fibrillating atrium.
They really do. Let's start with stasis. Because the atria are quivering like a bag of worms instead of firmly contracting, the blood doesn't get squeezed out efficiently.
It just sits there.
Right. And there's a very specific anatomical spotlight here: the left atrial appendage, or the LAA.
Right. The notes describe it as looking like a small, wrinkled, ear-shaped pouch hanging off the left atrium.
That's a good description. It has a narrow opening and a trabeculated, which means highly ridged interior.
So when the atrium stops squeezing, the LAA basically turns into a stagnant puddle. The blood just pools in those ridges.
And because that blood is stagnant, it triggers the other 2 parts of Virchow's triad. The stagnant blood physically irritates and inflames the lining of that patch. That's your endothelial injury.
Okay, that's 2.
And on top of that, the state of a fib itself is independently associated with elevated levels of clotting factors in the bloodstream. So, boom, there's your hypercoagulability.
The perfect storm.
Exactly. This stagnation and inflammation trigger what is known as the coagulation cascade. Specifically, the body starts producing fibrin proteins. These proteins weave together into this sticky net that traps passing red blood cells, creating massive fibrin-rich clots.
These are often referred to as red clots, right? Because of all those trapped red blood cells.
Yes, red clots. And the result of this perfect storm is a striking statistic: 90 to 95% of atrial clots in non-valvular AFib form, right there in that one tiny little pouch, the LAA.
90 to 95%. That is staggering.
It's almost all of them.
And it's not just that a clot forms, it's where it goes once it breaks free. Because when one of these massive red clots dislodges from the LAA, it shoots out of the heart right through the aorta, and it has a terrible tendency to go straight up the carotid arteries into the brain.
A direct flight to the brain.
It's not just throwing a pebble into the plumbing, it is sending a massive boulder straight toward the brain's main highways.
That's why these strokes are so severe. These clots are unusually large because they've been forming in that stagnant pouch.
Mm-hmm.
When they lodge in the brain, they block large proximal cerebral vessels.
Which is why the data from the famous Framingham Heart Study proved that AFib does not just raise your stroke risk, it quintuples it.
5 times the risk. And these specific cardioembolic strokes are significantly more fatal and more disabling than strokes from other causes, precisely because of the size of the clot.
So, since these strokes are so catastrophic, clinicians have to figure out who needs blood thinners without causing everyone to bleed out unnecessarily.
Right? It's a delicate balance.
To solve this, they use the CHA Urone Vasek score to tally up a patient's risk factors.
Let's break that acronym down for the nursing students listening.
Right, so congestive heart failure, hypertension, age 75 or older, diabetes, prior stroke or TIA, vascular disease, age 65 to 74, and sex category specifically, being female.
And each of these factors independently raises the baseline stroke risk. Generally, a score of 2 or more in men or 3 or more in women warrants putting the patient on a blood thinner. It's really a brilliant example of applying epidemiological data to risk stratification right at the bedside.
So you tally up the score, you hit the threshold, and you get a prescription. That seems incredibly straightforward until someone's Apple Watch chimes at 2 a.m.
Yes. The wearable tech disruption.
Sure. Modern technology is completely disrupting that neat scoring system. Historically, you either had a fib or you didn't. You went to the doctor, they hooked you up to an ECG, and boom, you were diagnosed.
Right, binary.
But now, implantable loop recorders and smartwatches are finding subclinical atrial high rate episodes, or AHREs, tiny episodes lasting just a few minutes.
And because of that, we have a flood of otherwise healthy people getting alerts on their wrists.
Right. And if my watch says I had a 3-minute episode, but I feel completely fine, like no palpitations, no dizziness, why would I take a risky blood thinner to treat a math equation on my wrist?
I hear this all the time.
Yeah.
But we have to firmly bust the myth that if you can't feel it, it can't hurt you.
Okay, let's bust it.
A substantial portion of all AFib, up to half in some populations, is completely silent. You feel absolutely nothing.
Wow, to half.
But silent AFib carries a stroke risk that is comparable to symptomatic AFib. The forming clot does not care if you felt your heart flutter. The CHED, your Graf score, does not care if you felt it.
But still, treating a 3-minute silent flutter with heavy-duty anticoagulants feels like an extreme escalation, doesn't it?
And that right there is the most heavily debated topic in cardiology right now. We recently had 2 major clinical trials, Artesia and NOAA-AFNET 6, designed specifically to answer this question about smartwatch-detected microepisodes.
And what did they find?
Well, they showed a modest reduction in stroke when treating these patients, but it was heavily balanced against a higher risk of severe bleeding from the drugs.
So a trade-off.
A huge trade-off. The medical community has not settled on a definitive threshold yet. The definition of a fib is quietly shifting from a binary diagnosis to a much murkier spectrum of electrical instability.
This tension, knowing the immense danger of a clot but fearing the complications of the intervention, it really explains why medical guidelines for a fib have flipped so dramatically over the years, especially when you look at the debate between rate versus rhythm control.
Oh, the great rate versus rhythm debate. Yes. There are 2 fundamentally different philosophies for treating a fib.
Oh.
Rate control basically accepts that the atria are broken and will keep fibrillating.
It just surrenders to the chaos.
Basically. It simply uses drugs like beta blockers or calcium channel blockers to slow down the AV node.
It's essentially telling that nightclub bouncer to slow down and let fewer people through so the ventricles aren't racing at a dangerous, exhausting speed.
Exactly. Keep the bouncer relaxed. Rhythm control, on the other hand, refuses to accept the chaos.
It fights back.
It fights back. It uses antiarrhythmic drugs or electrical shocks called cardioversion to literally force the heart back into a normal sinus rhythm.
Or they use catheter ablation.
Right. In 1998, a French electrophysiologist named Michel Haït-Séguier revolutionized this by realizing the rogue electrical signals often start in the pulmonary veins. So electrophysiologists go in and literally burn or freeze the tissue to electrically isolate those veins.
And logically, you'd think everyone assumed forcing the heart back to normal would obviously be better. Normal has to be better than broken, right?
That was the universal assumption. Until 2002.
The AFFIRM trial.
The AFFIRM trial. It was massive, and it shook the cardiology world because it showed that aggressive rhythm control did not improve survival over simple rate control.
Which is wild.
In fact, the rhythm group had more hospitalizations and adverse effects.
Okay, but how is forcing the heart back into a normal rhythm actually worse for the patient?
It came down to 2 major issues. First, the antiarrhythmic drugs available at the time were highly toxic. They successfully stopped a fib, sure, but they sometimes triggered other far deadlier ventricular arrhythmias,
Oh, so the cure was sometimes worse than the disease?
literally. Second, the patients in the AFFIRM trial had often been in a fib for years. When the atria quiver for that long, they physically stretch out, scar, and remodel.
So you can't just electrically shock a permanently warped fibrotic chamber and expect it to behave perfectly.
Exactly. The hardware is damaged.
So for nearly 20 years, the medical consensus was to just leave most patients in a fib and slow their heart rate down. But then the eStaffNet-4 trial in 2020 flipped the guidelines again.
It did. eStaffNet-4 added a critical nuance that we missed. They found that early rhythm control does help reduce cardiovascular death and stroke, provided you catch the patient soon after they are diagnosed.
Catching it before the structural damage is done.
Yes.
If you stop the chaos before the atria permanently stretch out and scar, fixing the rhythm actually works. The timing is the treatment.
Precisely.
Yeah.
But whether you choose rate or rhythm control, you still have to deal with the stroke risk.
Right.
Which brings us to the blood thinners. And the most famous one has an origin story that honestly sounds like a Hollywood thriller. Warfarin.
This is my favorite part of the notes. This drug was not invented in some pristine pharmaceutical lab. It started in a pasture.
A literal field.
In the 1920s and 30s, farmers noticed their cattle were mysteriously bleeding to death. It turned out the cows were eating spoiled sweet clover, which contained a natural anticoagulant.
Is naturally occurring in the clover.
Researchers in the 1940s isolated the compound, decumerol, and they initially marketed a highly potent derivative of it as rat poison.
Yes. It was incredibly effective at causing the rodents to hemorrhage. But eventually, researchers realized that in carefully controlled human doses, it was a life-saving medicine.
Which is crazy to think about.
For 60 years, warfarin, derived from cattle-killing clover and rat poison, was the only oral drug we had to prevent AFib strokes.
The journey from a dead cow to a rat trap to the gold standard of cardiac care, it's just unbelievable.
It's an amazing story. It worked by blocking the liver from using vitamin K to produce clotting factors, effectively starving the coagulation cascade. But it was notoriously difficult to manage.
It's because of the diet restrictions, right?
Right. Because it targeted vitamin K, if a patient ate a big salad full of leafy greens, the sudden influx of vitamin K would completely blunt the drug's effect.
So it required constant, tedious blood tests to ensure the blood wasn't too thick, leading to a stroke, or too thin, leading to a hemorrhage.
Which is why the cardiology world basically threw a parade in the early 2010s when the DOACs arrived, the direct oral anticoagulants.
Trials like ARLE-A, ROCKET-AF, and Aristotle proved these new drugs were a massive paradigm shift.
Massive. Instead of starving the body of vitamin K, DOACs act like chemical snipers. They target a single specific enzyme in the coagulation cascade like factor XA or thrombin and block it directly.
So patients can eat all the spinach they want because the drug doesn't care about vitamin K.
Exactly. And they prove to be just as effective and generally safer regarding catastrophic bleeding into the brain without needing constant blood draws.
But there are still patients who simply cannot take any blood thinner, right? They have a high bleeding risk, perhaps due to a history of gastrointestinal bleeds, but they also have a high stroke risk. What happens to them?
That is where the mechanical fix comes in. Remember that left atrial appendage, the LAA, where 95% of the clots form?
The little ear-shaped pouch?
Yes. Biomedical engineers asked a very simple question. Why thin the blood in the entire body when we can just plug the one pouch causing the problem?
Which is brilliant.
They developed LAA occlusion devices,
Yeah.
like the Watchman. The Protect AF trial showed you can deploy this little parachute-like plug right into the LAA, mechanically sealing it off.
So the blood can no longer pool in the ridges?
Right. The stasis is eliminated, and the risk is structurally removed.
So with treatments ranging from freezing the heart's veins to prescribing rat poison derivatives to implanting tiny parachutes, it is no wonder patients and even clinicians fall victim to dangerous misconceptions. Let's clear those up based on the clinical notes.
Let's do it.
Rapid fire. Myth number 1, AFib is basically the same thing as a heart attack.
Completely false. A heart attack is a plumbing issue, a blocked coronary artery starving the heart muscle of oxygen. AFib is purely an electrical issue in the upper chambers. You could have a perfectly clean plumbing system and still suffer a massive electrical short. They are mechanistically completely distinct.
Good to know. Myth number 2. If my doctor shocks my heart back into a normal rhythm, or I get an ablation, I can finally stop taking my blood thinners.
Okay, this is perhaps the most deadly misconception of all. Even after successful cardioversion or ablation, the atrium can remain electrically and mechanically stunned for weeks.
So you think you're fine, but you're not.
Right. Silent recurrences happen frequently. Your need for blood thinners is dictated strictly by your CHA risk score, not by whatever rhythm you happen to be in today. If your risk score is high, you stay on the thinners. Period.
That's a crucial takeaway. Myth number 3, and this is a big one for anyone studying pharmacology. I don't want to take heavy-duty blood thinners, so I'll just take a baby aspirin every day. It's a safe, gentle alternative.
The Avero's trial definitively closed the door on this. Aspirin is meaningfully less effective at preventing AFib strokes, and it still carries a real bleeding risk. Current guidelines have largely abandoned it for AFib.
As a conceptual clarification for the nursing students listening, you have to understand why aspirin fails based on what we discussed earlier. Aspirin targets platelets. It works beautifully on platelet-rich white clots that form when arterial plaque bursts.
Yes, the white clots.
But an AFib clot is different. As we established, it is a fibrin-rich red clot born out of stasis and the coagulation cascade in the LAA.
It's a completely different structure.
Using aspirin for a fibrin-rich AFib clot is like bringing a sponge to a grease fire. A sponge is a great cleaning tool, but it is fundamentally the wrong chemical tool for the makeup of the problem.
I love the grease fire analogy. You need true anticoagulants, the DOACs or warfarin, to target the fibrin cascade, not antiplatelet agents.
So, to summarize this wild journey we've been on, we started in the 18th century with a physician feeling a delirious pulse at the bedside.
Jean-Baptiste de Sénac.
We moved to Willem Einthoven, visualizing the electrical chaos with a twitching string. We uncovered the exact ear-shaped pouch where 95% of these massive clots form, and we talked about calculating the risk with the CACOYO VASC score.
And we are now in an era of modern debates sparked by Apple Watches, realizing that AFib is a complex spectrum of electrical instability.
It's not just a simple switch anymore.
No, and if we connect all this wearable tech back to the bigger picture, it raises a rather profound question.
Oh, I like where this is going.
Think about it. If smartwatches are now revealing that huge numbers of perfectly healthy, asymptomatic people occasionally have these brief, silent flutters of AFib.
Right, the silent episodes we talked about.
Yeah, it makes you wonder about the future of human health. When we reach a point where we can monitor every single electrical impulse of the body 24/7, will we discover that normal does not actually exist? Maybe everyone is just a little bit irregular.
I mean, if you look closely enough at any metronome, maybe none of them are truly perfect. That is something to think about. Thank you for joining us on this deep dive. Keep questioning the things you take for granted, keep learning, and don't forget to check your pulse.
You know, usually when we talk about a medical diagnosis, there's this expectation of absolute precision, like engineering.
Right.
You break your arm, the x-ray shows that jagged white line, and the doctor just points to the screen and says, there it is. It's broken or it's not.
Exactly. We rely on that visual evidence. I mean, it's comforting to have categories that are strictly binary, right? Things that feel like they're handed down by absolute biological laws.
Yeah, but diving into the stack of sources we have for today's deep dive, we're looking at nursing texts, obstetric research, clinical guidelines on what the medical world calls the stages of labor. And that expectation of precision just completely shatters.
It really does. It's a deeply constructed landscape.
Totally. And the thing that absolutely blew my mind reading through this material, and we're so glad you're here joining us for this, by the way, is that childbirth is this universal, fundamental human process. But the clinical definitions governing it have an incredibly dramatic history.
Oh, dramatic is the right word.
I mean, imagine a woman in labor in 1995 being rushed to emergency surgery for, failing a medical test, while that exact same woman today would be told she's progressing perfectly normally.
Because the rules literally change overnight. So our mission today is to walk you through this timeline from the very first contraction to the critical recovery period.
Right.
We are going to unpack the biology of what is actually happening in the body, debunk some major misconceptions like the idea that labor follows a steady, predictable clock, and understand why these 4 distinct stages are really the ultimate foundation for global nursing and medical practice.
Okay, let's unpack this, because we have to start at the very beginning of the process, which is stage 1. And the most important thing to grasp here is that the 4 stages of labor are defined by physiological endpoints.
Right, they are biological milestones.
Exactly. Opening the cervix, pushing out the baby, delivering the placenta, and then the uterus recovering. They are not defined by a fixed clock time. But reading the history in these texts doctors spend a very long time acting like they were.
They absolutely did. And the historical misstep here is just one of the most fascinating examples of how medicine evolves. To
Yeah.
set the baseline, stage 1 begins with true labor.
Which is different from, like, practice labor, right?
Exactly. True labor means regular, progressively intensifying contractions that are actually causing measurable change to the cervix. It's a very distinct process from Braxton Hicks contractions.
Right, the Braxton Hicks.
Yeah. Those are the irregular practice spasms a woman might feel for weeks before labor, but they don't mechanically alter the body. So stage 1 officially ends when the cervix reaches 10 centimeters, meaning full dilation.
But the way they used to measure how fast you were supposed to get to that 10-centimeter mark is where things just get wild. I mean, it all goes back to 1954 and this obstetrician named Dr. Emanuel A. Friedman.
Right. So Dr. Friedman tracks cervical dilation over time in about 500 first-time laboring mothers at Columbia University. And he plotted their progress on a graph and produced this very neat S-shaped curve. Based on his specific group of 500 patients, he basically declared a universal biological rule.
Based on just 500 people.
Just those 500. He said a slow latent phase is followed by a steep active phase that kicks in exactly at 4 centimeters of dilation. He even derived expected speed limits from this.
Speed limits for birth.
Literally. He published that first-time mothers should dilate at a rate of about 1.2 centimeters per hour once they hit that 4-centimeter mark.
And if a laboring woman deviated from that strict 1.2 centimeters per hour speed limit, she was diagnosed with abnormal labor or failure to progress. And the texts point out that this diagnosis became one of the leading justifications for performing a C-section for decades.
Decades. Entire generations of women.
I was trying to wrap my head around this, and honestly, it feels a bit like judging modern highway traffic speeds using a map and data from 1950s dirt roads.
That is a perfect analogy. What's fascinating here is that we rarely see this kind of shift.
Well, the most shocking detail I found in the research is looking at who those 500 women actually were. Friedman's 1950s patients were heavily sedated. They were often under what was called twilight sleep, and a massive percentage of them had forceps-assisted deliveries.
Right.
And both heavy sedation and, pulling a baby out with metal tongs artificially alter the natural pace of labor. Yet that deeply flawed, highly specific benchmark ruled hospital wards for half a century.
It's staggering when you think about the surgical consequences of that benchmark. Like I said, entire generations of women subjected to major abdominal surgery just because their bodies weren't adhering to a timeline established by sedated patients in 1954.
Yeah.
And it really took until 2010 for the medical establishment to formally challenge this with modern data. That's when Jun Zhang and colleagues with the Consortium on Safe Labor analyzed over 60,000 contemporary U.S. births.
Wow, 60,000.
Yeah, a data set 120 times larger than Friedman's.
And what they found completely upended the system.
Entirely. The Zhang curve looked completely different. The data showed that in a contemporary, diverse population, active labor often doesn't clearly begin until 6 centimeters of dilation, not 4.
Okay, so a huge shift right there.
Huge. Furthermore, progress before that 6-centimeter mark can be incredibly slow. It can stall and start and be highly variable without being dangerous or pathological to the mother or the fetus.
The impact of that realization is just staggering to me. The text mentioned that in 2014, major medical bodies like ACOG, the American College of Obstetricians and Gynecologists, they formally moved the definition of the start of active labor to 6 centimeters.
Exactly.
You just don't see that very often.
Yeah.
A core textbook clinical definition being formally revised specifically to stop doctors from intervening too early and ultimately reducing the rate of iatrogenic, meaning medically caused, C-sections.
Yeah, the clinical takeaway is profound here. Patience is a medical intervention in itself.
I love that.
But to really appreciate what is happening during this redefined timeline, we need to look at the biological engine. Opening a human cervix to 10 centimeters requires a massive amount of physiological force.
That's exactly where my head went next. Now that we understand the map of stage 1, how does this dilation actually happen? The texts mention things like gravidity and parity, which I understand means how many times a woman has been pregnant versus how many times she has given birth.
Correct.
And those are the strongest predictors of how fast these stages go. But what is physically driving those uterine muscles to pry open the cervix in the first place?
So the entire mechanism is driven by a neuroendocrine loop. It's called the Ferguson reflex.
The Ferguson reflex.
Right. As the fetal head descends into the pelvis, it physically distends or stretches the lower uterine segment, the cervix, and the upper vaginal walls.
Okay.
Now, nerves in those tissues sense that extreme mechanical stretching. They send a rapid signal straight up the spinal cord to the mother's hypothalamus in the brain.
And the brain reacts to that.
Yes. The hypothalamus directs the posterior pituitary gland to release a surge of oxytocin into the bloodstream.
And oxytocin is the hormone that forces the uterine muscle fibers to contract.
Exactly. Endogenous, naturally occurring oxytocin binds to receptors on the uterus, causing a powerful contraction.
All right.
And that contraction pushes the baby further down into the pelvis, which causes more cervical stretching.
Ah.
That extra stretching triggers the brain to release a larger surge of oxytocin, which causes an even stronger contraction, leading to even more stretching.
Wait, so is this sort of like when someone brings a microphone too close to a speaker on a stage?
How do you mean?
Like the mic picks up the ambient sound, amplifies it through the speaker, then the mic picks up that louder sound, amplifies it again, and you get this screeching audio loop that just escalates and gets louder and louder until someone unplugs the system.
The mechanics of your analogy are spot on.
Yes.
Biologically speaking, what you're describing is incredibly rare. Yeah. Almost every system in human biology relies on self-correcting negative feedback loops to maintain equilibrium.
Like sweating when you're hot.
Exactly. Your body's sweating to cool down your temperature. But the Ferguson reflex is one of the very few genuine positive feedback loops in human physiology. It is a self-amplifying cascade expressly designed to escalate in intensity until the stimulus, the baby, is entirely expelled from the body.
Wow. And while this positive feedback loop is raging, which, according to the sources, can take anywhere from 6 to 18 hours for a first-time mother, I was curious how the nurses are tracking it in real time, because they aren't just standing there guessing.
Definitely not.
I saw terms in the clinical guidelines like effacement and station, and frankly, I felt like I was reading a foreign language. What are they actually measuring with those?
It's a great question because we tend to focus entirely on dilation, the 1 to 10 centimeters. But dilation is only one piece of the puzzle. The cervix isn't just a flat door. It's a thick cylindrical structure, almost like the neck of a bottle. So effacement refers to the thinning and shortening of that tissue, and it's measured as a percentage from 0 to 100.
So if 0% effaced is a thick bottleneck, what does 100% effaced look like?
Okay, imagine stretching a thick turtleneck sweater over a bowling ball.
Okay.
Initially, the neck of the sweater is thick and stands up. But as you force the ball through, the fabric of the neck stretches so thin it essentially becomes flesh with the ball itself.
Oh, wow.
That extreme thinning is 100% effacement. The cervix must completely thin out before it can fully dilate.
Okay, that visual helps a lot. And what about station?
Station tracks the physical descent of the baby. Inside the mother's pelvis, there are 2 bony landmarks called the ischial spines.
Ischial spines, got it.
Clinicians use those spines as the 0 point on a map. If the baby's head is above those spines, it's measured in negative centimeters, like -2 or -3.
Still pretty high up.
Exactly. But as the baby descends past the spines and gets closer to birth, the numbers turn positive, +1, +2, all the way to +5 at delivery. Nurses combine all these metrics, dilation, effacement, station, along with the physical consistency and position of the cervix to calculate what is called a Bishop score.
And that score tells them what?
It's a predictive tool to evaluate how ready a body is for that Ferguson reflex to take over.
Okay, that makes sense. And to track all of this over those 18 hours, the sources highlight a tool called the WHO Partigraph. It was originally developed in the 1970s in Rhodesia, which is now Zimbabwe, and it's basically a paper chart that plots these cervical changes against time.
Right. And the brilliance of the partigraph is in its visual simplicity for busy clinical settings.
Yeah, just lines on a graph.
It uses pre-drawn alert and action lines. If a laboring woman's plotted progress drifts across the alert line, it tells the nurse to monitor more closely.
And the action.
If it crosses the action line, it triggers a mandatory clinical response, like transferring the mother to a higher level of care or evaluating for interventions. It's a direct, highly practical descendant of the curves we discussed earlier, designed to catch complications before they become emergencies.
Okay, so let's say this self-amplifying positive feedback loop of stage 1 has done its job. The cervix is 100% effaced, it's 10 centimeters dilated, the tissue is essentially gone, and the baby has descended into the positive stations. We're officially in stage 2.
Stage 2.
And reading the text, it seems like the entire physiological goal completely shifts here. It goes from a neuroendocrine process of forcing a door open to a purely mechanical process of navigating an object through a very specific bony hallway.
The The transition from stage 1 to stage 2 is arguably the most dramatic shift in human physiology. Stage 2 is strictly defined as the time from that full 10-centimeter dilation to the actual delivery of the baby.
Right.
It is physically navigating the maternal pelvis.
And the baby isn't just dropping straight down a smooth tube, right? The texts outline this complex sequence called the cardinal movements of labor, but they just list them out. What is actually happening physically?
Well, think of the human pelvis as a curved, bony maze that changes shape.
Changes shape.
Yeah, the inlet, or the top of the pelvis, is wider side to side, but the outlet, the bottom of the pelvis, is wider front to back, and the baby's head is an oval.
Ah, so the shapes don't line up at first.
Exactly. To get an oval through a passageway that shifts its orientation by 90 degrees, the baby has to execute a precise sequence of twists and turns. These are the cardinal movements.
So it's literally an evolutionary lock and key mechanism.
Precisely. First, the baby must engage and descend. Then, it undergoes flexion, tucking its chin firmly to its chest to present the absolute smallest diameter of its skull to the pelvis.
Right, getting as compact as possible.
Yes. As it descends further into that changing pelvic shape, it must internally rotate, essentially turning its head to face the mother's spine. Once under the pubic bone, the baby extends its neck to navigate the curve of the birth canal. Finally, after the head is born, it must externally rotate, called restitution, untwisting its neck, so the broad shoulders can align with the widest part of the pelvic outlet for final expulsion.
Hearing the physics of that makes the clinical debate around pushing make so much more sense.
Mm-hmm.
Because stage 2 is divided into phases, right?
Yes, it is.
The texts talk about a passive phase, often called laboring down, where the fetus is descending through that maze, but the mother has no active urge to push. And then an active phase, where maternal pushing is synchronized with the contractions. Here's where it gets really interesting for me, and I want to push back on a huge misconception I held before reading this material.
Oh, what's that?
I always assumed the urge to push was just a psychological reaction to the pain. Like your body hurts, you feel pressure, so you actively strain to get the source of the pain out.
A lot of people think that.
Right. But the research explicitly states that pushing isn't just a psychological response at all.
No, you've hit on one of the most common misunderstandings about human birth. The overwhelming, uncontrollable urge to push is not a conscious decision born out of discomfort. It is the Ferguson reflex arc reaching its absolute zenith.
Wow.
As the baby's head crowns and heavily distends the lower vagina and the perineal floor, those stretch receptors fire so intensely that the subsequent oxytocin surges command the abdominal muscles and the diaphragm to bear down involuntarily.
Just completely taking over.
It is a profound neuroendocrine imperative.
Which explains why women describe it as an unstoppable force. And just like we saw in stage 1 with the timeline debates, there are massive debates about the timeline of stage 2, especially regarding medical interventions.
The historical approach to stage 2 was defined by strict, short time limits. If a woman had been pushing for 2 hours, traditional teaching dictated immediate intervention.
Using a vacuum or forceps?
Yes, a vacuum extractor, forceps, or rushing to a C-section to just pull the baby out of the maze.
Going back to that 1950s mindset of the clock ruling the biology.
Exactly. But contemporary guidelines are stepping back from the clock. They are shifting toward allowing much more permissive time limits, especially for first-time mothers. We now understand that variables like epidural analgesia can significantly lengthen stage 2.
Why is that?
Well, epidurals numb the stretch receptors in the pelvic floor, which dampens the Ferguson reflex, meaning the urge to push is delayed or diminished.
Oh, that makes total sense. The feedback loop gets interrupted.
Right. And modern medicine is learning to accommodate that physiology. As long as the continuous fetal heart rate monitoring shows the baby is tolerating the descent without distress, doctors are giving the lock and key mechanism the time it needs to work, rather than rushing to the operating room.
It is genuinely a relief to see clinical patients being codified into the protocols. So the baby has successfully navigated the twists of the pelvis, the cardinal movements are complete, and the baby has arrived.
The main event.
Right. In my mind, and probably in most people's minds, the dramatic part is over. The room breathes a sigh of relief. But reading the nursing texts, the tone shifts completely here. From a clinical perspective, the highest risk of mortality actually begins after the main event.
The clinical vigilance has to remain incredibly high because the physiological danger is far from over. We are now entering stage 3 and stage 4.
Okay.
Stage 3 covers the delivery of the placenta, the organ that sustained the baby, and that normally detaches and is expelled within 5 to 30 minutes post-birth.
I was reading about how they monitor this, and I saw these two terms. The Schultz mechanism and the Duncan mechanism. What is actually happening inside the uterus to detach this organ, and why does it matter which way it comes out?
So the placenta is deeply attached to the uterine wall. It shares massive vascular connections. When it's time for it to detach, it can peel off in 2 primary ways, named after the physicians who first categorized them.
Got it.
The Schultz mechanism is the most common. It means the placenta separates from the center first. Imagine an umbrella closing inward.
Okay, an umbrella closing.
Because it detaches centrally, the bleeding is trapped behind the placenta until the whole organ is delivered. The fetal shiny surface presents first, so clinicians often call it the shiny Schultz.
Add a Duncan.
The Duncan mechanism means it separates from the outer edges first. Because the edges peel away, maternal blood escapes continuously during the separation.
So it's messier.
Right. The rough maternal side of the organ presents first, earning the nickname the Dirty Duncan.
Shiny Schultz and Dirty Duncan.
Exactly. Clinicians watch for these mechanisms along with classic signs of detachment. They look for a sudden gush of dark blood, the lengthening of the visible umbilical cord, and the uterus rising in the abdomen and becoming firm and globular.
I think the text called that Calkin sign.
Yes, Calkin.
Good to know they have specific visual cues to rely on. But once the placenta is out, we enter stage 4, the recovery period. This covers roughly the first 1 to 4 hours postpartum. The uterus begins a process called involution, meaning it's contracting back down to its non-pregnant size. But this is the window where the danger really spikes, right?
It is the most critical window for maternal survival. Postpartum hemorrhage, which is catastrophic rapid bleeding, is the leading cause of maternal death worldwide. And it most commonly happens right here in stage 4, usually due to a condition called uterine atony.
What causes that? Why does it just start bleeding?
Think about the physics of the placenta detaching. When it peels off the uterine wall, it leaves behind an open wound the size of a dinner plate.
Oh, wow.
With massive, exposed blood vessels pumping maternal blood. There is no bandage you can apply. The only physiological mechanism the body has to stop a woman from bleeding to death is for the muscle fibers of the uterus to crisscross and clamp down fiercely, acting as a biological tourniquet on those open vessels.
A biological tourniquet.
Yes. If the uterine muscle is exhausted from a long labor, which is what uterine atony means, a lack of muscle tone, it fails to clamp down. The vessels remain open and severe hemorrhage can occur in a matter of minutes.
So what does this all mean for how childbirth is managed? Because if birth is this deeply natural process shaped by millions of years of evolution, I was surprised to read about a massive global public health push for active management, which specifically means injecting synthetic oxytocin or pitocin during stage 3.
It's a very fair question.
Right. If the Ferguson reflex was so perfectly designed to get the baby out naturally, why do we suddenly need to intervene with synthetic drugs to get the placenta out and stop the bleeding? Doesn't the body know what to do?
It's an excellent challenge, and if we connect this to the bigger picture, it sits at the heart of a major global health debate. At an individual level, some midwifery models do favor a physiologic or expectant approach, letting the body's natural oxytocin slowly detach the placenta without medication.
Which makes intuitive sense.
It does, but you have to look at the data from a population scale. Routine active management is heavily championed by the World Health Organization. This protocol involves giving a prophylactic injection of oxytocin immediately after the baby is born, applying controlled cord traction to guide the placenta out, and vigorously massaging the uterus to stimulate those muscle fibers.
And they recommend this universally, regardless of how natural the birth was.
Universally. Because when you analyze global health outcomes, especially in resource-limited settings where blood transfusions aren't readily available, postpartum hemorrhage is a rapid, silent killer.
Yeah.
A body's natural physiology might work 90% of the time, but at a population level, that 10% failure rate equals hundreds of thousands of deaths. Administering a simple, low-cost dose of synthetic oxytocin to force that uterus to contract firmly and immediately is one of the most cost-effective, high-impact interventions in all of modern medicine.
It's a genuine case where an unglamorous routine protocol during the quietest stage of labor has an outsized, life-saving impact on a global scale. It really reframes the whole experience for me.
Yeah.
It's not just something that happens to you, it is this wildly complex, active biological machine. So, to recap the journey we've just been on through these sources, the 4 stages map perfectly to 3 distinct mechanical tasks plus a critical recovery phase.
Right.
Stage 1 is the neuroendocrine process of opening the cervix, driven by the escalating positive feedback loop of the Ferguson reflex. Stage 2 is the purely mechanical navigation of the fetal oval through the shifting bony maze of the pelvis via the cardinal movements. Stage 3 is the detachment and expulsion of the placenta. And stage 4 is the vital biological tourniquet of uterine involution to prevent hemorrhage.
This is perfect summary.
We've seen how understanding the actual biology is leading modern medicine away from strict clocks, and how sheer nursing vigilance in that quiet 4th stage genuinely saves lives.
The complexity of the system is just awe-inspiring. But for me, the lingering takeaway from these texts goes back to our earlier discussion of Dr. Friedman and Dr. Zhang. We saw how a fundamental biological rule, the expected start and speed of active human labor, turned out to be an accidental artifact of 1950s hospital practices. It wasn't human nature at all. It was a reflection of sedated patients with forceps deliveries being recorded as normal.
Which is still so crazy to me.
It really leaves you with a profound question to consider as you go forward. What other fixed medical definitions or expected timelines in our bottles, things we accept as absolute biological facts today, are actually just reflections of the specific flawed populations we chose to study decades ago?
That is a phenomenal question to end on. Are we still judging our health by 1950s dirt roads when we should be looking at modern data? It challenges us to look past the surface of any diagnosis, to realize that medicine is an evolving landscape, not just a binary black and white X-ray. Thank you so much for joining us on this deep dive. Keep asking questions, keep challenging the definitions you are handed, and we will see you next time.
You know, you walk into any modern hospital ward, and there is this this profound, almost comforting illusion of control.
Oh, absolutely.
Like everything is bright, it's sterile, it's highly categorized. You look down the hallway and you see those brightly colored signs taped to patient doors, right?
Right. The yellow one for this pathogen, the blue one for that one.
Exactly. Maybe a green one near the end of the hall. And it just projects this absolute certainty, this feeling that the medical world has like completely mastered the physical space and everything invisible within it.
Yeah, it creates the atmosphere of this highly organized fortress. I mean, the underlying message of that laminated piece of paper on the door is that the enemy, the pathogen, has been perfectly contained by our administrative protocols.
But when you actually read the literature, you know, when you dig into this stack of sources on isolation precautions in nursing, like we are today, you realize those tidy little signs are covering up a messy, ongoing battleground.
Messy is definitely the word for it.
Right. We treat these protocols like they descended from a mountain carved in stone, but the reality is this landscape is driven by evolving aerobiology, complex fluid dynamics, and frankly, a whole lot of historical trial and error.
Yeah, we are constantly negotiating with biology. The rules we follow today are really just the current uneasy truce we've struck with microorganisms that are actively trying to bypass our defenses.
So our mission today is to decode that rulebook for you, to look past the laminate and understand what is actually happening invisibly in the air and on the clinical surfaces around you.
It's a huge topic.
It is. We're zeroing in on the modern CDC and HICPAC framework. That's the Healthcare Infection Control Practices Advisory Committee.
Yeah.
This is the standard 2-tiered system taught in every single U.S. nursing program.
Right, and the foundation of that is standard precautions,
Yep.
which applies universally to every single patient encounter.
Which basically means treating all blood and body fluids as inherently infectious.
Exactly. Hand hygiene, safe injection practices, throwing on gloves for fluid contact. You do that whether the patient is there for a routine appendectomy or, a mysterious fever. It is the absolute baseline of clinical practice.
And sitting right on top of that baseline is the second tier, the transmission-based precautions, heavy hitters.
Right. Contact, droplet, and airborne.
Okay, let's unpack this. Because before we can understand the massive debates currently raging about how these rules are applied, we have to look at the mechanical foundation they're built on.
The physics of it all.
Yeah, exactly. We have to answer the physical question, how does this specific pathogen actually cross the space between a patient and a clinician?
Because pathogens aren't magic, even if they sometimes feel like it. They obey the laws of physics.
Right.
They need a physical vehicle to cross that space.
Yeah.
So let's look at contact precautions first. The vehicle here is direct touch, or a contaminated intermediate surface, a fomite.
So like a bed rail.
Exactly. If you're dealing with MRSA or VRE, those bacteria are heavily colonizing the patient's skin, the bed rails, the IV pole. The moment you walk into that environment, your uniform is at risk of becoming the vehicle.
Which dictates the protocol.
Right, donning a gown and gloves before crossing the threshold and keeping dedicated diagnostic equipment inside that specific room.
But, reading through the sources, there's this fascinating exception that completely upends the standard routine, and it involves Clostridioides difficile, C. diff.
Oh, C. diff. It is the ultimate trip-up in clinical practice.
Yeah.
It forces a complete behavioral override of the standard hospital routine.
Right, because everywhere else in the hospital, the gold standard, like the absolute reflex, is the alcohol-based hand sanitizer. You finish an assessment, you pump the phone, you rub your hands, you move on.
It's pure muscle memory.
But alcohol does not denature C. diff spores.
Yeah.
It reminds me of working on a car engine. Imagine your hands are just coated in thick, heavy axle grease. If you pour rubbing alcohol on them, you aren't cleaning anything. You're just smearing the grease around your skin.
Right. It doesn't break it down.
Exactly. The only way to get it off is mechanical friction. You need heavy soap, running water, and vigorous scrubbing to physically pry that grease off your epidermis and wash it down the drain. You can't chemically kill the stoles with alcohol. You have to physically evict them.
I love that analogy because it perfectly captures the physical mechanics of the spore. C. diff spores have an incredibly hardy protein coat that evolved specifically to survive harsh chemical environments.
Like the stomach.
Precisely, the acidic human gut. So a splash of ethanol isn't going to breach it. You have to rely on the sheer force of soap and water. It's a vital concept because it breaks that deeply ingrained muscle memory of the healthcare worker.
Now, if a pathogen isn't relying on touch, it might be hitching a ride in a respiratory droplet, which brings us to the droplet precaution category.
Right. The vehicle here is respiratory fluid expelled during a cough, a sneeze, or even just talking. These droplets are relatively large and heavy.
So gravity is doing a lot of the work.
Exactly.
Yeah.
Because of their mass, gravity is the dominant physical force acting on them. They're pulled down to the floor pretty rapidly, typically falling within a 3 to 6 foot radius of the patient.
That implies a safe zone. Like if you are standing 7 or 8 feet away, gravity has already done the protective work for you.
That's the clinical assumption. The required PPE is a standard surgical mask, donned when coming within that physical radius to block those macroscopic droplets from hitting your mucous membranes.
And notably, you don't need any specialized room ventilation.
No, not at all. The droplets are on the floor. They aren't, lingering in the HVAC system.
The sources list the usual suspects for this category, influenza, pertussis, mumps, rubella. But the standout that really caught my attention is Neisseria meningitidis, bacterial meningitis.
Oh, yeah, that is a pathogen that instantly changes the temperature in the emergency department.
Because the timeline is so aggressive, right, it can kill a healthy adult within hours. If a nurse or a physician conducts a close-up assessment without a mask and the lab comes back positive for meningitis, that clinician urgently needs post-exposure prophylactic antibiotics.
It's a massive deal.
It's not a situation where employee health says, monitor yourself for fever, let us know. It's immediate intervention. It really hammers home that these precaution categories aren't just bureaucratic suggestions.
Right.
They map directly onto life or death clinical urgency.
Absolutely. But what happens when the droplet is so small that gravity is no longer the dominant force?
Oh.
That is when we cross into airborne precautions. We are no longer talking about macroscopic fluid hitting the floor. We are talking about microscopic aerosolized particles.
So they don't fall.
No, they float. They ride the thermal plumes and ambient air currents in the room, and they can remain suspended for hours after the source patient has physically left the space.
Wow. So a standard surgical mask is essentially useless against that kind of physics?
It offers virtually no protection. Airborne particles simply flow around the loose edges of a surgical mask or pass straight through the macroscopic pores of the material.
Right.
You need a fit-tested N95 respirator, which uses an electrostatic charge to trap microscopic particles, or a PPR, a powered air-purifying respirator. Furthermore, the environment itself has to be engineered.
The patient has to be in a specific room.
Yes, an airborne infection isolation room, or AIR.
The negative pressure room.
Exactly. The HVAC system actively exhausts more air from the room than it supplies, creating a pressure differential. When you open the door, air from the hallway rushes in.
Ah, preventing the contaminated air inside from drifting out and infecting the rest of the ward.
Right. The system is also required to perform a minimum of 6 to 12 complete air changes per hour, physically scrubbing the room's atmosphere.
What's terrifying is that you need that level of engineering because these pathogens are wildly infectious.
What's fascinating here is just how efficiently some of these airborne viruses exploit the air. Look at measles. It has a basic reproduction number, an R0, of 12 to 18. In an unprotected population, one case generates, on average, over a dozen secondary cases. To put that into perspective, in 1985, the CDC investigated an outbreak in Michigan.
Okay.
A child with measles had an appointment in a pediatrician's exam room. They finished the exam and left the clinic entirely. Sometime later, a second child, completely unrelated to the first, was brought into that exact same, now empty room.
Wait, the room is empty. The source of the infection is just gone.
The patient was gone, but the air itself was still contagious. That second child contracted measles simply by inhaling the lingering suspended aerosols in that enclosed space.
Oh, wow.
It's a chilling demonstration of why airborne rooms require high-velocity air changes before they are considered safe to re-enter.
It is chilling. And looking at this modern framework, contact, droplet, airborne, it feels so mechanically logical. You identify the physical vehicle and you block it. But going through the historical sources, it begs a massive question. If this is just applied physics and biology, how did it take the medical establishment nearly 150 years to agree on it?
Well, the delay was driven by a powerful combination of unseen biology and deep professional stubbornness.
Stubbornness?
Oh, yeah. If we look back to the mid-19th century, we see the very first crude attempts at infection control. During the Crimean War in the 1850s, Florence Nightingale didn't actually understand germ theory. She believed in the miasma theory that diseases were caused by bad air.
Right, the classic bad air theory.
But her intuitive response was to aggressively improve ward ventilation and physically separate patients based on their symptoms. It was primitive, but it was effective source control.
Which was happening almost concurrently with Ignaz Semmelweis in Vienna in 1847.
The tragic pioneer of hand hygiene. He demonstrated with rigorous data that maternal deaths from puerperal fever plummeted if physicians simply washed their hands in a chlorinated solution between performing autopsies and delivering babies.
But the medical establishment didn't just ignore his data. They actively destroyed his career over it.
They were deeply insulted. The prevailing mindset was that a gentleman's hands could not possibly transmit disease.
Wow.
The idea that the doctors themselves were the vectors of death was professionally abhorrent. Semmelweis was mocked, sidelined, and eventually died in an asylum.
That is so sad.
It is a stark reminder that solid infection control data often loses out to professional ego and established dogma.
It really does. And, it took until 1970 for the CDC to publish its first formal hospital isolation guideline. They essentially created a menu of precaution bundles. You had strict isolation or respiratory isolation, and nurses would just select the bundle that matched the patient's diagnosis.
Yeah, that was the model for a while.
But that entire paradigm slammed into a brick wall in the early 1980s, HIV and AIDS.
HIV completely shattered the existing logic of isolation. For decades, the philosophy had been identify the sick patient, diagnose them, and isolate them. But HIV presented a terrifying new reality. You had a deadly pathogen where patients could remain asymptomatic and undiagnosed for years. You simply didn't know who was infected.
So because they didn't know who was actually infected with HIV, they had to flip the whole philosophy from isolate the known sick patient to assume every single person is a risk.
Precisely why the CDC introduced universal precautions in 1985, formalized heavily in 1987. Healthcare workers were contracting HIV through accidental needle sticks and blood exposures. Universal precautions established the radical new baseline that all blood and certain body fluids must be treated as highly infectious, always.
But the sources highlight that this didn't entirely solve the problem on the floor.
No, it didn't.
Because at the exact same time, you had infectious disease experts like Patricia Lynch pushing back. She proposed a rival system called body substance isolation, or BSI, arguing that focusing only on blood was dangerously narrow.
Right.
BSI demanded protection against all moist body substances, feces, urine, sputum, from every patient.
Imagine being a charge nurse in the late 1980s or early 90s. You have two competing, fundamentally different sets of protocols being published and debated simultaneously.
That sounds awful.
One focuses strictly on bloodborne pathogens. The other requires gloves for touching absolutely any body fluid. It created massive confusion and compliance failures on the floor.
That sounds like an administrative nightmare. So how did we finally get to the system we use today?
In 1996, Julia S. Garner, leading the CDC's HIC pack, performed a brilliant piece of clinical synthesis.
Okay.
She took universal precautions, merged it with the best elements of body substance isolation, and created standard precautions, the universal baseline we discussed earlier.
Ah, okay.
Then she took the old, clunky, disease-specific bundles and streamlined them into contact, droplet, and airborne. She built a cohesive two-tiered architecture that finally made sense.
It's an elegant piece of rulemaking, but as we know, pathogens don't read rule books.
They certainly don't.
The tension in these sources really spikes when we look at what happens when the system breaks down. And it does break down. Usually it's a failure of human execution or a failure of the scientific model itself.
Human error is the most common vulnerability. A tragic and highly publicized example was the Dallas Ebola cluster in 2014.
Oh, right, I remember that.
Thomas Eric Duncan was the first person diagnosed with Ebola on U.S. soil. The hospital utilized contact and droplet precautions, escalating their PPE as his condition worsened. Yet two of the intensive care nurses treating him, Nina Pham and Amber Vinson, contracted the virus.
And the subsequent investigations revealed that the precaution category wasn't technically wrong, right? The failure was in the execution, specifically the doffing, the removal of the protective gear.
Yes.
It makes me think of an explosive ordnance disposal technician wearing a bomb suit. The suit works perfectly against the blast, but if the technician decides to unlatch the helmet while the shrapnel is still flying around the room, the suit becomes meaningless.
That's exactly it.
With Ebola, if a nurse exposes even a millimeter of bare skin at the wrist while sliding off a heavily contaminated fluid-resistant gown, the virus finds its window.
Doffing is incredibly perilous. You're dealing with healthcare workers at the end of a grueling 12-hour shift.
Yeah.
Cognitively depleted, physically sweating inside impermeable gear, and operating under immense psychological stress.
Just a recipe for a slip-up.
The Dallas cases forced the entire industry to realize that having the right PPE is insufficient if your donning and doffing technique isn't flawless and actively monitored by a trained observer.
Right.
But beyond human error, there are terrifying instances where the clinicians do everything perfectly, and the mental model of transmission itself is what fails.
Which brings us to the 2003 SARS outbreak in Hong Kong, specifically the Amoy Gardens apartment complex.
Over 300 residents in a single high-rise complex were infected with SARS-CoV-1, and the epidemiological mapping defied everything we knew about standard respiratory droplet transmission.
Because they weren't coughing on each other in the hallways.
No. The virus was moving vertically through the building's infrastructure.
Wait, I remember reading this in the sources and being completely baffled. How does a respiratory virus travel through a building's infrastructure?
Through the plumbing.
The plumbing.
Yes. The floor drains in the bathrooms utilized U-traps, those curved pipes designed to hold a little bit of water to block sewer gases from coming up.
Okay, sure.
But in many apartments, the floor drains were rarely used, and the water in the traps had evaporated. When a resident who was shedding massive amounts of the virus in their feces used the bathroom exhaust fans created a negative pressure environment.
Oh, no.
It literally sucked aerosolized, virus-laden fecal matter out of the dry plumbing pipes and into the apartments.
Literal airborne feces traveling backward through dry plumbing. I mean, there wasn't a precaution category in the 1996 CDC playbook for that.
Because the medical establishment desperately wants categories to be neat. We want respiratory viruses to exclusively utilize the respiratory droplet vehicle. We do not want them utilizing aerosolized sewage.
Here's where it gets really interesting. Because that deep institutional desire for neat, predictable categories brings us to the biggest scientific brawl in modern epidemiology.
The 5-micron controversy.
Yes, during the COVID-19 pandemic.
It was an absolute seismic shift in infection control. It forced a global reckoning regarding how we define the very air we breathe.
For decades, the rigid textbook definition separating a droplet from an airborne particle was based on a strict measurement. 5 microns.
Right.
The dogma stated that if a respiratory emission was larger than 5 microns, it was heavy, and it would fall to the floor within 6 feet. If it was smaller than 5 microns, it was an aerosol, and it would float.
And relying on that rigid metric, in early 2020, the WHO and the CDC confidently classified SARS-CoV-2 as a droplet spread pathogen.
I remember.
The public health messaging was entirely built on this. Stay 6 feet away, wear a standard surgical mask, wash your hands, and you are protected.
While N95 respirators were fiercely rationed.
Exactly, restricted only for specific aerosol-generating procedures like intubating a patient.
I always assumed that 5-micron rule was the result of some massive, definitive clinical trial. But aerosol scientists, experts like Lindsay Marr at Virginia Tech and Jose Luis Jimenez at the University of Colorado began looking at this and essentially said, this is fundamentally bad physics.
They did a deep historical dive and realized the 5-micron rule wasn't based on modern fluid dynamics. It was a bureaucratic misinterpretation of tuberculosis research from the 1930s.
The 1930s?
Yes. Marr and her colleagues argued forcefully that human beings do not emit perfectly uniform 5-micron droplets. When we speak, when we cough, when we sing, we emit a massive, continuous spectrum of particle sizes.
Right.
And the physics dictate that in poorly ventilated indoor spaces, even particles much larger than 5 microns can dehydrate in the air, shrink, and travel much further than 6 feet.
And the undeniable tragic proof of this bad physics was the Skagit Valley chorale rehearsal in Washington State in March 2020.
The super-spreading event that irreparably broke the droplet model.
You had roughly 60 people gathered in a room for a 2.5-hour choir practice. They were aware of the virus. They actively tried to maintain distance, staying more than 6 feet apart.
Right, following the rules?
Following the rules. There was only one symptomatic person in the room. And out of those 60 people, 52 were infected.
You cannot mathematically or physically explain 52 infections in a room of that square footage using a 6-foot droplet model. It is impossible.
Just doesn't work.
The virus was not falling to the floor. It was accumulating in the air as fine aerosols, drifting across the room like cigarette smoke. The sheer force of the epidemiological math proved the aerosol scientists right.
And it took months of fierce debate, but eventually, by mid-2021, the CDC and the WHO had to bend to the physics. They revised their guidance, conceding that inhalation of fine aerosols was a primary route of transmission.
The medical establishment had to publicly renegotiate its own foundational science in real time.
Yeah.
If we connect this to the bigger picture, it illustrates exactly why a deep understanding of these mechanics is so vital for the clinician and the informed patient. When the underlying science is this messy and subject to revision, misconceptions thrive on the hospital floor.
People cling to simplified rules of thumb that often fail under pressure.
Exactly.
Let's actually clear the air on some of those operational misconceptions right now, because the sources dedicate a lot of ink to how these protocols are misunderstood in practice. Let's start with vocabulary. I hear isolation and quarantine used interchangeably by medical professionals all the time.
The media conflation of those terms during COVID really entrenched that error, but they are clinically distinct.
Okay, how so?
Isolation is for the infected. You isolate a patient who is confirmed sick or symptomatic to keep them away from the healthy population. Quarantine is for the exposed. You restrict the movement of an asymptomatic person who is exposed to a pathogen, waiting to see if they develop the disease.
Ah, okay, that makes sense. Here's a massive point of confusion on the floor regarding room assignments. If a patient is on droplet precautions, they must be in a negative pressure room.
That is a persistent myth, largely driven by the lingering trauma and hypervigilance from the pandemic. Droplet precautions do not require negative pressure.
They don't.
No, a standard private room with normal HVAC ventilation is perfectly adequate because those heavy droplets are settling out of the air. Reserving negative pressure AIRs is strictly for airborne precautions, where the virus is actively riding the air currents.
Which leads directly to the mask myth. There is a deep psychological reliance on the blue surgical mask to stop anything respiratory.
Well, a standard surgical mask is essentially a splash guard. It's highly effective at stopping large droplets from hitting your nose and mouth, but it does not form a seal against your face.
Right.
If you are dealing with tiny, suspended airborne particles, they will simply follow the air current right through the gaps of your cheeks. If a pathogen is airborne, anything less than a fit-tested N95 is an illusion of safety.
But the pendulum swings the other way too, right? Because of that fear, you see an over-application of airborne precautions. The assumption that any infectious respiratory illness demands an N95 and a negative pressure room.
That better safe than sorry mentality is understandable, but it creates massive operational bottlenecks. Seasonal influenza, for instance, requires only droplet precautions.
Okay.
If a hospital routinely places standard flu patients in airborne rooms, they will rapidly exhaust their specialized infrastructure. When a patient with active pulmonary tuberculosis or measles arrives, The resources they genuinely need to survive won't be available.
Let's look at one final misconception going back to contact precautions. A nurse is rushed, an IV pump is beeping, and they think, I'm just running in to silence the alarm and grab a trach. I'll just throw on some gloves. I don't have 45 seconds to tie a gown.
That shortcut completely neutralizes the precaution. Contact protocols mandate a gown and gloves for a reason. If you lean across a bed to silence that IV pump wearing only gloves, your unprotected scrubs will inevitably brush against the bed rail or the linens. You've now transferred MRSA or VRE to your uniform.
You become the vehicle.
Exactly. You will carry that fomite out into the hallway and introduce it to your next patient.
So what does this all mean? Why did we just spend this entire deep dive obsessing over fluid dynamics, historical U-traps, and the cognitive load of doffing PPE?
It matters because the stakes in modern healthcare are astronomical. Hospital-acquired infections, driven by protocol failures, cost health systems billions and drive the terrifying acceleration of multi-drug-resistant organisms. When a patient acquires VRE or C, diff, because of a broken chain of infection control, it dramatically prolongs their suffering and limits our pharmacological options.
And it extends far beyond the ICU. With the rapid resurgence of measles in under-vaccinated populations globally, a deep mechanical competency in airborne precautions isn't just a niche skill for an infectious disease specialist.
No, not at all.
It is an immediate, highly relevant necessity for every single healthcare worker.
And beyond the clinical mechanics, there's a profound philosophical lesson hidden in these sources. We are conditioned to view medical guidelines as absolute, settled truths.
Right.
But the collapse of the droplet versus airborne paradigm during COVID-19 proved that these categories are merely our best temporary attempts to impose order on a chaotic microscopic reality.
Those brightly colored signs on the hospital doors are essentially just clinical simplifications.
Exactly. This raises an important question, a final thought I'd like to leave you to ponder on your own today.
Okay.
If the strict 5-micron boundary between a droplet and an airborne particle was just a convenient clinical simplification of messy physics, one that spectacularly fell apart when tested by a novel virus, what other rigid life-or-death medical rules are we unquestioningly following today?
Wow.
What other foundational protocols are built on outdated science, just waiting for the next pandemic to expose them?
It fundamentally changes how you look at the physical space of a hospital. Think about that the next time you see a yellow contact precautions sign on a door. The invisible world is significantly messier than we like to admit.
And the rule book is always being rewritten.
Until next time, keep questioning what you think you know.
So picture a hospital room at 2 in the morning. A patient is just, trying to get out of bed to use the bathroom.
Right.
And it seems like a completely simple moment. But the most dangerous thing you can do in a hospital isn't like undergoing complex surgery or taking some experimental medication. It's actually that just trying to use the bathroom alone in the dark.
Yeah, I mean, it sounds like an exaggeration, right? But clinically speaking, it is absolutely true that one simple action triggers more injuries than almost anything else that happens on a medical floor.
Welcome to today's deep dive. We are jumping into a really fascinating stack of sources you brought us all about fall prevention in nursing. And the mission here is to explore how a concept that sounds like basic common sense, just stopping people from falling down, is actually this massive invisible web of clinical assessments and liability rules and shifting human behavior.
It really is an entire matrix of risk.
Yeah, and whether you're, say, a healthcare student prepping for your clinicals or you're just someone with an aging parent trying to keep them safe, understanding this hidden architecture completely changes how you view a simple trip across the room.
Definitely. And I think the most compelling part of this research, well, for me anyway, is discovering that almost every intuitive solution we've come up with to prevent falls historically.
The obvious stuff, right?
Exactly. The obvious stuff actually turned out to be incredibly dangerous.
Which is wild. And we are definitely going to get into those backfires. Some of them are just staggering. But I feel like before we can even talk about preventing a fall, we should probably agree on what a fall actually is.
You'd think that would be the easy part.
Right. Because looking at the World Health Organization, they define a fall as an event which results in a person coming to rest inadvertently on the ground or floor or other lower level.
Yeah, which sounds incredibly straightforward on paper, like you're standing up and then inadvertently you are on the ground.
Pretty black and white.
But the moment you take that definition and put it into a high-stakes, heavily monitored hospital environment, the reality gets remarkably complicated. Think about a scenario known in nursing as a controlled descent.
Okay, let me picture this. So this would be a situation where, like, a nurse or a physical therapist is walking down the hallway with a patient,
Right.
and the patient's knees buckle. They start to lose their balance,
Yeah.
but the staff member is right there, so they grab them and gently guide them down to the floor so they don't hit their head.
That is the exact scenario, yeah. And under the strictest reading of that WHO definition, you could argue that shouldn't count as a fall because the staff member controlled the descent and prevented an injury.
Well, yeah, they caught them.
Right, but most modern hospital incident reporting systems mandate that an assisted descent is officially documented as a fall.
Wait, I have to push back on that. If a nurse catches you, you didn't fall. You were caught. I mean, why would a hospital penalize its own safety metrics by counting a successful intervention as a failure?
Because for years, hospitals were using that exact logic as a loophole to vastly underreport their true fall rates.
Oh, I see.
Yeah, if a unit manager could just say, well, we caught them on the way down so it doesn't count, then the hospital loses crucial data about how often their patients are actually losing their balance. And that leads to this massive debate in geriatric research right now regarding near misses.
A near miss being when someone stumbles, almost goes down, but manages to, like, grab a handrail or catch their own balance at the last second.
Yes, and researchers are arguing that those near falls are incredibly vital clinical data. Even though they never reach the floor, a near miss is a glaring red flag.
It's a warning sign.
Exactly. It tells the medical team that the patient's physical capacity is actively failing to meet the demands of their environment.
And that actually brings up, I think, the biggest historical shift in how medicine views this entire concept. Looking through these sources, it seems like back in the 1980s and 90s, the medical field treated fall risk almost like a permanent medical diagnosis.
Yeah, it was a totally static label.
Wow. Right. You got evaluated when you walked through the doors. They stamped fall risk on your chart, and that label just followed you around for a week.
You were either at risk or you weren't, based on a single snapshot in time.
But treating fall risk like a one-time label is kind of like checking your car's tire pressure on January 1st and assuming it's safe to drive on the highway every single day for the rest of the year.
That's a great way to look at it.
Conditions change, right? The sources emphasize really heavily that fall risk is a highly dynamic state.
And the speed at which that state can fluctuate is exactly what makes bedside nursing so difficult. I mean, just think about what a patient goes through in a single 24-hour period in a hospital.
Right.
They might be prescribed a new pain medication that causes dizziness, or perhaps they develop a urinary tract infection, which in older adults can trigger sudden and severe confusion.
Delirium.
Exactly. Or maybe they've just been lying in bed for 3 days straight, completely immobile. Every single one of those factors completely rewires their risk profile from the morning shift to the night shift.
So you really can't rely on the data you gathered yesterday to keep them safe today. But I mean, if the risk changes constantly, how does a nurse actually keep up with that? This idea of systematically checking someone's fall risk every 12 hours didn't just appear out of nowhere.
No, it didn't. It was born out of this collision between academic geriatric medicine and the practical realities of bedside nursing, starting back in the mid-1980s.
Okay, let's unpack this origin story. It starts with Mary Tinetti, a geriatrician at Yale, right? She published this foundational research proving that falls in older adults were not just random, unavoidable bad luck. They were predictable outcomes of measurable physical deficits. So she created the Performance-Oriented Mobility Assessment, often called the Tinetti test, in 1986.
And Tinetti's contribution was huge because she proved the multifactorial nature of a fall. It is almost never just one single issue.
It's a combination of things.
Exactly. It's an accumulation of small deficits, a little bit of muscle weakness, some slight vision impairment, maybe a side effect from a blood pressure pill. These tiny factors slowly stack up until they cross a critical threshold and the patient goes down.
But the problem was the Tinetti test was this very thorough academic evaluation. And bedside nurses simply do not have 45 minutes to run a complex mobility diagnostic on every patient, every single shift.
They needed something fast.
Right. And that's where Janice Morse comes in. In the late 80s in Canada, she developed the Morse Fall Scale because she realized nurses needed a tool that took 60 seconds, not an hour.
The Morse Fall Scale is brilliant because it boils the entire multifactorial theory down to just 6 rapid-fire items. A nurse looks at the patient's history of falling, any secondary diagnoses, their mental status, their gait, whether they use a cane or walker, and whether they have an IV line or a heparin lock in their arm.
Let me stop you on that last one, actually, because I think a lot of people outside of medicine might be confused by it.
Right.
I understand why using a walker or having a history of falling puts you at risk, but why does simply having an IV line in your arm make you a higher risk for falling over?
It really comes down to the physical mechanics of walking. When you walk normally, your arms swing naturally to counterbalance your stride.
Right.
But if you have an IV, you are suddenly tethered to a heavy rolling metal pole.
Oh, I see.
Yeah, you have to use one hand to push it, which completely alters your natural center of gravity. Plus, you have plastic tubing hanging down, creating a crippling hazard, and you're likely trying to navigate this bulky pole around a small, cluttered hospital room.
Which is tough.
So your environmental demand just spiked while your physical capacity to balance is restricted.
That makes total sense when you break down the mechanics. It's not the fluid in the IV, it's the physical anchor you're dragging around with you. And this need for quick practical assessment led to other tools too, like the Hendrick II fall risk model in the early 2000s. And that one actually added this physical therapy-inspired get up and go test.
Right, where they actually ask patients to stand up from a chair and walk a few steps so the nurse could physically observe their mechanics rather than just checking boxes on a clipboard.
But having a good clinical tool doesn't automatically mean a hospital is going to mandate its use every single shift.
No, absolutely not.
The thing that actually turned these clinical checklists into mandatory universal hospital policy was a massive financial mandate. Specifically, the Deficit Reduction Act of 2005.
And if we connect this to the bigger picture, this completely shifted the landscape of hospital administration.
Yeah, because by October 2008, the Centers for Medicare and Medicaid Services, CMS, announced they were no longer going to reimburse hospitals for the extra costs of treating certain preventable hospital-acquired conditions.
Right.
And injuries resulting from inpatient falls were put right on that list.
Overnight, falls went from being viewed as, unfortunate clinical events to a direct, massive financial penalty for the hospital.
Here's where it gets really interesting, because it's basically like a local weather forecast suddenly becoming a legally binding requirement for you to install hurricane shutters on your house.
That's exactly it.
If you don't have documented proof that you checked the clouds and applied the shutters, you are financially on the hook for the entire cost of the storm damage.
Right. The financial lever forced universal compliance. The Joint Commission instituted national patient safety goals specifically around falls, requiring mandatory documented risk assessments. The clinical tools were ready, and the financial pressure just forced them into everyday practice.
Okay, so we have the mandated checklists, we understand the financial pressure, but let's dig into the actual physical science of a fall. If we strip away the scorecards, what are the first principles here? The sources lay out three basic mechanisms, and the first goes back to what you mentioned earlier. A fall is a mismatch between a person's capacity and their environment.
Exactly. A patient doesn't fall simply because they are labeled old or weak. They fall when their available balance, strength, and reaction time fail to meet the specific physical demands of a specific moment.
Like trying to stand up quickly from a low bed to reach a TV remote that fell on the floor.
Right. On legs that have lost muscle mass from 3 days of bed rest, while slightly dizzy from a new medication, the demand of reaching for that remote far exceeds their physical capacity in that exact second.
Wow.
This is why true fall prevention has to target both sides of the equation. You try to improve their capacity with physical therapy, but you also rigorously lower the environmental demand. You put the bed in its lowest position, you ensure the call light is physically in their hand, and you clear all the clutter from the path to the bathroom.
Which feeds into the second principle. Risk factors are multiplicative, not just additive.
We see this constantly with something called polypharmacy, which is simply the medical term for a patient taking multiple different medications concurrently.
Which is incredibly common, right? Especially for older adults.
Highly common. So let's say a patient takes a standard medication for high blood pressure. That alone can cause a slight head rush when they stand up, a modest risk. But tonight, because they are anxious in a noisy hospital, they are also given a benzodiazepine.
A strong sedative used for anxiety or sleep.
Yes. Now you are combining a medication that lowers blood pressure with a strong sedative that severely dulls reaction time and coordination. The risk doesn't just add together, it multiplies.
Oh, I see.
If that patient tries to stand up in the dark, their blood pressure drops, their brain is too foggy from the sedative to process the dizziness, and their leg muscles don't react fast enough to catch their balance, the risk skyrockets exponentially.
And speaking of standing up in the dark, we have to talk about principle number 3. the single highest risk activity in a hospital. The sources indicate that a third to a full half of all inpatient falls happen when a patient is trying to get to or from the toilet unassisted.
It's the most dangerous activity on the floor.
But I have to ask on behalf of a listener, why? If you are in a hospital surrounded by call buttons with nurses stationed right outside the door, why are people getting up alone in the dark anyway?
This touches on one of the most profound psychological elements of healthcare. It often comes down to deeply ingrained pride, dignity, and embarrassment.
Oh, sure.
Most adults have been using a bathroom privately, without assistance, since they were toddlers. The psychological barrier to hitting a button and asking a complete stranger to come help you with something as intimate as urination or a bowel movement is massive. People simply don't want to do it.
They don't want to feel like a burden, or they're just embarrassed.
Exactly. So they convince themselves they can manage it alone. The clinical evidence supports this heavily, but the most actionable proof of how to fix this came from a major 2006 study by the Mead and Studer Group, published in the American Journal of Nursing. They instituted a protocol called purposeful hourly rounding.
Meaning the nurses aren't just walking by, they are systematically checking in on a schedule.
Right. Nurses would do structured rounds every single hour during the day and every 2 hours at night. And they wouldn't just ask, do you need anything? They would specifically and proactively ask about pain, positioning, and toileting needs.
So they just say, I have time right now. Would you like help getting to the bathroom?
Exactly. And by doing that, they completely remove the psychological barrier. The patient doesn't have to swallow their pride and push the button to ask for help because the nurse is already offering it as a standard routine part of the day.
That's so smart.
Oh.
And did it work?
The results were dramatic. It drastically slashed both fall rates and the use of the call light. They fundamentally altered the behavioral risk environment.
Okay, so if we know toileting is the biggest behavioral risk, and we know people will try to get up when they shouldn't, I have to play devil's advocate here.
Go for it.
If you have a patient who is confused, heavily medicated, and keeps trying to walk to the bathroom on a broken hip, why not just use bed rails or physical restraints to keep them safely in the bed?
Because intuitively obvious solutions have historically backfired in spectacular and tragic ways. For a large part of the 20th century, physical restraints like vests, wrist ties, or putting all 4 metal bed rails up so the patient was essentially caged in, were the absolute default response if someone was deemed a fall risk.
Well, I mean, it makes logical sense on the surface. If they can't get out of bed, they can't fall.
But rigorous research in the 1990s proved this approach was a disaster. Restrained patients actually sustained far more severe injuries.
Wait, really? How?
A confused patient doesn't just lie there peacefully, they struggle. They get entangled in the vests, which led to suffocation risks. Or, if you put all the bed rails up, the patient views it as a puzzle to solve. They try to climb over the rails.
Oh, wow. So instead of falling 2 feet from a sitting position on the mattress, they are now falling 4 or 5 feet head first from the top of the metal rail.
Exactly. The restraint turned a minor fall into a catastrophic head injury or a shattered pelvis. Furthermore, being tied down causes immense psychological trauma and deconditioning. Today, physical restraints are an absolute last resort in medicine. The formal, legal, and ethical standard is the least restrictive alternative.
Okay, so physical restraints are out. But what about bed alarms? Those pressure-sensitive pads you put under the mattress that beeps loudly if a patient tries to stand up. The sources point to a major 2012 study in JAMA Internal Medicine looking specifically at these alarms. If it beeps, a nurse comes running. That has to stop at least some falls, right?
The medical community assumed the exact same thing. Hospitals spent millions universally adopting bed alarms, viewing the alarm itself as a protective intervention. But this large cluster randomized trial showed that adding bed alarms did not reduce hospital fall rates at all.
Wait, zero statistical difference?
Zero. And the reason comes down to the brutal realities of hospital staffing. An alarm only prevents a fall if a nurse can hear it, drop whatever they are doing, sprint down the hallway, and reach the bed fast enough to catch a falling adult.
Which is not likely.
Right. Given real-world staffing ratios where a nurse might be 3 rooms away managing an IV pump for another patient, that instant teleportation is physically impossible.
So the alarm isn't actually protective, it's just an alert. It tells you a fall is currently happening, but it doesn't do anything to stop it.
It just creates noise, which leads to alarm fatigue for the staff.
And this brings us to what the sources highlight as the biggest misconception in practice today: the immobility paradox. There's this lingering idea that the best way to prevent a fall is to just keep the patient safely in bed for their entire stay.
Yes, which is so harmful.
I look at it this way. Keeping a patient in bed to keep them safe is like putting your car on cinder blocks in the garage so it won't get into a crash. I mean, sure, it won't crash today, but the battery's going to die, the engine will seize, the rubber on the tires will rot. So a breakdown is absolutely guaranteed when you finally try to drive it down the street.
What's fascinating here is that analogy perfectly translates to human physiology. The medical term is deconditioning. If you keep an older adult in bed for 3 days for their safety, they rapidly lose significant muscle mass, cardiovascular endurance, and joint flexibility.
So they actually get worse.
Much worse. So when it's finally time to discharge them and they stand up to walk to the car, they are fundamentally weaker and far more likely to fall than they were the day they arrived. The modern mandate in nursing is safe mobility, not restricted mobility. You have to get them moving.
But that puts nurses in an incredibly difficult position. If alarms don't actually work, physical restraints are dangerous, and keeping them in bed makes them weaker. How do you actually use these risk scores? Because the sources discuss a massive ongoing debate right now between using universal precautions versus targeted interventions based on these scores.
Right, and the debate centers around the accuracy of the scoring tools themselves. Massive Cochrane reviews have shown that tools like the Morse Fall Scale rank general risk across a population moderately well, but they are actually quite poor at predicting whether an individual patient will fall on a given Tuesday.
Meaning a lot of people who score as low risk end up falling, and a lot of high-risk patients never do.
Precisely. So one camp of clinical experts argues, since the scoring is flawed, we should abandon complex risk tiers and just apply universal fall precautions to every single patient. Give everyone the low beds, the non-slip socks, and ensure the call light is in reach, regardless of their score.
And what's the argument against that?
The rival camp says, if we apply intense, heavy interventions to everyone, we waste incredibly scarce nursing resources and staff time on healthy 30-year-olds who don't need it.
So where has modern medicine landed? What's the middle ground?
Most modern hospitals use a hybrid model. Universal basic safety for everyone, and then escalating tiers of specific interventions based on their validated score. But the crucial takeaway in what they teach in nursing schools today is that a score is merely a starting point for clinical judgment, not a substitute for it.
It's just a guide.
Exactly. A high score just means you need to pay closer attention. And you have to look beyond age. An 88-year-old who is mobile and cognitively sharp can actually be a much lower fall risk than a 45-year-old recovering from spinal surgery who is just given a heavy dose of narcotics.
So if individual tools and alarms aren't silver bullets, how does a hospital actually keep people safe?
By treating fall prevention as an interconnected ecosystem, you have to look at the overlapping web of risk. For instance, we talked about confusion earlier. Many hospitals now bundle fall risk assessments with something called the CAM tool.
The CAM tool, what exactly is that measuring?
CAM stands for the Confusion Assessment Method. It is a rapid screening tool specifically looking for delirium. Delirium is an acute, sudden change in a patient's mental status. A patient might be perfectly lucid at breakfast, but by dinner, due to a mild infection or a medication interaction, they become highly confused and agitated.
Wow.
Yeah, they might forget they just had hip surgery and try to walk away.
So you have to measure their cognitive awareness right alongside their physical strength because a confused patient doesn't know their own physical limits.
Exactly. You layer the CAM tool with rigorous medication reviews from the pharmacy to catch that polypharmacy we talked about. This layered approach relies on James Reason's Swiss cheese model, which is foundational to patient safety.
The idea being that every safety protocol has flaws or holes, like a slice of Swiss cheese.
Yes. Under a just culture framework, a fall is almost never the fault of one single nurse. It is a system failure. The hospital sets up multiple slices of cheese staffing ratios, environmental design, medication screening, communication protocols.
Right.
But every layer has holes in it. A fall happens when the holes in those defensive layers happen to line up perfectly on a given shift.
And when the outcome is severe, like a fall resulting in a fatal brain bleed, that is what the accrediting bodies call a sentinel event, which triggers a mandatory, exhaustive root cause analysis by the hospital to figure out exactly how those holes lined up and how to shift the slices of cheese to prevent it from happening again.
It is a constant, rigorous evolution of system safety.
So let's bring this all back to you, the listener. How do these clinical frameworks translate beyond the hospital walls? What if you're just taking care of an aging relative at home?
Well, the beauty of studying this matrix is that the exact same first principles apply in your own living room. You start by looking for those compounding risk factors. You don't just write it off and say, well, mom's getting older. You say, mom was just prescribed a new blood pressure medication, and she has to navigate a dark hallway with loose rugs to get to the bathroom at night.
Capacity versus environment.
Exactly. So you fix the environment, you prioritize safe bathroom access, maybe installing motion sensor lights or getting a bedside commode for the nighttime. And you remember the immobility
No
paradox.
cinder blocks.
Encouraging safe, active mobility is vastly superior to wrapping someone in bubble wrap on the couch, which will only cause their muscles to decondition further.
And public health agencies agree completely. The CDC has a massive program called the STEADY Initiative, Stopping Elderly Accidents, Deaths, and Injuries, which is designed to take these exact same hospital principles, like medication reviews and environmental checks, and push them out into primary care clinics and living rooms.
Because falls remain a leading cause of fatal injuries for older adults. The hospital is really just a microcosm of the larger challenge we face as a society.
Let's quickly recap the journey we've taken today. We started with the realization that fall risk isn't a permanent label. It's a highly dynamic, fluctuating state that requires constant reassessment. We learned that the physical mechanics of IV poles and the psychological barriers of using the bathroom make simple tasks incredibly dangerous. We learned that the obvious solutions, like tying people down, relying on alarms, or keeping them in bed, actually cause far more trauma and weakness. And ultimately, we learned that real safety isn't a single checklist. It's an interconnected ecosystem of vigilance.
If I can leave you with a final thought to mull over, building on that push from the CDC to bring clinical safety into the home, we now know that hospital fall risk is so dynamic, it changes hour by hour based on medication, hydration, and just the simple need to use the toilet. As our aging population grows, and as healthcare pushes aggressively toward keeping people in their own homes rather than in facilities, how long will it be before our own smart homes and wearable technology start conducting their own digital version of hourly rounding on us?
Tracking us in real time.
Exactly. Wearables constantly analyzing your gait for slight stumbles, smart lighting tracking how often you get up for the bathroom at night, algorithms scoring your daily fall risk, and adjusting the environmental demand before you even consciously realize your physical capacity has dipped. The future of fall prevention might be an invisible matrix built right into the architecture of your house.
That is an incredible thought to end on. An invisible safety net right in your own bedroom. Thank you for joining us on this deep dive.
Yeah.
The next time you wake up at 2 in the morning and swing your legs out of bed into the dark, I guarantee you'll look at the environment around you with a completely new perspective. Catch you next time. So you definitely know the feeling. You're sitting in a clinical room, shivering a little in one of those drafty paper gowns.
Oh, yeah, those terrible gowns.
Right? And someone hands you a clipboard with a pen attached by a string. It's time for your procedure, and there's a form you have to sign.
And usually there's this expectation of it just being, an administrative hurdle.
Exactly. You sign the paper, the doctor does the thing, and you go home. It feels exactly like signing the terms and conditions on a new software update.
I mean, you don't read it. You just scroll to the bottom, click accept, and hope for the best.
You really do. We treat it like just one more piece of annoying paperwork standing between us and feeling better.
It feels incredibly routine.
But what if I told you that routine clipboard is actually a massive legal fault line? Like one forged by historic atrocities, Supreme Court battles, and the fundamental question of who actually owns your body.
It is a lot heavier than most people realize.
It really is. Today, we are taking a deep dive into a stack of sources covering medical law, nursing ethics, and the often misunderstood concept of informed consent.
Which is a huge topic.
Massive. And our mission today is to demystify what that ubiquitous hospital form actually means, dissect the shocking events that created our modern rules, and definitively clarify the exact legal role of a nurse in this entire process.
Right.
Okay, let's unpack this. Because making the leap from a quick signature in a drafty room to a heavy legal framework is huge. The sources we're looking at make one thing abundantly clear right away, which is that informed consent is not a piece of paper.
Far from it. The piece of paper is merely the artifact, the receipt, essentially, proving that a highly specific, legally mandated conversation took place.
The receipt.
Exactly. Informed consent itself is an ongoing process, and looking through the legal frameworks in our sources, that process has to contain 5 distinct elements before that pen ever touches the paper.
Okay, what are the 5?
So they are disclosure, comprehension, voluntariness, capacity, and an explicit decision.
I was actually looking at that list in the sources, and a couple of those elements seem a bit, I don't know, redundant on the surface, like capacity and comprehension. If I am awake, alert, and listening to a surgeon talk, don't I automatically have both?
Well, not necessarily, and that distinction is actually where lawsuits are born.
Really? How so?
So you might have the cognitive capacity to understand language and logic, but if the surgeon explains a complex neurosurgery using only dense medical jargon,
Like you have no idea what they're saying.
right, you lack comprehension, you didn't actually understand what was going to happen to you. Conversely, someone could explain a simple blood draw perfectly clearly, ensuring comprehension.
Okay.
But if the patient is severely intoxicated or suffering from acute delirium, they lack the legal capacity to weigh that information.
That makes sense. And then there's voluntariness, which implies you aren't being coerced.
Exactly.
But honestly, the trickiest part of this entire 5-step mechanism seems to be the very first one, disclosure. Because how much information is enough?
That is the million-dollar question.
Right. If a surgeon lists every single microscopic thing that could possibly go wrong, you'd be sitting there for 3 days and you'd be too terrified to get, like, a hangnail removed.
Oh, absolutely. Finding that line is the most contested part of medical law. For a long time, American courts relied on something called the reasonable physician standard.
Okay. What did that mean in practice?
This meant a doctor only had to disclose the information that a reasonable, similarly trained physician would customarily disclose in that exact same situation.
I have to say, looking at the legal history, that standard seems incredibly flawed.
Oh, it was heavily criticized.
I mean, it is essentially letting a guild of magicians legally decide how much of a trick they have to reveal to the audience. It meant doctors could completely justify keeping patients in the dark about major life-altering risks, just as long as their peers were also keeping their patients in the dark.
Right. The medical profession was entirely defining its own duty to inform. It was a closed loop, and it incentivized a culture of silence. But that closed loop was completely shattered in 1972 with a landmark case called Canterbury v. Spence.
Oh, this is the back surgery case, right?
Yes. Jerry Canterbury was a young man who had back surgery for a herniated disc. His surgeon did not tell him that the procedure carried roughly a 1% risk of paralysis.
Because under that old standard, other doctors wouldn't have bothered mentioning a mere 1% risk either.
Precisely. They would have considered it too small to worry the patient about. But during his recovery in the hospital, Canterbury fell from his bed and did, in fact, become paralyzed.
Oh, it's awful.
It is. And when this went to court, the ruling caused a massive paradigm shift in American medicine. The court determined that failing to disclose even a low-probability, high-severity risk that a patient would want to know about is, in itself, an injury.
That is a fascinating mechanism. So the doctor doesn't even have to perform the surgery badly.
Right.
The surgery could be technically flawless, but simply withholding the information is the actionable offense.
Because it robs the patient of their agency. This case replaced that old closed-loop rule with the reasonable patient standard.
Meaning what, exactly?
Meaning, doctors must disclose whatever a reasonable patient would need to know to make an informed decision, completely regardless of what other doctors typically say at the bedside.
That's a huge shift.
It really was. Now, a minority of U.S. states still use the old physician-centered standard, but Canterbury v. Spence shifted the fundamental center of gravity in medical law from professional custom to patient autonomy.
Which raises a really important question. If the patient's right to know, this sacred idea of bodily autonomy, is the new center of the legal universe, where did that idea actually come from?
Well, it certainly didn't appear overnight.
Because reading through the historical sources, it wasn't always this way.
No, not at all. We can trace the legal seed back to 1914 to a case called Schloendorff v. Society of New York Hospital.
Right.
A patient consented to an abdominal exam under anesthesia but explicitly refused surgery. While she was under, the surgeon removed a tumor anyway.
And that case gives us the quote that nursing and medical students still memorize to this day, from Justice Benjamin Cardoso. See, it's every human being of adult years and sound mind has a right to determine what shall be done with his own body.
Which is a beautiful foundational statement, though it is worth noting a fascinating legal quirk here.
Oh, yeah.
That famous quote was actually just dicta.
Meaning it was just a side comment in the judge's written opinion, right?
Yeah.
It wasn't the actual legally binding rule of the case.
Correct. The case itself was actually decided on the technicalities of hospital immunity. Cardozo was just sort of philosophizing on the nature of human rights.
Wow, so a side note became the absolute bedrock of bodily autonomy.
It did. Interestingly, the actual compound term informed consent wasn't even coined until decades later. In a 1957 California case called Salgo, where a patient woke up permanently paralyzed after a procedure because he hadn't been warned of the risk.
So the legal framework was slowly building in the courtrooms. But the ethical scaffolding, the deep moral reason we treat this as a human right today, didn't come from judges debating back surgeries.
No.
Our sources make it painfully clear that modern medical ethics were forged in the fire of some truly horrific atrocities.
If we connect this to the bigger picture, the evolution of these ethical mechanisms was entirely reactive.
Reactive to what?
Well, following World War II, the Nuremberg trials exposed the lethal, forced experiments conducted by Nazi physicians on concentration camp prisoners.
Right.
The resulting 1947 Nuremberg Code is widely considered the founding document of modern informed consent. It states right in its first line that voluntary consent of the human subject is absolutely essential.
But the sources also point out that the U.S. didn't just learn this lesson from looking overseas. We had our own domestic scandals that forced this doctrine into everyday practice.
We did, unfortunately.
The most infamous, of course, being the Tuskegee syphilis study.
Yes. A study spanning an unbelievable 40 years. From 1932 all the way to 1972, the U.S. Public Health Service enrolled nearly 400 black men in Alabama who had syphilis, but researchers deliberately never told them they had the disease.
They were just told they were being treated for bad blood.
Exactly.
And the most damning detail in the historical record is that the researchers intentionally withheld treatment for 25 years after penicillin became the standard, widely available cure.
It's horrifying.
They just wanted to observe the natural, fatal progression of the disease. They didn't stop until a whistleblower leaked the reality of the study to the press in 1972.
And Tuskegee wasn't an isolated mindset of the era. The sources detail the Cold War human radiation experiments where the government exposed thousands of people, including pregnant women and terminally ill patients, to radiation without proper disclosure, all for defense research.
That is just wow.
And then there were the Willowbrook hepatitis studies.
The Willowbrook case is chilling because of how it manipulated that element of voluntariness we talked about earlier. Researchers deliberately infected intellectually disabled children with hepatitis.
Yes.
To get the parents to consent, they sometimes made admission to this highly sought-after, overcrowded state facility conditional on participating in the study.
That is the ultimate example of coercion.
Yeah.
When a vulnerable population is denied basic care or access unless they submit to experimentation, consent cannot possibly be voluntary.
Definitely not.
These public outrages finally forced the government's hand. It led to the 1979 Belmont Report.
And the Belmont Report isn't just a list of rules. Looking at how it's structured, it's essentially a mathematical balancing act designed to prevent these specific abuses.
Very much so.
It codified 3 bioethical principles: respect for persons, which translates to autonomy; beneficence, which means acting in the patient's best interest; and justice.
The report acknowledged that these principles will often conflict. You know, you have to balance a patient's autonomy against the doctor's duty of beneficence. But autonomy emerged as the heavyweight champion of that trio. Your body is yours.
But if autonomy is this absolute ironclad rule, what happens when a piece of your body is removed and sitting in a jar across the room?
Oh, this is where it gets complicated.
Is it still yours? Can someone else profit off a piece of you?
This brings us to a very bizarre legal gray area regarding excised tissue. Let's look at the foundational case of Henrietta Lacks from 1951.
She was a black woman treated for cervical cancer at Johns Hopkins, right?
Yes. Her cells were taken without her knowledge or consent, which, horrifyingly, was a standard legal practice at the time.
Just standard procedure.
Yeah. Those cells became known as HeLa cells, and they were the first human cells to reproduce indefinitely in a lab.
Incredible.
They literally changed the trajectory of human history. They were the foundation for the polio vaccine, cancer treatments, and countless other breakthroughs.
But her family remained completely in the dark. living in poverty, while her cells were sold and studied worldwide for decades.
Exactly. Her specific case eventually forced massive changes to the laws governing research consent, specifically the 2018 revision of the Common Rule.
All right.
But the question of who actually owns the physical tissue gets even weirder when you look at the 1990 case of Moore v. Regents of the University of California.
Okay, let's get into this one.
So John Moore had his spleen removed as part of his leukemia treatment. Without telling him, his surgeon patented a cell line derived from Moore's unique tissue, the Mo cell line, which became massively commercially valuable.
Wait, I need to walk through the logic of this ruling. The doctor gets in trouble for not disclosing his financial interest? Right. But Moore still doesn't get a cut of the millions of dollars in profits from his own spleen. How does that work?
It seems entirely counterintuitive, I know. But the court drew a very fine legal line here. They ruled that the doctor did breach his fiduciary duty.
Meaning he violated that sacred legal trust where a doctor is obligated to act solely in the patient's best physical and financial interest rather than their own.
Exactly. Hiding his financial interest was a breach of that duty, and it was a breach of informed consent. That was actionable. Moore could sue the doctor for that deception.
Okay.
However, the court also ruled that patients have no property rights over their excised cells once they are removed from the body.
That's wild.
The court's reasoning was that granting property rights to patients over every removed appendix or blood sample would severely chill biological research and stifle medical innovation.
So the doctor is punished for the secret, but the patient still doesn't own the biological material once it hits the petri dish.
Exactly.
Because Moore proves that you lose ownership once the tissue leaves your body. That conversation at the bedside before the scalpel hits the skin is literally your last line of defense.
This absolutely is.
Which puts an unbelievable amount of pressure on the person holding the clipboard. And usually, that person is a nurse. Here's where it gets really interesting.
It does. This brings us to the single biggest misconception we need to debunk for anyone working in or interacting with the healthcare system.
Let's hear it.
The nurse who gets the patient's signature is not legally responsible for obtaining the informed consent.
Let me repeat that because it is the most vital takeaway in our nursing sources. The nurse holding the clipboard is not the one liable for the disclosure.
Not at all.
Wow.
The legal duty to disclose the risks, the benefits, and the alternatives belongs entirely and exclusively to the provider who is actually performing the procedure.
So the surgeon.
The physician, the surgeon, the advanced practice provider, meaning a nurse practitioner or PA who is doing the actual intervention, they hold the duty to inform.
So what is the frontline nurse's actual role in that high-stakes moment? Because they're the ones standing there with the paper.
The nurse's legal role is to witness the patient's signature, to confirm that the patient appears to be acting voluntarily, and, crucially, to act as a patient advocate.
Advocate.
Right. Let's walk through a real scenario. If a nurse hands you the form and you say, wait, what are the alternatives to this surgery? The doctor didn't mention any. The nurse's job is to stop the line.
They don't try to explain the surgical alternatives themselves to save time?
Never. Because doing so would mean the nurse is absorbing the physician's liability. They escalate the issue back to the provider. The nurse says, I cannot witness the signature until the surgeon comes back and answers your questions.
That distinction changes everything. It transforms the clipboard moment from, I, the nurse, am legally certifying that you understand complex anatomy, to, I am witnessing that you are signing this willingly and I will fiercely advocate for you if you look confused.
Exactly.
And the sources outline some really vital legal distinctions that frontline workers have to navigate regarding this, like the difference between battery and negligence in tort law.
Right, tort law being the area of law that deals with civil wrongs and damages. And the distinction here is massive.
How so?
If a provider performs a procedure with absolutely no consent at all, say amputating the wrong leg, or operating on a patient who explicitly refused, that is battery. It is unauthorized touching.
Okay, that makes sense.
But if they perform a procedure and the patient signed the consent form, but the doctor failed to adequately disclose a major risk, like the Canterbury paralysis case, that is negligence.
Negligence, got it.
Yeah.
There's also a major distinction made in the sources between capacity and competence. We touched on capacity earlier, but clinically, these two terms are worlds apart.
They are. The best way to understand this is to think of it like a driver's license.
Okay, I like analogies.
Competence is having your driver's license. It is a global legal status granted by the state, decided by a judge in a court of law. It says you are generally fit to make decisions.
Right.
Capacity, on the other hand, is whether you are sober enough to drive this specific car right now.
Oh, that's really clear.
It is a clinical, situational decision made by a healthcare provider at the bedside.
So you can be a legally competent person, but temporarily lack capacity for one afternoon because you just woke up from anesthesia.
Exactly. And this leads to an obvious question. What happens when you are entirely unconscious? Let's say you're rolled into the ER after a car accident. You can't sign a form, you can't show capacity. Do the doctors just stand around waiting for a lawyer while you bleed out?
I would certainly hope not.
They don't, thanks to the emergency doctrine.
Oh, okay.
It provides implied consent. If an unconscious patient faces imminent, serious harm or death, the law assumes that a reasonable person would consent to life-saving care. The doctors can act immediately without explicit consent.
So understanding this entire framework, battery versus negligence, capacity versus competence, the emergency doctrine, it isn't just about passing a nursing exam or avoiding a lawsuit. It's about navigating the most complex, real-time ethical dilemmas we face in society.
And those dilemmas are constantly evolving. The ultimate live debate in clinical ethics today is the tension between paternalism and autonomy.
Meaning, when, if ever, can doctors override a competent patient's informed refusal of care, claiming it is for their own good?
Exactly. And the sources highlight a very specific paradigmatic test case for this. Jehovah's Witness patients who refuse blood transfusions on religious grounds.
Right, that's a classic ethical dilemma.
It is the ultimate stress test of autonomy, and courts have consistently upheld a competent adult's right to refuse a transfusion, even if it is a 100% medical certainty that the refusal will result in their immediate death.
Wow.
The patient's right to dictate what happens to their own body wins over the doctor's duty to save a life.
And that absolute right to refuse was codified on a national level in the 1990 case Fuzan v. Director.
Yes, that was the Supreme Court's first major right-to-die case. It affirmed that competent patients have a constitutionally protected liberty interest in refusing unwanted medical treatment, including life-sustaining treatment like feeding tubes.
And that single case is the entire reason we have modern advance directives and living wills today.
It is.
It's fascinating how this tension between individual autonomy and public health beneficence plays out everywhere. We saw it heavily debated with modern vaccine mandates. And regardless of where anyone stands politically on those mandates, you can see the exact same ethical fault lines from our deep dive.
You really can.
Do we prioritize the individual's absolute right to refuse a medical intervention? Or do we prioritize the broader public health need to stop a communicable disease? It's the same fundamental legal struggle.
The ethical framework is tested by every new societal crisis.
And a key point the sources make is about revocability. Consent is never logged in. You can withdraw your consent mid-procedure, assuming it's clinically safe to stop.
Right.
And if a surgeon is inside you and finds something totally unexpected, some new material finding, they generally need to wake you up and get new consent to treat it. They can't just say, well, I was already in there, so I fixed it.
No, they cannot. This raises an important question as we look to the future. These laws were built over a century for surgeons, scalpels, and physical procedures. They are severely struggling to keep up with tomorrow's technology.
Like what?
Think about genetic testing companies asking you to consent to sharing your DNA data. Do you really comprehend what you are consenting to 20 years from now when that data can be used in ways we haven't even invented yet?
Or the looming debate over artificial intelligence. Hospitals are struggling right now to figure out if they need to explicitly disclose to patients that an AI diagnostic tool was used to read their scans.
Exactly.
Is that part of the reasonable patient standard? Does a patient need to know a computer made the call, not a human?
It is the bleeding edge of medical law. The foundational rules, autonomy, disclosure, comprehension are the exact same, but the application is entirely uncharted territory.
So what does this all mean for you, the listener? We've traveled from the incredibly dark history of forced experiments that birthed the very idea of bodily autonomy to the realization that informed consent is not a piece of paper, but a continuous, living conversation.
Yes.
We've seen the legal loopholes of tissue ownership, and we've clarified the vital, fiercely protective role of the nurse who acts as your advocate when that final signature is requested.
The main takeaway is that your bodily autonomy was incredibly hard-won by those who came before you, and it is entirely yours to exercise and protect.
But as we look to that uncharted future, I want to leave you with a final provocative thought to mull over. We mentioned AI just a second ago. Imagine a hospital starts using a highly advanced AI to diagnose your illness or recommend a surgery.
Okay.
That AI was trained on millions of past patients' data, finding patterns no human doctor could ever see. If even the software developers who built the AI admit that the algorithm is a black box, meaning they don't actually fully understand how it reaches its conclusions.
How can a doctor ever provide you with truly informed consent?
Exactly. Can you, or anyone, legally consent to a medical decision that no human mind fully comprehends? Next time you're sitting on that exam table in that drafty gown and someone hands you a clipboard, take a second to think about the massive invisible machinery behind that single piece of paper. This has been another deep dive into the forces shaping our world. Thank you for listening, and keep questioning the world around you.
Picture this. You're sitting in a dead silent room.
Oh, I know where this is going.
Right. Maybe it's a high-stakes board meeting, or, you are taking a massive, perfectly quiet exam. You could literally hear a pin drop.
The absolute worst time for it.
Exactly. And then suddenly, without any warning at all, your stomach just lets out this massive, audible, whale-like growl.
The ultimate biological betrayal.
It really is. Everyone hears it, and you just have to sit there sort of hoping they all pretend it was an air conditioning vent or something.
You just want the floor to swallow you whole.
It is a universally awkward human experience, but actually, today's deep dive is all about that exact noise. We are exploring the sources you shared with us on bowel sounds.
Yes, specifically looking at how nurses and doctors assess your gastrointestinal function by ear.
Right. We are exploring the good, the bad, and the ominously silent.
Which is such a fascinating area to look into, because listening to the abdomen has been this untouchable cornerstone of the physical exam for generations.
Right.
But as your sources highlight, the science behind what clinicians are actually hearing and how much they should even trust those sounds is going through a pretty dramatic paradigm shift right now.
Okay, let's unpack this. Because before we get into why modern medicine is suddenly questioning this practice, we really have to establish what this noise actually is.
And who first thought to systematically listen to it?
Yes. And the sources point out this fantastic ancient Greek word that I just can't stop thinking about. It's borborygmus.
Borborygmus, it's such a great word.
Or borborygmi if you have multiple rumbles going on. It actually dates back about 2,400 years to the Hippocratic corpus.
Wow.
And it's literal onomatopoeia, borborygmos. It just sounds like a rumbling, gurgling gut.
It really is a brilliant word. But to understand why the gut makes that borborygmi sound, we kind of have to look at the underlying machinery.
Okay, lay it on us.
Well, we have this tendency to think of the gastrointestinal tract as a passive pipe.
Like the plumbing under a sink.
Right, exactly, where food just falls down via gravity. But it's not. It is a continuous, highly active muscular tube.
I mean, it has to be to move everything along.
Yeah, it's lined with both circular and longitudinal layers of smooth muscle. And those muscle layers contract in these highly coordinated, rhythmic waves.
To push the contents.
Yes, the food, fluid, and gas, all the way from your stomach down to your colon. That coordinated wave action is called peristalsis.
And as that fluid and gas gets pushed through the tube, I mean, it doesn't just flow silently, right?
Not at all.
The sources describe how this material eventually hits areas where the diameter of the tube suddenly changes.
Like a bottleneck.
Exactly. A prime example is the ileocecal valve. That's where the small intestine empties into the large intestine.
Right.
When you force a mix of liquid and gas through a narrower space like that, you create mechanical turbulence.
And that turbulence is the key. The physical sloshing and bubbling of contents being forced through a dynamic tightening tube, that's the actual acoustic wave you were hearing.
So the bowel sound is just the auditory byproduct of peristalsis.
You hit the nail on the head.
But for most of human history, physicians just heard the really loud rumbles, right? The borborygmi.
Yeah, the ones you can hear across the room.
Right. They didn't have a way to systematically listen to the quieter, everyday baseline operations of the gut.
Not until the stethoscope.
Exactly. René Laennec invented the stethoscope in 1816. Originally for the chest, but physicians eventually started placing it on the abdomen.
Naturally.
But what really caught my eye in the sources was how this became a validated scientific practice. It all traces back to this guy, Walter Bradford Cannon, in the early 1900s.
Oh, yeah. Cannon is a legendary figure in physiology.
He was at Harvard, right?
He was. And he wanted to prove that the sounds clinicians were hearing through the stethoscope weren't just random abdominal noise.
Right, he wanted to prove they meant something.
Exactly, that they were directly tied to the mechanical contractions of the gut.
I read the notes on his methodology, and it's honestly brilliant. He took cats and fed them meals mixed with bismuth.
Bismuth, right.
which is a radiopaque contrast agent, meaning it blocks X-rays and shows up as this bright white shadow on an imaging screen.
So clever for the time.
Super clever. So he used early fluoroscopic X-ray imaging to watch the bismuth move through the cat's intestines while simultaneously listening to their abdomens with a stethoscope.
He was effectively linking the visual evidence of a peristaltic contraction with the auditory evidence of a bowel sound.
It's like the invention of synchronized sound in movies.
I think it's a great way to think about it.
Because before Cannon's 1905 work, doctors were just listening to the audio track of the gut and guessing what the machinery was doing.
Right, they were just guessing.
But Cannon finally matched the audio from the stethoscope to the actual video of the gut contracting. He proved you aren't just hearing noise, you are hearing motility.
And because he provided that physiological anchor, auscultation, the act of listening with a stethoscope, became this mandatory, standardized part of the abdominal exam for nurses and doctors throughout the 20th century.
Which is a huge deal.
It is. And it introduced a very specific sequence to how a clinician examines you.
Oh, the look, listen, feel rule.
Yes, exactly.
The sources mention this. If a doctor or nurse is examining an abdomen, they are taught to inspect it visually, then auscultate with the stethoscope, and only after that are they allowed to palpate.
To press their hands into your stomach.
Right, to feel for masses or pain, they have to listen before they poke.
And if you think about the reactivity of the gut, that sequence is vital.
Why is that?
Well, if a clinician were to press deeply into the abdominal tissue first, they're mechanically stimulating that smooth muscle.
Oh, I see.
Or, say the patient has an inflamed organ. Pressing on it causes sudden pain.
Which triggers a whole reaction.
Exactly. It triggers a sympathetic nervous system response that can cause the gut to completely freeze up.
So you'd artificially alter the very peristalsis you were trying to measure.
Right. You need the baseline acoustic recording before you introduce any physical interference.
Okay, so the clinician listens first to gauge the baseline motility. And the sources break down what they are listening for into 4 official clinical classifications.
The tidy categories.
Right. Normal, hypoactive, hyperactive, and absent. And on paper, it seems like a perfectly organized diagnostic system.
It does. The clinical framework assumes a very tidy correlation between sound and function. Let's look at how textbooks define normal bowel sounds.
Okay.
Historically, medical literature has characterized this as intermittent gurgles and clicks occurring roughly 5 to 34 times per minute.
Okay, I have to stop you there.
I thought you might.
Because the sources dedicate a huge amount of time to dismantling that specific metric. The 5 to 34 sounds a minute rule is essentially just medical folk knowledge.
It really is.
It wasn't derived from some massive, rigorous, peer-reviewed clinical trial where they established a statistical bell curve for gut sounds.
Not at all.
It is literally just a number that got copied and pasted from one medical textbook to the next, generation after generation.
Which is wild when you think about it.
And there isn't even a consensus on the decibel threshold for what officially constitutes a sound in the first place.
It's a fascinating vulnerability in medical education. The clinical mind craves measurable parameters.
Right, they want a solid number.
Exactly. So when a specific number range appears in print, especially in a foundational textbook, it gets absorbed as an absolute biological truth rather than an arbitrary historical guideline.
That makes total sense. But despite that shaky empirical foundation, these 4 categories are still used daily to paint a clinical picture.
They are. Take the classification of hyperactive sounds.
Okay, how does that work in practice?
The classic real-world application here is gastroenteritis.
So like your standard viral or bacterial stomach bug.
Right. When the mucosal lining of the gut is under attack by an irritant or a pathogen, the local inflammatory response often triggers fluid to shift into the lumen of the intestine.
Because the gut is trying to defend itself.
Exactly. The gut's primary defense mechanism is to flush that offending agent out as rapidly as possible. So the enteric nervous system kicks the smooth muscle into overdrive.
You get hyperperistalsis.
Yes. The resulting sounds are incredibly loud, frequent, and turbulent. These are your hyperactive bowel sounds.
Which directly correlates with the physical symptoms, right? The gut is contracting so fast that the colon doesn't have the normal amount of transit time to reabsorb water from the waste,
Precisely.
which is why hyperperistalsis almost universally presents with diarrhea.
The body is basically hitting the eject button.
And the stethoscope is just picking up the alarm bells, but then you have the complete opposite end of the spectrum, which is postoperative ileus.
Right, which falls under hypoactive or absent.
So what exactly is an ileus?
An ileus is a temporary paralysis of the gastrointestinal tract. It is incredibly common after abdominal surgery.
Because of the trauma of the surgery itself.
Exactly. When a surgeon handles, cuts, or manipulates the intestines, it triggers a massive local inflammatory cascade.
The body knows it's been invaded.
Right. Macrophages release cytokines, the sympathetic nervous system ramps up, and all of these factors combine to essentially tell the gut's motor function to go to sleep.
Just to facilitate healing.
Yes. The peristaltic waves just stop. So, if a clinician auscultates that patient's abdomen, they will hear very faint, infrequent hypoactive sounds or just total silence.
Okay, so that's gastroenteritis and ileus. But here's where it gets really interesting.
The mechanical bowel obstruction.
Yes. This is where the diagnostic reliability of the stethoscope gets really murky. Because an obstruction is not a static acoustic event, it's a dynamic progression.
It changes over time.
Exactly. Imagine a physical blockage in the small intestine, maybe a tumor or a twisting of the bowel or severe scar tissue from a previous surgery.
Right, something physically blocking the tube.
Early in the obstruction, the intestine proximal to the blockage, like the part upstream, realizes nothing is moving forward.
So it tries to overcome the physical barrier by contracting harder.
Right. The smooth muscle thickens and strains against the blockage, trying to force the accumulated fluid and gas past it.
And this immense physical pressure squeezing fluid through whatever tiny gaps remain creates extremely loud, hyperactive sounds.
The sources describe them as high-pitched tinkling or rushing sounds.
In clinical terms, yes.
But this is where I want to push back on the idea that the stethoscope is a reliable tool for this.
Go for it.
The sources emphasize that if the obstruction isn't resolved, those hyperactive rushes eventually disappear.
They do.
The bowel distends, the smooth muscle becomes exhausted, and the sounds fade into complete silence.
That's right.
So a clinician could listen at, say, 10:00 a.m. and confidently document hyperactive obstructive sounds. But a different clinician could listen to the exact same patient at 10:00 p.m. and document ominously absent sounds.
And the underlying physical emergency hasn't changed at all.
Exactly. The auditory data has completely flipped, even though the blockage is still there.
That dynamic progression is the fatal flaw of relying solely on auscultation. You are capturing a single acoustic snapshot, not the whole continuous movie of the patient's pathophysiology.
A snapshot, not a movie. That makes so much sense.
And your point about muscle exhaustion is mechanically vital. Visceral smooth muscle doesn't fatigue in the exact same rapid way that your skeletal muscles do if you are, say, lifting weights.
Right, it's a different kind of muscle.
But it does have a breaking point. When the bowel becomes massively distended upstream of a blockage, the stretching of the intestinal wall compresses the microscopic blood vessels supplying that muscle.
Cutting off the blood supply.
Exactly. That localized ischemia, the lack of oxygen combined with the prolonged mechanical strain, eventually causes the muscle fibers to fail and lose their tone.
Wow.
The contractions stop and the loud tinkling sounds transition into silence.
Which brings us to the great rebellion currently happening in nursing and medicine regarding this exact practice.
It's a huge debate right now.
Because these four categories, normal, hyperactive, hypoactive, absent, they sound incredibly authoritative. But at the actual hospital bedside, the reliability of human ears interpreting these sounds completely falls apart.
It really does.
The sources cite a fascinating 2014 study by Felder and colleagues published in the Journal of Surgical Education. They essentially put the stethoscope on trial.
The methodology of the Felder study is what makes it so devastating to the status quo.
They didn't just ask doctors for their opinions, right?
No, they took high-quality digital audio recordings of actual patients' bowel sounds.
Okay.
Then they had a group of trained, practicing physicians listen to those exact same audio clips and ask them to classify the sounds into the standard clinical categories.
And the inter-rater reliability, which is the statistical measure of how often these highly trained professionals actually agreed with each other on what they were hearing, was shockingly poor.
Abysmal, honestly.
In some of the data sets, their agreement on whether a sound was normal or abnormal was only marginally better than if they had just flipped a coin.
Basically random guessing.
It's like taking your car to 5 different mechanics who listen to your engine. One says it's perfectly fine, and another says it's about to explode. How can this be a trusted medical standard?
Well, calling it completely useless might be a bit harsh, as it still offers some contextual clues, but the study absolutely proves that subjective auditory interpretation is wildly inconsistent.
Because there's no objective measurement.
Exactly. There is no digital readout for a vowel sound. It relies entirely on the acoustic limitations of the human ear, human memory of what quote-unquote normal sounds like, and highly subjective interpretation.
And because of that inherent unreliability, a major theme in the sources is the dismantling of clinical myths that have built up around auscultation.
There are quite a few of those.
Let's talk about the 30-second rule. There's this deeply entrenched idea where people assume a doctor can place a stethoscope on your stomach, listen for 30 seconds, hear nothing, and just declare you have absent bowel sound.
Which is a physiological impossibility based on how the gut operates.
Why is that?
Peristalsis is not a constant ticking metronome. It is intermittent. A 30-second window of silence could simply be a normal refractory period between contractions.
So they just caught it on a break.
Right. The strictly defined textbook standard to legitimately and legally document absent bowel sounds in a medical chart requires a clinician to listen continuously for a full 5 minutes per abdominal quadrant.
Wait, a full 5 minutes per quadrant.
That's the rule.
But the abdomen is divided into 4 quadrants. That means a nurse or doctor would have to stand at the bedside in absolute silence, listening to a patient's stomach for 20 continuous minutes just to verify the absence of sound.
Precisely. And in the reality of a chaotic, understaffed modern hospital ward,
nobody has time for that.
Absolutely no one is doing a 20-minute abdominal auscultation.
So when absent bowel sounds gets written in a patient's electronic health record, it almost never represents a rigorously confirmed absence.
Usually, it just represents an unconfirmed temporary silence during a rushed exam.
That completely undermines the data in the medical chart. And speaking of the 4 quadrants, the sources dismantle that practice too.
The 4-quadrant myth.
Yeah, I've always seen clinicians move the stethoscope to 4 different corners of the stomach, but the physics of sound transmission actually render that unnecessary.
We have to remember the physical environment of the abdomen. It is essentially a densely packed continuous tube filled with fluid and trapped pockets of gas.
Right.
Acoustic physics dictates that sound waves transmit incredibly efficiently through fluid media, much better than they do through open air.
Okay.
So a rumbling contraction that originates deep in the lower right quadrant, say near the appendix, will easily propagate through the fluid-filled spaces and be perfectly audible in the upper left quadrant.
So listening in just one central location is enough.
Studies and modern clinical guidelines show that auscultating in a single central spot, usually just below the umbilicus or belly button, is completely sufficient to determine the presence or absence of bowel activity.
That's wild. So moving it around is just habit.
The ritual of moving the stethoscope to all 4 quadrants is driven far more by historical habit and the performative desire to appear thorough than by any actual physiological or acoustic necessity.
And then there's the final major myth the sources tackle, which is the concept of the surgical abdomen.
Ah, yeah.
For a long time, there was this dogmatic belief that if a patient genuinely had absent bowel sounds, it was an immediate red flag for a catastrophic, life-threatening emergency, like peritonitis.
To understand why that was taught, you have to understand the peritoneum.
Which is what, exactly?
It's the thin, continuous serous membrane that lines the inner wall of your entire abdominal cavity and folds inward to wrap around all your internal organs.
Like a protective sac.
Right. If an organ ruptures, like a burst appendix or a perforated ulcer, highly irritating digestive acids or bacteria spill into that cavity, severely inflaming the peritoneum.
Yeah, that's peritonitis.
Yes. And the body's reflective response to that severe peritoneal inflammation is to instantly paralyze the intestinal tract.
Just shut it all down.
It's an evolutionary defense mechanism to stop peristalsis so the gut doesn't churn and spread the dangerous infection further around the cavity.
So in that specific scenario, the absent bowel sounds are an indicator of a major emergency.
They are.
But the sources point out that assuming the reverse is a classic logical fallacy.
Exactly. All patients with severe peritonitis might have absent bowel sounds, but not all patients with absent bowel sounds have peritonitis.
It's just a highly non-specific finding.
Right. A completely silent abdomen might indicate a surgical emergency, but it might also just indicate a patient who is heavily sedated, receiving certain pain medications, or simply experiencing a normal lull in baseline motility.
So you absolutely cannot rule a life-threatening emergency in or out based on acoustics alone.
No. Clinicians have to look for tangible physical signs of peritoneal irritation, like an involuntarily rigid abdominal wall or severe rebound tenderness where the pain spikes when the clinician suddenly releases pressure.
So if the stethoscope is this subjective, this prone to physical artifact, and statistically unreliable, how is actual bedside medicine adapting?
Well, the sources highlight a major critique published in the British Journal of Nursing by Helen Bade in 2009 that really challenged the status quo.
And the primary battleground where this paradigm shift is playing out is in post-operative surgical care.
Yes, we discussed the postoperative ileus earlier. There has historically been a deeply entrenched nursing and surgical ritual surrounding this.
The feeding ritual.
That's the one.
A patient just had major abdominal surgery. They are awake, they're starving, they want to eat solid food.
Of course they do.
But the medical team is standing around waiting. The absolute rule was always, a patient is not allowed to consume solid food until a nurse formally auscultates and confirms the return of bowel sounds.
It was the gatekeeper to recovery. Wait for bowel sounds was treated as untouchable medical gospel.
But from a physiological and anatomical perspective, that logic is fundamentally flawed.
Because of the regional pacemakers of the gut.
Right, because different parts of the gastrointestinal tract wake up at different speeds after the trauma of surgery.
Exactly. The stomach and the upper small intestine generally recover their motor function and begin peristalsis within roughly 24 hours after surgery.
That's pretty fast.
It is, but the large intestine, the colon, which is way downstream, can remain paralyzed in a state of ileus for 3 to 5 days.
So a nurse could place a stethoscope over the stomach, hear plenty of loud, reassuring gurgles, and declare that the gut is fully awake.
They hear the noise and think, okay, good to go.
They give the patient a tray of food. The stomach processes it, pushes it into the small intestine, but then that food hits an absolute roadblock when it reaches the paralyzed colon.
Because the whole system isn't actually online yet.
Which leads to terrible outcomes for the patient.
The food backs up, the intestine distends, and the patient experiences severe nausea, vomiting, and delayed recovery.
And on the flip side, some clinicians would hear nothing and unnecessarily starve a patient for days.
Even when their gut was actually ready for clear liquids.
Right. Depriving them of the nutrition needed for wound healing.
Relying on the acoustic sign was causing patients to be fed either dangerously early or detrimentally late.
This realization has driven modern surgical departments to move away from the stethoscope.
Towards protocols called ERS.
Enhanced recovery after surgery.
Right. Rather than waiting for a subjective, isolated noise, ERS protocols demand undeniable functional proof that the plumbing is working collectively from top to bottom.
So what does this all mean? They look for clinical endpoints that cannot be misinterpreted.
And the ultimate functional proof that the entire continuous tube is open and operating is flatus.
Passing gas.
Passing gas.
If a patient passes gas or has an actual bowel movement, it doesn't matter what the stethoscope hears.
Not at all.
You have physical evidence that material is successfully navigating the entire length of the gastrointestinal tract and exiting the body.
ERS protocols aggressively de-emphasize auscultation. They focus on minimizing surgical trauma, getting patients out of bed, and walking as soon as possible to mechanically stimulate motility.
Yeah. Getting them moving.
Exactly. And doing early, cautious feeding trials based on whether the patient actually feels hungry and isn't nauseous, rather than waiting for an arbitrary rumble.
We are essentially watching a 2,400-year-old medical sign get actively downgraded in real time.
We really are.
It is moving from a strict diagnostic requirement to just an optional piece of background context.
It hasn't been completely thrown in the trash, obviously.
Right, because applying a stethoscope is incredibly cheap, it's non-invasive, and if you combine it with the patient's history and the rest of the physical exam, it still provides a tiny puzzle piece.
But modern evidence-based practice finally recognizes that bowel sounds are low yield and terribly low reliability when used in isolation.
It is the ultimate clinical snapshot, not the whole movie.
Beautifully said.
So to synthesize all of this for you listening, Vowel sounds, those ancient borborygmi, are the audible acoustic signature of peristalsis.
They are the sound of mechanical turbulence as your smooth muscle aggressively pushes fluid and gas through a continuous tightening tube.
But the historical clinical practice of classifying them into tidy categories of normal, hypoactive, or hyperactive is highly subjective.
And the rigid rules passed down in textbooks often disintegrate when tested at the actual hospital bedside.
Which means the very next time you find yourself sitting in that dead silent meeting room and your stomach lets out a massive room-shaking growl.
You shouldn't just feel awkward.
Exactly. You should actually appreciate the immense, complex mechanical turbulence of your continuous smooth muscle tube hard at work.
It's just your enteric nervous system doing exactly what Walter Bradford Cannon and his bismuth-fed cats proved it does over a century ago.
Such a great perspective.
And looking at the history of this practice raises an incredibly important question, something really worth thinking about long after this deep dive ends.
What's that?
Well, we just explored how the 5 to 34 sounds a minute rule, the necessity of listening to all 4 quadrants, and the strict ritual of waiting for sounds before feeding a patient were largely just medical folk knowledge.
Passed down as absolute truth.
Right. They were practices passed down blindly through textbooks for generations until modern researchers finally stopped to test their actual clinical validity.
Yeah.
It makes you wonder, what other established everyday rituals in modern clinical medicine are highly trained professionals blindly trusting right now, just waiting for the evidence to prove them wrong? So imagine you are standing in an emergency room and you're looking at a patient who presents this, complete medical paradox.
Right, a total contradiction.
Yeah, exactly. On the monitor, their blood pressure is just spiking to terrifying, potentially lethal levels. But mysteriously, their heart rate is aggressively slowing down.
Which is not what you expect to see.
Not at all. And when you look at the patient, they are literally split in half. From the chest up, they are flushed, sweating profusely, complaining of this pounding, blinding headache.
Yeah.
But from the chest down, they're pale, their skin is freezing cold, and they've got severe goosebumps.
It is a bizarre, terrifying presentation.
Yeah.
Because looking at them, you're essentially seeing a body at war with itself.
Yeah.
The vascular system is, it's effectively acting as 2 completely independent antagonistic networks just stitched together at the chest.
And that split body presentation is the absolute classic fingerprint of a condition called autonomic dysreflexia, or AD.
Right.
It's a massive, life-threatening spinal cord emergency. And looking at a stack of clinical case studies, historical journals from the 1940s, and some really wild recent sports medicine white papers, our mission for today's deep dive is to unpack this crisis.
It's definitely a crisis you need to catch early.
Definitely. So we're going to explore the fascinating mechanics of how it works, its surprising origin story, how it's secretly weaponized in elite sports, which is mind-blowing, and most importantly, how you can recognize and reverse it before it's too late.
Because the stakes are incredibly high here.
Right. If you miss this, we're talking about seizures, retinal hemorrhage, strokes, myocardial infarction, or just death.
Yeah.
And it can happen in a matter of minutes.
Yeah, it's one of those rare physiological events where the body's own defense mechanisms become a literal lethal threat.
Which is terrifying.
It is. To understand what's actually happening to that patient in the ER, we kind of have to look at the circuitry of the sympathetic nervous system.
Right, the wiring.
Exactly. Under normal conditions, this system's outflow to the vascular bed is organized segmentally along the spinal cord. Basically from the first thoracic vertebra down to the second lumbar vertebra, so T1 to L2.
Okay.
And autonomic dysreflexia typically manifests in patients who have a spinal cord injury at or above the T6 level.
Okay, let's unpack this because visualizing the circuitry really helps. I like to move away from the basic, biology textbook analogies. I look at this like a two-way radio or like a closed-loop feedback system that's failing to reach a critical subnet.
I like that analogy.
Right. So under normal circumstances, a noxious stimulus in the lower body, say a severely distended bladder, sends a danger signal up the ascending spinal tracts.
The body's alarm players.
Exactly. The brainstem registers that noxious stimulus, triggers a sympathetic vasoconstriction to manage the stress, but simultaneously sends inhibitory signals back down the descending pathways to, turn the alarm down and modulate the response.
It maintains homeostasis.
Yeah, but that two-way communication is the key.
And that descending inhibitory signal, the turn it down message, is the vital piece of the architecture, and that is exactly what a high-level spinal cord lesion
So
severs.
the feedback loop is just physically cut.
Completely cut. Imagine a patient with a complete lesion above T6. That noxious stimulus below the injury still travels up the spinal cord, but it hits the lesion and essentially short circuits.
Wow.
It triggers a massive, unchecked reflex arc at the spinal level. The intact sympathetic nerves below the injury fire off this massive catecholamine surge.
So it's just dumping adrenaline.
Pretty much, you get intense vasoconstriction across a huge vascular bed.
Right.
The peripheral resistance skyrockets, and that is what drives the blood pressure to those astronomical levels.
It's like hydraulic shock, like a water hammer effect in a massive plumbing grid.
Yeah,
All the valves below the chest suddenly slam shut,
that's exactly what's happening mechanically.
and the blood is squeezed out of the peripheral skin vessels, which perfectly explains the bottom half of the patient. They are pale, cold, and covered in goosebumps piloerection. Below the level of injury because the local sympathetic outflow is just going haywire.
But here's where it gets really interesting.
Okay.
The brain is sitting above the lesion, right? And it's registering this catastrophic hypertension via the baroreceptors in the carotid sinus and the aortic arch.
It knows the pressure's too high.
It knows it's going to blow a vessel, but its descending communication line is severed, the brain scrambling to deploy a workaround.
Because it can't send a signal down the spine.
Right. It realizes the descending spinal tracts are out of commission, so it leverages the only major parasympathetic pathway it has that bypasses the spinal cord entirely.
Which is?
The vagus nerve, or cranial nerve X. The brainstem uses the vagus nerve to heavily parasympathize the heart's sinoatrial node.
Oh, I see. Hence the severe bradycardia.
Exactly.
The brain is literally slamming on the heart's emergency brakes to stop it from pumping against that insane peripheral resistance.
Yes. And at the same time, the brain manages to send inhibitory signals to the sympathetic pathways that are above the level of the lesion.
So it's trying to open whatever relief valves it can reach.
Exactly. It dilates the blood vessels in the head, neck, and upper chest as wide as possible, desperately trying to create a low-resistance reservoir to bleed off all that pressure.
And there is our physiological split. The vasodilation above the injury causes the pounding headache from the engorged cerebral vessels, the intense facial flushing, and the sweating.
It's an incredible mechanical failure.
It really is. Flushed above, pale below, pulse plummeting. But, I mean, if you're looking at this patient's chart in a busy ER, it's pretty easy to get tangled up between AD and all the other various shocks associated with spinal injuries, right?
It is a very common diagnostic trap. Autonomic dysreflexia sits in a cluster of concepts that are, functionally distinct.
Right.
For instance, AD is fundamentally different from spinal shock.
Which is what happens right after the injury, right?
Yeah. Exactly. Spinal shock is the acute temporary state of flaccidity and a total loss of reflexes immediately following the initial trauma. AD actually cannot occur during spinal shock because the reflex arcs are completely suppressed.
Yeah.
AD is a hyperreflexic state that only emerges weeks or even months later once those spinal circuits reorganize and basically awaken.
So it's essentially a rebound into hyperexcitability.
Yeah.
And that also separates it from neurogenic shock.
Right.
Because neurogenic shock is a distributive shock issue, isn't it?
Correct. Neurogenic shock is characterized by a profound loss of sympathetic vascular tone, resulting in severe low blood pressure hypotension and bradycardia right after the injury.
So it's almost the exact opposite.
It is, in many ways, the physiological inverse of an AD crisis. You also have orthostatic hypotension, which is gravity-induced pooling due to compromised venous return, and poikilothermia, the inability to regulate temperature.
Wow, okay. So AD is really the acute hypertensive outlier in that whole group.
Exactly. It's the one spiking the pressure.
So what does this all mean historically? Because, I mean, humans have been suffering catastrophic spinal injuries since the dawn of time, combat, falls, industrial accidents.
Sure.
Yet looking through the historical journals for this deep dive, this dramatic split body crisis wasn't systematically defined until 1947. Why did it take until the mid-20th century for modern medicine to document this?
Well, if we connect this to the bigger picture, it actually reveals a pretty grim reality about early 20th century medicine.
Oh.
The reason autonomic dysreflexia wasn't documented before 1947 is that patients simply didn't survive long enough to transition out of spinal shock.
Wait, really?
Yeah. Prior to World War II, a severe spinal cord injury was essentially viewed as a palliative sentence.
A death sentence.
Pretty much. The prevailing medical dogma at the time was just sedation and immobilization, Bladders were either drained passively or just left to overflow.
God, so they were dying of secondary complications.
Yeah.
Sepsis, renal failure, infected bed sores.
The mortality rates were staggering. Most succumbed within weeks. So the physiological evolution of the injury never had time to progress to that hyperreflexic stage we were just talking about.
Right, they never lived long enough for the reflexes to come back.
Exactly. That paradigm only shifted when a neurologist named Ludwig Guttmann arrived on the scene.
The guy at Stoke Mandeville.
Yes. Guttmann was a Jewish neurosurgeon who fled Nazi Germany, and in 1944 he took over a newly created spinal injury center at Stoke Mandeville Hospital in England, treating paralyzed Allied servicemen.
And from what I read, he practically went to war with the medical establishment at the time.
Oh, he absolutely did. Guttmann refused to accept the systemic neglect. He introduced rigorous active management.
Like what?
He mandated turning patients every 2 hours to prevent tissue necrosis bed sores. He instituted strict schedule-based sterile catheterization to protect their kidneys. He essentially invented comprehensive spinal rehabilitation.
Wow.
And because of those interventions, alongside, the timely introduction of penicillin, these patients actually survived.
Which is the profound irony here. Autonomic dysreflexia wasn't some new disease mutation. It was a latent physiological consequence unmasked by survival.
Exactly. Discovered because patients survived.
Guttmann and the physiologist Derek Witteridge published their landmark findings in the journal Brain in 1947 because, for the first time, a critical mass of patients lived long enough for doctors to notice the pattern.
They saw the direct correlation between bladder distension and catastrophic hypertension.
And that correlation remains the cornerstone of clinical management today, doesn't it?
It does. Across all the modern literature, bladder distension is the undisputed primary trigger for an AD episode.
Something as simple as a full bladder.
A kinked indwelling catheter, an overfull collection bag, or simply a misvoiding schedule that accounts for the vast majority of these crises.
And what's the second most common?
The secondary culprit is typically gastrointestinal, specifically bowel impaction or severe constipation.
Okay, but I have to play the skeptic for a second here.
Go for it.
Because I'm sure you're wondering this too. If the patient is paralyzed, right, and they have zero sensation below the chest, how can a full bladder cause this massive pain response?
It's a huge misconception, but it raises an important question regarding nociception versus conscious pain perception.
Nociception meaning just the nerve detecting a stimulus.
Exactly. The sensory nerves in the bladder wall or the bowel still detect the extreme stretch or irritation. Those afferent signals still travel to the dorsal horn of the spinal cord.
But they don't reach the brain.
Right. Instead of continuing up to the somatosensory cortex for you to consciously register, ouch, pain, the signal gets trapped at the lesion, and it synapses directly with the sympathetic efferents.
So it's entirely a spinal level circuit.
Completely. A completely insensate bladder one you can't feel at all will trigger a lethal episode that the patient never actually felt coming.
The nociception is real, even if the perception is absent. The body is screaming, but the brain's intercom is off.
That is a perfect way to put it.
Which actually leads to one of the most staggering things in the sports medicine white papers we reviewed. Because if you understand that this is a predictable mechanical spinal loop,
Uh-oh. I don't know who you're going with this.
someone who understands that loop could intentionally trigger it. And in the world of elite Paralympic sports, this physiological crisis was actively weaponized.
Yes, you're referring to the practice of boosting.
Yes, elite wheelchair racers with high-level SCIs figured out that if they deliberately induced a controlled episode of AD right before a race, it acted like a biological supercharger.
It is incredibly dangerous.
They were intentionally hacking their own autonomic nervous systems.
But from a strictly biomechanical standpoint, the logic is sound.
Explain that, because it sounds crazy.
Well, by purposefully triggering the reflex arc, for instance, by clamping their catheter to overfill the bladder, painfully over-tightening leg straps, or even, in some cases, sitting on a sharp object.
Oof, sitting on something sharp.
Yes, just to generate that noxious stimulus. These athletes force their bodies to dump a massive surge of epinephrine and norepinephrine into the bloodstream.
Which artificially spikes their stroke volume.
Right, and increases cardiac output. Furthermore, that intense peripheral vasoconstriction in the paralyzed lower extremities essentially squeezes pooled blood back into central circulation.
Oh, wow. So it forces all that blood up into the working muscles.
Exactly. It massively increases venous return, which drives extra oxygen delivery to their working upper body musculature. It is functionally a form of blood doping, achieved through targeted self-harm.
It's staggering to think about the risk calculus there. I mean, you are pushing your vascular system to the brink of a hemorrhagic stroke just for a VO2 max advantage.
And obviously, sports regulators didn't just let athletes race with a systolic pressure of 250.
Right, they cracked down on it.
The International Paralympic Committee formally banned the practice of boosting in 1994.
But how do you even police that?
The policing mechanism is directly tied to the underlying physiology. Before high-exertion wheelchair events, athletes undergo strict, unannounced blood pressure screenings.
Oh, smart.
If an athlete presents with a resting systolic reading over 180 millimeters of mercury, they face immediate medical evaluation or outright disqualification.
Because they know you couldn't get that high normally.
Exactly. The officials are screening specifically for that artificially induced sympathetic surge.
Which proves how predictable the syndrome is in a controlled environment.
Definitely.
But that brings up a massive clinical blind spot. If it's this predictable, why is a patient who rolls into a general ER with a blocked catheter in so much danger of being misdiagnosed? I mean, why is AD chronically underrecognized outside of specialized SCI clinics?
It comes down to a fundamental bias in how triage vital signs are interpreted.
Okay, what do you mean?
Well, imagine our patient from the beginning of the episode arrives at a community ER. They have the pounding headache, the sweating above the injury level. The triage nurse takes their blood pressure, and the monitor reads 120 over 80.
Which, to anyone trained in general medicine, is the textbook definition of normotension, like totally healthy.
Right. To a general ER physician, 120 over 80 looks perfectly benign. They might diagnose the patient with a severe migraine or maybe anxiety or just essential hypertension.
And they just give them a Tylenol or something.
Exactly. Offer a basic analgesic and send them to the waiting room. But the critical rule for autonomic dysreflexia is normal for you is not normal for them.
Because their baseline is different.
Because individuals with high-level spinal cord injuries lack descending supraspinal sympathetic tone, their peripheral vascular beds are chronically relaxed. So their normal baseline resting systolic blood pressure is usually low, often hovering between 90 and 110.
Oh, wow. So a reading of 120 over 80 isn't perfect. If their baseline is 90, that's a 30-point spike.
Exactly. A sudden elevation of 20 to 40 millimeters of mercury above their specific baseline constitutes a hypertensive emergency.
That's terrifying.
That 120 over 80 is a massive red flag. And while the medical staff is falsely reassured by a normal number on the monitor, the underlying trigger, the blocked catheter or the impacted bowel, is going entirely unaddressed.
And the hydraulic shock is just compounding.
Getting worse by the minute.
Normal is a myth when the anatomy has been fundamentally altered. And speaking of altered anatomy, I want to challenge the T6 threshold we established earlier.
Okay, the T6 debate.
Yeah, the literature constantly hammers on T6. Is T6 a rigid anatomical iron curtain, or is there a more complex physiological reason why that specific coordinate matters so much?
That is actually the subject of ongoing clinical debate among specialists.
Oh, really?
Yeah, T6 is taught as a hard diagnostic cutoff, mostly for simplicity, but it's more accurately a clinical heuristic. It represents where the splanchnic sympathetic outflow disconnects from the brainstem.
The splanchnic vascular bed. This is where it gets into the heavy plumbing of the body.
It is. The splanchnic bed is a massive network of capacitance vessels in the abdomen. It's controlled by sympathetic nerves that arise roughly from T5 to T9, and they converge on the celiac and superior mesenteric ganglia.
Okay.
This single vascular bed can hold up to a third of the body's total blood volume.
A third. Wow.
So if a spinal lesion is at or above T6, that entire enormous reservoir is disconnected from brainstem modulation. When an AD trigger occurs, that entire vascular bed constricts simultaneously.
Oh, man.
It displaces a massive volume of blood into central circulation, which is what drives the catastrophic spike in preload and afterload.
So it's not just local constriction in the legs. You are literally wringing out the body's largest internal blood sponge all at once.
That's a very visceral way to put it, but yes.
But human neuroanatomy isn't perfectly symmetrical, is it?
It isn't. The sympathetic chain spans multiple segments and collateral innervation exists. So while T6 is the classic benchmark, the clinical data absolutely shows a gray zone between T6 and T10.
Oh, so it can happen lower down.
Case reports document patients with lower lesions T8, even T10 experiencing clinically significant, albeit sometimes less severe, dysreflexic episodes.
Because a portion of that splanchnic outflow is still caught in the disconnected reflex arc.
Precisely. Which is why some specialists argue for diagnosing based on symptoms rather than a rigid spinal coordinate.
Which makes sense.
Yeah.
You treat the presentation, not the textbook coordinate. If they have the headache and the bradycardia, you just assume the crisis.
Absolutely.
So let's put this into practice. Let's say we are in the ER or a nursing facility, and we recognize it's autonomic dysreflexia. Given that this is fundamentally a mechanical plumbing issue caused by a trapped noxious stimulus, I'm guessing the first move isn't reaching for a systemic antihypertensive pill.
No, the clinical mantra here is sit them up before you dose them up.
Sit them up, okay.
Pharmacological intervention is a backup, not the first move. Your immediate, absolute first-line action is positional orthostatic offloading.
Because they lack descending vascular tone, gravity is actually your best friend.
Exactly. You sit the patient bolt upright and lower their legs if possible. By utilizing gravity, you induce venous pooling in the lower extremities, which rapidly decreases venous return and takes the acute pressure off the cerebral vasculature.
So it's an immediate mechanical way to lower the blood pressure.
Immediate, non-pharmacological afterload reduction.
Smart.
Once they are upright, you aggressively remove any restrictive clothing, tight belts, or abdominal binders that might be acting as a noxious stimulus.
And then you go hunting for the primary trigger. Following the data, T6 and above, check the plumbing first.
T6 and above, bladder first. You immediately inspect the urinary catheter for kinks or blockages. You check the collection bag.
And if they don't have a catheter?
If the patient does not have an indwelling catheter, you must perform in and out catheterization immediately to decompress the bladder. However,
There's a catch.
There's a critical caveat. You must use generous amounts of topical anesthetic like lidocaine jelly.
Because the sheer mechanical friction of inserting the catheter adds a new noxious stimulus to the dorsal horn.
Precisely. Which could exacerbate this reflex arc. You don't want to worsen the AD episode while trying to treat it.
And what if the bladder is fine?
If the bladder is decompressed and the blood pressure remains volatile, you move to the gastrointestinal system to check for fecal impaction. And again, utilizing copious topical anesthetic before performing a rectal exam is absolutely mandatory for the same reason.
So it is mechanical problem solving first. Find the kink in the hose, remove the nociceptive input, and the spinal reflex loop should theoretically break.
Right. You only turn to fast-acting pharmacological agents if the trigger cannot be quickly identified or resolved and the blood pressure remains critically elevated.
What kind of meds do they use for that?
Depending on institutional protocols, fast-acting agents like nifedipine, which is a calcium channel blocker that relaxes vascular smooth muscle, or topical nitrate paste, which provides systemic venal dilation, are commonly used.
Just to artificially force the vessels open until the underlying irritant is cleared.
Exactly. It buys you time.
It's remarkable how mechanistic the human body is when you strip away the conscious perception. And I think what really sticks with me as we wrap this up is the everyday vigilance this requires.
It requires a lot.
Because, we've framed this deep dive in an emergency room, but for someone living with a high-level thoracic injury, a life-threatening split body crisis doesn't require massive trauma.
Not at all. The threshold for nociception can be remarkably low.
It can be triggered by things that wouldn't even register for most people. A leg bag strap pulled slightly too tight, severe menstrual cramps, an ingrown toenail.
Or even a bad sunburn on their legs.
A sunburn. A totally mundane irritant hits that severed feedback loop, and suddenly they are fighting for their life. It means patients and their care teams have to act as physiological detectives constantly.
It demands an exhaustive level of situational awareness, day in and day out. Autonomic dysreflexia serves as this profound reminder of the intricate architecture of our nervous system. We are wired with these aggressive, deeply embedded evolutionary fail-safes designed to maintain homeostasis, like the sympathetic alarm bells. But it begs a fascinating question.
Yeah, I wanted to ask, what does this all mean for the bigger picture of medical intervention?
Well, think about it. When medical advancements like Gutmann's revolutionary rehabilitative protocols or modern trauma surgery alter our fundamental anatomy, allowing us to survive previously fatal neurological injuries, how many other hidden physiological loops are waiting in the dark?
Oh, wow.
We successfully solved the acute survival problem of spinal cord injuries, but in doing so, we unmasked a latent biological circuit that we never knew existed.
Because no one had ever lived long enough for us to see it.
Exactly. It makes you wonder what other well-intentioned physiological failsafes might become our greatest vulnerabilities as medicine continues to push the boundaries of human survival.
The alarms we haven't even heard yet. That is a thought that will definitely linger long after this deep dive.
It's a lot to mull over.
It really is. Well, just remember the clinical triad. Flushed above, pale below, pulse plummeting. Catch the baseline, utilize gravity, and hunt for the trigger. Imagine a house with pristine paint and perfectly smooth drywall. Visually, everything looks completely structurally sound.
Right, but behind those walls, termites have entirely hollowed out the wooden support beams.
Exactly. The outside looks totally fine, but the destruction is already complete. One heavy touch, and the whole wall just collapses.
And right now, in intensive care units and, nursing homes around the world, this exact phenomenon is happening inside the human body.
Welcome to today's deep dive. I'm your host, and whether you're a nursing student studying for boards or just someone who's intensely curious about the hidden mechanics of human health, today's deep dive is custom built for you.
And I am your resident expert, here to help break down the science. We are looking at a medical condition today that is incredibly common, fundamentally misunderstood, and frankly, potentially deadly if it goes unchecked.
We are unpacking the science of pressure injuries today. We're going to look at the physical forces that literally crush cells to death, the intense controversies around how to stop it, and why the established medical vocabulary you might be familiar with has completely shifted.
It's a huge topic, yeah. There's a lot of history and physiology to get through.
Okay, let's unpack this, because right out of the gate, we have to talk about the name. If you're outside the medical field, you probably know this condition as a bed sore or maybe a pressure ulcer.
Right, which are terms that everyone uses, but they are actually entirely outdated now.
And the reason for that is wild. So the word bed sore is gone, and even pressure ulcer has been quietly retired.
Yeah, the shift in vocabulary is actually the key to understanding how the damage happens in the first place. In April 2016, the U.S. National Pressure Ulcer Advisory Panel held this big consensus conference, and they officially dropped the word ulcer in favor of injury. They also modernized the staging system, so they swapped out the old Roman numerals for Arabic numerals, like just 1, 2, 3, 4.
I can hear people rolling their eyes thinking, this is just some minor housekeeping thing for a medical dictionary. Just semantics.
Oh, it's so much more than semantics. What's fascinating here is that by definition, an ulcer implies an open wound.
Right. It means there is a physical break in the skin.
Exactly. So calling it an ulcer when the skin isn't even broken is a massive contradiction. And that contradiction basically forced nurses into a corner for decades.
Because they were seeing damage where the skin was perfectly intact, right?
Yes. The medical community realized that some of the earliest stages of this condition, and frankly, some of its absolute most dangerous forms, happen when the skin is completely intact.
Wow.
So the term injury covers the entire spectrum. It includes that intact, discolored skin all the way down to a deep crater that exposes bone. And it does that without falsely implying that every single stage has to be an open sore.
And they were so serious about this, right, that in 2019, the organization actually renamed itself to the National Pressure Injury Advisory Panel, or NPIAP, just to reflect this new reality.
They did, yeah. It was a huge paradigm shift.
Which brings us right back to that termite analogy from the beginning. In the source material, there is a specific classification called a deep tissue pressure injury, or a DTPI.
Ah, yes, the DTPI.
People think a dark red or purple patch of intact skin is just a bruise.
And that assumption is incredibly dangerous. A deep tissue pressure injury represents damage that has already been done deep down in the muscle and the fat layers, right next to the bone.
So it's not starting at the surface at all?
Not at all. The damage happens from the inside out. Bone is hard, and the mattress is hard. The tissue trapped in between takes the absolute brunt of the force.
Oh, I see.
So by the time you actually see that purple or maroon discoloration on the surface of the skin, the underlying tissue has already suffocated and died.
So the collapse is pretty much inevitable at that point. You're basically just waiting for the surface to give way.
Unfortunately, yeah. Because the structural damage is already done, a DTPI can just burst open into a massive, full-thickness wound within a matter of days.
And when we say full thickness, we mean a wound that is burned through the outer epidermis, through the dermis, and down into the subcutaneous fat or even muscle.
Right. And it can happen rapidly, even if the patient is receiving meticulous, perfect care from the exact moment that purple spot is discovered.
That hidden damage completely reframes who we think is at risk, doesn't it?
Mhm.
Because we always picture someone bedbound, just lying in a hospital bed all day.
Oh, definitely. But the 2016 conference also added a category specifically for medical device-related pressure injury.
Right, which totally shatters the myth that this is solely a bedsore problem.
Exactly. I mean, seated patients get them over their sitting bones. Surgical patients get them just from lying on a rigid operating table during a really long procedure.
And crucially, everyday medical devices cause them too.
Hmm.
Think about the rigid plastic of oxygen tubing wrapped really tightly behind the ears.
Or a stiff cervical collar around the neck, or even just a plaster cast.
Right. If that plastic presses against the skin for even a couple of hours, it is compressing the blood vessels in the exact same way a mattress compresses a tailbone.
It's the exact same mechanism, yes.
So let's get into the actual physics of that. We really need to look at the mechanical forces that are actively destroying these cells.
Well, if we strip away all the clinical vocabulary, we're basically left with straightforward physiology. Your capillaries, those microscopic blood vessels that feed oxygen to your tissues, they require a certain minimum internal pressure to stay open.
Okay, that makes sense.
So when you push down on the skin over a bony prominence, you are applying external pressure. If that external pressure from, say, the bed frame or the oxygen tubing is stronger than the internal pressure of the blood vessel, the blood flow simply stops.
It's like stepping on a garden hose. The water just can't get through.
That's a perfect way to look at it. And when blood flow stops, oxygen stops. That creates a state of hypoxia.
And without oxygen, the cells in that area just begin to die off, right?
Yeah. Exactly, which we call necrosis. Now, a healthy person who is shifting in their sleep, they don't get these injuries because their nervous system sends a discomfort signal.
You just roll over without even waking up.
Right. The pressure is relieved and the blood rushes right back. But a patient with reduced sensation or mobility, maybe from a spinal cord injury or heavy sedation in an ICU, they never get that signal to move.
So we're essentially looking at three distinct physical forces at play here based on the research. There's pressure, shear, and friction.
Yes, the big three.
So pressure is that perpendicular force crushing the tissue against the bone, like we just described with the garden hose. Friction is surface abrasion, like skin dragging across a rough hospital sheet.
And friction doesn't usually cause the deep internal injury on its own, but it strips away the protective outer layer of the skin, which makes it super vulnerable.
But I want to zero in on shear,
Yeah.
because the source text had a really fascinating example.
Shear is arguably the most insidious of the three forces, for sure, because it happens entirely beneath the surface.
The mechanics of it are wild. It's an angular force. So imagine a patient lying in a hospital bed, and the head of the bed is raised up so they can watch TV or eat their lunch.
Okay, a very common scenario.
Gravity naturally makes the patient's heavy skeleton want to slide down toward the foot of the bed. But friction is keeping their skin firmly anchored to the bed sheet.
Right?
So the skin stays put, but the bones and the deep tissues slide downward inside the body. It essentially stretches and kinks all the perforator blood vessels trapped between the bone and the skin. Is that why nurses are taught the strict rule to keep the head of the bed at 30 degrees or lower?
That is exactly why. You're creating an internal scissor effect that just tears those vessels from an angle.
Oh, wow.
Keeping the head of the bed low minimizes that downward gravitational pull. It physically limits the skeleton's ability to slide inside the skin, which protects those fragile blood vessels from being sheared and basically choked off.
Okay, so we understand the physics of the crush and the tear, but how much pressure does it actually take to cause this? Because this is where human intuition and honestly medical history kind of totally fails us.
Oh, the historical benchmarks are wild.
Right. For generations, nursing textbooks taught a very specific threshold,
Yeah.
32 millimeters of mercury. That was supposedly the exact pressure that closed the capillary.
The famous 1930 physiology study by Eugene Landis, it became an absolute pillar of nursing education.
But here's where it gets really interesting. I mean, Landis measured this in the healthy fingernails of young people.
Yes, he did.
How on earth did a localized measurement from a healthy 20-year-old's fingernail in 1930 become the unquestioned gold standard for treating the sacrum of a frail 84-year-old ICU patient?
It is one of those fascinating quirks of medical history, where a single flawed data point just becomes gospel through sheer repetition.
It's great.
Modern science has completely reevaluated that. We now treat that 32 millimeters of mercury as a very rough historical benchmark, not a hard universal threshold.
So what's the actual metric then?
Well, actual tissue tolerance varies wildly depending on the anatomical location, the patient's overall blood flow, their disease state, and crucially, the element of time.
Right, time is the other half of the equation.
In 1959, a physician named Dr. Marian Kosiak conducted experiments proving that tissue damage is about the dynamic interaction of magnitude and time.
So it's like a curve.
Exactly, it's a pressure time curve. A very high pressure applied for just a brief moment might be completely harmless. But a comparatively low pressure, well below that 32 millimeters of mercury, if it's sustained for hours, it can completely destroy the tissue.
So if time is just as much of an enemy as the raw pressure itself, then the obsession with turning patients makes total sense. You hear it constantly in healthcare. Turn the patient every 2 hours.
The QH rule, yes.
It has been treated like scripture. But I'm looking at this major NIH-funded study from 2013, the TURN study, led by Nancy Bergstrom. And turning them every 2 hours didn't actually solve the problem, did it?
It genuinely shocked a lot of people in the field. They took patients in nursing homes, placed them on high-density foam mattresses, and compared repositioning them every 2 hours, every 3 hours, or every 4 hours.
And the results?
There was absolutely no meaningful difference in the incidence of pressure injuries between the three groups.
Wait, really? So the 2-hour rule was just arbitrary?
It proved that the rigid, universal rule wasn't as absolute as everyone assumed, provided you have the right technology underneath the patient.
The support surfaces?
Right. High-density foam mattresses work by redistributing the patient's weight over a much larger surface area. Instead of all the mechanical force being point-loaded onto just the tailbone or the heels, the foam contours and spreads that pressure out.
So when you change the physics of the surface, you change the math on how quickly the tissue dies.
Exactly.
But if the 2-hour rule isn't an absolute shield, and foam mattresses really just buy us time, we hit a massive philosophical wall here. If nurses do everything right, if they follow the protocols perfectly, are these injuries always preventable?
That is the million-dollar question, and it remains highly, highly debated today.
We have to look all the way back to Florence Nightingale to understand why, don't we? In her 1859 book, Notes on Nursing, she famously wrote that if a patient develops a bed sore, it is generally not the fault of the disease, but of the nursing.
Right. She basically invented the idea of a nursing-sensitive outcome.
But she also planted a seed that grew into a century-long belief that every single injury equals a failure in care.
And that underlying idea heavily influenced the modern quality improvement campaigns we saw in the 2000s and 2010s.
Yeah.
There were massive administrative pushes for, target zero hospital environments.
Right.
The message was clear. Every pressure injury is a lapse in nursing vigilance. You basically just need to try harder.
But human biology isn't a spreadsheet. The bedside reality pushed back hard against that narrative, didn't it?
It really did, because the target zero message just constantly collides with the biological reality of critically ill and dying patients. This is where we really have to discuss the Kennedy terminal ulcer, which was first described by a nurse named Karen Lou Kennedy Evans back in 1989.
What exactly did she find?
Well, she observed a very specific, undeniable pattern in dying patients. They would develop a pear-shaped or sometimes a butterfly-shaped area of rapid skin breakdown, usually right over the sacrum.
And this wasn't from neglect?
No, it would appear suddenly, sometimes literally in a matter of hours, and progress incredibly fast, despite the nurses providing absolutely meticulous care.
So what is the biological mechanism there? How does the skin just give up like that?
If we connect this to the bigger picture, it introduced the clinical concept of skin failure. This is now captured in consensus statements like SCALE, which stands for Skin Changes at Life's End.
Okay, skin failure.
Think about the physiological process of a human body shutting down. As blood pressure drops and oxygen levels fall, the autonomic nervous system goes into survival mode.
It's trying to save the core, right?
Exactly. It triggers massive vasoconstriction, basically clamping down the blood vessels in the extremities and the skin just to shunt whatever oxygen is left to the vital internal organs, the heart, the lungs, the brain.
So the body is actively sacrificing the skin to keep the brain alive.
Exactly. And the skin is the largest organ in the body. We readily accept that the kidneys can fail at the end of life. We accept that the lungs can fail.
But we expect the skin to be invincible.
Right, but the skin fails too. Therefore, not every pressure injury is a lapse in care. Sometimes it is just the unavoidable biological process of dying.
But the stakes of this debate aren't just academic or emotional. They are incredibly financial. In 2008, the Centers for Medicare and Medicaid Services made a massive policy change.
Oh, the CMS rule, yes.
They added hospital-acquired stage 3 and stage 4 pressure injuries to their list of reasonably preventable conditions. Basically, they said, if a patient gets one of these severe injuries while in your hospital, we are no longer paying you the extra cost to treat it.
It was an absolute earthquake in hospital administration. It essentially turned a clinical problem into a massive billable cost problem overnight.
Wow.
Suddenly, hospitals had intense financial motivation to fund skin assessment programs, invest in those expensive high-density support surfaces we mentioned, and strictly enforce documentation.
It also meant they had to rely heavily on standardized risk assessment tools. Right?
Okay.
You mentioned Nancy Bergstrom earlier with the TURN study. Back in 1987, she and Barbara Braden created the Braden scale.
Yes.
And before that, a British nurse researcher named Doreen Norton developed the Norton scale in 1962.
Right. And the Braden scale is still the most widely used risk screen in the world today. It scores patients on 6 specific subscales: sensory perception, moisture, activity, mobility, nutrition, and friction or shear.
And interestingly, a lower score means a higher risk.
Yeah.
Right?
Exactly.
Let's pause on those subscales for a second.
Yep.
Immobility and friction make obvious sense based on the physics we talked about earlier. But how does moisture or a bad diet physically accelerate a pressure injury?
It all comes down to cellular integrity. Prolonged moisture, whether that's from sweat, wound drainage, or incontinence, it alters the pH of the skin.
Okay.
It strips away the skin's slightly acidic protective mantle, which is a condition called maceration. The skin becomes waterlogged and incredibly fragile, kind of like when you stay in the bathtub way too long.
Right. It gets all pruny and soft.
Yeah, and then it tears with almost zero force. As for nutrition, the body requires massive amounts of protein to maintain and rebuild cell walls.
So if they aren't eating well?
If a patient is malnourished, they literally lack the physical building blocks required to repair the microscopic tissue damage that happens just during normal daily movement.
That makes it so clear why this isn't just a surface-level cosmetic issue.
Yeah.
You see how dangerous this is when you look at the tragic case of the actor Christopher Reeve.
Such a sad case, yes.
He was paralyzed in a horse riding accident in 1995. And years later, he developed a severe pressure ulcer. Because his sensation was impaired, he couldn't feel the early warning signs.
Right.
It became deeply infected, and he ultimately passed away from complications related to that systemic infection. It is a stark reminder that a pressure injury is a direct portal for life-threatening infections to enter the bloodstream.
Which is exactly why nurses on the floor today must assess, stage, and document these injuries with absolute precision. But I will say, there are some major traps and misconceptions when it comes to actually staging these wounds.
Yes, and this is where human intuition completely fails us again. The biggest exam-style takeaway here for you listening is this. Staging is not a trajectory. Injuries do not progress neatly from stage 1 to 2 to 3 to 4, and they absolutely do not heal backwards.
This is a very common point of confusion, even among seasoned healthcare workers. Staging only describes how deep the anatomical damage is at the exact moment you assess it.
Right.
So a wound can show up as a deep stage 4 immediately, with no prior warning signs on the surface whatsoever. And here's the really critical part. When a massive stage 4 wound heals, the body does not magically regenerate the missing muscle or subcutaneous fat.
So what actually takes its place?
It fills in with granulation tissue, which is that bumpy, pink, new connective tissue the body uses to patch holes, and eventually it becomes dense scar tissue.
But it's never the same tissue.
No.
Yeah.
Because the original anatomical layers of fat and muscle are gone forever, the structural integrity of that area is permanently altered. Therefore, it is always documented as a healing stage 4. You never, ever downstage it to a 3 or a 2 just because it gets smaller.
That makes total sense. If the muscle is gone, you can't just pretend it's a superficial stage 2 just because the hole is shrinking.
Exactly.
Then there's the trap of the unstageable wound. If I see a wound labeled unstageable, my brain immediately assumes it is so mild, or maybe so small, that it hasn't even hit the scale yet, right?
That is a very dangerous myth, and it's exactly the opposite of the truth. In this clinical context, unstageable means the wound bed is completely obscured by necrotic dead tissue, what we call slough or eschar.
What does that actually look like to a nurse assessing it?
Slough is essentially dead white blood cells and cellular debris just clumping together into this yellow, stringy mass. And eschar is when the dead tissue dries out into a hard, dark, leathery scab.
Okay, so it's acting like a lid.
Yes, exactly like a lid. Because that dead tissue is blocking your view, you literally cannot see the bottom of the wound to know how deep it goes. By NPIOP convention, you must assume an unstageable wound is at least a severe stage 3 or stage 4 until that dead tissue is surgically or chemically cleared away.
So hiding the depth never implies mildness.
Never.
We also have to separate pressure injuries from other types of skin breakdown that look super similar to the naked eye. The source material mentions terms like moisture-associated skin damage, or MASD, and specifically incontinence-associated dermatitis, or IAD.
Oh, these are frequently confused, especially when assessing the sacrum. The key here is understanding the direction of the damage.
What do you mean by direction?
Well, pressure injuries happen from the inside out or bottom up due to those crushed capillaries near the bone that we talk about. But IAD happens from the outside in or top down.
Ah, okay.
It is a surface-level chemical irritation caused by the ammonia and the enzymes in urine and stool just breaking down the epidermis over time.
So a patient could have a red area on their tailbone, and it could be a bottom-up stage 1 pressure injury, or a top-down IAD, or I guess a combination of both.
Exactly. But getting that diagnosis wrong alters the treatment protocol entirely. And because of that 2008 Medicare rule we mentioned, it drastically alters what the hospital is legally required to report and pay for.
So what does this all mean? When you put all this together, the physics of internal shear, the complex staging rules, the biological variables of the Braden scale, why is distinguishing all these nuances so critical on the floor today?
It matters right now because hospitals are facing just a perfect storm of challenges. We have a rapidly aging population entering the healthcare system with more complex, compounding diseases and vastly reduced mobility.
Right.
At the same time, there is a massive push in intensive care units for early mobility, getting ventilator patients moving sooner, specifically because fewer sedated, immobile patients means fewer pressure injuries.
But counteracting all of that is a severe, widespread hospital and nursing home staffing crisis. And doing this right requires serious manpower, doesn't it?
It really does. Consistent skin checks, applying barrier creams, and careful two-person turning to avoid friction and shear. These are incredibly labor-intensive tasks. When nurses are stretched thin, managing multiple critical patients, these physical, time-consuming preventative tasks are often the very first things forced to slip.
It is a profound systemic challenge. Thank you for going into the medical trenches with us to explore how this hidden damage actually works.
It was my pleasure. Thanks for having me.
We've covered the physics, the history, and the intense realities facing bedside care today. But I want to leave you with a final thought to mull over. Think back to the Kennedy terminal ulcer and that biological concept of skin failure we discussed. We readily accept that a heart or a lung can simply give out at the end of life, despite our absolute best medical efforts to save them. But because the skin is on the outside, because it is entirely visible to grieving families and to strict financial regulators, we have spent decades demanding that it be invincible. If we fully embrace the skin as an organ that is biologically allowed to fail at the end of life, how might that change the way we approach end-of-life care and the grace we give to the nurses providing it? I want you to picture a scene for a second. Imagine a paramedic kneeling next to a car crash victim on the side of a busy highway.
Right. Highly stressful environment.
Exactly.
Yeah.
It's chaotic, it's loud, and the patient is completely unresponsive. Now, that paramedic needs to communicate the exact neurological state of this victim to a hospital trauma team, miles away.
Yeah.
And they have to do it in just a few seconds over a crackling radio.
Mm.
So the question for this deep dive is, how do you compress something as deeply mysterious as human consciousness into a quick, objective transmission?
Well, I mean, it is the ultimate diagnostic paradox, right? You are dealing with this completely impenetrable black box
Right.
because a clinician can't simply press a stethoscope against a patient's forehead and just listen to their level of awareness. Consciousness isn't a heart rate. It's this invisible, highly subjective experience.
Yeah, you can't just draw blood and measure it.
Exactly. And for most of medical history, doctors really lacked any reliable way to share data about that invisible state.
Which is our mission today. We are looking at the sources detailing the single most famous 15-point scale in medicine, the Glasgow Coma Scale, or the GCS. We're going to look at its history, its core components, and some of its pretty famous failure modes.
And this isn't just medical trivia for you listening. Understanding the GCS is really a masterclass in how human beings try to take something profoundly subjective like human consciousness and force it into an objective, shareable number.
Okay, let's unpack this. Because to really get the genius of the GCS, we have to look at the absolute mess that existed before it. We're going back to Britain in the 1960s and early 1970s.
Yeah, this period is totally crucial. We were seeing a massive surge in road traffic accidents. Cars were getting faster, right?
But safety features were, well, they weren't really a thing yet.
Yeah.
Seatbelt laws were lagging far behind.
Right, so hospitals were suddenly just inundated with severe traumatic brain injuries. The trauma wards were overflowing.
And the vocabulary they were using was a disaster, right?
Yeah. Oh, profoundly inadequate. Doctors and nurses were relying on these highly subjective, almost literary descriptors. You'd look at a patient's chart and it might say they were stuporous or semi-comatose.
Obtunded is one I saw in the source.
Obtunded lethargic, yeah?
It's like trying to describe a highly specific paint color to a hardware store over the phone. But instead of giving them a hex code, you just use your feelings. Like, oh, it's a melancholic blue, but a little sleepy.
That analogy captures the danger perfectly because a patient described as lethargic by the night shift nurse might look exactly the same to the day shift doctor. But that doctor's personal definition of lethargic is different, you know? So they record the patient as improving.
Oh, wow. So it's a total miscommunication.
Total miscommunication.
Oh.
When that patient gets transferred from a small local hospital to a major neurosurgical unit, the receiving team has zero reliable data. They don't know if the brain is recovering or if the patient is actively dying.
So the need for this hex code for consciousness was desperate. And enter Graham Teasdale and Brian Jennett. These are two neurosurgeons in Glasgow, Scotland.
Right.
In 1974, they published a paper in The Lancet called Assessment of Coma and Impaired Consciousness, a Practical Scale. This is the birth of the GCS. Though the wild piece of trivia from our source material is that the original 1974 scale wasn't even out of 15.
Yeah, that always surprises people. The original version actually maxed out at 14.
Wait, really? Just 14?
Just 14. Teasdale realized a few years later that the motor response section was missing a crucial clinical nuance, so he patched the scale, adding a 6th grade to that specific category.
That's fascinating.
And if we connect this to the bigger picture, this small historical detail reveals the entire philosophy behind the GCS. Teasdale and Jennett weren't philosophers trying to quantify the human soul, you know?
You're right, they were pragmatists.
Exactly. They needed a tool that a nurse with no specialized neurology training could apply consistently at the bedside every single hour. It was designed as a serial observation tool first and a severity score second.
Okay, so since they needed this standardized language, how exactly did they break down the massive concept of consciousness? They used 3 distinct behavioral ladders, E, V, and M.
Right. Eye-opening, verbal response, and motor response.
Let's break those down, but rather than just listing numbers, let's look at the neuroanatomy. Starting with the eye response, which is graded 1 to 4, that's essentially a proxy for arousal, right?
It is, and that distinction between arousal and awareness is basically the foundation of neurology. The eye-opening component specifically tests the reticular activating system.
Which is located where?
It's this network of neurons deep down in the brainstem. It acts as the brain's main power switch. It shoots arousal signals upward to the cortex.
Okay, so if a patient opens their eyes spontaneously, that's a 4. The power switch is on.
Right. But if they only open them when you apply deep, painful pressure like to a fingernail bed, that's a 2. The switch is barely functioning. But crucially, just because the power is on doesn't mean the higher cortex is actually processing anything.
The lights are on, but nobody's home.
Exactly.
So to test if someone is actually home, we move up the ladder to the verbal response, which gets 5 points. This is testing higher cortical functions, specifically language centers, usually in the left hemisphere.
Yeah. And as the cortex suffers increasing damage or pressure, you can track the degradation of language. A fully oriented patient, a 5, knows who they are and what year it is.
Right.
But as pressure mounts, that degrades into a 4, which is confused, conversational sentences. Then down to a 3, which is inappropriate, random words with no conversational exchange at all.
And then it just becomes sounds.
Yeah. A 2 is incomprehensible groans.
Yeah.
And eventually, as the language centers completely fail, a 1, the patient is completely silent.
Wow. Okay, then we hit the heavy hitter, the motor response. This gets a maximum of 6 points.
Yeah.
And the sources point out this is the single strongest predictor of outcome?
Oh, absolutely. Motor is paramount.
Why is it weighted higher?
Because mechanically, you are mapping the structural integrity of the brain from the top down.
Yeah.
You can assess it even if a patient's eyes are swollen shut or they have a breathing tube. You are watching the nervous system disconnect in real time.
Okay, walk us through that disconnect.
If a patient obeys a command like, squeeze my fingers, that's a 6. Their cortex is processing the sound, formulating a plan, and sending signals down the spinal cord.
Right.
But say they can't obey commands, but they purposefully reach across their body to swat your hand away when you pinch them. That's a 5. Localizing pain. The cortex is still somewhat involved, but the deeper you go, the more primitive the reflexes become.
And this is where we get into those 2 terrifying clinical terms I read about. Decorticate and decerebrate posturing. These are the 3-point and 2-point motor scores.
Right. Let's look at the mechanics of those postures. A score of 3, abnormal flexion or decorticate posturing, happens when the arms bend rigidly inward, curling toward the chest.
What does that mean anatomically?
It indicates that the damage has severed the connection between the cortex and a structure in the midbrain called the red nucleus. The brainstem is basically operating on its own, trying to pull the body into a protective fetal position.
That is wild. And a 2 is worse.
Much worse, abnormal extension or decerebrate posturing. The arms and legs straighten out rigidly and the wrists rotate outward.
Oh, man.
Yeah, the damage has now descended directly into the brainstem itself. It's disconnected the red nucleus entirely. The brain is relying on the most primitive vestibular tracts just to maintain muscle tone. It is a massive neurological emergency.
Let's apply this to a concrete example from the text. A high-speed motorcycle crash.
Okay.
Patient comes into the trauma bay. No eye opening to pain, so E is 1. No vocal sounds at all, V is 1. But when the doctor applies a sternal rub, that deep, painful friction on the chest, the patient's arms rigidly extend outward.
Right, decerebrate posturing, M2.
So E1, V1, M2. Total GCS is 4. This triggers a very famous medical mnemonic, right? GCS less than 8, intubate.
Yes, GCS less than 8, intubate. It's universal. The mechanics of that rule are entirely about airway protection. At a score of 8 or below, the neurological depression is so severe that the brainstem is rapidly losing its ability to manage basic protective reflexes.
Like coughing or swallowing.
Exactly. The gag reflex goes. The tongue might fall back, or they might aspirate their own secretions. The trauma team isn't even treating the brain yet. They are instantly moving to place a plastic endotracheal tube to secure the airway before the patient suffocates.
Okay, this all feels incredibly elegant. You run the tests, map the degradation, get the score, secure the airway. But trying to shove the wild reality of human consciousness into a neat numerical box has to create blind spots, right?
Oh, massive blind spots.
Let's talk about where the GCS fundamentally fails, starting with the deceptively awake patient.
This is a classic flaw. Consider a patient who has suffered a massive ischemic stroke, specifically in the left middle cerebral artery. Okay.
This patient opens her eye spontaneously. She scans the room, tracks you when you walk in. Her eye score is a 4. When you pinch her right arm, she uses her left hand to purposely swat you away. Motor score is a 5.
Doing pretty well so far.
But because the stroke obliterated Broca's area, the motor speech center in her left brain, she has expressive aphasia. She cannot utter a single word or sound. Her verbal score is a 1.
Wait, E4, M5V1. That's a total score of 10, and a 10 clinically suggests a moderate traumatic brain injury, right?
Right.
Doesn't this mean the GCS is measuring the ability to move or speak rather than actual consciousness? Because she's fully awake, she's sitting there trapped in silence, perfectly aware, and the scale calls her half comatose.
Exactly. It exposes the deepest philosophical flaw of the tool. The GCS does not measure subjective awareness. It exclusively measures behavioral responsiveness.
Wow.
The most extreme example of this is locked-in syndrome. A patient with a specific brainstem stroke might be entirely awake, fully conscious, processing every conversation in the room, but they are paralyzed from the eyes down, so they can't move or speak at all.
Nothing. Their GCS would be a 3. The lowest possible score, equivalent to a deep coma, even though their inner consciousness is perfectly intact.
That is terrifying. It completely conflates the capacity to respond with the presence of a mind. And on top of that philosophical blind spot, the sources detail a glaring mathematical flaw that statisticians absolutely hate.
Oh, the math problem. Summing the E, the V, and the M into a single number is, well, it's technically mathematically illegitimate.
How so?
The designers took three separate ordinal scales and disguised them as a single interval scale. In statistics, an ordinal scale just means the categories have a rank order. 4 is better than 3, 3 is better than 2.
Right.
But the distance between the numbers isn't equal. The neurological leap from a 1 to a 2 in motor response is vastly different from the leap from a 4 to a 5 in eye-opening.
It's like a restaurant review, like, say, a 3-star rating on Yelp. A 3-star rating could mean incredible Michelin-level food, but the waiters literally throw the plates at your head. Or it could mean the food is terrible, but the service is incredible. The final number completely obscures the actual experience.
And the clinical danger of that math is very real. Imagine patient A has no eye opening, makes incomprehensible sounds, and withdraws from pain. E1, V2, M4. Their total is a 7.
Okay, a 7.
Now patient B opens their eyes to pain, makes no sound, and shows decorticate posturing. E3, V1, M3. Their total is also a 7.
But those are completely different emergencies.
Exactly. Patient A might have a diffuse metabolic issue, while patient B is showing signs of focal brainstem compression. Adding them up into a single digit destroys the most vital diagnostic information.
Which is why the sources say experienced clinicians will rarely just say the GCS is 7. They report the breakdown. But even with the breakdown, we run into the most notorious failure point, the intubation controversy.
This is the flaw that throws clinical trials into absolute chaos. When a patient is in the ICU with a severe brain injury, they almost always have a breathing tube in place. That piece of plastic passes directly through their vocal cords. It is physically impossible for them to speak.
So if you have to score their verbal response, you give them a 1 because they're silent.
Well, if you do that, you are artificially dragging down their total score. You're making their brain injury look mathematically worse than it actually is just because of a piece of plastic.
So what do doctors do?
For decades, there was no global standard. Clinicians would just write T for tube, so you'd get a score like E4, VT, M6.
But wait, how do you add a letter to a number?
You can't, and that artificial drag ruins comparative data. Imagine a pharmaceutical company trying to run a multi-center trial for a new brain injury drug. Hospital A might assign a verbal score of 1 to all intubated patients. Hospital B might use complex statistical models to guess what the score would be without the tube.
It's a methodological nightmare. So the math is fuzzy if it conflates responsiveness with awareness, and a plastic tube ruins the data. Why is it still invoked thousands of times a day worldwide?
Because its true power isn't in a single snapshot. What's fascinating here is its immense value lies in the motion picture, the trend over time.
Okay, let's trace the mechanics of that trend with a classic case. The epidural hematoma. Someone takes a baseball bat to the side of the head.
Right.
They arrive at the ER, seemingly fine. They open eyes to speech, they're confused but talking, and they obey motor commands. E3, V4, M6. Total score is 13.
A mild to moderate injury. But underneath the skull, an artery has torn. Blood is beginning to pool between the skull and the dura mater. Because the adult skull is a rigid, closed box, that expanding pool of blood has nowhere to go. It pushes inward, crushing the brain tissue.
2 hours later, the nurse does a routine check. Now, eyes only open to pain, they're speaking inappropriate words, and only localizing pain. E2, V3, M5. The score has dropped from a 13 to a 10.
And an isolated score of 10 is still technically classified as a moderate injury, but that drop of 3 points is a massive blaring alarm. It signals expanding pressure before Cushing's triad sets in.
Cushing's triad. Let's explain that.
It's the late-stage physiological signature of a brain being crushed. The pressure squeezes the brainstem, starving it of oxygen. The sympathetic nervous system panics and triggers a massive spike in blood pressure to try and force blood up.
And when that pressure spikes, the body senses the danger.
Right. The baroreceptors tell the vagus nerve to slam the brakes on the heart rate. So you get sky-high blood pressure, a dangerously slow heart rate, and irregular breathing.
And once that happens, it's almost too late.
Exactly. The brain is on the verge of herniating, literally being squeezed out the base of the skull. But the GCS trend caught the rising pressure early. That 3-point behavioral drop gave the trauma team the lead time to rush the patient to the OR, drill a hole, evacuate the blood, and save their life.
Here's where it gets really interesting. Because this tool is so powerful and ubiquitous, it spawns some persistent misconceptions. Let's rapid fire through the big ones from the text. First, a GCS score directly measures brain damage.
False. It measures current neurological output, not structural integrity. A patient's brain could be anatomically pristine on an MRI.
But they could still have a low score.
Oh yeah, if they're profoundly intoxicated with alcohol or severely hypothermic from falling in a freezing river, their neurons can't fire efficiently. The score plummets. The hardware is perfect, but the software is frozen.
Myth 2. A GCS of 6 is twice as bad as a 12.
We circle back to the ordinal scale problem. You can't divide or multiply these categories. A 6 means profound unresponsiveness, likely life support. A 12 might just be a confused patient with a mild concussion. It's not a ratio.
And the final myth. A GCS of 3 means the patient is brain dead.
Absolutely not. A GCS of 3 just means the patient has hit the floor of the behavioral scale. No eye-opening, no sounds, no movement to pain. But brain death is a highly rigorous legal diagnosis.
They need other tests for that.
Yeah, neurologists have to check cranial nerves, corneal reflexes, and perform an apnea test disconnecting the ventilator to see if the brainstem's primitive urge to breathe is gone. You can have a GCS of 3 for weeks and still be alive.
So because of all these weaknesses and myths, the medical field hasn't just sat still since 1974. They've tried to build better mousetraps. We have some rivals to the GCS.
Yeah, a lot of push for refinement. In 2005, a neurologist named Ilko Wijeks introduced the FOU score.
FOUR, full outline of unresponsiveness.
Exactly. And it was designed specifically to fix the blind spots. It drops the problematic verbal score entirely, sidestepping the intubation controversy. And it adds brainstem reflexes like pupil reactions, which the GCS ignores.
And then there's the AVPU scale used by EMS. Alert, voice, pain, unresponsive.
Super crude, but a paramedic running toward a burning vehicle doesn't have time to calculate a 15-point index. They need a fast triage tool.
But TZL himself wasn't blind to the criticisms, right?
No, in 2014, for the 40th anniversary, he helped update the scale to GCS pupils, or GCSP. Clinicians can subtract points from the 15-point total if the pupils are fixed and non-reactive to light.
Addressing that brainstem blind spot. Real quick, just to clarify some alphabet soup for you reading the literature.
Yeah.
There's also the GOS, the Glasgow Outcome Scale.
Right, totally different application.
Oh.
Created by the same Glasgow team in the 70s, but it's not for the emergency room.
It's for long-term recovery.
Yes. While GCS measures initial severity, GOS measures the long-term reality. Does the patient end up in a vegetative state or make a good recovery 6 months down the line? Students constantly confuse them, but GCS is the starting line. GOS is the destination.
So despite the FOUR score, the fuzzy math, the intubation issues, why does the GCS still rule the medical world today?
Because it shapes triage in mass casualties. It dictates entry for clinical trials. It impacts legal insurance claims. Most importantly, it's a foundational rehearsal for nursing students learning to turn subjective impressions into reproducible data.
It imposes order on the chaos. So what does this all mean for you listening?
Yeah.
It means the next time you hear a medical show yell about a GCS of 7, you know exactly what they're actually measuring, what they're missing. We've gone from a communication crisis in 1970s Scotland to a 15-point scale that changed medicine forever.
And it proved that we can standardize the measurement of human responsiveness to save lives. But you know, as AI and neural interfaces become more advanced, it leaves us with a wild question.
Oh, I like where this is going.
Will we eventually need a new digital version of the GCS? Not to measure if a human brain is responding to pain, but to measure if a synthetic mind has achieved its own form of spontaneous eye-opening.
Wow. Now that is a thought to keep you up at night. Right now, that paramedic on the highway is just assessing the physical hardware of a human crash victim. But in the coming decades, the very nature of the minds we are trying to measure might change entirely. Imagine for a second that you are, well, in absolute peak physical condition.
Right, like you're a professional athlete at the top of your game.
Yeah, exactly. Maybe even a gold medalist. And you undergo this fairly routine foot surgery, and the operation goes perfectly. You go home to rest, but then, days later, you find yourself struggling to breathe, literally fighting for your life in an emergency room.
And it's not because of an infection or anything like that.
Exactly. No infection. You didn't tear a muscle.
Oh,
you were being taken down by something completely invisible. It's this microscopic threat that formed entirely because you did exactly what you were told to do.
Which is to stop moving.
Right. You stop moving.
It's honestly one of the most counterintuitive paradoxes of the human body. I mean, we are conditioned from childhood to believe that resting is the ultimate form of healing.
Right. You get hurt, you go to bed.
Exactly. But in the context of human circulation, absolute rest can actually be the very trigger for a catastrophic medical event.
And that is the exact paradox we're diving into for you today. Welcome to the Deep Dive. We have this fascinating stack of sources in front of us today. We've got nursing protocols, some wild historical medical cases, and modern clinical trial data.
It's a really comprehensive pile.
It is. And our mission today is to explore this concept, the clot that forms when you stop moving. We are talking about deep vein thrombosis, or DVT. So, okay, let's unpack this.
Let's do it.
Looking at these sources, they draw a very hard line between different types of veins. What exactly is a DVT, and why is it so much more dangerous than just getting a bruise or a surface-level clot?
Well, the distinction is purely anatomical, but it really makes all the difference in the world. A deep vein thrombosis is a blood clot, or a thrombus, that forms inside one of the body's deep veins.
So, like where exactly?
Typically, these are buried deep inside the muscle of your calf, your thigh, or your pelvis. So if you think of the veins just under your skin as small, winding side streets.
Okay, side streets.
Right. If a clot forms there, yeah, it's painful, but it's relatively contained. The deep veins, on the other hand, are the massive high-speed return highways.
Oh, wow.
Yeah, they're responsible for channeling huge volumes of oxygen-depleted blood directly back to the right side of your heart and then immediately into your lungs to get reoxygenated.
Which means if a clot forms on that high-speed highway, there is no detour.
None at all.
If a piece of that clot breaks off, like it embolizes, right? It has a straight, unobstructed shot right into the heart and then into the pulmonary arteries.
Exactly. And when it lodges in the lungs, it completely blocks blood from picking up oxygen.
Right.
That is what we call a pulmonary embolism, or PE.
And that can be instantly fatal.
It can. In modern clinical practice, doctors actually don't even view DVT and PE as separate diseases anymore.
Really?
Yeah, they group them together under the umbrella term venous thromboembolism, or VTE, because honestly, they're just two stages of the exact same disease process. The clot forms in the leg, and it basically finishes its destructive journey in the lung.
Wow. So the entire goal of modern medicine, and really the main through line of all the nursing protocols in our sources today, is early recognition and prevention.
Prevention is everything here.
It's about understanding that something as basic as, bending your knees and walking is literally a matter of life and death. But to figure out how to stop these clots, we first need to understand the blueprint of how they form.
Right.
And reading through these historical documents, I was genuinely stunned to see that the prevailing theory on this isn't from modern times at all. It's from the 19th century.
Yeah, it's pretty wild. Despite all our advanced MRIs and, genetic sequencing, the foundational framework for understanding blood clots was actually established way back in 1856.
1856.
It's incredible. By a German physician and pathologist named Rudolf Virchow. He basically proposed that for a clot to form inside a blood vessel, one of three specific conditions had to be met.
And this is Virchow's triad.
Exactly. We still call it Virchow's triad today. It is literally the first thing taught in every single medical and nursing school when covering this topic.
So let's break those three conditions down because they really dictate everything else we are going to talk about today.
Okay, so the first pillar of the triad is stasis.
Which means?
This is simply blood flow slowing down to a crawl. The second pillar is endothelial injury, which means physical damage to the smooth, delicate inner lining of the vein itself.
Okay, stasis and injury.
Right. And the third is hypercoagulability. That's a systemic state where the blood's chemistry is altered. So it makes the blood fundamentally primed and eager to clot even when there is no physical bleeding to stop.
Okay, I want to linger on that first pillar for a second, stasis, because it really highlights the mechanical engineering of our bodies.
Oh, absolutely.
If you think about the blood in your legs, it has a massive problem to overcome, which is gravity. It has to travel all the way from your ankle back up to your chest. And your heart alone just isn't strong enough to suck that blood upward.
No, it's not. So your body relies on your leg muscles, specifically the calf muscle pump. The soleus muscle in the calf is actually often called the second heart for exactly this reason.
The second heart. I love that. It's basically a biological plumbing system. Every time you take a step, that calf muscle contracts and physically squeezes the deep veins, just shooting the blood upward. And then these little one-way valves inside the vein snap shut so the blood doesn't fall back down. But when that pump is turned off, like when you are immobilized in a hospital bed or sitting at a desk for 12 hours, the blood just pools.
It just sits there.
Right. If a plumbing pipe has a fast-flowing river of water, it stays clean. But if the water stops waiting, All the heavy sediment, the debris, the clotting factors, they all start to settle against the walls of the pipe.
And that sediment settling triggers a microscopic chain reaction.
Yeah.
And that cascade is dramatically accelerated if you introduce the second pillar, which was endothelial injury.
So physical damage to the pipe itself.
Exactly. If you undergo surgery like a knee replacement, or if you suffer trauma in a car accident, the lining of your vein is damaged. When that lining breaks, it exposes a protein underneath called tissue factor.
Tissue factor.
Yeah, and tissue factor is basically a biochemical alarm siren. It screams to the rest of the body, hey, we're bleeding, send the clotting crew right now.
Wow.
So even if the bleeding is purely internal, a clot will rapidly build at that exact site of injury.
So, I mean, if your pipes are flowing and the pipes aren't physically damaged, you should be completely safe from a clot, right?
Well, you'd think so.
Right, but that brings up the third part of the triad, hypercoagulability. Because what if the fluid running through the pipes is genetically primed to basically turn into sludge?
Exactly. Sometimes the blood itself is the core problem. Our sources highlight a condition called Factor V Leiden. It was identified in the mid-90s, and it's a genetic mutation that essentially breaks the off switch for blood clotting.
The off switch.
Yeah, so people with this mutation create clots much faster than their bodies can dissolve them. But the thing is, hypercoagulability doesn't have to be genetic. You can acquire it.
How does that happen?
Things like active cancer, systemic inflammation, or severe obesity can all basically dump chemicals into your bloodstream that lower the threshold for clotting.
And looking at this 165-year-old triad, it completely destroys the modern stereotype we have about who actually gets a DVT.
Oh, completely.
I think the average person assumes this is a disease strictly for the elderly or maybe someone confined to a nursing home. But Virchow's triad proves that age is entirely irrelevant if those conditions are met.
The triad does not care how young you are. It doesn't care how fast you can run a marathon. If the scales tip, a clot forms, period.
The story of David Bloom in our sources is just a heartbreaking example of this. He was this incredibly prominent, dynamic NBC News correspondent. And in 2003, during the invasion of Iraq, he was embedded with U.S. forces.
Right.
He was only 39 years old. But he spent days folded up with his knees to his chest inside this cramped Bradley fighting vehicle just bouncing across the desert.
He had almost no ability to extend his legs or activate that calf muscle pump we talked about. The stasis was absolute.
The pump was turned off, the sediment settled, and a massive DVT formed. And it eventually embolized into a fatal pulmonary embolism. I mean, he wasn't elderly, he wasn't sick. It was pure stasis-driven thrombosis caused entirely by his environment.
And we see this phenomenon regularly at the extreme opposite end of the health spectrum, too, like in elite professional athletes.
Right, going back to the surgery example.
Yeah, the tennis legend Serena Williams developed a life-threatening pulmonary embolism following foot surgery in 2011. And she was arguably in the top fraction of a percent of human physical fitness.
Truly peak condition.
But the physical trauma of the surgery created endothelial injury, and the prescribed recovery period created stasis. So 2 pillars of the triad were met, and her incredible fitness just couldn't stop the clot.
Chris Bosh is another prime example from the sources. He was an NBA All-Star, constantly moving, but his career was tragically cut short by recurring blood clots.
Yeah, he had an underlying hypercoagulable state.
So you combine that with the constant microscopic physical trauma of professional basketball and the endless hours sitting on airplanes, and boom, you trigger the triad.
Exactly. And if we connect this to the bigger picture, the realization that prolonged stillness is deadly forces us to look back at medical history with a lot of horror.
Oh, totally.
Because for a very long time, the medical establishment was prescribing the exact thing that was killing people.
The era of strict bed rest. Reading these older protocols, it is wild how universal it was.
It was the standard for everything.
Right. For much of the 20th century, if you had a baby, you were on strict bed rest. Heart attack, weeks of bed rest, surgery, do not move a muscle.
The logic was that a recovering body needed to conserve every single ounce of energy to heal tissue, and moving might, rip open surgical stitches.
It was incredibly intuitive logic at the time.
It was. But the outcomes data eventually revealed an absolute disaster. Doctors were noticing horrifying rates of sudden death in patients who seemed to be recovering perfectly from their initial surgeries.
And they didn't know why.
Not at first. It took decades of autopsies and outcome tracking to realize that the bed rest was allowing massive clots to form in the deep veins. Orthopedic surgeons were actually some of the very first to sound the alarm on this, particularly as joint replacements became more common in the mid-20th century.
Because replacing a hip or a knee is basically a worst-case scenario for the triad,
Oh,
right?
yeah.
You have massive bone and tissue trauma causing endothelial injury, plus the patient can't walk.
Precisely. The DVT rates in early orthopedic surgeries were astronomical, and this realization forced one of the most profound paradigm shifts in modern nursing and medicine.
Right.
Immobility went from being a prescribed treatment to a recognized pathogen. Today, if you wake up from a major surgery, a nurse is likely going to have you standing up and shuffling down the hallway within hours. Early mobilization is now the ultimate protective standard.
But wait, let me push back on that for a second.
Sure.
If getting up and moving is the cure, if activating the calf muscle pump sweeps the sediment away, why do the nursing protocols in our sources still mandate heavy blood thinners for patients in the hospital?
That's a great point.
I mean, if I am walking the halls, why are they injecting me with anticoagulants? Doesn't the walking basically cancel out the need for the drugs?
It raises an important question, but the flaw in that logic goes right back to Virchow's triad. You cannot view the triad as a single problem with a single solution.
Ah, okay.
Walking down the hallway absolutely solves the stasis problem. But what if you just had major abdominal surgery? You still have immense endothelial injury that is actively calling for clotting factors. Or what if you are hospitalized for cancer treatment? Your blood is still hypercoagulable.
So the movement only fixes 1/3 of the blueprint.
Yes, exactly. Walking cannot fix a chemical imbalance or a torn vein lining, and that is why mechanical prophylaxis like walking and chemical prophylaxis like blood thinners are not substitutes for one another.
They work together.
They do. Medications like heparin or the newer direct oral anticoagulants work synergistically with movement. The movement keeps the blood flowing, and the medication alters the blood chemistry to raise the threshold for clotting, preventing that tissue injury from triggering a massive response.
Okay, so what does this all mean for things like compression socks? Because for years, the conventional wisdom was just to put tight stockings on immobilized patients to keep the pressure up and prevent stasis.
Right.
It seems like a perfectly logical physical solution, right?
It does seem logical, and for decades, graduated compression stockings were used as this blanket preventive measure for almost everyone in a hospital bed. But the medical community eventually learned that you cannot just slap a mechanical Band-Aid on a complex system without testing it rigorously.
And that's where the CLOTS trial comes in.
Exactly. The UK CLOTS trial in the 2000s completely upended this assumption.
So what did the trial actually test?
They looked specifically at stroke patients. Now, stroke patients are highly vulnerable to DVT because they often suffer from paralysis and simply cannot move their legs.
So ultimate stasis.
Right. The researchers assumed thigh-length compression stockings would artificially squeeze the veins and prevent clots, but the data showed the exact opposite of what they hoped.
Wait, really?
Yeah. Not only did the stockings fail entirely to reduce DVT rates in these stroke patients, but they also actively caused harm. The constant tight pressure on fragile skin led to terrible ulcers, skin breakdown, and even restricted arterial blood flow.
Oh man, that is a massive backfire. Trying to passively squeeze the leg ended up causing a whole new set of injuries.
It forced a total reevaluation. It taught clinicians that you just cannot apply a universal passive fix to every single patient. Prevention requires an active, tailored approach based on individual risk factors, not just handing out tight socks.
And the urgency of getting that prevention right is magnified by how sneaky these clots actually are. Because even with early walking and even with blood thinners, a clot can still form.
They absolutely can.
And the most terrifying detail in these sources isn't just that they form, but that they often form in complete silence. There is this huge misconception that a DVT will always present as this massive, red, swollen, throbbing leg.
And that expectation is incredibly dangerous. While a classic DVT certainly can cause swelling and pain, a huge percentage of them are completely asymptomatic.
Just zero symptoms.
Zero. Or the symptoms are so mild, just a vague ache or a feeling of heaviness, that a patient will completely dismiss it as a muscle cramp or a pulled hamstring.
Wow.
Very frequently, the absolute first sign that someone has a DVT is when a piece of it breaks off, travels to the lungs, and they suddenly collapse with crushing chest pain and shortness of breath.
The silent nature of the disease is just deeply unsettling. But historically, that silence has also served as a very dark warning sign for other hidden diseases. There was a story in our sources about Armand Trousseau, a French physician in 1865.
Trousseau is a fascinating figure. He was a brilliant diagnostician studying thrombophlebitis, which is basically inflammation and clotting in the veins. And during his practice, he noticed a very strange pattern in a subset of his patients.
What did he see?
They would develop unexplained blood clots that would appear in one leg, resolve, and then spontaneously appear in an arm or the other leg.
Okay, so just popping up everywhere.
Right. These migrating, recurring clots were happening without any obvious stasis or injury.
So he realized he was looking at severe hypercoagulability.
Yes, and he made a groundbreaking connection. He discovered that this specific pattern of migrating clots was often the very first visible symptom of an occult or hidden visceral cancer, most notably stomach or pancreatic cancer.
Because the tumor is changing the blood.
Exactly. The tumor itself was secreting chemicals that threw the clotting cascade into absolute overdrive. Today, this phenomenon is still taught in medical schools as Trousseau's sign of malignancy.
But the truly chilling part of the story is how his research ended.
It is incredibly tragic, honestly. Just 2 years after publishing his findings in 1867, Trousseau felt a strange ache in his own body. He observed his own veins and saw the very pattern of migrating blood clots he had just documented.
Oh my God.
Yeah, because he wrote the paper on it, he knew instantly what it meant. He used his own physical symptom to diagnose himself with advanced pancreatic cancer, and he succumbed to the disease just months later.
The clots were the smoke and the hidden cancer was the fire. It is an amazing testament to the power of clinical observation. But obviously, how we look for that smoke has evolved a lot, because back in the 1940s, a doctor trying to figure out if you had a clot would basically just physically squeeze your leg.
You were talking about Hohmann's sign.
Right. The old bedside test where the doctor forcibly flexes your foot upward toward your shin to see if it causes deep pain in your calf.
Yeah, it was the gold standard physical exam for decades. But modern medicine completely abandoned it, and for very good reason. First of all, it is essentially useless from a diagnostic standpoint.
Because almost anything can make your calf hurt when you stretch it like that, right?
Yeah.
Like a cramped muscle or a ruptured cyst.
Exactly. The sensitivity and specificity are terrible. But more importantly, performing Hohmann's sign is actively dangerous.
How so?
Think about the mechanics. You have a fresh, gelatinous blood clot precariously clinging to the wall of a vein. Then a doctor comes along and aggressively stretches and squeezes the muscle surrounding that vein.
Oh, no.
Yeah, the physical manipulation can actually dislodge the clot right then and there, causing the exact pulmonary embolism the doctor is trying to diagnose.
It's literally squeezing a live bomb to see if it's ticking. So Hohmann's sign is out. Today, clinicians use a much more sophisticated algorithm. Our sources highlight this three-step pathway. First, instead of guessing, they use the Wells score, which is basically a strict mathematical checklist.
Right.
It assigns points for things like recent surgery, swelling, or cancer history to determine the mathematical probability that a clot is present. Then, they use a D-dimer blood test.
The D-dimer is fascinating. When a clot forms, your body immediately starts trying to break it down. As the clot degrades, it sheds these microscopic protein fragments into the bloodstream.
And the test looks for that.
Exactly. The D-dimer test detects that specific biochemical wreckage. So if the D-dimer is completely negative, you can be fairly certain there is no active clotting going on.
But if it is positive, you move to the ultimate tool, which is the compression ultrasound. It uses sound waves to actually visualize the blood flowing through the deep veins in real time. And here's where it gets really interesting, because this advanced ultrasound technology actually sparked a massive ongoing debate in the medical community.
It absolutely did.
Yeah.
Before ultrasound, a clinical DVT was just a DVT, and it was treated aggressively. But ultrasounds became so sensitive that doctors could suddenly pinpoint exactly where the clot was located.
Right.
This created a new anatomical distinction. They asked, was the clot proximal, meaning high up in the large veins of the thigh or pelvis? Or was it distal, meaning it was tiny and isolated solely in the deep veins of the calf?
And that matters, because a clot in the calf has a much longer, more difficult journey to get to the lungs than a clot in the thigh, right?
Precisely. The data eventually showed that distal calf clots have a remarkably low rate of embolizing. In fact, the body's natural enzymes often just dissolve them over time without any medical intervention whatsoever.
Wow.
And this realization caused a massive fracture in standard protocols. Historically, the moment a clot was found anywhere, the patient was put on powerful blood thinners for months, but blood thinners carry a significant risk of severe internal bleeding.
So doctors started asking, like, are we risking a brain bleed to treat a tiny calf clot that might never cause a problem.
Exactly. This led to a controversial new approach called watchful waiting for isolated distal clots.
Watchful waiting.
Right. Instead of prescribing dangerous anticoagulants, some clinicians now opt to simply perform serial ultrasounds every few days. They just watch the clot. If it doesn't grow or move upward toward the thigh, they never medicate it.
That's a huge shift.
It was considered medical heresy 20 years ago, and professional hematology guidelines are honestly still actively debating exactly when to treat and when to watch.
It shows just how incredibly nuanced our understanding of blood clotting is becoming. And that nuance isn't just for hospital wards. It applies to all of us living our daily lives. Because the triggers for Virchow's triad are hiding in our everyday routines. For example, economy class syndrome.
Yes, the World Health Organization actually launched a massive study called the RIGHT Project to investigate that specific phenomenon.
And the data they found is just stark. I mean, if you were listening to this deep dive right now while sitting on a flight that is longer than 4 hours, your risk of developing a venous thromboembolism has roughly doubled compared to when you were just waiting in the terminal.
Because your calf pump is off.
Exactly. The pump is off, and the dry cabin air is dehydrating you, making your blood slightly thicker. So it is pure stasis combined with mild hypercoagulability.
And everyday life events affect that hypercoagulability too. Taking estrogen-based birth control pills, undergoing hormone replacement therapy, or simply being pregnant prompts the liver to produce more clotting factors.
Which is natural, right?
It is. It's the body's evolutionary way of preparing for the bleeding of childbirth, but it dramatically increases the risk of a DVT.
And then there are massive, unpredictable global events that throw the entire clotting cascade into chaos. The COVID-19 pandemic is heavily featured in these clinical notes.
The vascular impact of COVID-19 was a terrifying surprise to the medical community in 2020. Clinicians were seeing patients whose lungs were full of microclots and whose legs were developing massive DVTs, even when those patients were already on high doses of preventive blood thinners.
Wait, how is a respiratory virus causing blood clots in the legs?
It comes back to endothelial injury and inflammation. COVID-19 triggered what we call a cytokine storm, a massive uncontrolled inflammatory response by the immune system. The virus and the inflammation aggressively attacked the inner lining of the blood vessels throughout the entire body. So the body misinterpreted this massive systemic inflammation as widespread physical trauma.
Oh, wow. So it thought it was bleeding everywhere.
Exactly. It essentially panicked, thinking it was bleeding out, and dumped massive amounts of clotting factors into the blood. It created a hypercoagulable state so aggressive that standard drugs just couldn't stop it.
That is terrifying. But medical research also delivers incredible, positive surprises regarding how our vascular system works. The Jupiter trial from 2009 is a perfect example of this.
Oh, the Jupiter trial is one of my favorite anomalies in modern medical research.
Tell us about it.
It was a massive multinational study looking at a drug called rosuvastatin. Statins are widely known and prescribed exclusively to lower bad cholesterol. The goal was to see if the statin prevented arterial plaques from bursting and causing heart attacks.
But they accidentally discovered a massive benefit for the venous system.
Yeah. They did. When they analyzed the data, they found that the patients taking the statin had a dramatic, statistically significant reduction in venous thromboembolism.
Which makes no sense.
It confused everyone at first because cholesterol plaques do not form in veins, they only form in arteries. So how is a cholesterol drug preventing DVTs?
Right, what was the actual mechanism there?
It turns out statins don't just lower cholesterol, they're also powerful anti-inflammatory agents. They soothe the endothelium, the inner lining of the blood vessels.
Okay.
By reducing systemic inflammation, the statin essentially calmed the vein walls down, preventing them from sending out those chemical distress signals that trigger a clot. It was a total accident of research that proved how interconnected our cardiovascular systems really are.
It is incredible how a drug built for one side of the circulatory system ended up protecting the other just by calming the environment.
Yeah.
So as we pull all these threads together, the core takeaways from this massive stack of research are incredibly clear.
Very clear.
First, Virchow's triad stasis, endothelial injury, and hypercoagulability is the ultimate blueprint. Every risk factor you will ever face traces back to one of those three pillars. Second, bed rest is no longer the cure. It is a profound risk. Early, active movement is the gold standard of prevention.
Movement is medicine.
Exactly. And finally, you cannot wait for obvious pain to warn you because a clot can be utterly silent until the exact moment it threatens your life.
And as you think about the silent, lingering nature of this disease, I want to leave you with a final concept to ponder that illustrates the true long-term stakes of a deep vein thrombosis.
Okay.
It is a condition called post-thrombotic syndrome. We focus so heavily on the immediate life or death threat of the clot breaking off and traveling to the lungs. But what happens to the leg itself after the crisis is over?
That's a good question.
Even if you were diagnosed early, even if you are given the right blood thinners, and even if the clot completely dissolves, the physical trauma of that clot sitting in your vein can permanently destroy those tiny, delicate one-way valves we talked about earlier.
Oh, no.
And when those valves are ruined, they never grow back. The blood can no longer fight gravity efficiently. It constantly falls backward and pools in your lower leg.
Wow.
For the rest of your life, you can be left with chronic, heavy swelling, persistent pain, and irreversible skin discoloration. It is the permanent structural footprint that a clot leaves behind long after it is gone.
Oh.
And it is the ultimate reminder that the true goal of medicine isn't just to survive a blood clot. The goal is to never let it form in the first place. You know, if you grew up watching television any time in the last 30 years, you probably have this very specific, very dramatic image burned into your brain of what happens when someone's heart stops.
Oh, absolutely. It's always the exact same scene.
Right. The alarms start blaring, the monitor flatlines with that terrifying continuous tone, and then a doctor jumps onto the bed, pumps the patient's chest a few frantic times, yells clear.
As they shock them.
And then magically, the patient just violently gasps, opens their eyes, and immediately starts talking.
It's basically a miracle every time.
It is the ultimate medical drama trope. I mean, the narrative arc of a television show requires a miracle, so the whole process is portrayed as fast, highly dramatic, and almost always successful.
We see it so often that I think we just assume, well, that must be how it works. But we're looking at a huge stack of medical history papers, EMS data, and AHA guidelines today. And our mission in this deep dive is to unlearn basically everything Hollywood ever taught you about CPR.
Because the reality is so much more complicated and fascinating, honestly. Yeah, we are going to break down the actual science of why it works, and most importantly, why you, the untrained bystander listening to this right now, why you are the absolute most critical factor in saving a life.
Without a doubt.
And to set the stakes for why we need to shatter that television myth, there's a study in our sources from 1996 by researchers DM, Lantos, and Tulsky that, honestly, it completely blew my mind.
Yeah, what's fascinating there is just how stark the gap is between fiction and reality. Those researchers actually sat down and systematically analyzed medical dramas, shows like ER and Chicago Hope, to measure the outcomes of CPR on television.
Which sounds like a fun research project, honestly.
Right, but the findings were wild. They found that on screen, roughly 67 to 75% of characters who received CPR survived and just walked out of the hospital.
Which sounds incredibly reassuring, I mean, if it were true.
But it creates a tremendous false sense of security, because in reality, historical survival rates for out-of-hospital cardiac arrest have hovered around like 10%.
Wow, 10%.
Yeah, and in some communities, it's even lower than that.
A 10% survival rate in the real world versus a 75% survival rate on television. And for you listening, that gap is exactly why understanding the mechanics of CPR matters so much.
It really does.
Subsequent research has actually shown that this massive distortion in expectation alters real-world end-of-life decisions. Because if you go through life believing CPR is this magic guaranteed reset button, you make very different medical choices for yourself or, your aging family members than if you understand the clinical reality of what it actually is.
Definitely. And to understand what CPR actually is, we have to start by clearing up the single most common misconception about the human heart. We basically have to separate the plumbing from the electrical.
Okay, let's unpack this. Because people use the terms heart attack and cardiac arrest interchangeably in casual conversation all the time. I mean, I know I've done it.
Oh, everyone does it.
Yeah.
It happens constantly, even in news reports.
We talk about them as if they're the exact same medical event.
Right, but medically, they are entirely different crises. A myocardial infarction, which is a heart attack, is it's fundamentally a plumbing problem.
Like a clogged pipe.
A literal blockage, yes. It's a blockage in the coronary arteries, the blood vessels that supply oxygen to the heart muscle itself.
Yeah.
Blood can't get through, so a section of the heart muscle begins to starve and die.
Which I imagine is incredibly painful.
Extremely. But during a classic heart attack, the heart is usually still beating. It's still pumping blood to the brain.
Yeah.
And the rest of the body, it's doing so less effectively, and tissue damage is occurring.
So the plumbing is backed up, but the machine is still running.
Exactly. Sudden cardiac arrest, on the other hand, is an electrical problem. The heart's internal pacemaker and electrical signaling system completely malfunction.
Like a short circuit.
Pretty much. Often the lower chambers of the heart start quivering chaotically instead of contracting in a coordinated rhythmic way. That specific erratic rhythm is called ventricular fibrillation, or VFib.
Yeah, fib. Okay.
And when the heart is in VFib, it is pumping absolutely zero blood. The engine hasn't just sputtered, it is completely seized up.
Okay, I want to make sure I'm visualizing this correctly. If cardiac arrest is an electrical issue where the pump has completely seized, what is pushing on the chest actually accomplishing?
That's the big question.
Because the myth is that pushing hard enough shocks the heart back into a normal rhythm. But if it's an electrical short circuit, mechanical pumping shouldn't fix that. Let me try an analogy here.
Go for it.
Let's say you have a gasoline engine, like a lawnmower, and the spark plug completely dies. Pumping that little rubber fuel primer bulb over and over isn't going to fix a broken spark plug.
No, it won't.
But manually squeezing that bulb does keep fuel pressurized in the lines, right? So that the engine doesn't completely dry out and ruin the carburetor while you wait for someone to bring a new spark plug.
That is a highly accurate way to look at it, actually.
Yeah.
You're maintaining the internal pressure of the system. And that highlights the central medical reality that most people misunderstand. CPR does not restart the heart.
Wait, it doesn't restart the heart at all?
Almost never. It almost never converts a lethal rhythm like VFib back to a normal sinus rhythm on its own.
That is a huge paradigm shift.
It's a profound shift in understanding. What CPR does is buy time. When the heart stops pumping, brain cells begin dying within 4 to 6 minutes due to a lack of oxygen.
Just 4 minutes. Wow.
Right. So what you're doing when you perform chest compressions is acting as an external manual pump. You are physically squeezing the heart between the sternum and the spine.
Ouch.
Yeah. And by doing that, you alter the pressure inside the chest cavity to force whatever oxygenated blood is left in the system up the carotid arteries and into the brain. You're delaying irreversible cell death.
So you are a bridge.
You are the literal bridge to the mechanic with the spark plug. And in this scenario, the mechanic is an automated external defibrillator, or an AED.
The machine that shocks them?
Exactly. The defibrillator is what delivers the massive electrical shock to stop the quivering and reset that chaotic rhythm. But here's the catch. The defibrillator will not work if the heart tissue has been starved of oxygen for too long and is already dead.
Ah, I see.
So CPR preserves the heart tissue and the brain, so the shock actually has a chance to work.
Knowing that CPR is essentially just a mechanical pumping action to preserve pressure, you'd think humans would have figured this out centuries ago, but the origin story of modern CPR in these sources is wild.
Oh, it really is.
It's bizarrely recent, and it was pieced together like this medical Frankenstein's monster over just a few years in the mid-20th century.
Yeah, up until the 1950s, resuscitation was this chaotic mix of very ineffective methods. Before modern CPR, they relied on things like the back pressure arm lift method, where responders would literally just push on a victim's back and lift their arms up and down.
Which sounds like aggressive physical therapy, not a way to save someone from dying.
Right. It moved a tiny bit of air, but it was incredibly ineffective. The turning point came in pieces. The breathing half of CPR, the mouth-to-mouth component, came first.
Okay, how did that happen?
Well, in the late 1940s, an American physician named James Elan made this radical proposition. At the time, prevailing medical wisdom dictated that the air you exhaled from your lungs was entirely waste-like, mostly carbon dioxide.
Which makes intuitive sense.
It does, but Elam demonstrated that exhaled air actually contained about 16 to 17% oxygen.
And since normal room air is about 21% oxygen, 16% is still plenty to sustain life. We simply don't absorb all the oxygen we breathe in.
Exactly. He realized that. And to prove it, he didn't just run theoretical models. He tested it by blowing his own exhaled air into anesthetized patients to keep their oxygen saturation up.
Wow, just directly into patients.
Yeah, and he even self-experimented in front of deeply skeptical colleagues. He proved the physiological concept. A few years later, in the mid-1950s, he partnered with an anesthesiologist named Peter Safar at Baltimore City Hospital.
Safar is a big name in this, right?
Huge. Safar took it a step further to definitively prove mouth-to-mouth was superior to those old arm-lifting techniques. And the way he proved it was quite extreme by today's standards.
A paralyzing thing.
Yes, he systematically paralyzed human volunteers.
He paralyzed them on purpose.
Yeah, he administered Curare, which is a paralyzing agent, to healthy volunteers, often his own colleagues, actually, to completely suppress their ability to breathe.
That is insane, just casually paralyzing your coworkers for mid-century medical trials.
It was a very different era of research, for sure. But then he had rescuers try to keep them oxygenated using the old manual back pressure methods versus mouth-to-mouth.
And I'm guessing mouth-to-mouth worked better.
The results were undeniable. Mouth-to-mouth won decisively. Safar published these findings, and in 1957 he actually coined the famous ABC mnemonic airway, breathing, circulation, in a manual called the ABC of resuscitation.
So that solved the breathing half. But the compression half, the actual violent pumping of the chest, that didn't come until 1960 at Johns Hopkins. And it sounds like it was basically a complete accident.
It was an accidental observation by an engineer named William Cowenhoven, who was working with a surgery resident named Guy Knickerbocker and a cardiologist named James Jude.
So what were they trying to do?
Well, before 1960, if a patient's heart stopped, the standard of care was open chest cardiac massage. A surgeon would literally take a scalpel, crack the chest open, reach their hands inside the cavity, and squeeze the heart manually.
Oh my God. Which obviously requires a highly sterile operating room and, a surgeon. You cannot do that on a sidewalk outside a grocery store.
No, nor should you try. But Knickerbocker was running experiments on dogs, pressing very heavy external defibrillator paddles onto a dog's chest.
Okay.
And he noticed, purely by observation, that simply pressing down heavily on the chest wall caused the dog's blood pressure to temporarily spike.
So he was accidentally squeezing the internal pump without having to actually open the chest to get to it.
Exactly. He was altering the intrathoracic pressure. They realized that rhythmic, deep, external compression of the sternum could effectively circulate blood.
That's incredible.
They published a landmark paper in the Journal of the American Medical Association in 1960 called Closed Chest Cardiac Massage. Suddenly, you didn't need a scalpel to keep someone alive. Safar, Jude, and Cowenhoven ultimately combined the breathing and the compressions into the unified technique we now know as CPR.
And to train the public on this new unified Frankenstein technique, they realized they needed a dummy, which introduces, honestly, one of the most uncanny, haunting details in this whole stack of research.
The face.
Yes. In 1960, a Norwegian toy maker named Osmund Lærdal was hired to build a lifelike training mannequin. He created Rasushi Ann. But for the face of this mannequin, he used a mold of a famous Parisian death mask known as L'Inconnue de la Seine, the unknown woman of the Seine.
Right.
It was supposedly cast from the face of a young woman who drowned in the river in the 1880s.
It is a remarkable piece of history. Because of that choice, for decades, millions of people around the world have learned how to save a life by pressing their lips against the death mask of an anonymous 19th century drowning victim.
That is so wild.
She's often called the most kissed face in history.
It is beautiful and intensely creepy all at once. But it worked. I mean, the dummy allowed mass training. So they had the technique and they had the training tool. But having a medical technique doesn't save lives if you can't get it to the person before their brain dies.
Exactly. If we connect this to the bigger picture, creating the technique was only half the battle. That localized medical discovery had to be turned into a massive public health strategy.
Right, a system.
Yes. In 1991, researchers formalized decades of EMS data into a framework the American Heart Association called the chain of survival. The idea is that out-of-hospital survival relies on a sequence of events, and it's only as strong as its weakest link.
The original links were early recognition and calling 911, early CPR, early defibrillation, and then early advanced life support by paramedics, right?
Yes, and it has evolved. In 2015, they expanded the chain to recognize that post-cardiac arrest care in the hospital is just as critical. They added a link for things like targeted temperature management.
I saw that in the notes and wanted to ask about it. Why do they cool the patient's body down after they finally get the heart restarted? That seems totally counterintuitive.
It addresses something called reperfusion injury. Think of it like this. When brain cells are starved of oxygen during cardiac arrest, they become incredibly fragile.
Okay.
If you suddenly restart the heart and blast those fragile, starving cells with a massive rush of oxygen-rich blood, it paradoxically causes a massive inflammatory response.
Like shocking the system too hard.
Exactly. It's like throwing gasoline on smoldering embers. The brain swells, which causes severe damage. So by lowering the patient's core body temperature, doctors slow down the brain's metabolism. They are essentially putting out the inflammatory fire to protect the neurological function while the cells recover.
Okay, that makes perfect sense. Cooling the engine so it doesn't overheat when you turn it back on. But the true power of this chain of survival really relies on those first few links recognitions, CPR, and the shock happening almost instantly.
The data on this is staggering, honestly. When we look at environments where the response time is essentially zero, the survival rates completely transform. A famous study from the year 2000 by Terence Valenzuela looked at cardiac arrest inside Las Vegas casinos.
Because casinos are basically the ultimate surveillance state. I mean, they have cameras on every square inch of the floor, and they have roaming security everywhere.
There are absolutely no blind spots. If someone collapses at a slot machine, security knows instantly. In this study, the casino security guards were heavily trained in CPR and equipped with AEDs.
And what were the results?
The data showed that when a patron collapsed in sudden cardiac arrest, and the guards delivered a defibrillator shock within 3 minutes of that collapse, 53% of those patients survived to be discharged from the hospital.
53%. When the national average out in the real world was hovering around 10%. That is a massive jump.
It completely proves that the system works if you eliminate the time delay between the collapse and the shock.
It fundamentally changes the math. And we see similar evidence at the city level too, right? Seattle's Medic One program.
Yes. Started in the 1970s by cardiologist Leonard Cobb, he paired a highly trained paramedic system with a massive citizen training initiative called Medic 2.
Where they trained regular people?
Right, they trained over 100,000 ordinary residents in CPR. The result was that if you collapsed in Seattle, there was a massive statistical probability that a random person next to you would start compressions immediately, bridging the gap until paramedics arrived.
Seattle became famous as the best place in the world to have a cardiac arrest.
Yeah.
But how do we know their numbers were actually better than anywhere else?
That is because of the Utstein style. Before 1990, comparing survival rates between cities was completely impossible. Well, different cities defined cardiac arrest differently. They started the clock at different times, and they measured survival differently.
Oh, so the data was just a mess.
Exactly. But a consensus conference at Utstein Abbey in Norway created a standardized template for reporting resuscitation data worldwide. That allowed researchers to definitively isolate bystander intervention as the primary variable changing outcomes.
Because the math of survival is just brutal. The sources show that every single minute that goes by without fibrillation, the chance of survival drops by 7 to 10%.
When no CPR is being performed, yes. The VFib rhythm degrades, the cells starve, the brain dies. But here is the critical detail. If a bystander is performing high-quality CPR, that drop in survival slows down to just 3 to 4% per minute.
So you are literally buying time. You're slowing down the clock of cell death.
Exactly.
But if this system was working so well and the ABC method from Peter Safar was the gold standard for 50 years, why did the American Heart Association completely overhaul the rules in the 2000s?
It was a big shift.
Yeah, because in 2010, they flip it from ABC to CAB compressions first, airway and breathing last.
This raises an important question about human behavior. The shift to CAB was driven by failure analysis. Researchers realized that the ABC sequence was creating dangerous hesitation.
Like people freezing up.
Yes, lay people, and even some professionals, were wasting critical time trying to tilt the head, open an airway, or struggling to get a good seal to deliver a breath before they ever started pumping the chest.
Or they were just terrified of catching a disease from a stranger.
The psychological barrier was immense. The data showed that bystanders often refused to perform mouth-to-mouth on a stranger, which meant they did nothing at all.
Wow, so they just let them die because of that fear.
The fear of doing it wrong, or the physical aversion to the breathing component, was paralyzing people. So flipping it to compressions, airway, breathing, prioritized the most vital action pushing blood to brain and empowered people to act immediately.
Wait, I'm struggling with this. For decades, we were told that getting oxygen into the lungs was the absolute most important part of staying alive. Are we saying that doing zero breathing is actually medically superior?
It's a valid question.
Or is hands-only CPR just a dumbed-down compromise for squeamish bystanders? Are we accepting a medically inferior technique just to get people to do something instead of nothing?
That is the exact debate the medical community had. But the answer is no, it's not a compromise. For sudden, witnessed adult cardiac arrest, hands-only CPR is medically justified and in many cases superior in the first few minutes.
Really?
Yes. A cardiologist named Gordon Huey at the University of Arizona championed this. He called it cardiocerebral resuscitation, focusing entirely on the heart, and the brain.
So how can zero breathing be better for the brain?
It comes down to hemodynamics. Dr. Yui argued that when a healthy adult suddenly collapses, their blood and lungs already have residual oxygen in them.
Because they were just breathing normally right before it happened?
Exactly. The problem isn't a lack of oxygen. The problem is that the oxygen isn't moving. Building up blood pressure with manual compressions is incredibly difficult. Think of it like pushing a heavy boulder up a steep hill.
Okay.
You have to push several times just to get the coronary perfusion pressure high enough to force blood into the tiny vessels of the brain.
So you were building momentum.
Yes. And Dr. Yui's research showed that the moment you pause compressions to stop and give a rescue breath, you let go of the boulder. The blood pressure instantly drops to zero.
Oh, man, so the boulder rolls all the way back to the bottom of
It
there?
rolls all the way back down, and then it takes several more compressions just to get it back to where it was. The argument was that the harm caused by stopping blood flow to give a breath is actually far greater than the benefit of the breath itself during those first few crucial minutes.
Wow.
Because of this, in 2008, the AHA formally endorsed hands-only CPR, just continuous compressions, for untrained bystanders witnessing an adult collapse.
The blood already has the oxygen, you just need to keep the cargo train moving. That makes a lot of sense. But there are exceptions to this, right?
Yes, a critical caveat. This does not apply to children or to victims of drowning or drug overdoses.
Because those arrests are caused by a lack of oxygen in the first place, not a sudden electrical short circuit, they desperately need the air.
Exactly. Those are respiratory arrests first, which eventually lead to cardiac arrest. The oxygen tank is empty. So for kids, drowning and overdoses, conventional CPR with rescue breaths is still the absolute standard. But for an adult who suddenly grabs their chest and drops, you just push hard and fast in the center of the chest.
Here's where it gets really interesting, because the AHA didn't just change the rules. They had to market this to the general public. They had to teach ordinary people the correct speed to push that boulder up the hill without a medical degree. The optimal target is 100 to 120 compressions per minute.
Which is incredibly fast and physically exhausting.
But the AHA promoted this brilliant viral mnemonic do compressions to the beat of the Bee Gees song Stayin' Alive. The song literally clocks in at about 103 beats per minute, putting you perfectly in that target zone to maintain that blood pressure.
It's genius marketing.
But even with the catchy rhythm and the removal of the mouth-to-mouth requirement, there are still major fears that hold people back.
Yeah.
Two specifically stand out in the literature. First, the fear of causing physical injury. People think, what if I push too hard and crack their ribs?
Right. And the clinical reality is you probably will.
Really?
Yeah. Rib fractures and cartilage separation are common and entirely expected when you are performing adequately deep compressions on an adult. The chest needs to be compressed at least 2 inches to squeeze that internal pump.
That's a lot of force.
It is. If ribs break, it is not a sign that you're doing it wrong. It's an acceptable, necessary cost of keeping the brain alive.
The alternative to a broken rib is death. I think most people would happily take the broken rib. And the second fear is legal liability. People are terrified of being sued if they break those ribs or fail to save the person.
And the sources address this very clearly. Good Samaritan laws in the U.S. and in many other countries specifically protect bystanders who step in to give reasonable emergency aid in good faith. You are legally protected from civil liability when you try to help.
Which brings us to the ultimate takeaway from all of this data, all of these historical shifts, and all of these physiological mechanics. Cardiac arrest is a disease governed by a strict, merciless dose-response curve.
Merciless is the right word.
Every second of delay has a measurable, irreversible negative impact on cell survival. The biggest lever we have to improve national survival statistics isn't a new drug, and it isn't an advanced hospital machine.
No, it's the bystander. It is the untrained person who recognizes what is happening, refuses to hesitate, and starts compressions to keep that pressure up.
So what does this all mean for you listening right now? It means rethinking who you are actually learning this skill for. The overwhelming majority of out-of-hospital cardiac arrests do not happen in an airport terminal or on a sidewalk surrounded by strangers.
That's a great point.
They happen at home. If you are ever called upon to do this, you likely won't be doing it for a stranger. You will be doing it for a family member, a spouse, or a parent. You are the first link in that chain.
You are the bridge.
But it does leave us with a fascinating, slightly provocative thought to chew on. We started this deep dive talking about how Hollywood distorts our view of reality, creating these perfect, instantaneous saves in hospital rooms.
Right.
But then we looked at the Las Vegas casino data. 53% survival when an AED is applied within 3 minutes by a roaming guard.
An incredible statistic.
If we know that mass public AEDs and instant surveillance work in casinos and airports, but the overwhelming majority of fatal cardiac arrests happen in our homes, how should that change the way we live?
That's an excellent question.
As we design the smart home technology and residential neighborhoods of the future, how do we bring that casino-level response time straight into our living rooms? Because if every second counts, our homes are currently the weakest link in the chain.
It's a critical question for the future of public health and urban design, really.
Something to mull over the next time you watch medical drama. Thanks for joining us on this deep dive. We'll catch you next time.
So if you take a standard aspirin right now, your body will, it'll flush it completely out of your bloodstream in about 20 minutes.
Right, 20 minutes.
And this is the crazy part, that single pill will physically alter your blood cells for the next 10 days.
Yeah, it's wild to think about.
And then on the flip side, you have a potent painkiller like methadone. It might stop relieving your pain after just like 6 hours, but it secretly lingers in your body for days.
Which is a huge hidden mismatch.
A mismatch that has actually fueled a major public health crisis. I mean, we take these instructions on our pill bottles totally for granted, right? You know, take once a day, take every 4 hours.
We just blindly follow the label.
Exactly. But those simple labels are hiding this really complex, invisible world of mathematical decay.
Yeah, and it is entirely invisible to the patient. But understanding that underlying math isn't just academic trivia for nursing or medical students to memorize for some exam. It is the quantitative backbone of safe medication. Whether we're calculating insulin schedules, setting antibiotic dosing intervals, or, trying to figure out why missing a dose of one drug is a non-event.
Well, missing another is like a total medical emergency.
Exactly. It all comes back to a concept called drug half-life. And, well, knowledge is most valuable when it's understood and applied. And today we're looking at how clinicians actually apply this math to keep you safe.
Yeah, we've got a fascinating stack of clinical pharmacology notes, historical medical papers, and pharmacokinetic research right in front of us. And the mission for this deep dive is to demystify those numbers on the side of your pill bottle.
Absolutely.
We're going to explore steady states, dosing intervals, and really why timing a dose is quite literally everything. So, okay, let's unpack this, because before we can understand how drugs work in your body, we actually have to look at where this concept even came from.
Yeah, the history is super interesting.
Right, because looking at the sources, it apparently wasn't even cooked up in a pharmacy.
No, not at all. The origins actually lie in early 20th century physics, specifically the study of radioactivity.
Wait, radioactivity, like glowing green rocks.
Well, yeah. I mean, if you look at the research of Ernest Rutherford and Frederick Soddy around like 1902 to 1907, they were studying how radioactive isotopes decay over time.
Okay.
And they were the ones who first defined the concept of a half-life, or T1/2, as you'll often see it written in clinical math.
Which sounds completely unrelated to, swallowing a Tylenol for a headache.
Yeah.
How did we jump from glowing uranium to pain relief?
Well, exactly how radioactive elements decay turns out to be the exact same mathematical model for how your body eliminates most foreign substances.
Seriously?
Yeah. Rutherford and Soddy basically discovered exponential decay. So the core definition of a drug's half-life is simply the time required for the concentration of a drug in the blood plasma to fall by 50%.
Okay, so just having it.
Right. If the mathematical curve for a radioactive isotope decaying in a lab looks like a clean downward exponential slope, well, the curve of a drug clearing from your bloodstream looks mathematically identical.
So let me make sure I've got this. If I have like 100 milligrams per liter of a drug floating in my bloodstream and its half-life is 4 hours.
Yep.
I'm just having that number every 4 hours.
Yeah.
Like at hour 4, I'm down to 50 milligrams.
Yeah, exactly.
And then at hour 8, I'm at 25 milligrams, then 12.5, then 6.25, and it just keeps dropping by half.
That is the fundamental mechanism, yeah. But translating that physics equation into human biology, that actually required a massive conceptual leap.
I bet.
We really owe that to a Swedish physiologist named Torsten Terrell.
Right.
So in 1937, Terrell published this 2-part paper that radically reframed how we even think about medicine.
How so?
Well, before his work, the medical community's primary question was totally binary. Just, does this drug work?
Simple enough.
Right. But Terrell shifted the paradigm entirely by asking, where is this drug, quantitatively, at every single moment after it enters the body?
Oh, wow. which is such a brilliant shift in perspective.
Yeah.
But the sources actually note his work was largely ignored for decades. Why wouldn't doctors jump all over this?
I mean, the sheer complexity of the math was a massive barrier.
Oh, because they didn't have computers?
Exactly. TRL was building these intricate mathematical compartment models to track the drugs movement, and he was doing the matrix calculus by hand.
Yikes.
Yeah, decades before computers were available to run those simulations, he fundamentally changed the model of the human body from like a static vessel to a highly dynamic system.
And there was another guy too, right? Widmark.
Oh yeah, Eric Widmark, another Swedish scientist, a chemist. He was actually doing similar mathematical modeling for blood alcohol concentrations even earlier in the 1910s and 20s.
That's fascinating.
And Widmark's equations are still used by forensic toxicologists today. But TRL was really the one who formalized the idea of the body as a system of interconnected tanks.
I really love that visual because we so often think of our bodies as just a single bucket. You know, you swallow a pill, it drops into the bucket, the water sloshes around, and eventually the bucket empties.
Right, the bucket model.
But Tyrrell is saying, no, you are a complex plumbing system. You've got the stomach tank flowing into the blood tank, which then leaks into the fat tissue tank, which filters through the liver and kidney tanks. And each of those pipes has a completely different flow rate.
It's a great analogy. That interconnected plumbing system is the very foundation of what we now call pharmacokinetics, which researchers like Gerhard Levy and Milo Gibaldi finally brought to the bedside in the 60s and 70s.
Okay, but, and tell me if I'm wrong here. If I'm an ICU nurse juggling 5 different patients, I am absolutely not doing natural logarithms by hand at the bedside.
Definitely not.
Right, I'm not calculating when a drug will clear from my patient's blood tank with a matrix.
Yeah.
So how is this actually applied in the real world without a graphing calculator?
Clinicians actually rely on a foundational shortcut called the rule of 5.
The rule of 5.
Yeah. It is the single most clinically useful application of all this exponential math. The rule of 5 basically states that it takes roughly 5 half-lives for a drug to reach what we call steady state during continuous dosing.
Okay.
Or, conversely, to be effectively eliminated from the body after you completely stop taking it.
Let's walk through that because, I don't know, 5 feels like an arbitrary number. Why not 3 half-lives or 10?
It comes down to where that exponential curve flattens out into clinical insignificance. So, as we established, after 1 half-life, you have 50% of the drug remaining.
Right.
After 2, you have 25%. After 3, 12.5%.
The halving math again?
Exactly. By the time you reach the 4th half-life, you're down to 6.25%, and at the 5th, you're at 3.125%.
Oh, okay.
At that point, roughly 97% of the drug has been cleared. And for the vast majority of clinical applications, that remaining 3% is functionally negligible. The body has effectively eliminated it.
And the sources say this same rule of 5 applies in reverse. Like when you are trying to build a drug up in your system.
Yes, the math completely mirrors itself. When you take a medication repeatedly at a fixed interval, the concentration in your blood doesn't just keep climbing infinitely, right?
Unless you're overdosing.
Well, yes, but at a normal dosage, it rises toward a plateau. That plateau is the steady state. It's the point where the amount of drug you're putting in exactly equals the amount your body's eliminating during that same time frame.
Got it.
And because of that exponential math, it takes about 5 half-lives of regular dosing to reach that steady state plateau.
Wait, I have to push back on this because it feels completely counterintuitive.
How so?
Well, if I want to get to that steady state plateau faster, can't I just take a much bigger dose?
Yeah.
Like if my doctor says take 10 milligrams a day and I double it to 20, shouldn't I hit the plateau in half the time?
That is a super common misconception, actually, but the math doesn't support it at all. Yeah. A larger dose does not reach steady state faster. It merely reaches a higher steady state.
Oh, wow.
So if you double the dose, your blood concentration will ultimately plateau at a higher level, but it will still take exactly 5 half-lives to get to that new, higher plateau. The time to steady state is entirely governed by the drug's half-life, completely independent of the dose size.
Okay, but wait. If a drug has a really long half-life, and it always takes 5 half-lives to reach a therapeutic steady state, isn't the patient just suffering in the meantime?
That's the real problem.
Yeah. Because if I have a serious condition today, I do not want to wait a week for my medicine to finally reach the effective level.
This raises a really important clinical question, and it's precisely why clinicians utilize what are called loading doses.
Loading doses.
Right. The sources highlight digoxin as a prime example of this. Digoxin is a medication used to treat heart failure and irregular heartbeats. And in a patient with normal kidney function, its half-life is roughly 36 hours.
36 hours. Let me do the rule of 5 math on that really quick. 36 hours times 5 half-lives. That's 180 hours.
Yep.
That's 7.5 days.
Which is completely unacceptable for a patient experiencing acute heart failure symptoms.
Right.
If a physician just prescribed standard daily doses, that patient would be waiting over a week for the drug to slowly climb that exponential curve just to reach a therapeutic steady state.
So what do?
To bypass this, clinicians administer a large loading dose upfront. This massive initial dose basically front-loads the body. It instantly forces the blood concentration up to the therapeutic plateau on day 1.
That makes sense.
And then from then on, the patient just takes smaller maintenance doses. And those are mathematically calculated to replace exactly whatever the body eliminated over the past 24 hours, keeping them perfectly balanced on that steady state plateau.
Okay, that makes perfect sense for getting the drug into the system.
Mm-hmm.
But the sources highlight this really terrifying scenario where this exact same math can silently change and cause major harm. So digoxin is cleared almost entirely by the kidneys, right? What actually happens if that patient suddenly gets a severe kidney infection or an acute kidney injury?
Well, the foundational math just collapses. If the kidneys lose their filtering efficiency, digoxin isn't excreted at the normal rate anymore. Its half-life stretches from 36 hours to somewhere between 3.5 and 5 days.
Oh, wow. So the patient's internal clock just slowed way down.
Exactly. And this is where it becomes a literal matter of life and death. The maintenance dose hasn't changed. The patient is still taking the exact same daily pill that was perfectly safe last week.
But the body isn't clearing it.
Right. Because the half-life has drastically lengthened, the body is no longer clinching the daily input, the steady state is totally lost, the drug begins to accumulate slowly and silently climbing toward toxicity.
All because the underlying physiological decay rate changed.
Exactly.
That is wild to think about. The danger is completely invisible to the patient.
Yeah.
But here's where it gets really interesting, though.
Oh, yeah.
The rule of 5 works beautifully, assuming the drug actually follows these exponential rules. But the sources point out that some drugs are absolute rule breakers.
Very true. The clean exponential decay we've been discussing assumes the drug follows what we call first-order kinetics, meaning a constant fraction of the drug is eliminated over time, always 50% per half-life.
Right.
But there is a rebel category of substances that follow zero-order kinetics.
Zero-order kinetics. And the sources say this means instead of a constant fraction being cleared, the body clears a constant amount per hour, regardless of how much is in the system.
Exactly.
Which perfectly explains the classic drinking myth. People think they can just drink a pot of coffee or take a cold shower to sober up faster after a heavy night out.
Yeah, that doesn't work. Ethanol, or alcohol, is the quintessential zero-order kinetic substance. To understand why you can't just speed it up, you have to look at the actual cellular mechanism.
Okay.
So your liver uses specific enzymes, primarily alcohol dehydrogenase, to metabolize ethanol. But there is a finite number of these enzyme molecules.
Right.
Once they are all actively processing alcohol, the system is fully saturated. It is operating at absolute maximum capacity.
It's like a toll booth on a highway.
Yeah.
If the toll booth can only process, say, 1 car per minute, it doesn't matter if there are 2 cars in line or 200 cars in line.
Mm-hmm.
The throughput is a flat, constant rate. The heavy drinker just has to wait in line.
That analogy perfectly captures the bottleneck. Because the elimination rate is a flat, say, roughly 1 standard drink per hour rather than a percentage, the concept of a fixed half-life doesn't even exist for ethanol.
It makes total sense.
The time it takes to have your blood alcohol concentration changes wildly depending on your starting level. And alcohol isn't alone in this. High-dose aspirin and the anti-seizure medication phenytoin also follow zero-order kinetics.
Oh, wow.
Which is why a neurologist has to be incredibly careful adjusting phenytoin doses. A tiny increase in the dose can suddenly overwhelm the liver's enzymes, backing up the toll booth instantly and causing massive toxicity.
And it isn't just about how the drug is cleared, right? It's also about where the drug decides to hide. This brings us back to Terrell's interconnected plumbing system.
Right, the multi-compartment model.
Drugs don't just hang out in the bloodstream waiting to be filtered. They distribute through the body in phases. which the sources call multi-compartment kinetics.
Yeah, when a drug first enters the bloodstream, we typically see a very rapid drop in blood concentration, but this isn't elimination. This is distribution.
Okay.
The drug is moving out of the blood and permeating into tissues and organs. We call this the alpha phase. Once the drug has settled into those tissue compartments, we enter the beta phase, or the terminal elimination phase.
And that's when the liver and kidneys kick in.
Exactly, where they actually start removing the drug from the entire system.
Wait, so when I look up the official half-life of a drug in a medical textbook, which phase am I actually looking at?
You are almost always looking at the terminal beta phase.
Yeah.
However, that single number can drastically understate a drug's persistence in the human body, particularly if we are dealing with a lipophilic drug.
Lipophilic, meaning fat-loving.
Correct. Lipophilic drugs are highly fat-soluble. They easily slip across cell membranes and pack themselves into your adipose or fat tissue.
So they just sort of camp out there.
Yeah, and blood flow to fat tissue is relatively low compared to major organs like the heart or brain. So once a lipophilic drug gets into the fat, it essentially gets locked in a physiological vault.
A volt.
Amiodarone, which is a powerful antiarrhythmic drug used for irregular heartbeats, is a notorious example of this. Because it accumulates so heavily in fat vaults, its terminal half-life isn't measured in hours. It is measured in weeks and sometimes months.
Months? You mean a single dose takes months to clear?
Oh, yes. A patient who has been taking amiodarone and then stops can have detectable levels of the drug and remain at risk for its toxic side effects for up to 100 days after their final dose.
That's horrifying.
The drug just slowly and continuously leaks out of the fat tissue back into the bloodstream. If a patient develops, say, pulmonary toxicity from the drug or needs to stop it prior to a major surgery, the medical team is dealing with a substance that effectively refuses to leave the premises.
So asking what is the half-life and asking how long do I need to worry about this drug are two entirely different questions.
They require completely different clinical mindsets.
So amiodarone proves that a drug can physically linger in your body long after you stop taking it. But there's an even more dangerous scenario in the sources. What happens when the drug is physically gone, but the effect remains?
Oh, yes. To understand this, we have to separate two foundational concepts in pharmacology: pharmacokinetics and pharmacodynamics.
Okay.
Pharmacokinetics is everything we've been discussing, what the body does to the drug, how it absorbs, distributes, and eliminates it. Pharmacodynamics is what the drug does to the body, the actual physiological change or clinical effect it triggers.
And these two timelines can diverge.
In extraordinary ways.
Okay, this is the aspirin paradox I mentioned at the very beginning of the show. The sources say aspirin's plasma half-life was only 15 to 20 minutes.
Right.
Following our rule of 5, the drug itself is effectively eliminated from the blood in an hour or two. Yet, it prevents your blood from clotting normally for a week to 10 days.
Yep.
If the drug is physically gone from my blood in 20 minutes, how on earth is it still working a week later? Where is it hiding?
It isn't hiding at all. The drug really is gone. The prolonged effect is due to the specific mechanism of action it deployed during the brief 20 minutes it was actually present.
Okay.
Aspirin permanently inactivates an enzyme called COX-1 inside your blood platelets.
Wait, it permanently breaks the enzyme?
Yes, the inhibition is irreversible. And because platelets lack cell nucleus and DNA, they cannot synthesize new COX-1 enzymes to replace the broken ones.
So they're just useless.
Those specific platelets are permanently impaired from clotting for the rest of their natural lifespan, which happens to be about 7 to 10 days.
It's less like a lingering guest in your house, and more like someone who walked by, threw a rock through your living room window, and immediately ran away.
I love that.
The drug is completely gone in seconds, but the broken window remains until your body physically builds a new one.
That is an excellent way to visualize irreversible enzyme inhibition. But if we connect this to the bigger picture, this mismatch between a drug's physical presence and its clinical effect isn't always a convenient feature.
It can be bad.
It can be profoundly dangerous. U.S. public health agencies have flagged this exact pharmacokinetic-pharmacodynamic mismatch as a key driver of the opioid overdose crisis, specifically regarding methadone.
How does the mismatch work with methadone? I know it's used for severe pain and opioid use disorder, but why is the timing so deadly?
It comes down to the patient's subjective experience versus the objective math. Methadone's analgesic effect, the actual pain relief the patient feels, lasts only about 4 to 8 hours.
Okay, but what is its elimination half-life? Like, how long is the drug actually in the blood tank?
The elimination half-life is highly variable, but it ranges anywhere from 8 to 59 hours.
Oh, no. I see where this is going.
Imagine a patient managing chronic pain. After 6 hours, the pain relief wears off. They are hurting, so they assume the drug is gone and they take another dose.
Naturally.
6 hours later, the pain returns, they take a third dose. But because the physical elimination half-life can be up to 59 hours, the body hasn't even come close to clearing that very first dose.
They're just stacking new doses on top of a rising mountain of the drug in their bloodstream.
Precisely. They are unknowingly driving their plasma concentration higher and higher. The pain relief is gone, so their brain tells them the drug is gone, but the physical chemical is accumulating, silently pushing them toward the threshold of respiratory depression.
That's terrifying.
Patients and sometimes even prescribers fail to account for the fact that the drug's physical mass is still heavily present long after the clinical relief has faded.
That is incredibly tragic. But it really crystallizes why clinicians have to understand this math at a deep level. It's not just numbers on a page, it's human behavior interacting with invisible decay rates.
Absolutely.
Now, because this half-life number can be so misleading, there are intense, high-stakes debates happening right now in intensive care units about how to even measure it.
Yes, particularly in anesthesiology. In 1992, researchers Hughes, Glass, and Jacobs published a landmark paper introducing a concept called context-sensitive half-time.
Context-sensitive half-time, meaning the half-life literally changes depending on the context of how you give it.
Specifically how long you give it. They were studying continuous intravenous infusions, which are standard during long surgical procedures.
Like an IV drip.
Right. And they found that for certain lipophilic drugs, like the opioid fentanyl, the effective half-life actually lengthens the longer the IV drip runs.
Wait, how does running an IV longer change the drug's decay rate? Does the liver just get exhausted from processing it?
It goes right back to Terrell's interconnected tanks. When you start an IV infusion, the drug fills the blood tank and begins flowing into the peripheral tissue tanks, like muscle and fat.
Yeah.
If it's a short procedure, you turn off the IV, the blood level drops, and the patient wakes up. But if you run that continuous infusion for 6 or 8 hours, you eventually saturate those peripheral tissues. They are completely full.
So what happens when you finally turn off the IV after 8 hours?
The concentration of the drug in the blood drops rapidly, but now, because the peripheral tissues are fully saturated, a massive concentration gradient is created.
Meaning?
The drug begins flowing backward, it leaks out of the fat and muscle tissues and back into the bloodstream.
Oh, wow.
These saturated tissues basically act as a slow-release internal reservoir, artificially sustaining the drug levels in the blood. So, after a brief infusion, fentanyl clears very quickly. But after a prolonged infusion, its effective half-time can actually become significantly longer than a drug like morphine.
Which completely blows up the standard drug chart. I mean, a textbook might say fentanyl is short-acting, but in the context of an 8-hour surgery, it suddenly acts like a long-acting drug.
And this realization revolutionized how anesthesiologists choose between different drugs for prolonged procedures. It also ties directly into how we monitor patients in the ICU, a practice known as therapeutic drug monitoring, or TDM.
TDM, right.
For drugs with a very narrow therapeutic index, meaning the margin between a safe dose and a toxic dose is incredibly thin, like the antibiotic vancomycin or the psychiatric medication lithium, we have to draw the patient's blood to physically check the concentration.
But based on everything we've talked about, the timing of that blood draw has to be mathematically perfect.
The timing is everything. Clinicians typically want to measure the trough level, which is the lowest concentration of the drug in the blood, drawn immediately before the next dose is administered.
Okay.
But a common critical error is drawing that trough level too early, before 5 half-lives have passed and steady state has actually been achieved.
Because if you haven't hit the 5th half-life, the patient is still climbing the curve. The plateau hasn't leveled out yet.
Exactly. The number you get from the lab might look reassuringly low, but it's a phantom number. It doesn't represent the true steady state.
So the doctor might increase the dose.
Right. And if a physician increases a dose based on that premature, falsely low number, they could push the patient directly into toxicity once the true steady state finally arrives.
So what does this all mean for you, listening to this right now? Well, it means this complex, invisible math governs your everyday life and your everyday safety.
It really does.
If you were ever told by a surgeon to stop taking your blood thinner, like a Pixaban, exactly 3 days before a scheduled procedure, you now know that isn't a random guess.
No, not at all.
That is a clinician doing a rule of 5 calculation on your behalf to guarantee your blood will clot normally when the scalpel hits.
It also explains your daily habits. When sleep experts advise no caffeine after 2 p.m., they are referencing pharmacokinetic decay.
Wait, really?
Yeah. Caffeine has a half-life of roughly 5 hours in a typical adult. So if you drink a cup of coffee at 2 p.m., by midnight, 2 half-lives have passed.
Which means, based on our math, 25% of that caffeine molecule is still physically circulating in your brain, actively binding to receptors and keeping you awake.
And what's fascinating is that caffeine's 5-hour half-life is just a population average.
Right.
The sources note that it is highly variable.
Variable how?
Well, if you are pregnant, the half-life extends significantly. If you are a smoker, the half-life actually shortens due to enzyme induction. It is wildly dependent on your personal genetics and liver function.
Which leads to a really fascinating thought to leave you with today. Because right now, the entire medical system relies on these generic textbook half-life, these population averages printed on package inserts.
Right.
But what if, in the near future, we don't have to guess? What if you could swallow a smart pill or wear a biometric patch that constantly samples your interstitial fluid and calculates your personal pharmacokinetic decay rates in real time?
That would represent a monumental paradigm shift in pharmacology. I mean, imagine a clinical landscape where the rule of 5 isn't based on a historical clinical trial of strangers, but becomes perfectly customized to your exact metabolism, your precise kidney function, and your genetic makeup on any given Tuesday.
It would be revolutionary.
We could effectively eliminate the guesswork of dosing, preventing toxicity before it ever happens.
You would have a real-time dashboard of your own interconnected tanks right on your wrist. It is incredible to think about. Well, next time you look at a pill bottle and see take every 4 hours, you'll know there's a whole world of physics, saturated tissues, and exponential decay hiding behind that simple label. Thank you for joining us on this deep dive. Keep questioning the everyday, keep learning, and we'll see you next time.
If you give a patient 0.5 nanograms of this drug per milliliter of blood, you might actually keep them out of the hospital, vastly improve their quality of life.
Right, but if that level creeps up to like 1.2 nanograms, you might kill them?
Yeah. Today, we are looking at the terrifying math of digoxin.
It really is the ultimate narrow therapeutic index drug, NTI. The margin for error isn't just thin. I mean, it is practically invisible.
And yet, it's one of the oldest medications that is still actively prescribed in modern cardiology.
It is, yeah.
Which is exactly why we're dedicating this entire deep dive to decoding it. Because if you are prepping for nursing boards or you're managing medications in an ICU or, you're just fascinated by the extremes of human pharmacology, this drug is constantly popping up.
Absolutely.
So we're going to break down how it forcefully rewires the heart's cellular machinery, the critical lab values that actually predict its toxicity, and the major misconceptions that trip up even really seasoned medical professionals.
But to understand why a fraction of a nanogram dictates life or death today, you kind of have to realize this exact same tightrope was being walked 250 years ago.
Yeah, I was looking at this timeline, and it is just wild to me.
Right.
We have to travel back to 1775 to this physician and botanist named William Withering in Birmingham, England. He was called in to treat a patient suffering from dropsy?
Dropsy, yeah.
Yeah.
Such an archaic, haunting word.
It really paints a picture. Today, we'd call it severe fluid retention from heart failure.
Right,
The
exactly.
patient is essentially drowning from the inside because their heart just cannot pump fluid effectively through the body.
And the standard medical treatments of the 18th century were just completely failing this patient. But they were also taking this folk remedy.
The family recipe.
Yeah, it was this muddy, complex mixture of more than 20 different herbs.
Yeah.
Just a recipe passed down from an elderly Shropshire herbalist who history sometimes remembers as Mother Hutton.
And because Withering was a trained botanist, he didn't just dismiss the sludge, right?
No, he didn't. He analyzed it. And he suspected that out of those 20 plants, one single ingredient was doing all the heavy medical lifting.
Which was Digitalis purpurea, right? The common foxglove plant.
Exactly. So he isolated the foxglove, and spent the next 10 years conducting these systematic clinical trials on his patients.
Which is incredible for the 1700s.
It really is. It all culminated in his 1785 book, An Account of the Foxglove. And that text is considered a foundational pillar of clinical pharmacology.
Because he was systematically tracking dose titration.
Yes, he wasn't just, handing them the plan. He was methodically figuring out the exact amount needed to trigger a physical response.
Wait, so let me ask you this. My initial assumption when reading about historical medicine is always that, they thought they'd found a miracle cure and then they only realized it was a deadly poison like decades later.
Oh no, not with this.
So he knew.
Yeah, Withering actually documented the toxicity from day one. He explicitly warned that pushing the dose even slightly too high caused, violent vomiting, bizarre visual disturbances, and a really slow, highly irregular pulse.
Wow. So he recognized the double-edged sword immediately.
He did. He knew this plant had a power over the cardiac system, unlike anything else in the known world. But, he also saw how easily it could turn lethal.
Right. He meticulously documented what the drug did and the exact signs that you'd given too much. But the actual black box of the cellular machinery was totally hidden from him.
Completely hidden.
Yeah.
I mean, they had no idea how it worked.
Yeah, because the active compound itself, digoxin, which actually comes from a related plant, Digitalis lanata, the woolly foxglove, that wasn't chemically isolated until the 1930s.
Right, and the mechanism of action wasn't even figured out until the mid-20th century.
So for 150 years, doctors were prescribing this incredibly potent, dangerous drug purely based on empirical observation.
Yeah, they could see the outcome, but the biological engine driving that outcome was just a complete mystery.
Okay, so let's open up that black box for the listener. From first principles, I want to really understand the physical mechanism here. How exactly does this molecule force a failing heart to pump harder?
Well, we have to look at the electrochemical gradient of a single heart muscle cell.
Okay.
Every cardiac cell has a pump on its outer membrane called the sodium-potassium ATPase pump.
The ATPase pump, right?
Yeah, and its entire existence is dedicated to using cellular energy ATP to continuously pump sodium out of the cell and pull potassium inside.
So it's maintaining a very steep concentration gradient.
Exactly. So digoxin comes along, finds that specific pump, binds directly to it, and just completely inhibits its function.
It just jams the machinery.
It completely shuts it down, yeah.
Okay, so to make sure this sticks, let me try mapping this onto a physical space.
Okay, let's hear it.
Imagine the heart cell is like a highly exclusive, incredibly crowded nightclub.
Oh, I like this.
Right, so the main exit door, the one everyone uses to leave the club, is that sodium pump. Digoxin is a rogue bouncer who just suddenly barricades that main exit. Okay.
Now, the regular patrons, the sodium, are trapped inside, and the room is just getting totally packed.
That is actually the perfect setup, because the cell has another door, a secondary transporter called the sodium-calcium exchanger, and the situation gets even more chaotic because of it.
Because that secondary door relies on the flow of the main door.
Yes, exactly. The secondary exchanger uses the natural outward flow of sodium to power its own job, which is to pump calcium out of the cell.
Ah.
But digoxin has ruined the sodium gradient. The main door is jammed, the sodium is backed up, so the secondary exchanger completely stalls.
It has no power.
Right. And the end result is that intracellular calcium levels begin to rise drastically.
Okay, going back to the nightclub analogy, because the main exit is blocked, the VIP section, the calcium, also can't get out through their special side door.
Right, they're stuck.
So all these highly energetic VIP calcium molecules are now stranded on the dance floor.
And calcium is the direct biological trigger for muscle fiber contraction.
Wow, okay. So having all that extra calcium trapped inside the cell means the physical contraction of the muscle fibers becomes much, much more intense. We call that a positive inotropic effect.
So the failing heart muscle is basically forced to squeeze with significantly more force.
Yeah. It's a massive rave on a cellular level.
But forcing the heart to squeeze harder is only half of the drug's mechanism, right? Because it also hits the brakes on the heart rate.
It does. Separately from the muscle contraction, digoxin increases vagal tone.
Okay, what does that mean exactly?
It stimulates the parasympathetic nervous system, which acts as the body's natural brake pedal. This stimulation slows down the electrical conduction specifically at the AV node.
And the AV node is the electrical gateway between the top and bottom chambers of the heart.
Exactly. We call this a negative chronotropic or dramatropic effect.
Which is why we see it used for atrial fibrillation, or AFib.
Right.
Because in AFib, the top chambers of the heart are quivering chaotically, just firing off hundreds of rogue electrical impulses down toward the ventricles.
Yeah, it's a mess.
So digoxin doesn't cure that chaotic rhythm, but by slowing down the AV node, it acts like a strict toll booth operator.
I love that. A toll booth operator, yeah.
It throttles how many of those chaotic impulses are allowed to pass through to the main pumping chambers, which keeps the overall heart rate from just spiraling completely out of control.
Stronger contractions, but a slower, more controlled rate. I mean, it sounds like the perfect combination for a failing chaotic heart.
It really does.
But because this mechanism physically alters the foundational electrical gradient of the cells, the line between therapeutic benefit and a fatal arrhythmia is terrifyingly thin.
Yeah, digoxin is the textbook NTI drug. It sits right alongside things like lithium and warfarin.
Oh, absolutely.
But the part of the story that truly shocked me when I was reading the research is that for decades, modern cardiology actually got the definition of safe completely wrong.
The paradigm shift here is massive.
Yeah?
Historically, clinicians defined the therapeutic range for serum digoxin as roughly 0.8 to 2.0 nanograms per milliliter.
That was the gold standard target.
It was. If a patient's blood work came back at 1.5, their doctor felt completely confident they were in the safe zone.
Then the DIG trial happens.
Right.
The Digitalis Investigation Group trial, which was published in the New England Journal of Medicine in 1997, they looked at almost 7,000 patients with heart failure.
A huge study.
Yeah, and I was reading these results, and I have to admit, I'm kind of baffled. The trial proved that the drug does not actually reduce overall mortality.
No, it doesn't.
It does not help you live longer. So given how dangerous the toxicity profile is, I just don't understand why any modern doctor would choose to prescribe this over incredibly effective, safer drugs like beta blockers or ACE inhibitors.
Well, it is a question that gets debated in hospitals literally every day.
I bet.
But the justification lies in what the DIG trial actually did show. It didn't extend life, sure, but it drastically reduced hospitalizations for worsening heart failure.
Oh, okay, so it's about symptom control.
We are talking about severe symptom control. Picture a patient who is already maxed out on beta blockers and modern therapies, but they are still suffocating from fluid buildup. They can't even sleep lying down.
That's awful.
Or an AFib patient whose blood pressure is just too low to tolerate other rate control drugs. Digoxin keeps them out of the ICU. It offers a massive quality of life benefit for a very specific, highly vulnerable niche.
But the 1997 trial wasn't the end of the story, was it?
No, it wasn't.
Because in 2003, researchers published a post-hoc analysis of that exact same DIG trial data in the journal JAMA. And when they broke down the numbers, they found this hidden warning that kind of changed everything.
They did. They realized that the patients who actually had the best outcomes, the fewest hospitalizations, and the lowest risk had serum digoxin levels between 0.5 and 0.8.
Okay, wow, that's really low.
Very low. But patients whose levels were above 1.2, which remember was historically considered the perfect safe mid-range, they actually suffered increased mortality, particularly women.
That is wild. The physical pill didn't change at all. But the medical consensus on what constituted a poison just shrank drastically overnight.
Exactly. The new therapeutic range was redefined downward to a tiny window of just 0.5 to 0.9 nanograms per milliliter.
Outcome data finally caught up with centuries of empirical dosing.
It did. And with the safe range shrinking to such a microscopic window, recognizing when a patient has inadvertently crossed the line into toxicity is, well, it's one of the most critical skills a clinician can have.
Let's talk about that, because if a patient comes into the emergency room complaining of sudden, bizarre visual changes, that is your first major clue.
Oh, yeah.
And medical students are often taught this really vivid historical theory to remember it. It involves the Dutch post-impressionist painter Vincent van Gogh.
Right. Late in his life, Van Gogh's paintings, like The Starry Night or The Night Cafe, are just dominated by heavy, brilliant yellows and these massive swirling halos around the stars and artificial lights.
It's his signature style from that period.
Yeah, and medical historians have proposed that he might have been suffering from xanthopsia.
Xanthopsia, right.
Which is a condition that causes yellow-tinted vision, alongside seeing physical halos around lights. And both of these are hallmark, classic symptoms of digitalis toxicity.
Obviously, we have to note for the listener that this is entirely speculative.
Oh, 100%.
There is no hard medical record confirming Van Gogh was ever prescribed digitalis, though, it was sometimes used for suspected epilepsy back then. Art historians usually just argue he went through a period where he really favored the color yellow.
The historical debate is endless on that one. But as a teaching tool, it is absolutely brilliant.
It really sticks in your mind.
If you want to remember the unique visual toxicity of digoxin, you just picture the Starry Night.
Yeah.
Yellow vision and halos around lights.
Right.
When a patient on digoxin describes those visual changes, alongside severe nausea, vomiting, lack of appetite, and confusion, you are looking at systemic poisoning.
So visual symptoms and nausea are the subjective clues, but the immediate next step is getting them on a heart monitor.
Always.
And this is where nurses and doctors get completely faked out by what they see on the screen.
Yes, they do.
Because there's a very specific ECG finding a stooped ST segment depression that literally looks like a Salvador Dali mustache. I've always heard people associate that shape with digoxin toxicity.
It is arguably the single most common misconception regarding this drug.
Really?
Yeah, that scooped ST segment does not mean the patient is poisoned. It is simply the digoxin effect.
Wait, then why does it create that specific shape if it isn't toxic?
Well, think back to the jammed cellular pumps.
The nightclub doors.
Right. The ST segment on an ECG represents repolarization, the moment the heart is electrically resetting itself for the next beat.
Okay.
Because digoxin is blocking the sodium-potassium pumps, those cellular ions are physically struggling to get back to their baseline positions.
Oh, I see.
That electrical struggle literally pulls the baseline of the ECG downward, creating that scooped, mustache-like appearance.
So it shows up in patients who are taking a perfectly therapeutic, non-toxic dose.
Exactly. It just proves the drug is in their system doing its job.
Wow. Okay. So a Dali mustache is expected. What does actual fatal toxicity look like on the monitor then?
True toxicity manifests as highly dangerous arrhythmias.
Like what?
For example, paroxysmal atrial tachycardia with an AV block.
Okay, break that down for me.
This means that the top chambers of the heart are firing at an incredibly fast abnormal rate. But because digoxin is clamped down so heavily on the AV node's toll booth, those signals are blocked from reaching the ventricles.
Got it.
You might also see bidirectional ventricular tachycardia.
That sounds intense.
It is. It's where the electrical signal is so profoundly corrupted, it is literally ping-ponging back and forth across the ventricles in opposite directions on the monitor.
Jeez.
Yeah, so you had to combine those severe arrhythmias with the physical symptoms and then verify it all with a blood test.
But even the blood test can lie to you if you don't time it perfectly, right?
Oh, absolutely.
Because if a patient takes their morning pill, feels nauseous 2 hours later, and you draw their blood right then, the lab level might come back completely normal.
The timing is everything. Because the digoxin binds extensively to tissue, especially the heart and skeletal muscle.
Okay.
If you draw blood within the first 6 to 8 hours after a dose, the drug hasn't fully distributed into the tissues yet. It's still just circulating in the bloodstream.
So the lab is just measuring that free-floating amount.
Right, and it will give you a deceptively low or normal number, which completely masks the lethal amount of drug that's already bound to the heart muscle.
That's terrifying.
You must always draw the level at the trough, which is the absolute lowest point of concentration, ideally right before they are scheduled to take their next dose.
Okay, so drawing the level at the trough ensures you see the true baseline. But there is another lab value that we have to check alongside the digoxin level, and it introduces this massive paradox.
Potassium.
We need to talk about potassium, because I was always taught that low potassium is the biggest danger for a patient on digoxin. But the data shows that a high potassium level is actually the ultimate red flag for mortality.
This is the potassium paradox. And to untangle it, we have to completely separate chronic everyday toxicity from an acute massive overdose.
Oh, okay.
Because they behave in entirely opposite ways. Let's look at chronic toxicity first.
All right, lay it out for me.
A classic scenario. An 80-year-old patient on a stable, perfectly calculated daily dose of digoxin gets a severe stomach bug and becomes dehydrated. Or, maybe their doctor starts them on a new diuretic.
Right.
As a result, their total pony potassium drops. This is hypokalemia.
Okay, so in that everyday scenario, the low potassium is the driver of the danger. Why does a lack of potassium make the drug more toxic?
Because potassium and digoxin are physically competing for the exact same binding sites on those sodium-potassium ATPase pumps.
Oh, they're fighting for the same parking spot.
Exactly. If the patient's potassium drops, the competition disappears. Digoxin is left unopposed, so it binds much more aggressively to the pumps, heavily exaggerating the drug's effect.
Wow. So the dose didn't change at all, but because the potassium vanished, the drug suddenly grips the heart much tighter.
Yes, hypokalemia worsens the chronic poisoning.
That makes perfect sense for the slow, creeping toxicity. But what happens in an acute overdose? Say someone accidentally ingests a massive handful of pills all at once.
In a massive acute overdose, the biological mechanism flips entirely.
Really?
The sheer volume of digoxin floods the system and completely paralyzes the ATPase pumps all over the body. Not just the heart, but skeletal muscle too.
Huh.
Because those pumps are entirely disabled, potassium cannot be pumped into the cells at all. It gets trapped outside and leaks rapidly into the bloodstream faster than the kidneys can filter it out.
Which causes severe hyperkalemia.
Dangerously high potassium in the blood, exactly.
So the high potassium isn't causing the toxicity in this case. It's a massive downstream symptom of the pumps shutting down globally.
Yes. And we owe that realization to a toxicologist named Charles Bismuth in the 1970s.
What did he find?
He proved that in acute digoxin overdose, the degree of hyperkalemia is a direct predictor of whether the patient will survive.
Yeah.
He found that if a patient's serum potassium crossed roughly 5.5 milliequivalents per liter during an acute overdose, their mortality rate skyrocketed to nearly 100% without immediate intervention.
That is a staggering statistic.
It really is. The direction of the potassium abnormality tells you exactly what kind of poisoning you are dealing with.
Well, if a patient is in that nightmare scenario like massive acute overdose, potassium soaring past 5.5, their heart ping-ponging in bidirectional VTach, we actually have a highly specific antidote to save them.
We do.
I read about how they developed this antidote in 1976, and it sounds like absolute science fiction for the era. They didn't just, mix chemicals in a lab.
No, they didn't. Thomas Smith and his research team developed DigiFab, which was originally known as DigiBind. It was an incredibly early, groundbreaking use of biologics in toxicology. They systematically immunized sheep with digoxin derivatives.
Sheep.
Yes, sheep. The sheep's immune systems created specific antibodies to fight off the digoxin. The researchers then harvested and cleaved those antibodies into microscopic fragments.
So when you infuse those sheep antibody fragments into a dying, poisoned patient, they basically hunt down the free digoxin molecules in the bloodstream and bind to them.
Exactly.
They act like little molecular handcuffs, just rendering the poison completely inert.
That is exactly how it works. And the new digoxin antibody complex is highly water-soluble, meaning the kidneys can easily recognize it and excrete the handcuff poison straight out of the body in the urine.
That is incredible.
You just calculate the required number of antidote vials based directly on the patient's estimated total body digoxin load or their steady-state serum level, and the reversal of toxicity is rapid and profound.
The sheer brilliance of using targeted biologics to neutralize a 250-year-old plant derivative is just stunning.
It's one of my favorite stories in medicine.
The entire landscape of this drug requires such intense precision. I mean, we've seen how the Dali mustache on the ECG represents the cellular struggle of repolarization, not an actual poisoning.
Right.
We unpack the paradox where low potassium tightens the drug's grip in chronic cases, but high potassium acts as the ultimate alarm bell for massive pump failure in an acute overdose.
Which is so crucial to remember.
And we looked at how the 1997 DIG trial and its 2003 follow-up forced the entire medical community to shrink the therapeutic safe zone down to that tiny window of 0.5 to 0.9 nanograms per milliliter, specifically to keep patients out of the hospital without increasing their mortality risk.
And, all of this history and cellular mechanics matters deeply today because our demographic landscape is shifting.
Oh, so?
We have millions of older adults living with atrial fibrillation and heart failure, and their kidney function naturally declines with age. Digoxin is cleared almost entirely through the kidneys.
Which means a patient can be perfectly stable on their daily dose for years, but the moment they get a minor infection or become dehydrated or simply start taking an over-the-counter NSAID like ibuprofen for arthritis,
their kidney clearance takes a subtle hit.
Right.
They haven't taken a single extra pill of digoxin.
Right.
But because their kidneys slowed down, the drug silently accumulates in their tissues day after day until they cross that invisible line from 0.8 to 1.2 nanograms.
And then they arrive in the emergency room with yellow vision and a failing heart.
Exactly. It requires vigilant polypharmacy review from every doctor, nurse, and pharmacist involved in their care.
We are essentially demanding flawless kidney function to manage a centuries-old plant extract in an aging population with incredibly complex medication lists.
That's a huge challenge.
It really makes you pause and think about the origins of all this. If William Withering hadn't possessed the exact right dual training to investigate Mother Hutton's family recipe for dropsy in 1775, would we have ever isolated it?
It's hard to say.
And considering how many other strange, muddy folk remedies were casually discarded by modern science over the centuries, you have to wonder, could there be other incredibly potent, undiscovered, narrow therapeutic index drugs hiding in historical texts, just waiting for modern biologics and precise dose titration to unlock their potential?
The line between a deadly poison and a life-saving cure is often just a matter of knowing exactly where and how closely to look.
Keep questioning the margins, and we'll see you on the next deep dive. Every single day, in hospitals all around the world, doctors inject patients with a chemical derived from a drug that is, well, it's responsible for over 80,000 accidental American deaths every year.
Yeah, it's a staggering number.
It really is. I mean, it is the ultimate medical paradox, right? A drug that is both an absolute compassionate necessity and simultaneously a mass killer. So, welcome to a new deep dive. We are super thrilled you're joining us today.
You really just cannot practice modern surgery or complex trauma care or, oncology without these medications. They are pretty much the absolute backbone of severe pain management.
Right.
And yet managing them requires walking this incredibly tightrope over a very steep cliff, because the very mechanism that brings all that relief is inherently tied to a fatal shutdown of the body's respiratory drive.
So here is the mission for this deep dive. We're going straight into our source material to examine the pharmacology of opioid analgesics. We're going to look at exactly how they relieve pain, the precise mechanism of how they stop breathing, and how a life-saving reversal drug actually works at the microscopic level to pull someone right back from the brink of death.
It's a lot of ground to cover, but it's so important.
Definitely. And to do that, okay, let's unpack this. We have to immediately correct a massive misconception that you see in the news, like every single day. The media constantly talks about the opiate epidemic.
Yeah, constantly.
Right. But technically, almost from the very start of this crisis, that phrase was just completely wrong.
It is, yeah. It's a crucial pharmacological distinction that just completely gets lost in the public conversation. The terms opiate and opioid are treated as synonyms, but structurally, they are entirely different categories. So break that down for us. Well, opiates with an ATE refers strictly to the naturally occurring alkaloids that are extracted directly from the sap of the opium poppy, the Papaver somnifera plant. And that list is actually remarkably short.
We're basically just talking about like morphine, codeine, and the bane, right?
Exactly. Those are the opiates, just the chemical compounds produced by nature. But opioids with an OID at the end is the broader overarching umbrella term.
Okay, so it covers a lot more ground.
Right. It covers any compound that binds to the opioid receptors in the human body, regardless of where it came from. So this includes semisynthetics, where scientists basically tweak the natural plant molecules to make drugs like oxycodone or hydrocodone.
And it also includes the fully synthetic ones.
Yes, and that is the critical part. Fully synthetic drugs like fentanyl and methadone. Those synthetics share absolutely zero chemical ancestry with the poppy plant. They're created entirely in laboratories.
Wow.
And the reason this matters for you to understand today is that the deadliest drugs driving the modern overdose crisis, well, they aren't opiates at all.
They're entirely synthetic opioids. It's wild to think about how far we've come from just the natural plant. And I mean, to truly grasp how these powerful synthetic molecules operate, we kind of have to look back at how humanity discovered their natural predecessors.
History gives us a lot of context here.
It totally does. The timeline in our sources starts all the way back in like 3400 BCE in Sumeria. Archaeologists actually found cuneiform tablets referring to the poppy as hulgil, which translates directly to the joy plant.
And we see that through line across so many civilizations. Its medical use is heavily documented in ancient Egyptian text and classical Greek medicine.
Right, but for thousands of years, practitioners were simply using crude opium, weren't they?
Exactly. They would score the seed pod of the poppy, collect the milky latex, and just use it as a raw substance. They completely understood the effects, the pain relief, the sedation, the constipation, but they were completely in the dark regarding the actual active ingredient driving those effects.
Which brings us to a really pivotal and frankly kind of terrifying moment in 1804. So there was this German pharmacist named Friedrich Serturner. He was working in his lab, and he actually managed to isolate the primary active alkaloid from that crude opium sap.
And he named it morphine.
Yes, after Morpheus, the Greek god of dreams, because of its incredibly heavy sedative properties.
Right.
But here's the crazy part. He doesn't just write a paper about it. He decides to test it on himself.
And on 3 of his young, unconsenting assistants. Right.
Yeah. What I struggle to understand is the sheer recklessness of it. He administered this massive, uncalibrated dose of this newly isolated, highly concentrated chemical to himself and these teenagers.
And it predictably caused near-fatal respiratory depression.
Right. They all slipped into unconsciousness and almost died. He reportedly had to revive everyone by aggressively forcing them to drink, like, large quantities of vinegar to induce vomiting and stimulate them.
It's just astonishing.
It is. This 1804 self-experiment is one of the very earliest recorded medical encounters with the exact same mechanism that kills overdose victims on the streets today. And yet, even after he isolated morphine, and it went into massive worldwide medical use, especially during the American Civil War when they paired it with the hypodermic needle, science was still operating totally blind.
Yeah, for well over a century, clinicians only defined these drugs by their outward clinical effects.
They could observe the pain relief and the euphoria, but they were essentially just guessing at the invisible machinery operating inside the human body.
They assumed there had to be a biological target, a receptor of some kind, but it remained entirely theoretical. And what's fascinating here is that we didn't actually prove the physical existence of these receptors until 1973.
That timeline is just staggering to me. We were landing human beings on the moon before we had definitive proof of how morphine actually functioned in the human brain.
Right. In 1973, a researcher named Solomon Snyder and his graduate student Candace Pert at Johns Hopkins achieved this massive breakthrough.
How did they finally prove it?
To prove these receptors weren't just a theory, they used radioactively labeled opioids and applied them directly to rat brain tissue. Because the opioid molecules were radioactive, they could physically track exactly where they accumulated.
Oh, wow, so they can actually see it.
Exactly. They demonstrated stereospecific binding sites in the brain tissue. For the first time in human history, there was direct, undeniable evidence that opioid receptors were real, physical, anatomical structures in the central nervous system.
And the evolutionary implication of that discovery is just profound, because if human beings and rats and mice all possess a highly specific, complex physical lock, perfectly shaped to receive a chemical key derived from a random flower, why would we have that?
Right. Human biology wouldn't evolve a highly specialized receptor complex and just let it sit dormant for millions of years, waiting for the opium puppy to invent the key.
Exactly. That realization led to an immediate secondary hypothesis, right? The body must manufacture its own internal version of the drug. We must produce endogenous opioids.
And that was proven true just 2 years later, in 1975, when Scottish researchers John Hughes and Hans Kosterlitz discovered enkephalins.
Those are our body's own opioid molecules.
Yes. Later, researchers identified endorphins and dynorphins as well.
So morphine isn't some magical external cure-all that the plant graciously provides. It is simply a chemical mimic. It literally hijacks our body's pre-existing internal pain relief system.
The hardware is already built into our nervous system to manage stress and pain. The external drugs just flood that system with a volume of chemicals it was never designed to handle at once.
But if these drugs are just utilizing a natural biological system that we already possess, why are they so incredibly lethal? That brings us to the core mechanism of the mu-opioid receptor, which is frequently abbreviated as the MOR.
To really understand the lethality, we have to look at the cellular level. Opioid analgesics act as agonists at G-protein-coupled receptors.
Okay, getting into the chemistry here.
Just a bit. When an opioid molecule binds to that mu-opioid receptor on a neuron, it triggers a cascade of intracellular events. It inhibits adenylate cyclase, it closes voltage-gated calcium channels, and it opens potassium channels.
Hold on. We need to translate that chemistry into something a bit more visual for the listener. What is actually happening to the nerve cell when all those channels open and close?
Okay, think of a nerve cell, a neuron, like a charged battery that sends electrical alarm signals. When the opioid binds to the receptor, it essentially opens the floodgates for positively charged potassium ions to rush out of the cell.
Okay, so the potassium is leaving.
Right. As the potassium leaves, the neuron loses its electrical charge. It drains the battery. And because the neuron loses that charge, it literally quiets down. It becomes far less excitable. And crucially, it stops releasing pain-signaling neurotransmitters, specifically substance P and glutamate.
It basically unplugs the alarm system.
That's a perfect way to put it. In the dorsal horn of the spinal cord, this silencing effect effectively blocks pain signals from traveling up to the conscious areas of the brain. That is the profound analgesia that makes surgery possible.
And what about in the brain itself?
Well, in the brain's reward pathway, particularly the nucleus accumbens, this same receptor activity triggers a massive release of dopamine. That creates euphoria, which drives the intense addiction potential.
Right.
But crucially, this exact same quieting effect happens in the brainstem, specifically in the medullary respiratory centers, which control your automatic, unconscious drive to breathe.
And here's where it gets really interesting, because I think a lot of people fundamentally misunderstand this part of the pharmacology. When you take a medication, you usually have the therapeutic effect, and then you have accidental side effects.
Right, like taking an allergy pill.
Exactly, like you take an antihistamine to stop a runny nose, and the side effect is you feel drowsy. But the pain relief happening in the spinal cord, and the respiratory depression happening in the brainstem, the thing that stops your lungs from moving, they are not separate things.
No, they aren't. And it is a vital concept for anyone handling these drugs to grasp. Respiratory depression is not an allergic reaction. It is not an unintended side effect.
They are two faces of the exact same biological mechanism, right?
Exactly. The drug is doing the exact same thing, silencing neurons by draining their electrical charge, just in different geographical locations of the central nervous system.
Which means there is no such thing as a perfect opioid that kills pain entirely, but carries zero risk of stopping your breathing. The biological lock and key are identical.
And this mechanism is so perfectly reliable that bedside nurses, paramedics, and emergency physicians use it to spot an overdose instantly. They don't even need a blood test.
They look for a specific physical pattern.
Yes, they look for the opioid toxidrome triad. Toxidrome is just a portmanteau of toxic syndrome. First responders are trained to look for 3 simultaneous clinical signs.
Okay, what's the first one?
First, profound central nervous system depression, meaning the patient is unresponsive, lethargic, or entirely unconscious. Second, respiratory depression. And third, meiosis, which refers to symmetrical pinpoint pupils.
And if a patient presents with all 3 of those?
If they have all 3, it is considered almost entirely diagnostic of an opioid overdose.
When we talk about respiratory depression in this context, we really need to be crystal clear about what that actually looks like in an emergency. Our sources highlight a 2018 clinical review analyzing EMS naloxone administration across Massachusetts.
What did they find?
They documented that overdose patients were frequently found breathing just 4 to 8 times a minute.
Oh, wow. To put that into perspective for you, a normal resting adult respiratory rate is anywhere from 12 to 20 breaths a minute.
So these patients are taking a single breath every 10 or 15 seconds, sometimes even less. It's a phenomenon called agonal breathing.
It sounds like snoring or gasping, doesn't it?
Yeah, but it is actually the brainstem struggling to send the signal to the diaphragm. It perfectly illustrates how razor-thin the margin is between a therapeutic dose that sedates a patient for surgery and fatal apnea where the oxygen supply is simply cut off.
With a margin of safety that narrow, the pharmacology just becomes a numbers game, which is why we have to discuss drug metabolism, because not all opioids are created equal, and how the body breaks them down can be really unpredictable.
Okay, give us an example.
Consider codeine.
That brings up a massive myth we need to dispel. There is a persistent belief that codeine is a weak, harmless option. It's often thought of as this mild opioid historically prescribed in cough syrups for kids.
Codeine is what pharmacologists call a prodrug. By itself, in its original chemical structure, codeine has incredibly low affinity for the mu-opioid receptor. It basically does nothing.
Wait, really?
Yeah. However, your liver acts like a chemical refinery. When you swallow codeine, it travels to the liver, where a specific enzyme called CYP2D6 strips away a methyl group, chemically transforming that codeine directly into active morphine.
So you aren't really taking codeine, you are taking a delayed-release morphine pill.
Exactly. And the danger lies in genetics. Because of genetic variations, some people possess multiple copies of the gene that creates that CYP2D6 enzyme. They are known as ultra-rapid metabolizers.
Meaning their liver processes it faster.
Much faster. Their liver runs that chemical refinery at 10 times the normal speed. So if you give a standard, supposedly mild dose of codeine to an ultra-rapid metabolizer, their liver instantly transforms it into a massive, overwhelming spike of morphine in the bloodstream.
That's terrifying.
It is. People, including children recovering from tonsillectomies, have literally died from standard prescribed doses of codeine simply because of their genetics.
It's why the FDA ultimately slapped a black box warning on codeine for pediatric use. And this variation in drug strength becomes even more terrifying when we move from natural opiates to the fully synthetic opioids flooding the illicit market today. The milligram for milligram potency differences are just staggering.
To visualize the potency scaling for you, 10 milligrams of intravenous morphine is roughly equivalent in pain relief to about 100 micrograms of intravenous fentanyl.
A microgram is a significantly smaller unit of measurement.
Yes, this means fentanyl is roughly 50 to 100 times more potent than morphine by weight.
To picture that, a lethal dose of fentanyl is roughly equivalent in physical size to just a few grains of table salt, which really emphasizes the sheer terror of the illicit counterfeit pill market.
Because a tiny error changes everything.
Exactly. A microscopic visual error in how a counterfeit oxycodone pill is pressed in a clandestine lab, just 2 or 3 extra grains of salt worth of fentanyl transforms a recreational dose into a fatal one. And the source material also mentions carfentanil.
Yes, that's a veterinary tranquilizer designed for large animals like elephants, which occasionally contaminates the street supply.
And that is estimated to be 10,000 times more potent than morphine.
It is active in the extreme microgram range. It completely overwhelms the mu-opioid receptors instantaneously.
The obvious question is, how did we get here? How did the United States transition from a medical system where opioids were closely guarded hospital medications to a crisis landscape where over 80,000 people are dying annually?
A significant catalyst in that historical shift involves the launch of OxyContin by Purdue Pharma in 1996. Purdue aggressively marketed this sustained-release formulation of oxycodone for long-term outpatient management of chronic non-cancer pain.
Right.
And to convince hesitant doctors that prescribing powerful opioids for backaches or arthritis was safe, Purdue sales representatives heavily promoted the idea that the risk of addiction was less than 1%.
The origin of that less than 1% statistic is genuinely shocking. The source material traces it back to a 5-sentence letter to the editor published in the New England Journal of Medicine in 1980.
5 sentences.
Just 5 sentences. It wasn't a peer-reviewed study. It wasn't a clinical trial. It was just a brief observation describing extremely low addiction rates among hospitalized patients receiving short-term opioids under strict medical supervision.
Right. It described a highly controlled clinical environment that had absolutely nothing in common with handing a patient a 30-day prescription to take home unmonitored.
But they ran with it anyway.
They did. That single misused citation was repeated in academic articles and marketing materials hundreds of times over the next 2 decades. It became the foundational piece of evidence used to justify a massive cultural shift toward aggressive prescribing.
And part of how they justified that shift was by exploiting another major misconception, right? Conflating physical dependence with addiction.
This is a critical distinction that medical science really failed to communicate properly. Physical dependence is a guaranteed physiological adaptation. If you take opioids for a sustained period, your brain receptors adjust to the new chemical baseline.
And if you stop?
If you stop abruptly, your body will go into severe withdrawal. Anyone's body will do this, regardless of their psychology. Addiction, however, formerly known as opioid use disorder, is a separate behavioral and neurological condition. It's characterized by compulsive drug seeking and use, despite devastating harm to the person's life.
By blending those two concepts, pharmaceutical companies could argue that patients weren't experiencing addiction, they were just experiencing pseudo-addiction or physical dependence.
Which could supposedly be solved by prescribing even more opioids.
Exactly. Our sources document that this aggressive marketing eventually led Purdue Pharma to plead guilty to federal criminal charges in 2007 and again in 2020 regarding their misbranding practices, which resulted in sweeping civil litigation and bankruptcy.
If we connect this to the bigger picture, though, it is vital to understand the clinical debate that preceded that marketing push. Before the 1980s, pain was genuinely chronically undertreated across the medical system.
Especially for cancer patients.
Yes. Doctors harbored such an exaggerated fear of creating addiction that they were literally letting patients die in agony.
Palliative care pioneers recognized this tragedy and fought to change the standard of care. This led to the 1986 World Health Organization's analgesic ladder, which established a stepwise approach that finally legitimized strong opioid use for severe cancer pain.
But the pendulum swung way too far. In the late 1990s and 2000s, heavily influenced by campaigns labeling pain as the fifth vital sign, the medical community swung into massive overtreatment.
Using opioids liberally for chronic everyday pain, which triggered what the Centers for Disease Control and Prevention calls the three waves of the opioid crisis.
Wave 1, starting in the late 90s, was driven entirely by those prescription pills.
But Wave 2 is where the unintended consequences of policy really show up. Around 2010, the government cracked down on pill mills. They reformulated OxyContin to make it harder to crush and snort, and they restricted prescriptions.
And because millions of Americans were already physically dependent on those pills, cutting off the legal supply didn't cure the dependence. It simply forced those patients into the illicit market, causing a massive transition to street heroin. That was Wave 2.
And Wave 3, starting around 2013, is the landscape we are in now. The illicit supply chain realized that smuggling plant-based heroin was bulky and expensive.
Synthesizing fentanyl in a lab was incredibly cheap, highly concentrated, and so easy to transport.
Now, the illicit supply is almost entirely dominated by illicitly manufactured synthetic opioids.
Today, the clinical pendulum is finally swinging back toward a cautious, conservative approach called opioid stewardship. The medical community recognizes that debating whether opioids are inherently good or bad is just useless.
The real clinical question is always about careful patient selection, minimizing the dose, shortening the duration, and aggressive monitoring.
Because if you are waking up from a traumatic injury or a major surgery, you absolutely want that mu-opioid receptor activated.
But with the margins so incredibly thin, what happens when it goes wrong? When a patient or just a bystander on the street crosses the line into respiratory depression, how do we reverse it?
That is where the ultimate pharmacological antidote comes into play: naloxone.
Often recognized by the brand name Narcan, it was synthesized back in 1961 by chemists Jack Fishman and Moses Bloomberg in a small New York laboratory, and they designed it to perform a very specific function: to be a pure competitive antagonist.
To visualize how a pure competitive antagonist works against an agonist like fentanyl, we can look at the receptor mechanics.
Okay, think of the mu-opioid receptor like a high-stakes game of musical chairs. You have the chairs, those are the physical receptors situated on the neurons in your brainstem. The opioids, whether it's morphine or fentanyl, are the players sitting in those chairs. As long as they're sitting there, they are draining the battery, silencing the neuron, and turning down your breathing. Now, you administer a dose of naloxone. Naloxone is like a hyper-aggressive, incredibly strong player who bursts into the room, violently shoves the opioid out of the chair, and this is the absolute key to the entire drug: naloxone does not sit down itself.
That analogy perfectly illustrates the binding affinity. Naloxone has a stronger affinity for the mu-opioid receptor than almost any opioid. It forcefully displaces the opioid molecule.
But because it's a pure antagonist.
Because it's a pure antagonist, it produces absolutely zero cellular effect of its own. It doesn't drain the battery, it just aggressively blocks the seat. And the moment the opioid is knocked out of the receptor, the neuron wakes back up. The electrical charge returns, and the patient's automatic respiratory drive kicks back in, often within just 2 to 5 minutes.
It is practically miraculous to witness. Someone can be completely cyanotic, turning blue, barely gasping for air, and minutes later they are awake and talking. But there is a massive myth associated with this reversal that we really need to address.
There is, yeah.
People assume that because naloxone saves your life, it is this peaceful, harmless medical intervention, like you just wake up feeling fine.
Oh, not at all. For a patient who is physically dependent on opioids, administering naloxone violently precipitates acute withdrawal.
It's immediate.
Yes.
Yeah.
Remember the mechanism. You are instantaneously ripping every single opioid molecule off the brain's receptors all at once. The central nervous system just goes into massive overdrive. The patient wakes up in severe
And they can be agitated.
highly agitated, combative, and they very frequently vomit, which presents a massive choking hazard for someone who is just regaining consciousness. It is absolutely life-saving, but it's deeply unpleasant. This is why paramedics and nurses prefer to titrate the dose slowly, giving just enough to restore breathing rather than slamming a massive dose that throws the patient into violent withdrawal.
And as miraculous as the reversal is, we have to talk about what happens an hour later.
This raises an important question, and honestly, it's the single most critical safety point in our entire pharmacological outline: the half-life mismatch. This is the phenomena of re-narcotization.
Explain that for us.
Well, naloxone has a notoriously short biological half-life. It is metabolized and cleared from the body in about 30 to 90 minutes.
But the opioid that caused the overdose in the first place might have a half-life of many hours. Methadone, for instance, can remain active in the system for over 24 hours.
Fentanyl patches continue releasing the drug into the subcutaneous fat long after the patch is physically removed.
The antidote wears off significantly faster than the poison does.
Exactly.
Going back to the musical chairs. The aggressive naloxone player eventually gets tired and leaves the room. The chair opens back up, and the fentanyl that is still circulating in the bloodstream simply sits right back down.
And the patient slips right back into fatal respiratory depression. This is why administering a single dose of community naloxone and just walking away or discharging an overdose patient immediately from the emergency room is incredibly dangerous.
Your reversal is temporary.
It is. Continuous medical monitoring for hours after the administration is absolutely mandatory.
You cannot just treat and street an overdose patient. So what does this all mean? Why does this deep dive into opioid pharmacology matter so much right now? It matters because opioids are going nowhere.
They really aren't.
They remain an absolute, irreplaceable necessity for surgical care and trauma management. Yet they sit at the center of the worst accidental death crisis in modern history. And with the widespread rise of community naloxone distribution, where this life-saving nasal spray is now stocked in public libraries, high schools, pharmacies, and coffee shops, this pharmacology isn't just specialized trivia for doctors and nurses anymore.
You, the everyday bystander, are now an active participant on the front line of defense. Knowing the toxidrome triad, understanding that the naloxone will wear off, recognizing that an overdose is fundamentally an oxygen deprivation emergency. That specific knowledge translates directly into saving lives in your community.
It really does. You might be the one standing there holding the naloxone when those seconds count.
And as we close this analysis, consider the profound historical irony of this entire timeline.
The irony.
Humanity's millennia-long search to understand the ancient Sumerian joy plant eventually forced us to look inward. It led us to map our own brain, to discover our own internal pain relief system. And it was the discovery of that precise biological blueprint, our own physical receptors, that gave us the knowledge to create both the most lethal synthetic chemicals on Earth and the only antidote capable of blocking them.
The very biological hardware that heals us is the exact same hardware that harms us. Like we said at the start, it's not a broken bone on an X-ray. It's a complex, precarious balance, and the margin between profound relief and absolute catastrophe is razor thin. Thank you for taking this deep dive with us. Keep questioning, keep learning, and we'll catch you on the next one.
Usually, when you think of a medical emergency, you kind of picture something localized, right? Like a broken bone or, I don't know, a blocked artery.
Right. You find the specific fire, and you put it out.
Exactly. But what if the emergency isn't just a single fire? What if what if the plumbing, the electrical grid, and the ventilation system of a whole building all just fail at the exact same time?
Yeah, that triggers a complete systemic collapse. You're looking at a profound metabolic crisis at that point.
Right. And when multiple organ systems start, violently overcompensating for each other, the whole situation just spirals exponentially.
It really does. It's a terrifying cascade.
And that systemic collapse is exactly what we are plunging into for today's deep dive. Welcome, by the way. Today we are looking at diabetic ketoacidosis, or DKA.
Which is really the absolute ultimate emergency of uncontrolled blood sugar.
It is. And our mission today, looking at sources ranging from modern nursing education materials all the way back to historical medical texts, is not just to list off a bunch of symptoms for you to memorize.
No, we want to dig into the invisible biochemistry of why this actually happens.
Right, and how it tricks even the most experienced emergency room doctors, plus the massive clinical debates that are currently, completely overturning decades of medical dogma.
Yeah, it's a very active field right now. But to even begin to understand this collapse, you kind of have to look at the classic definition first.
That baseline.
Yeah. So DKA is traditionally defined by a specific triad. Basically, three things happening simultaneously.
Okay.
First, you have hyperglycemia. That's blood glucose levels, traditionally above 250 milligrams per deciliter.
Right, the high sugar.
Second is ketosis. So that's elevated ketones in the blood or urine, specifically one called beta-hydroxybutyrate.
Beta-hydroxybutyrate, got it.
Yeah. And third, metabolic acidosis. The blood essentially becomes dangerously acidic, which usually means a pH below 7.3, low serum bicarbonate, and what we call a widened anion gap.
Okay, let's unpack this because that last part I hear widened anion gap thrown around on medical dramas all the time, but what does it actually mean in plain English?
Simply put, it's just a way to measure hidden acids in your blood.
Hidden acids.
Yeah, so your blood has positively charged particles like sodium and negatively charged particles like chloride. And normally, the positives and the negatives, they balance each other out pretty closely.
Okay, that makes sense.
The gap is just the small difference between the ones we routinely measure. But when your liver starts pumping out massive amounts of ketones,
Which are acidic, right.
right, they are unmeasured, negatively charged acids. So they flood the bloodstream, and suddenly that gap between your measured positives and your measured negatives just gets abnormally wide.
Oh, I see. So a widened anion gap basically tells a doctor, like, hey, there is a rogue acid hiding in this patient's blood and it's taking over.
Exactly. It's a massive red flag.
So the triad is high sugar, high ketones, and blood chemistry that is literally turning acidic. But, while that sounds like a very neat, tidy textbook definition, the rules around it are actively changing today.
They really are.
But to understand why this condition is so complex today, we actually need to look at what DKA was before modern medicine.
Yeah, back when it was an absolute death sentence.
Right. Because not that long ago, this triad wasn't just an emergency you treated in the ER, it was unavoidable.
If you go back to 1874, there was a German physician named Adolf Kussmaul, and he was observing patients dying of diabetic coma.
And he noticed something really specific about how they were breathing, right?
He did. He noticed they all shared this very distinct, deep, labored, sighing, breathing pattern. Now, he didn't have the tools to understand the biochemistry of why, but he documented it so precisely that we still actually call it Kussmaul respirations today.
But why do they breathe like that? Is it like because they aren't getting enough oxygen?
No, it actually has nothing to do with oxygen at all. It's the respiratory system trying to bail out the blood.
Bail it out from the acid.
Yes, exactly. Because the blood is becoming incredibly acidic from all those ketones we talked about, the body desperately tries to compensate. And one of the only ways it can quickly get rid of acid is by converting it into carbon dioxide and just breathing it out.
Oh, wow. So those deep sighing breaths are just the lungs working in absolute overdrive to physically blow off the acid and raise the blood's pH.
That's exactly it. The lungs are trying to fix a liver problem.
That is fascinating. And physicians back then also noticed a strange smell, didn't they? Like a fruity, almost acetone-like odor on the breath of these patients.
Yeah, that acetone smell. Acetone is a direct byproduct of the liver breaking down fat into ketones.
Wow.
So you are literally smelling the metabolic breakdown of the patient's body on their breath. They didn't know the chemistry back then, but they knew that fruity smell was, well, it was the smell of the end.
Because before 1921, if a child developed type 1 diabetes, they had a life expectancy measured in months. DKA was simply how that clock ran out.
And the only thing doctors could do back then was prescribe starvation diets.
Right. Their logic was kind of like, well, if the body can't process energy from food, we just drastically limit the food.
Which is tragically flawed logic, really. Because the cells are already starving, the body doesn't have the key to unlock the sugar in the blood, so denying them food just accelerates the whole wasting process.
Yeah, it's heartbreaking. But that brings us to 1921 at the University of Toronto. You have this legendary team, right? Frederick Banting, Charles Best, James Collip, and J.J.R. McLeod.
Right.
And they finally managed to isolate and purify insulin from animal pancreases. And the impact of this wasn't just, gradual. It was instantaneous.
It was basically overnight.
Yeah. There's the famous case of Leonard Thompson in the sources. He was a 14-year-old boy lying near death in Toronto General Hospital in early 1922. They give him this experimental purified insulin, and he just wakes up. He recovers.
Yeah.
Or Elizabeth Hughes, who was the daughter of the U.S. Secretary of State at the time. Under that starvation treatment, she had been reduced to weighing roughly 45 pounds.
At 14 years old.
Exactly. She was practically a skeleton. And Banting starts her on insulin, and it rapidly brings her back to life. She went on to live for decades.
What's fascinating here is that this remains one of the fastest bench-to-bedside transitions in all of medical history.
Yeah, from isolating the hormone in a lab to bringing people back from the brink of death in human trials. Took under a year.
Under a year. It literally took DKA from a universal 100% fatal condition and turned it into a survivable, albeit severe, emergency.
But, the fact that injecting this one single hormone literally stopped death in its tracks tells you something crucial for our deep dive today.
Right. It tells you DKA isn't really just a disease of having too much sugar.
The sugar is just a symptom. The actual emergency is a catastrophic hormonal domino effect that triggers the second insulin disappears.
Yes. The foundational mechanism of DKA is basically a hormonal seesaw. When insulin levels plummet to near zero, the body's counter-regulatory hormones instantly shoot up to fill the void.
Like which ones?
We are talking about glucagon, cortisol, catecholamines like adrenaline, and growth hormone.
So the body thinks it is in the middle of a massive famine, even though the bloodstream is completely saturated with glucose.
Exactly.
I want to try an analogy here for you listening, just to make sense of this invisible chemistry.
Yeah.
Let's think of insulin as having two very distinct jobs in the body.
Okay, I like this.
So Job 1 is like a bouncer at a nightclub. The bouncer opens the door of the cells and lets the glucose out of the bloodstream and into the club so the cells have energy to party.
Right.
Job 2 is acting like a strict supervisor at a factory, specifically the liver. The supervisor stands there and absolutely forbids the liver from breaking down fat into ketones.
Right. So when insulin drops, you lose both the bouncer and the supervisor simultaneously.
Everything goes chaotic.
Completely. Without the bouncer, the doors to the cells are locked. The bloodstream gets packed with glucose that has nowhere to go, but the cells inside are completely starved for energy.
And because the cells are starving, the body hits the panic button. It starts rapidly breaking down fat tissue, dumping massive quantities of free fatty acids into the blood to be used for emergency power.
But remember, the supervisor at the liver is gone too.
Right.
So the liver takes all those incoming free fatty acids and goes completely rogue. It churns them into ketone bodies, specifically that beta-hydroxybutyrate and acetoacetate.
Which are the acidic alternative fuels.
Yeah. And as the liver pumps them out at just a massive rate, they overwhelm the blood's natural buffering capacity. The pH plummets. This is the metabolic acidosis taking hold.
Okay, so that handles the acid side of the equation.
Yeah.
But what is all that stranded, locked-out sugar doing to the body in the meantime?
Well, it's causing osmotic diuresis. Glucose is a highly concentrated molecule. So as the kidneys try to filter this incredibly sugary blood, the glucose acts kind of like a sponge. It pulls massive amounts of water out of the body's tissues and into the urine through osmosis.
So you start urinating gallons of fluid.
You do, but it's not just water leaving the body. That osmotic pull drags critical electrolytes, potassium, sodium, phosphate straight into the toilet.
Oh, wow.
Yeah. The patient becomes profoundly, dangerously dehydrated while their electrolytes are completely depleted.
So the bouncer leaves, the cells starve, the supervisor leaves, the liver floods the blood with acid, the sugar pulls the water out, and the kidneys flush out the electrolytes. It really is the entire building collapsing at once.
Use it. Perfect storm.
But knowing the plumbing and chemistry is great in theory. Recognizing it when it rolls through the doors of an emergency department is completely different because it doesn't always look like the textbook, right? It wears masks.
Oh, definitely. The clinical presentation can be incredibly deceptive, really depending on the patient's age and their background.
Let's talk about how this actually looks on the ground with some concrete examples. Take scenario 1, the opening act.
Okay.
So you have a 9-year-old kid, previously perfectly healthy. For maybe a month, they've been a little extra thirsty, asking for water at bedtime. They're peeing a lot. Maybe they look a little thinner.
Right.
For a parent, this is so easy to rationalize, like, oh, they're having a growth spurt, or it's just really hot out. But then, one afternoon, they start vomiting uncontrollably and breathing heavily, those small respirations. They get rushed to the ER, and they are in full-blown, life-threatening DKA.
Yeah, and that scenario is tragically common. This is a vital takeaway for you listening. In many parts of the world, DKA is actually the first sign, the opening act of type 1 diabetes in children.
It doesn't just start with a slightly abnormal blood test.
No, it rarely does. The pancreas has been quietly failing for months, and because the early symptoms are so subtle, the disease basically announces its presence by completely crashing the system.
Okay, so that's the insidious, quiet buildup. But what about scenario 2, the sudden power outage? What if a patient already knows they have type 1 diabetes? Can they still be blindsided?
Absolutely, especially with modern technology. Consider an adult patient who uses an insulin pump.
Right, lots of people use those now.
Yeah, and a pump constantly drips tiny, tiny amounts of fast-acting insulin into the body. There is no long-acting background insulin injected.
Okay.
So if the patient goes to sleep and, say, the catheter kinks or the pump battery dies, the insulin supply stops instantly.
Oh, wow.
And because it's fast-acting, whatever insulin was in their system is completely gone in a matter of hours. The supervisor leaves the liver, ketogenesis starts rapidly, and by morning, they're in severe DKA.
It happens vastly faster than someone using traditional injections.
Much faster, which is exactly why pump users are always taught to keep backup pens or syringes on hand.
That makes total sense. The hardware fails, the system crashes. But here's where it gets really interesting. Scenario 3. The euglycemic illusion.
Oh, this one is tricky.
Yeah. You have an older patient with type 2 diabetes. They are taking a popular class of medication called an SGLT2 inhibitor. They go into the hospital for a minor surgery, which means they're fasting, barely eating.
Right.
Suddenly, they start vomiting, their blood turns acidic, they are in absolute full-blown ketoacidosis. But their blood sugar is only 180. It's basically normal. How is that possible?
Right. So this is known as euglycemic DKA, meaning DKA with normal blood sugar. It fundamentally breaks that classic triad rule we talked about at the start.
Because the sugar isn't high.
Exactly. And to understand it, you have to look at what SGLT2 inhibitors actually do. These drugs lower your blood sugar by forcing your kidneys to excrete glucose into your urine.
Oh, so the drug is artificially keeping the blood sugar numbers looking beautifully normal.
Precisely. The drug hides the evidence. The patient was fasting for surgery, so their insulin levels naturally dropped. The body panicked, the liver went rogue and started pumping out ketones. The acid is building up rapidly.
But because the drug is constantly flushing the sugar out through the kidneys, the blood sugar never spikes.
Right. And clinicians are trained to look for extremely high glucose as the gateway to diagnosing DKA. If they see a blood sugar of 180, their brain immediately says, well, it can't be DKA.
It unmasks the ketoacidosis while completely hiding the hyperglycemia. It's an illusion. And this became such a major clinical trap that the FDA actually had to issue a massive warning about it back in 2015.
Yeah, it caught a lot of people off guard.
But that euglycemic illusion isn't the only old rule that's falling apart. Because the way doctors actually treat DKA inside the emergency room is going through a massive upheaval right now.
It really is. The controversies in modern DKA protocols are fascinating because they challenge what seems like basic common sense.
Like the bicarbonate reversal. This one blew my mind. If I have a patient whose blood is literally turning to acid, kindergarten-level science tells me I should pour a base into it to neutralize it, right?
Right. Baking soda, essentially.
Yeah. Why can't doctors just hook up an IV of sodium bicarbonate and balance the pH?
I mean, it feels incredibly logical, but decades of data have proven it to be a severe physiological trap.
Really?
Yes. Giving high-V bicarbonate to a DKA patient generally does not improve outcomes, and it introduces real, terrifying risks. When you push bicarbonate into the blood, it reacts with the acid and creates carbon dioxide.
Okay. And carbon dioxide is what they're already trying to breathe out with those heavy Kussmaul respirations.
Right. But carbon dioxide easily crosses the blood-brain barrier while the bicarbonate itself does not. So while you might be neutralizing the blood in the patient's arm, you are actually pushing carbon dioxide into their brain fluid.
Wait. So giving them the base makes their brain more acidic?
Yes. It causes a paradoxical worsening of CNS acidosis. And beyond that, it can trigger rebound alkalosis, where the blood swings too far in the opposite direction.
That's wild.
And in children, retrospective studies linked giving bicarbonate to a higher risk of cerebral edema, which is a fatal brain swelling. So today, modern protocols categorically ban bicarbonate unless the patient is at death's door.
Like an extreme case.
Yeah, usually with a pH below 6.9, where their heart is threatening to stop from the acid. Otherwise, you just trust the IV fluids and the insulin to fix the biochemistry naturally.
Which brings us perfectly to the next massive dogma shift. The pediatric fluid dogma. You mentioned cerebral edema, the brain swelling. For decades, that has been the leading cause of death for kids in DKA.
It was the thing doctors feared most.
Right. And the reigning theory was that if a doctor aggressively rehydrated a severely dehydrated kid with IV fluids, the rapid shift in fluid volume would rush into the brain cells and cause them to swell and burst.
So pediatricians and ER doctors were understandably terrified. They adopted extremely cautious, slow drip feed protocols for hydrating these children.
Even though they were so dehydrated.
Exactly. You had kids who were profoundly dehydrated, their kidneys failing, and doctors were intentionally withholding rapid fluids out of fear of causing brain damage.
Until the Pecan fluid trial in 2018.
Yes. Published in the New England Journal of Medicine, it was this rigorous, massive multi-center trial that finally put this fear to the test.
And what did they do?
They randomized children to receive either the slow, cautious fluids or rapid, aggressive fluid resuscitation.
And the results were shocking. The rate at which the fluids were given did not significantly change the neurologic outcomes at all.
It was a true paradigm shift.
The brain swelling wasn't being caused by the doctors giving fluids too fast. It was likely just a tragic consequence of the sheer severity of the DKA itself. Decades of dogma were based on weak evidence.
Yeah. Thousands of doctors realized that their anxiety-inducing, cautious practice was basically slowing down life-saving hygiene for a ghost.
It just shows how essential it is to question the conventional wisdom. But there is another trap we have to navigate here, and it's arguably the most lethal one for a nurse managing a DKA patient on the floor.
The potassium trap.
Yes. I call it the wallet versus bank account analogy for potassium. Let's break down the chemistry of that.
Okay, let's do it.
When a patient arrives in DKA, the nurse draws blood. The lab results come back, and the potassium levels look totally normal, maybe even high. That lab test is like looking at the cash in their wallet.
Yeah.
It looks like they're rich, they have plenty of potassium, but what the lab test cannot show you is their bank account, their total body potassium stores.
And their bank account is completely bankrupt.
Exactly. Because of that osmotic diuresis, all that peeing, they have flushed almost all the potassium out of their body. So if their body is empty, why does the blood test show it's full?
Because of the acid. When the blood becomes highly acidic, it means there are too many hydrogen ions floating around. The body tries to buffer this by hiding those hydrogen ions inside the cells.
Okay.
But to maintain electrical neutrality, for every positive hydrogen ion the cell takes in, it kicks a positive potassium ion out into the bloodstream. So the acid physically shoves the very last remaining bits of potassium out of the tissues and into the blood.
Hence, the full wallet, but the empty bank account. Now, if we connect this to the bigger picture, why is this so dangerous? Let's say a nurse looks at that normal lab result and immediately starts an IV drip of insulin to lower the blood sugar. What happens?
It causes a violently rapid reversal. As soon as insulin enters the system, it acts like a vacuum. It turns off the acid production, and it actively forces potassium back inside the cells.
Oh, no!
Yeah, all that potassium in the blood, the cash in the wallet gets sucked back into the bank account, and suddenly the bloodstream is utterly devoid of potassium.
And potassium is what regulates the electrical rhythm of the heart.
Exactly. If the serum potassium crashes too low, the patient will go into a fatal cardiac arrhythmia right there in the bed.
Wow.
This is why sequence is life or death. A nurse must identify the trap. They have to aggressively pump IV potassium into the patient to refill the bank account proactively before or concurrently with starting the insulin drip.
Even if the initial lab test says the potassium is normal.
Even then, you have to repeat it.
It is a terrifying high-wire act. You're balancing the fluids, the acid, the sugar, and the electrolytes minute by minute. And just to complicate things further, there's a long-standing myth about who actually gets DKA. Historically, it was drilled into medical students that DKA is strictly a type 1 diabetes issue.
Right. The old assumption was that patients with type 2 diabetes still produce a tiny trickle of their own insulin. And that tiny trickle was supposedly enough to keep the supervisor at the liver preventing ketogenesis, even if their blood sugar went through the roof.
But the real world proved the textbooks wrong again. We have well-documented cases of something called ketosis-prone type 2 diabetes.
Yes.
This was first really documented in Black patients in Flatbush, Brooklyn, right? Sometimes it's literally called Flatbush diabetes.
Right.
These patients come into the ER in severe textbook DKA. But the twist is, once they are treated and the metabolic fire is put out, they don't need insulin injections for the rest of their lives. They manage their diabetes for years with just pills or diet.
It proved that severe acute metabolic stress can temporarily overwhelm and paralyze even a pancreas that still technically functions. It completely blurred a rigid clinical line.
So what does this all mean? When we synthesize all these traps, the hidden sugars, the crash in potassium, the debunked fluid rules, how do healthcare workers actually manage this on the ground?
It's a massive burden. For nurses and physicians, managing DKA is a high-stakes balancing act occurring in real time. You are basically managing 3 organ systems, the pancreas, the kidneys, and the brain simultaneously.
All at once?
Yeah, you're constantly drawing blood, checking the anion gap to see if the hidden acids are clearing, titrating the IV fluids, balancing the potassium, and adjusting the insulin drip. Sequence is life or death.
And they have to make sure they're actually treating DKA and not a neighboring condition that mimics it, right? Because if an older type 2 diabetic comes in with blood sugar of 800 and profound dehydration.
That might not be DKA at all. That is likely HHS, hyperosmolar hyperglycemic state.
How is that different?
In HHS, seen more in older type 2s, the blood sugar goes astronomically high and the dehydration is far more severe. But because they have just enough residual insulin, the liver never goes rogue.
So minimal ketones.
Right. Minimal ketones, no severe acid buildup. The treatment overlaps, but the fluid resuscitation in HHS is even more critical. Or you could see starvation ketoacidosis or alcoholic ketoacidosis, which share the chemistry but lack the extreme hyperglycemia.
This highlights exactly why patient education, specifically sick day rules, is so vital.
Oh, absolutely.
If someone with diabetes catches the flu or a stomach bug, the stress hormones in their body spike. They need to know how to adjust their insulin and monitor their ketones at home so a simple virus doesn't spiral into this systemic collapse.
Which actually brings up a modern twist. During the COVID-19 pandemic, clinicians globally noted a surge of cases of new onset diabetes presenting in DKA.
Really? Just out of nowhere?
Yeah, often shortly after a COVID infection. It's raised ongoing research questions about whether severe viral infections directly attack and cause beta cell stress in the pancreas.
Wow. We have covered an incredible amount of complex physiology today. Let's do a rapid-fire summary of the main takeaways for you listening, just to cement these concepts.
Sounds good.
First, DKA is a triad: hyperglycemia, ketosis, and metabolic acidosis, proven by a widened anion gap. It is not just high blood sugar.
Insulin has two jobs, the bouncer at the cell door and the supervisor at the liver. DKA is what happens when both fail.
A normal potassium lab result is a trap. The total body stores are severely depleted, and giving insulin without potassium is fatal.
Decades of dogma, like giving bicarbonate or cautiously restricting pediatric fluids, have been overturned by modern data.
DKA is incredibly deceptive. It's often the very first opening act of a brand new diabetes diagnosis.
And on that note of the opening act, I want to leave you with a final thought to mull over, building on that COVID-19 connection we just mentioned.
Yeah.
If we are just now realizing that a virus like COVID-19 can cause acute beta cell stress and unmask DKA in perfectly healthy people, it raises a massive question.
What's that?
What other environmental or viral triggers are out there right now, quietly tipping the human pancreas over the edge, just waiting to be discovered as the next opening act of a diabetes diagnosis?
It's a sobering thought. It reminds us that the human body isn't just a machine with isolated parts. It's a deeply interconnected ecosystem. And sometimes you don't even know the system is under attack until the alarms are ringing everywhere at once. Thank you for joining us on this deep dive. Keep questioning the medical dogma you encounter, and we'll catch you on the next one.
You know, usually when we talk about a medical diagnosis, there is this expectation of precision. It feels kind of like engineering.
Right. It's very binary. Like the bone is broken or it isn't. The boundary is clear.
You break your arm, the x-ray shows that jagged white line, and the doctor just points and says, well, there it is. But then you look at something as ubiquitous as diabetes, and suddenly that x-ray machine is broken.
Yeah, completely broken.
We are looking at a diagnostic landscape that is incredibly murky, mostly because we try to diagnose this massive, complex disease using just a single number.
Which is really the core reason we are doing this deep dive. For you listening, especially if you're a nursing student grappling with the realities of diabetes mellitus, or just a curious learner, we really need to look past those tidy diagnostic numbers.
So they can be super misleading, right?
Absolutely. Our focus today is unraveling the actual pathophysiology. We want to understand the profound biological differences between type 1 and type 2 diabetes.
So, okay, let's unpack this. Currently, the American Diabetes Association, the ADA, diagnoses diabetes using strict lab thresholds. Like they look for a fasting plasma glucose of 126 milligrams per deciliter or higher.
Right, or an A1C of 6.5% or higher.
Yeah. But there is a fundamental flaw here. You could have two patients standing right in front of you. They both just got their lab results back, and they both hit the exact same A1C of 8.2%. From the number alone, they have the exact same disease.
But clinically, they arrived at that 8.2% through completely different, almost opposite biological mechanisms. Diabetes mellitus isn't actually a single disease.
Wait, really? It's not one disease?
No, not at all. It is a broad group of metabolic diseases that just happen to share one final symptom, which is chronic hyperglycemia. That just means persistently elevated blood glucose.
So because the medical field historically only looked at that final symptom, they just slapped one overarching name on it.
Exactly. To really understand why we rely so heavily on the end result, we actually have to look at how humanity first discovered this disease. This takes us way back, thousands of years before anyone could look inside a pancreas.
Oh, this history is wild. We are talking about the year 1550 BCE. The Ebers Papyrus in Egypt describes a condition characterized by just relentless excessive urination.
Yeah, and the terminology evolved much later. Around the 2nd century CE, a Greek physician named Eratosthenes of Cappadocia observed patients who were desperately thirsty. They were seemingly wasting away as fluid just passed straight through their bodies.
Which is horrifying.
It is. He coined the term diabanon, a Greek word that means to pass through, as if through a siphon.
It paints a very vivid and tragic picture of the end stages of the disease before modern medicine. The body is desperately trying to flush out this excess glucose it can't process, and it pulls massive amounts of water with it.
Right, the kidneys are just overwhelmed.
And for over 1,000 years, physicians were just trying to figure out what was happening using observation, which led to some fairly gross diagnostic methods.
I know exactly what you're going to say.
In the 17th century, doctors were literally tasting their patient's urine to see if it was sweet.
Yeah, literal taste tests. So in 1675, an English physician named Thomas Willis officially added the Latin word mellitus, which translates to honey sweet.
Just to differentiate it, right?
Precisely. The medical community needed a way to distinguish this sweet urine disease from another condition called diabetes insipidus. That one involves very dilute, non-sweet urine caused by a completely different pituitary hormone issue.
Wow, that was the absolute limit of diagnostics back then. You just observed the output.
Yep. The ability to actually look inside the body and see the mechanics came in a very tight cluster of discoveries in the 19th and 20th centuries.
Like Paul Langerhans, right?
Yes. In 1869, this 22-year-old German medical student, Paul Langerhans, was looking at pancreatic tissue under a microscope. He noticed these unusual clusters of cells scattered throughout the organ.
He had no idea what they did he?
None at all. But they were later named the islets of Langerhans in his honor. Then 20 years after that, in 1889, two physiologists, Oskar Minkowski and Joseph von Mering, were actually studying fat digestion.
Okay, so not even diabetes.
Right. To figure out the pancreas's role, they surgically removed the organ from a dog. Weeks later, a lab assistant noticed that flies were suddenly swarming the dog's urine.
Because it was absolutely saturated with sugar.
Exactly. By taking the pancreas out, they proved for the very first time that this specific organ produces a substance essential for controlling blood sugar.
Which sets the stage for arguably the most dramatic medical breakthrough of the 20th century. In the early 1920s, at the University of Toronto, surgeon Frederick Banting and medical student Charles Best finally isolated a pancreatic extract that lowered blood sugar in diabetic dogs.
And then a biochemist named James Collip purified it for human use. On January 11, 1922, everything changed.
They had a 14-year-old patient, Leonard Thompson, who was actively dying of type 1 diabetes at Toronto General Hospital. Before insulin, a type 1 diagnosis was a guaranteed death sentence, usually within a year or two.
Physicians tried to buy these patients time with strict starvation diets, which reduced sugar intake but left the children skeletally thin. It was incredibly grim.
The first injection they gave Leonard Thompson was actually too impure. But a couple of weeks later, they gave her a purified batch. His blood sugar dropped, and he began to recover.
Insulin turned an inevitably fatal disease into a manageable chronic one almost overnight. It's an amazing story. Banting actually split his Nobel Prize money with Best because he was so furious the Nobel Committee excluded the medical student.
That's some great medical drama right there. But as incredible as the discovery of insulin was, I think it created a massive clinical blind spot.
Oh, it absolutely did. Insulin was a miracle cure, but it treated the symptom of a failing system. Because it fixed the end result, the high blood sugar, it heavily masked the fact that there are two very different ways that system breaks down in the first place.
Which brings us to the actual starting lines of these conditions, the first principles. Let's start with type 1 diabetes, which is fundamentally an autoimmune fire.
That's a great way to put it. In type 1, the immune system, primarily the T lymphocytes, goes rogue. It mistakenly identifies the insulin-producing beta cells inside those pancreatic islets as foreign invaders, and it systematically destroys them.
When a patient gets tested for this, they often see an alphabet soup of autoantibodies on their lab chart. Things like GAG65, IA2, or ZNT8. What are those actually doing in the body?
Well, those acronyms represent the specific targets the immune system is attacking. GAD65, for example, stands for glutamic acid decarboxylase.
Say that 5 times fast.
Right. It's basically an enzyme that naturally exists inside the beta cells and is essential for them to function. But in a type 1 patient, the immune system's threat detection software glitches. It tags GAD65 as a hostile pathogen.
So the presence of these autoantibodies in the blood is basically the smoke billowing up from that autoimmune fire.
Exactly.
And there is a genetic blueprint for this glitch, right? The HLA genes.
Yes, specifically the human leukocyte antigen genes like HLA-DR3 and HLA-DR4. These genes code for the major histocompatibility complex. That is basically the immune system's threat display window.
So if you have these specific variants, your immune system is highly sensitive and prone to friendly fire.
Yeah, but genetics alone aren't enough to start the destruction. Something in the environment, very likely a viral infection like an enterovirus, appears to act as the trigger. It tips a genetically susceptible person into full-blown autoimmunity.
The terrifying part is the silent progression. By the time a patient actually starts showing symptoms like intense thirst, 80 to 90% of their beta cell mass is typically already gone.
It's staggering.
I've often heard the analogy of a factory making keys for a lock, but that feels a bit passive to me. To visualize what's actually happening at the cellular level, I like to think of a massive city transit system.
Oh, I like that.
Yeah, glucose is the passengers, and insulin is the train fleet that moves them out of the bloodstream and into the cells. Type 1 diabetes is like the city's own military bombing the train yard. It's an absolute deficiency. It does not matter what your diet is or how much you exercise, the trains are gone.
That captures the absolute nature of the deficiency perfectly. Type 2 diabetes, however, starts from the complete opposite direction. It begins with insulin resistance.
Okay, so how does that look in the transit analogy?
Well, the transit system is fully operational and the trains are running.
Yeah.
But the stations, the peripheral tissues like your muscle, liver, and fat, refuse to open their doors to let the glucose passengers inside.
The stations are refusing entry because of ectopic fat, right? But
Yeah.
I always hear that term thrown around without much explanation. How does fat actually stop glucose from getting into a cell?
To understand that, we have to look at the Randle cycle. Sometimes it's called the glucose fatty acid cycle, which was described in 1963. Ectopic fat refers to lipid storage in places it shouldn't be, primarily inside the liver and muscle cells.
So they're just getting stuffed with fat.
Right. When these cells are overwhelmed by excess circulating free fatty acids, they start metabolizing the fat for energy instead of glucose.
Which makes sense on a survival level, I guess, but what does it do to the insulin signaling?
Burning all that fat generates high levels of intracellular metabolic byproducts, specifically things like diacylglycerol. These byproducts are physically disruptive. They interfere with the insulin receptor substrate pathways.
Wait, so they just block the signal?
Pretty much. Insulin arrives at the cell membrane and binds to the receptor, swiping its badge to open the door. But the electronic signal gets scrambled by these fat byproducts. The door stays shut.
And the glucose passengers just build up in the bloodstream. So what does the pancreas do when it senses this massive crowd of glucose going nowhere?
It compensates through brute force. The beta cells pump out massive amounts of insulin to try and force the signal through. This state is called hyperinsulinemia.
That sounds exhausting.
It is. For a few years, this works. The blood sugar stays roughly normal because the pancreas is working intense overtime.
But the beta cells can't pull overtime forever. The cellular stress must be immense.
The stress is terminal, honestly. Over decades, these overworked beta cells suffer from literal chemical damage caused by chronic exposure to high glucose and high lipids. We call this glucotoxicity and lipotoxicity.
So they basically poison themselves trying to keep up.
Exactly. The oxidative stress overwhelms the cell's internal machinery until they literally undergo apoptosis-programmed cell death. The insulin secretion eventually crashes, falling far behind the massive demand. And that is when the clinical hyperglycemia emerges.
So type 2 is a relative insulin deficiency layered on top of severe resistance.
Exactly right.
This mechanical difference isn't just theory. It dictates exactly how these diseases show up in the real world. I was looking at the concordance rates for identical twins, and the split between the two diseases is fascinating.
Oh, the twin data isolates the genetic variable perfectly. If one identical twin develops type 1 diabetes, the co-twin's risk of developing it is only about 30 to 50%.
Which proves they have the exact same genetic threat detection glitch, but an external environmental trigger is absolutely required to ignite the autoimmune fire.
Yep, spot on. Contrast that with type 2 diabetes. If one identical twin develops type 2, The co-twins concordance is commonly cited in the 70 to 90% range.
Wow, that is a massive jump.
It really is. This reflects just how heavily type 2 is driven by a shared genetic architecture for fat storage, combined with shared lifestyle and environmental factors.
This biological difference becomes a literal matter of life and death in the ER, too. For the nursing students listening, the emergency presentations for these two diseases look very different because of the underlying chemistry. Let's talk about DKA versus HHS.
Good idea. DKA stands for diabetic ketoacidosis, and it is the hallmark emergency of type 1 diabetes. Because a type 1 patient has virtually zero circulating insulin, their body thinks it's starving.
Even if their blood sugar is sky high.
Yeah, because the glucose can't get into the cells. Without insulin to act as a braking system, a specific enzyme in the fat cells called hormone-sensitive lipase goes into overdrive. The fat cells release massive amounts of free fatty acids into the blood.
And the liver tries to process all that fat, right?
The liver takes those fatty acids and rapidly converts them into ketone bodies for emergency fuel. The problem is that ketone bodies are highly acidic.
So the blood turns acidic.
Right. They flood the bloodstream, overwhelming the body's natural buffering systems, and the blood pH drops dangerously low. This acidosis disrupts enzyme functions body-wide, creating a life-threatening crisis. Sometimes DKA is the very event that reveals a type 1 diagnosis in a previously healthy child.
That is so scary. But a type 2 emergency plays out entirely differently. They usually don't go into DKA because they still have that struggling train yard pumping out a tiny bit of insulin.
That residual insulin is the key difference. A type 2 patient might not have enough insulin to control their blood sugar, which can skyrocket catastrophically to 600, 800, or even over 1,000 milligrams per deciliter.
Oh my gosh. 1,000.
Yeah, it can get that high.
Right.
But that tiny trickle of insulin is usually enough to keep that hormone-sensitive lipase in check, so they don't experience the massive fat breakdown, and they don't produce significant ketones.
Instead, they present with HHS, hyperosmolar hyperglycemic state. The blood sugar is so high, it essentially turns the blood into a thick syrup.
Yeah, syrup is a good way to picture it. This hyperosmolarity pulls water directly out of the brain and surrounding tissues, leading to severe dehydration and altered mental status, but without the extreme acid buildup.
The underlying mechanism completely dictates the clinical reality you see in the trauma bay. If the mechanics dictate entirely different emergencies, the historical labels of insulin-dependent and non-insulin-dependent diabetes must have been incredibly frustrating for clinicians.
They were deeply misleading. Until 1997, the World Health Organization and the ADA classified the disease based on the treatment you were receiving.
Which tells you nothing about what's actually wrong with the patient.
Exactly. Because type 2 is a progressive disease driven by glucotoxicity, plenty of quote-unquote non-insulin dependent patients eventually require insulin therapy as their beta cells undergo apoptosis. The label said nothing about the actual disease process.
So in 1997, the ADA's expert committee formally anchored the categories to the etiology. Type 1 became the label for autoimmune destruction, and type 2 became the label for progressive insulin resistance.
And this understanding of progression really crystallized with two massive clinical trials in the 1990s, the DCCT for type 1 and the UKPDS for type 2. Both trials proved that keeping blood sugar as close to normal as possible dramatically reduced microvascular complications.
Okay, but how does high blood sugar actually break a blood vessel in the eyes or the kidneys?
It comes down to a process called glycation. When glucose levels are chronically high, the excess sugar molecules literally stick to the proteins and lipids that make up the walls of your blood vessels.
Wait, they just stick to them?
Yeah. This creates what are called advanced glycation end products, or AGEs.
That sounds like rust building up inside a pipe.
It functions very much like that. These AGEs stiffen the vessel walls, promotes systemic inflammation, and cause the tiny capillaries in the retina of the eye, the filtering units of the kidneys, and the linings of the nerves to physically thicken and leak. The DCCT and UKPDS trials prove that the hyperglycemia itself is what drives this structural damage.
Okay, so we've established this very logical, neat two-bucket model. Type 1 is the autoimmune destruction. Type 2 is the fat-induced insulin resistance.
Right.
But here's where we get to the cutting edge, because nature hates neat boxes, and modern science is actively taking a sledgehammer to this binary.
Oh, yeah. The two-bucket model is now openly debated inside endocrinology. The major turning point was a 2018 Swedish study published by Almqvist and colleagues in the Lancet Diabetes and Endocrinology.
They didn't just look at a few basic labs, did they?
No, they applied complex cluster analysis to massive amounts of metabolic and genetic data from nearly 9,000 newly diagnosed diabetes patients.
And they didn't find two groups. They found 5 distinct clusters of the disease.
5 unique metabolic profiles. They identified a severe autoimmune cluster, which maps to our classic type 1, but then they broke the type 2 bucket into 4 separate diseases.
Wow, 4.
Yeah. They found a severe insulin-deficient cluster where patients look like they have type 2 but produce very little insulin and have a massive risk of retinopathy. They found a severe insulin-resistant cluster where patients produce plenty of insulin but have an incredibly high risk of kidney disease. And finally, they identified a mild obesity-related cluster and a mild age-related cluster.
The implication there is staggering. It means treating every quote-unquote type 2 patient the same is physiologically backward. A severe insulin-deficient patient needs a completely different pharmaceutical strategy than a severe insulin-resistant one.
Absolutely. The textbook binary is largely a simplification we've kept around for teaching and medical billing convenience. We can actually see this blurring of the lines in clinical practice right now with something called LADA.
LABA stands for latent autoimmune diabetes in adults. Some clinicians informally refer to it as type 1.5, right?
Yes. These patients test positive for the exact same autoantibodies as type 1, especially GAD65.
Yeah.
The autoimmune fire is burning, but it's burning in slow motion.
And because they are adults and they don't immediately go into DKA, they get misdiagnosed as having type 2.
This is a critical failure mode that nurses and clinicians must watch for. A lean adult comes in with elevated blood sugar. The clinician assumes it's type 2 based on age, puts them on an oral medication like metformin, and sends them home.
But metformin primarily reduces glucose production in the liver. It does absolutely nothing to stop the immune system from destroying the beta cells.
Right. Eventually, the destruction completes, and the patient absolutely requires insulin. Misdiagnosing LEA delays necessary therapy and causes immense metabolic stress.
That actually touches on one of the biggest misconceptions we need to clear up. The stereotype that type 2 diabetes only happens to overweight individuals.
Oh, that is a huge myth.
Lean people absolutely develop type 2 diabetes based on their specific genetic architecture for fat storage. If your body has a very low capacity to safely store fat in subcutaneous tissue, even a small amount of weight gain can spill over as ectopic fat into the liver and trigger the Randle cycle.
The epidemiology forces us to confront these stereotypes constantly. We saw this historically when pediatric type 2 diabetes became so common that the medical community had to retire the old name adult-onset diabetes.
Because kids were getting it.
Exactly. And we must also confront the myth that type 1 is caused by a poor diet. Type 1 has zero to do with sugar consumption. It is an autoimmune genetic roll of the dice, and the stigma around it causes needless guilt for families.
Which brings up a fascinating current debate in the medical community, the concept of reversing type 2 diabetes. We hear this a lot with the rise of bariatric surgery and extreme low-calorie diets, like those studied in the UK's DIRECT trial.
Yes, the DIRECT trial was groundbreaking.
They showed that intensive weight loss can effectively clear out that ectopic fat infiltrating the liver and pancreas, restoring normal glucose control in a substantial fraction of patients.
It is a phenomenal therapeutic advancement, demonstrating just how mechanically driven insulin resistance is. But the ADA strongly prefers the term remission over cure or reversal.
Because the genetic susceptibility to the Randle cycle hasn't gone anywhere.
Precisely. The genetic architecture remains. The beta cell capacity and the underlying insulin resistance will rapidly redeteriorate if the ectopic fat returns, or simply as a consequence of aging. Remission acknowledges that the environmental trigger has been removed, but the underlying biology requires lifelong vigilance.
So what does this all mean for you listening? Why did we just spend 20 minutes dissecting the Randle cycle, autoantibodies, and identical twin studies?
Because understanding the mechanism is the absolute foundation of clinical relevance. If you are a nurse and you treat a type 1 patient's DKA the way you would manage a type 2 patient's HHS, or if you assume a 35-year-old lean adult can't possibly have LADA, that misunderstanding can be fatal.
Furthermore, understanding these pathways is the only way to make sense of the modern pharmaceutical revolution we are seeing. Take the blockbuster GLP-1 receptor agonists, like semaglutide.
Right. They work by mimicking incretin hormones.
Yeah, which naturally amplify the pancreas's ability to print those insulin badges in response to food. Or the SGLT2 inhibitors, which bypass the insulin system entirely and just force the kidneys to dump the excess glucose cargo directly into the urine. You cannot understand the treatments without understanding the biological machinery they're acting upon.
The pathophysiology underpins every treatment algorithm, every emergency response protocol, and how you educate your patients to take control of their own health.
I want to leave you with a final thought to mull over. Back in 1997, the medical community redefined this disease overnight. They dropped a diagnostic threshold from 140 down to 126 milligrams per deciliter, and they retired the confusing IDDM and NIDDM labels.
It was a massive shift.
Given the 2018 discovery of the 5 distinct genetic and metabolic clusters we discussed today, how long will it be before the labels type 1 and type 2 themselves become historical relics?
It's a great question.
We are on the verge of completely changing how we diagnose and treat this 3,000-year-old disease tomorrow. The next time you look at an A1C number, remember, it is just a number. It's the biological mechanism behind it that tells the true story. You know, if you look really closely at a modern hospital, you'll notice this kind of startling paradox.
Oh, absolutely. It's pretty obvious once you see it.
Right, because the doctors are the ones writing all the orders, but they're darting in and out of the room for maybe like 5 minutes at a time.
Yeah.
But the person who actually decides if you survive the night, the one translating this whole chaotic maze of machines and alarms into your actual care is the nurse.
Yeah, it's really the central reality of healthcare. I mean, they are the constant stationary sentinels in what is otherwise a wildly transient environment.
And from the outside, I mean, to you or me sitting in that room, it can look like they're just constantly moving, like they're just checking boxes on a clipboard, running from room to room based on pure instinct.
Which is completely understandable. It looks like managed chaos.
Exactly. But today we are looking at a snack of sources. We've got medical texts, nursing theory, historical documents, and they reveal this hidden, mathematically rigorous engine driving every single move they make.
Yeah, and what we're actually looking at here is a framework borrowed directly from general systems theory, which, if you're not familiar, is just the idea that you can't look at isolated parts. You have to look at a complex system interacting with its environment.
Right, like the whole picture.
Exactly. It relies on continuous feedback loops to maintain stability. And when you apply that to clinical decision-making, it provides this deeply structured logic that keeps patients alive when, time is incredibly short and conditions are changing by the minute.
Okay, let's unpack this, because our mission for this deep dive is to uncover something called the nursing process, specifically a framework known by the acronym ADPIE.
ADPIE.
Yeah, ADPIE.
Mm-hmm.
And our goal is to show you how this isn't just dry medical jargon. It's a rigorous, literal, life-saving loop of critical thinking.
It really is.
But before we get into what the actual letters in ADPIE stand for, we need to talk about how the very definition of nursing care had to fundamentally shapeshift over the last few decades to even, make this framework possible.
And that shapeshifting is vital context. I mean, without understanding how radically the profession changed, the acronym just looks like some corporate management tool forced onto healthcare workers.
Yeah, totally. Because when I first looked at this framework, my immediate thought was to compare it to, a mechanic's diagnostic checklist for a broken car.
Oh, sure. That's a super common assumption.
Right, you bring the car in, the mechanic checks the oil, checks the tire pressure, ticks off a to-do list, and fixes the broken part. I assumed the nursing process was basically just a standardized to-do list to get through a 12-hour shift.
Well, what's fascinating here is that historically your mechanic analogy wouldn't have been too far off.
Wait, really?
Yeah, early on it was. But today, viewing human care through the lens of a static machine checklist completely misses the reality of biological systems. The nursing process actually went through 3 massive theoretical shifts to get where it is today.
Okay, so what was the first one?
The first was moving away from that linear model to a cyclical one. Back in the early 1950s and 60s, textbooks treated nursing care as a one-way street.
Meaning you just go from point A to point B and stop.
Precisely. You assess the patient once, you diagnose the problem once, you create a plan once, and you are done.
Kind of like climbing a staircase. You reach the top floor and your job is finished.
Right, but human bodies aren't static.
Right.
I mean, a medication given at 8 a.m. completely changes the body's chemistry by 9:00 a.m.
Well, it's true.
So by the 1980s, theorists redrew the entire model as a continuous circle. The final step of the process evaluation isn't the end of the road anymore. It acts as a mandatory feedback loop.
Oh, so it pushes you right back to the beginning.
Exactly. It's a re-entry point directly back into the first step. You are never actually done as long as the patient is in that bed.
Okay, that structural change makes total sense for a dynamic biological system. But shifting from a line to a circle doesn't automatically solve the problem of, well, what the nurse is actually trying to achieve, right?
And that brings us to the second major shift, which was moving from a task-based framework to an outcome-based framework.
Task to outcome, got it.
Yeah. Older versions of nursing heavily emphasized the physical tasks a nurse performed. Like the central question was always, did I take the vitals? Did I administer the medication? It only measured the nurse's output.
Right.
But contemporary theory reframed that entire philosophy around the patient's outcomes instead.
So it shifted from, say, a teacher asking, did I teach the math lesson, to did the students actually learn the math?
That is a perfect way to look at it, yes.
Yeah.
The metric of success is no longer the completion of a checklist. The metric is whether the patient's condition measurably improved against a highly specific goal.
Which is much harder to prove, I'd imagine.
Very much so. But it tracks with a broader move in medicine toward evidence-based practice. There's even this massive standardized classification system now called the Nursing Outcomes Classification, or NOC.
NOC.
Yeah. And NOC literally forces nurses to measure if a patient is actually getting better, using standardized indicators rather than just, vague subjective feelings like they seem fine.
But honestly, implementing something as rigorous as standardized outcomes across the board requires a lot of authority. And our sources highlight that this transition from simple tasks to complex, measurable outcomes, it didn't just happen because someone wrote a new textbook.
No, not at all. It was a fight.
Yeah, it was born out of this fierce rebellion for professional independence. But wait, before this existed, were nurses genuinely just viewed as extensions of the doctor? Like just executing orders without any independent judgment?
Pretty much, yeah. The clinical hierarchy of the mid-20th century was remarkably rigid. Nursing care was almost exclusively physician-directed.
Wow.
A doctor would write an order, administer this drug, change this dressing, and the nurse was expected to just execute it. They did not have a codified, independent framework for their own clinical judgment.
So they were just hands, essentially, not brains.
That's how the system treated them. The nursing process emerged specifically to push back against that, to establish nursing as an autonomous, intellectually rigorous profession with its own distinct legal and diagnostic authority.
But how does a profession entirely subordinate to physicians manage to carve out its own independent diagnostic taxonomy? I mean, that requires a massive shift in power. Who are the people actually pushing for this?
Well, the paradigm shift really began in 1955 with a nurse theorist named Lydia Hall.
Okay.
She was the first to formally describe nursing not as a series of delegated chores, but as a deliberate process of observation, administration, and validation. She basically planted the flag that nursing had a distinct intellectual component separate from medicine.
It sounds like she cracked the door open for everyone else.
She definitely did. And then in 1961, Ida Jean Orlando, who was working out of Yale University, essentially kicked it wide open.
Oh, wow, okay.
Yeah, she actually popularized the term nursing process. Orlando realized that patients were actively suffering because nurses were largely just waiting around for doctors to dictate the next move.
Oh, because the doctors aren't in the room all the time.
Exactly. She observed that if a nurse could systematically analyze their own observations and act on them independently, patient distress plummeted. Her original model was just 3 steps, though: observation, action, and evaluating the patient's reaction.
But wait, we are still 2 steps short of the 5-step ADPIA engine we use today. Where did the rest come from?
Right. So Dorothy Johnson expanded it to a 4-step model in 1959. But the true turning point, the moment that finalized the ADPIE model as we know it, happened at this pivotal conference at St. Louis University in 1973.
Okay, 1973. Who was leading that?
It was led by Christine Gebbe and Marianne Lavin. That was the moment where they formally split diagnosis out as its own distinct standalone step.
Hold on. Carving out the power to legally diagnose a patient, that sounds like a massive jurisdictional turf war with the doctors.
Oh, it was a clinical earthquake. It was huge. But by claiming the word diagnosis, they weren't trying to practice medicine without a license. They were claiming authority over a different domain entirely.
Interesting.
And that conference birthed what would eventually become the North American Nursing Diagnosis Association, which we now know as NANDA.
NANDA, right. And if we connect this to the bigger picture, this wasn't just like some academic debate over acronyms.
Really not.
This gave nurses a defensible, legally documentable rationale for their independent clinical decisions. Like, it defined their scope of practice in a court of law. It proved they were assessing, diagnosing, and treating something highly specific.
Yes, which brings us perfectly to how this engine actually operates on the floor of a hospital today.
Yeah, let's get into that. Let's talk about the mechanics of ADPII in action, specifically the difference between a medical diagnosis and a nursing diagnosis, because our sources spend a lot of time delineating those two things.
It's a very important distinction.
So tell me if this analogy holds up. If a medical diagnosis is the weather report, like, hey, a Category 4 hurricane is making landfall, is the nursing diagnosis basically a report on how your specific house is holding up to the storm?
That captures the division of labor beautifully.
Oh, awesome.
Yeah, the medical diagnosis names the pathology. It names the hurricane, right? So congestive heart failure, pneumonia, diabetes.
Right, the disease itself.
Exactly. The nursing diagnosis names the patient's unique, individualized response to that pathology. It assesses the house. Are the windows leaking? Is the foundation cracking under the stress?
Okay, let's run this through the actual 5 steps, using a clinical example from our sources. We have a 78-year-old patient who just came out of hip fracture surgery.
Perfect example.
Let's put ADPI into action here. Step 1, the A stands for assessment.
Right. Assessment is the foundation of the entire system. It is the systematic collection of both subjective data, which is what the patient tells you, like their fear of falling or their pain level, and objective data.
And objective is what the nurse observes and measures, right?
Correct. What they observe, measure, and test.
So for our 78-year-old post-op patient, a nurse isn't just writing down, patient appears to be in a lot of pain.
No. The data collection is highly granular. They are recording a blood pressure of, say, 148/92, a heart rate of 104. The patient reports pain as a 7 out of 10, characterized as sharp and worsening with any movement.
Very specific.
Very. They note the skin is cool and diaphoretic. They also use validated, standardized tools for assessment.
Like what?
Well, they might run a Braden scale assessment, scoring the patient between 6 and 23 to mathematically determine their risk for developing pressure injuries from just lying in bed, or they'll use a more Sval scale. This specific data becomes the raw material for the rest of the loop.
Which brings us to step 2, the D for diagnosis, naming the problem. Now, the doctor already gave the medical diagnosis, which was the hip fracture. So what exactly is the nurse doing in this step?
The nurse formulates a clinical judgment about the patient's response, using that NANDA International Taxonomy we mentioned earlier. And that taxonomy currently contains over 250 approved diagnostic labels.
Okay, wait, I have to push back here.
Yep.
250 different diagnoses just for how a patient responds to an illness. Doesn't that risk becoming this bloated bureaucracy? Like, is a nurse really flipping through a 250-item catalog while a patient is groaning in pain?
I know, it sounds completely overwhelming, but that taxonomy is necessary for precision.
How so?
Well, if a patient's oxygen is dropping, writing breathing poorly isn't a legally or clinically actionable term. NANDA forces the nurse to distinguish between ineffective airway clearance, which might be caused by mucus, and impaired gas exchange, which might be caused by fluid in the lungs.
Oh, I see.
Those require 2 completely different interventions to fix.
So the precision dictates the treatment. And our sources note they use a very specific format for writing these out called PES, problem, etiology, and signs.
Yes. So for our hip surgery patient, the nursing diagnosis wouldn't just be pain.
What would it be?
It would be formally written as acute pain related to surgical tissue trauma as evidenced by patient report of 7 out of 10 pain, guarding behavior, and an elevated heart rate.
Wow, okay. And I guess a different nurse could look at the exact same patient with the exact same hip fracture and add a completely second diagnosis, like risk for falls related to postoperative weakness and unfamiliar environment.
Exactly. The medical diagnosis is identical for everyone with that fracture, but the nursing diagnoses adapt to the individual person in the bed.
Which leads us directly into step 3, P for planning, setting the goals.
Yes, and these goals use SMART criteria, meaning they have to be specific, measurable, achievable, realistic, and time-bound.
Right. And this is where that alphabet soup of nursing language all kind of comes together, doesn't it?
It really does. They use the diagnosis from NANDA, they select interventions from the NIC taxonomy, that's Nursing Interventions Classification, and they set goals using the NOC Outcomes Classification we mentioned earlier, the NNN language.
NNN. Got it. So for our patient with acute pain, a SMART goal isn't just make the patient comfortable. It has to be something like Patient will report pain at a 3 out of 10 or lower within 1 hour of intervention.
Highly specific and strictly time-bound, which takes us right to step 4. I here for implementation. Action meets reality.
Okay, this is where the nurse actually gives the pain medication.
Giving the prescribed analgesic is one intervention, yes. But nursing interventions go so much further than just pills.
Like what else?
It involves repositioning the patient. Because this is a hip surgery patient, the nurse has to implement strict hip precautions. They are actively avoiding internal rotation or adduction, which could literally dislocate the brand new hip implant.
Ouch. Okay, so we've assessed the data, diagnosed the response, planned a measurable goal, and implemented the physical care. Now we reach the final letter, E for evaluation. Did any of this actually work?
The most crucial part.
Let's expand on our earlier analogy. The doctor says a hurricane is coming. The nurse says the roof is leaking. But the nurse doesn't just put a bucket under the leak and walk away for the rest of the shift.
No, the evaluation step mandates that they come back to the room in an hour to see if the bucket is overflowing.
Right.
So 1 hour after giving the medication and repositioning the patient, the nurse returns to the bedside. They reassess the subjective and objective data. And let's say the patient now reports their pain is a 4 out of 10.
But wait, the SMART goal was 3 out of 10 or lower, so the goal failed.
It did. But because ADPIE is a continuous loop, a failed goal isn't the end of the shift. The evaluation step forcibly cycles the nurse back to the A, back to assessment.
Ah, the loop.
Yes. Was the medication dose inadequate? Is the patient's anxiety exacerbating the pain? Does the care plan need to be totally rewritten? This continuous feedback loop is the mathematical safety net that catches subtle declines.
Okay, but here's where it gets really interesting for me. Because ADPIE sounds perfect in theory. It's elegant, it's rigorous, it's logically sound.
On paper, yes.
Right. But what happens when this highly academic 5-step framework collides with the chaotic, brutally understaffed reality of a modern hospital? Does forcing every single decision into this rigid, standardized box actually kill a veteran nurse's natural intuition?
You've just touched on one of the most prominent debates in nursing theory. This was spearheaded by Patricia Benner.
Okay, what did she say?
Well, in 1984, Benner published a landmark book called From Novice to Expert. She applied the Dreyfus model of skill acquisition to nursing, and she explicitly warned against the danger of what she called cookbook nursing.
Cookbook nursing, meaning like just blindly following a recipe without ever tasting the soup to see if it actually needs more salt.
That's a great way to put it. The Dreyfus model illustrates that while a novice desperately needs rigid, context-free rules, like a 5-step ADPIE checklist, just to function safely.
Right, because they don't know what they're doing yet.
Exactly. But an expert operates completely differently. An expert nurse relies on tacit, holistic pattern recognition. They don't think in rigid blocks anymore.
They just kind of feel it.
Yes. An expert can walk into a room, take one single look at a patient's skin tone, the rhythm of their breathing, the tension in their posture, and instantly sense the patient is crashing.
So they know the house is collapsing before they've even pulled out a clipboard to measure the water in the bucket.
Precisely. And critics of the nursing process argue that overstandardizing care privileges this bureaucratic documentation over that rapid, life-saving human intuition. And this ties into a known vulnerability called diagnostic drift.
Oh, right. Diagnostic drift is where two veteran nurses can look at the exact same objective and subjective data and select entirely different NANDA diagnoses.
Exactly. Because human experts prioritize different things based on their unique experiential patterns.
That makes sense.
Yeah, one expert might immediately prioritize the acute pain, knowing it's driving up the heart rate. Another expert might prioritize the fall risk, knowing the patient is disoriented from the anesthesia. But honestly, the deepest friction point in the real world isn't even theoretical disagreement.
What is it?
It's the sheer crushing burden of burnout and documentation.
Because proving you did ADPIE is what keeps the hospital legally accredited.
Yes, organizations like the Joint Commission constantly audit these care plans to ensure safety standards are being met. But the documentation is so extensive that nurses report spending massive chunks of their 12-hour shifts glued to a computer screen in the hallway, charting their assessments, rather than actually being at the bedside observing the patient.
Wow, that is a brutal paradox. The very tool designed to ensure meticulous, individualized care is physically pulling the nurse away from providing that care.
It is, and this raises an important question. What happens when systemic pressure becomes so immense that the core discipline of this process, the A for assessment, simply collapses.
And the sources cite a highly disturbing example of exactly this, the Mid-Staffordshire NHS Foundation Trust scandal in the UK, which blew up around 2013. And we aren't just talking about a few missed chart entries here. This was a catastrophic, systemic failure.
Yeah, it is a harrowing cautionary tale of what happens when that feedback loop is destroyed.
What actually happened?
Well, investigations found that the hospital culture became so aggressively focused on administrative targets, like emergency room throughput and financial metrics, that chronic short staffing became the norm.
So there just weren't enough nurses.
Right. Nurses simply did not have the time to perform systematic assessments. Basic hydration, pain management, and early signs of deterioration were entirely missed.
Because if you skip the assessment step, you can't diagnose, you can't plan, and you certainly can't evaluate. The entire engine just stalls out.
Exactly. And hundreds of patients suffered or died unnecessarily. It proved that ADPIE isn't just an academic decoration or, a hurdle for nursing students to clear. The rigorous discipline of gathering data and evaluating it is the literal difference between life and death.
That is heavy.
It is. But the process only functions if hospital administrators provide the staffing ratios and the time to actually execute the loop.
So what does this all mean? Let's bring us back to you, the listener. The next time you find yourself in a hospital bed or sitting in a chair next to someone you love, and you see a nurse checking a monitor, asking specific questions about your pain, or adjusting your physical position, you now know they aren't just ticking off a random checklist. They are executing a continuous, relentless cycle of observation and feedback.
That machinery of ADPIE is always running in the background.
Furthermore, you know that when they diagnose you, they aren't looking at the disease. The doctors are tracking the hurricane. The nurse is looking at you. They are looking at your personal, unique, individualized response to the crisis.
That's the beauty of it.
Yeah, this invisible framework is the reason why excellent care feels personal rather than generic. Every time a nurse catches a subtle decline in your health before it spirals into a full-blown emergency, it isn't just luck. It's ADPIE at work.
It is the structured discipline that allows them to apply their intuition safely and effectively. But I do want to leave you with one final thought to ponder today, building on that tension we discussed earlier between Patricia Benner's cookbook nursing and the modern documentation burden.
Oh, I like where this is going.
Right now, hospitals are racing to integrate AI and predictive algorithms into electronic health records. These systems can instantly analyze a patient's data, automatically generate a care plan, and instantly suggest NANDA diagnoses.
So basically taking the cognitive heavy lifting and the charting completely out of the nurse's hands.
Exactly. The question is, will this incoming algorithmic technology finally free nurses from the computer screen, giving them their time back so they can return to the bedside and engage in true human assessment? Or
what?
Or will it push the profession into the ultimate cookbook nursing trap, where rigid algorithms quietly override the irreplaceable, holistic intuition of an expert nurse?
Wow. It's the ultimate modern tension between the efficiency of the machine and the necessity of the human touch. Because when the storm hits, you want the person assessing your house to actually be looking at the foundation, not just trusting an automated report from the Weather Bureau. So I want you to picture a 17th century doctor, or just standing in this dim candlelit room, trying to physically pump the blood of a live sheep into a human patient.
I mean, it sounds like a horror movie.
It really does, and it was absolute unmitigated chaos. I mean, the results were exactly as disastrous as you would imagine.
Right, yeah.
But contrast that horrifying image with today, because when you think of modern nursing, there is this expectation of absolute unbending precision. It's like an assembly line of safety. Barcode scanners, exact milligram dosages, double-locked medication cabinets. Everything is just highly, highly controlled.
Oh, absolutely. And it's a system designed entirely around eliminating variables. Because, we crave predictability in medicine, especially when we're dealing with something as volatile as human biology.
Exactly.
The early days of transfusion were quite literally a shot in the dark. They didn't even fully grasp what the fluid they were transferring actually contained.
And that terrifying contrast is the mission of today's deep dive into our sources. We are taking a really comprehensive look at the modern science of blood transfusion.
Yeah, it's a huge topic.
It is. Specifically, we're unpacking the safety protocols, the severe physical reactions, and the absolute non-negotiable rules for the nurses administering it. Because this isn't just like a routine hospital checklist for you to fill out.
No, definitely not.
It is a high-stakes, risk-bearing treatment, A nurse's vigilance at the bedside is the literal difference between life and death.
And it requires that level of vigilance because, on the surface, a blood transfusion sounds deceptively simple.
Right, like a plumbing fix.
Exactly. You have a leaky system or an empty tank, and you just put fluid back into it to bring the pressure up. But the reality is that transfusion is a really complex, constantly shifting science. We're transplanting liquid tissue from one human being to another.
Liquid tissue. That's a crazy way to think about it.
But that's what it is. And the rules of what we give, when we give it, and how we monitor the body's reaction to it, they've radically evolved.
So to really grasp those modern rules, we sort of have to look at how we even figured out what blood, is. Because for the longest time, a transfusion just meant take blood from person A, put it into person B, and cross your fingers.
Yeah, and the foundational breakthrough there didn't even happen until the turn of the 20th century.
Really? That late?
Yeah, in 1900 and 1901. There was an Austrian physician named Karl Landsteiner, and he was mixing serum and red cells from his colleagues in a lab.
Just casually mixing his coworker's blood.
Basically, yes. And he noticed that certain combinations caused the blood to clump up or agglutinate. It was essentially turning into a thick sludge.
Oh, wow.
Right. And that single observation led him to discover the distinct blood groups we now know as A, B, and O. And then his colleagues identified the AB group shortly after, in 1902.
Which finally explained why some of those early desperate transfusions miraculously saved the patient, while others killed them almost instantly.
Exactly.
The blood was literally clumping up inside their veins.
It was a monumental discovery. But the tragedy of foundational science is that the recognition often lags decades behind the application. Landsteiner didn't win the Nobel Prize for this until 1930.
Wait, nearly 30 years later?
Yep, nearly 30 years.
That is wild. But okay, even with the blood types figured out, the physical logistics of moving blood from one body to another, it just sounds like a surgical nightmare back then.
Oh, it was incredibly grueling. So around 1906 and 1907, an American surgeon named George Quile was performing direct artery-to-vein transfusions.
Direct, like no tubes or bags.
Well, you couldn't just use a needle in a bag. You had to physically slice open the blood vessels of the donor and the recipient and stitch or clamp them together with tubing.
Oh, my God.
Yeah. It required extreme surgical skill. You couldn't really measure how much blood was actually being transferred. And it was really only viable in the absolute most desperate emergencies.
Just two people literally tethered together in a surgical theater. I mean, that is not a sustainable medical practice.
No, not at all. The real game changer, the thing that actually made modern blood banking possible, happened in 1914.
Okay, what happened then?
Two physicians, Luis Agode in Argentina and Albert Huston in Belgium, independently figured out a chemical workaround.
Oh, okay.
They realized that if you add sodium citrate to blood as it leaves the body, it prevents it from clotting.
How does that actually work, though? Does it, freeze the cells or something?
It's all about calcium. So the human body's clotting cascade relies heavily on calcium to form those biological nets that stop bleeding.
Right.
Sodium citrate binds to the calcium in the extracted blood. It essentially locks it up so the blood can't clot. Suddenly, you didn't need the donor in the room anymore.
You had a chemical pause button.
Exactly. You could store the blood in a glass bottle and use it days later.
Which obviously changes the entire landscape of global medicine, especially with the World Wars kicking off right around then.
Definitely. World War I saw the first organized use of stored blood on the battlefield by Oswald Robertson. And then World War II drove this massive institutionalization of the field.
Okay.
Charles Drew, who was an African-American surgeon and researcher, he developed large-scale methods for processing and storing blood plasma. He directed the massive Blood for Britain program in the early 1940s, and he really helped structure the American Red Cross's blood banking system.
Let me pause on that for a second, because our sources highlight a massive shift in how we actually deliver this blood today.
Right.
Because back on those battlefields, they were giving people whole blood, literally everything that came out of the donor's arm. But if you or I end up in the hospital today after a car crash, we aren't getting whole blood, are we?
In civilian medicine, almost never.
Wow, okay.
And that represents a fundamental shift in our definition of a transfusion. Today, when we say blood transfusion, it almost universally means component therapy.
So they break it down.
Yeah. When you donate a pint of whole blood, the lab spins it down in a massive centrifuge. They separate it into its parts. Packed red blood cells, fresh frozen plasma, platelets, and cryoprecipitate.
So it's more like a customized biological recipe. Like if I'm bleeding out, I might get red cells for oxygen, plasma for volume, and platelets for clotting, but they're all coming from different bags.
Exactly. Whole blood is mostly reserved for military trauma medicine out in the field and, some very specific pediatric cardiac surgeries.
Oh, interesting.
Yeah. Though I will say there is a bit of a current revival in researching low titer O whole blood for severe pre-hospital hemorrhage. But generally, component therapy remains the absolute default.
Yeah.
We give the patient only the specific part of the blood they are missing.
That makes a lot of sense from an efficiency standpoint. But the sources point out another massive shift, and this one is about when we decide a patient actually needs that blood.
This is a huge one. For most of the 20th century, the medical culture was incredibly liberal with blood.
Yeah.
The operating assumption was basically, when in doubt, transfuse. Doctors wanted to keep a sick patient's hemoglobin levels really high, usually near 10 grams per deciliter.
Because intuitively, I mean, if you are sick or injured, having a full tank of oxygen-carrying red blood cells just feels like it would help you heal faster.
It feels incredibly intuitive. But, biology rarely cares about our intuition.
Fair enough.
In 1999, there was a landmark study published in the New England Journal of Medicine called the CHIRI-CEC trial, and it completely upended this logic.
What did it find?
Well, it compared that liberal strategy to a restrictive strategy, where doctors forced themselves to wait. They only transfused when a stable patient's hemoglobin dropped all the way down to 7 grams per deciliter.
That sounds incredibly risky, like letting a patient get that anemic before intervening.
The results were staggering, though. The restrictive strategy proved that giving less blood produced equal or sometimes significantly better outcomes for the patients.
Wait, better outcomes by withholding a treatment? Why?
Because a transfusion is essentially a liquid organ transplant.
Oh, right, you said that earlier.
Right. When you infuse foreign biological tissue into a sick patient, you are introducing a massive inflammatory and immune burden. It causes immunomodulation, meaning it can actually suppress the patient's own immune system, which increases the risk of infection.
Wow.
It also risks volume overload, which stresses the heart. The CHIRI-CEC trial forced the medical community to realize that blood is a risk-bearing treatment, not just some harmless tonic. Today, that restrictive threshold fundamentally dictates how a nurse interprets a patient's lab results.
So if we are injecting foreign tissue that carries that much inflammatory risk, the biological matching process has to be, flawless.
It's absolutely flawless.
Let me try an analogy here to unpack the biology of compatibility, because antigens and antibodies can get pretty abstract quickly.
Let's hear it.
Okay, imagine the antigens on the surface of your red blood cells are like a team uniform. You're wearing an A uniform or a B uniform. And the antibodies floating around in your blood plasma, the liquid part, are like bouncers at a very exclusive club.
That's actually a highly accurate way to visualize it. The antigens are the physical identifiers, and the antibodies are the immune system's security force.
So if you have type A blood, you're wearing the A uniform. Your plasma has anti-B bouncers constantly on patrol.
Correct.
If a red blood cell wearing a B uniform gets infused into your bloodstream, those anti-B bouncers are going to aggressively attack it.
And they don't just, escort it out, they destroy it entirely.
Jeez.
The medical term for that destruction is hemolysis. The recipient's bouncer antibodies latch onto the incompatible donor cells and literally rupture the cell membranes.
And what does that physical destruction actually do to the patient lying in the hospital bed?
It triggers a systemic catastrophe. When those millions of red cells rupture simultaneously, they dump their contents, specifically free hemoglobin, directly into the bloodstream.
And that's bad.
Very bad. Inside a cell, hemoglobin carries oxygen. But free-floating in the blood, it is incredibly toxic.
Oh, wow.
It travels to the kidneys and physically clogs the delicate renal tubules, causing sudden acute kidney failure. Furthermore, all that massive cellular debris activates the body's clotting cascades inappropriately.
Wait, so the blood starts clotting everywhere?
Exactly. It leads to a condition called disseminated intravascular coagulation, or DIC. The body forms microscopic clots in all the small blood vessels, which consumes all your clotting factors, meaning you simultaneously start bleeding uncontrollably from everywhere else.
That is horrific. Clotting and bleeding at the same time.
It triggers systemic shock. And this entire cascade can be fatal within minutes of the incompatible blood hitting the patient's vein.
Within minutes, that is terrifying. And that's just the ABO uniform system, right? The sources also heavily emphasize the RH factor.
Right, the RH factor, which is the positive or negative attached to your blood type. About 85% of people carry the RhD antigen on their cells. They are Rh positive. The remaining 15% are Rh negative. But the Rh system behaves completely differently than the ABO system. If you are Rh negative, you don't naturally have anti-Rh bouncers already patrolling your blood from birth.
Oh, really? So if I'm Rh negative and I accidentally get infused with Rh positive blood, my immune system won't attack it right away.
You get a free pass on the first exposure.
A free pass.
Sort of. You can receive that one Rh positive transfusion without an immediate hemolytic catastrophe. But that exposure teaches your immune system to recognize the foreign antigen. It essentially prints wanted posters and builds an army of anti-Rh antibodies.
So the trap is set for the second time.
Exactly. If you ever get a second exposure to Rh-positive blood, that newly built army will instantly attack it, causing massive hemolysis.
Wow.
And this delayed sensitization is also the exact mechanism behind hemolytic disease of the newborn, or erythroblastosis fetalis.
How does that happen with a newborn? Like, how are they exposed?
So if an Rh-negative mother is carrying an Rh-positive fetus, and their blood mixes during delivery, the mother's immune system will build those anti-Rh antibodies.
Okay, I follow.
If she gets pregnant with a second Rh-positive baby, her antibodies can cross the placenta and destroy the fetus's red blood cells.
Oh my God, that's tragic.
It is, but thankfully today, we prevent this entirely by giving the mother an injection called RhoGAM during pregnancy.
RhoGAM.
Yes. It basically cloaks the fetal cells so the mother's immune system never even sees them, preventing the antibodies from ever forming in the first place.
It's brilliant that we can, like, hijack the immune system like that.
Truly.
Okay, speaking of the immune system, I have to bring up a huge assumption I had before reading these sources. I've watched medical dramas my whole life, right?
Sure.
And the doctors are always shouting, "Get me O negative." So I just thought O negative was the universal donor for everything.
You and everyone else.
Yeah.
That is perhaps the most dangerous misconception in public medical knowledge. O negative is the universal donor for red blood cells only.
Right, because O negative red cells have no A antigens, no B antigens, and no Rh antigens. They are wearing a totally blank uniform.
Precisely. You can put those blank cells into anyone, and no bouncers will recognize them to attack. But for plasma transfusions, the rules run in the exact opposite direction.
Wait, really?
Yeah. Remember, the plasma is the liquid where the bouncer antibodies live. Because an O-negative person has a blank uniform, their body naturally produces both anti-A and anti-B bouncers to protect themselves. Their plasma is fully loaded with both sets of antibodies.
Oh, wow. If you give O-negative plasma to a type A patient, you are literally injecting an army of anti-A bouncers directly into their bloodstream.
Exactly.
The donor plasma will start attacking the patient's own organs and blood cells.
It's a completely inverted reaction. So, if O-negative is the worst possible plasma to give universally, what blood type makes for the universal plasma donor?
It would have to be someone who has absolutely zero bouncers in their plasma, so someone with type AB blood, because they wear both the A and B uniforms, so their body wouldn't make antibodies against either one.
You nailed it. Type AB is the universal plasma donor.
That is so cool.
Their plasma contains zero anti-A or anti-B antibodies. It is completely safe to give to anyone. It's a total inversion of the red blood cell rules, and it's exactly why blood banks are constantly begging for AB plasma donors.
Okay, if the biology is this unforgiving, like, if a mismatch causes your kidneys to fail and your blood to simultaneously clot and hemorrhage, then the physical act of hanging that IV bag has to be flawlessly executed.
It has to be.
If I'm lying in an ICU bed, I want a supercomputer verifying that blood.
But the sources reveal a pretty shocking plot twist about where these fatal mismatches actually happen.
We all assume it's some deeply complex laboratory failure. Someone mislabels a test tube or misreads a chemical assay. But the hemovigilance data systems like the UK's SHOT program, which tracks serious hazards of transfusion, they repeatedly show that the leading cause of fatal ABO-incompatible transfusions is clerical error.
Clerical error? You mean like a typo? I mean, bedside identification failure.
Yeah.
The lab types the blood perfectly. They prepare the exact right unit. It gets sent up to the hospital floor, and the nurse hangs a correct unit of blood on the wrong patient.
Oh my God.
Someone skips a step or feels rushed or assumes they know who is in the bed.
That makes all those annoying hospital protocols make sense. Like every time a nurse asks for your name and date of birth, even though they just asked you an hour ago, it feels like bureaucratic overkill. But that physical check is literally the only firewall between a patient and a fatal hemolytic reaction.
It is the ultimate safety net. And because human error is so prevalent, the Joint Commission mandates a rigorous, non-negotiable two-nurse check.
2 nurses every time.
Every time. 2 qualified staff members must independently, physically verify the patient's identity and the product's identity directly at the bedside immediately before connecting the tubing. They must match the name, date of birth, and unique medical record number on the patient's physical wristband against the printed label on the blood bag.
And if they don't match?
If there is a single typo, a single digit off, the blood goes back to the lab.
Then once they pass that checkpoint and the blood actually starts flowing, the tension doesn't drop. The protocols dictate that the first 15 minutes are critical, right?
Incredibly critical. The infusion must start at a very slow crawl, usually around 2 milliliters per minute. And the nurse cannot leave the room.
They just stay right there.
They must remain physically at the bedside, directly observing the patient for that entire first 15 minutes.
Because if the bouncers are going to attack, they're going to do it fast.
Acute hemolytic reactions or severe allergic anaphylaxis will typically manifest within those first few milliliters.
Okay, let's run through the ultimate bedside scenario. You're the nurse, you've done the 2-person check, the blood is running at 2 milliliters a minute. Suddenly the patient spikes a fever, their teeth start chattering with chills, they complain of a sharp pain in their lower back, which I now know is their kidneys clogging, and they say, I just feel like something terrible is about to happen.
The impending sense of doom.
Right. What is the immediate response?
The very first step, regardless of what specific reaction you think is happening, is always the same. Stop the transfusion immediately. You clamp the line and shut off the pump.
Wait, you don't call the doctor to ask for permission. You don't slow down the drip to see if they stabilize.
Absolutely not. You stop the exposure to the foreign tissue. Next, you must keep the patient's IV access open because you are going to need to push emergency medications. You do this by running normal saline.
Okay.
But here is the critical detail that catches people off guard. You must completely disconnect the blood tubing and use entirely new saline tubing.
Wait, why can't you just hook the saline bag up to the existing tubing and just flush it through?
Think about the physical tubing. It is full of the incompatible donor blood. If you flush that line with saline...
You're pushing the bad blood in.
Right. You're physically pushing another 10 to 15 milliliters of lethal, unmatched blood directly into the patient's vein. So you disconnect the blood, attach fresh tubing with saline, and only then do you notify the physician in the blood bank.
That makes total sense.
And then the remaining blood bag, all the old tubing and fresh blood and urine samples from the patient goes straight back to the lab to figure out what went wrong.
Stop the blood, new tubing, run saline, notify the team. It has to be muscle memory.
Exactly.
But while you're executing that protocol, you also kind of have to be a detective, right? You have to figure out what kind of reaction is happening because the sources detail a massive spectrum of ways the body can fight back.
Yeah, we just described the worst-case scenario. The acute hemolytic reaction, where the red cells are actively rupturing. But statistically, the most common reaction a nurse will actually see is a febrile, non-hemolytic reaction.
Non-hemolytic, meaning the red blood cells are intact, they aren't exploding. So why the fever?
This is an inflammatory response. Blood isn't just red cells. It contains donor white blood cells too.
Oh, true.
While that bag of blood sits in a refrigerator for 3 weeks, those white blood cells slowly die and release cytokines. Yeah, cytokines are essentially inflammatory chemical messengers. When those messengers hit the recipient's bloodstream, they trigger the brain's thermostat, causing fever and intense chills. It's incredibly uncomfortable for the patient, but it rarely damages the organs.
Can we present that?
Yes, we prevent a lot of this today by using leukoreduced blood, physically filtering out the donor's white cells before storage.
Okay, so that's a fever from chemical messengers. What about anaphylaxis? I always associate that with like bee stings or peanut allergies where your throat closes up. How does blood trigger that?
It's an extreme allergic reaction, and it happens astonishingly fast, often after just a few drops of blood. We most commonly see this in patients who have a natural deficiency in an antibody called IgA.
Okay.
If they receive donor plasma that contains normal levels of IgA, their immune system views it as a massive foreign invader and triggers systemic anaphylactic shock airway constriction, plummeting blood pressure.
Wow. And the sources outline another massive diagnostic challenge for the critical care team. Two reactions that look almost identical at the bedside, but require totally opposite treatments. Cherry lye and taco.
This is one of the most dangerous showdowns in an ICU.
Hmm.
A patient is receiving blood, and suddenly they are gasping for air. Their oxygen saturation plummets, their breathing becomes rapid and shallow, and they are in severe respiratory distress. The bedside presentation is nearly identical,
Right.
but the mechanisms are worlds apart. Let's start with taco transfusion-associated circulatory overload.
Based on the name, that sounds like a plumbing problem, like we put too much volume into the tank.
It is pure hydrostatic pressure. You've infused too much fluid too quickly into a patient whose heart or kidneys can't pump it effectively. This is very common in elderly patients or those with heart failure. The fluid basically backs up into the lungs.
Oh, I see.
It is essentially congestive heart failure triggered by the IV pull. The treatment is to stop the transfusion, sit the patient upright, and administer diuretics medications that force the kidneys to excrete the excess fluid as urine.
Pull the fluid off to relieve the pressure. That makes sense. But Troy transfusion-related acute lung injury is entirely different, and this mechanism absolutely blew my mind.
It's intense, yeah.
Because I assumed Troy was the patient's immune system attacking the donated blood in the lungs, but it's the exact reverse.
It is a devastating biological ambush. In TRALI, antibodies floating in the donor's plasma launch a targeted attack against the recipient's own white blood cells, specifically inside the tiny capillary beds of the recipient's lungs.
So the donated fluid is actively attacking the patient's lung tissue.
Exactly. This attack causes intense, sudden inflammation. The capillaries in the lungs become highly permeable. They start leaking plasma directly into the alveoli, the tiny air sacs where oxygen exchange happens.
So they're drowning.
Basically, the lungs fill with fluid, but not because of volume overload like in taco. They fill with fluid because of inflammatory capillary leakage.
Which means if a nurse misidentifies Troy as taco and gives diuretics to pull fluid off,
It won't work. Diuretics don't fix an inflammatory immune attack. In fact, giving diuretics to a TRALI patient can dangerously drop their blood pressure, which is already unstable from the systemic inflammation.
wow.
TRALI is a leading cause of transfusion-related death precisely because it is so hard to distinguish and manage at the bedside.
And just when a patient thinks they are out of the woods, the sources highlight that the danger doesn't magically vanish when IV is removed. You can have a delayed hemolytic reaction days or even weeks after going home.
Yes. This comes down to the immune system's long-term memory. It's called an anamnestic response.
An anamnestic response, can you translate that for us?
Sure, think of it like a dormant memory waking up. Years ago, a patient might have been exposed to a minor blood antigen, maybe from a previous surgery or pregnancy.
Right.
Their immune system built a few antibodies, but over the years, those antibody levels dropped so low that they didn't even show up on the lab's pre-transfusion screening.
So the lab clears the blood as a perfect match.
The lab clears it, the patient receives the blood, and they feel fine. But a week later, their immune system recognizes that minor antigen, wakes up from its dormant state, and rapidly manufactures a massive new army of antibodies.
Oh, no.
Yeah, they start destroying the transfused red cells weeks after discharge. The patient suddenly develops a fever, jaundice, and dropping hemoglobin at home. It reinforces why a nurse's job isn't just hanging the blood, it's educating the patient on what subtle warning signs to monitor long after they leave the hospital.
Zooming out from the cellular level for a bit, the sources also dig into the broader systemic and historical realities of relying on human donors. And some of those realities fundamentally reshaped how we think about safety, like the debate over the age of blood.
Oh, yeah.
Because we naturally assume fresh is better, right? I wouldn't want milk that's been in a fridge for a month, so why would I want 30-day-old blood?
That bias dominated medicine for decades. Clinicians argued fiercely that older stored blood was less effective and more dangerous. But large randomized trials, specifically the ADLE trial in 2015, put that intuition to the test. They compared fresh blood, which was less than 7 days old, to standard older stored blood.
And what did the data actually say?
The data proved the bias completely wrong. The older stored blood, up to about 42 days, proved to be just as safe and just as effective at carrying oxygen as the fresh blood.
That's amazing.
Is a crucial finding, because if hospitals were forced to only use blood less than a week old, the entire global supply chain would collapse.
Wow. But, not all historical biases in blood banking were just harmless clinical assumptions. The sources bring up Charles Drew again, and a very dark chapter in the 1940s involving the U.S. military.
Right. Charles Drew was the foremost expert on blood preservation, yet he resigned from his leadership role at the American Red Cross in 1942. He resigned because the military insisted on segregating donated blood by the race of the donor.
Which, based on everything we just discussed about antigens and bouncer antibodies, is just biologically absurd.
It is entirely devoid of scientific merit. A type O negative red blood cell is identical regardless of the donor's race. Drew protested because the policy was purely driven by social prejudice, and it really proves how easily systemic biases can attempt to override hard biological science.
And the systemic vulnerabilities of the blood supply became undeniably apparent in the 1980s, right, with the tainted blood scandals.
That was an unprecedented global tragedy. Before we had reliable scientific screening, specifically the ELISA test for HIV, which was introduced in 1985, donated blood unknowingly transmitted HIV and hepatitis C to thousands of transfusion recipients and hemophilia patients worldwide.
Just devastating.
The biological product meant to save them carried a lethal virus.
It makes you view modern protocols differently. Like, it explains why blood banking today feels like a fortress of questionnaires and advanced nucleic acid testing.
It completely restructured the field. The priority shifted to protecting the recipient at all costs, which led to incredibly stringent donor eligibility rules. It also heavily spotlighted the concept of informed refusal.
Right, a patient's right to simply say, I know the risks, but no thank you. The sources cite Jehovah's Witnesses as a major driver of this.
Yes, Jehovah's Witnesses frequently decline blood products based on religious principles, even when facing severe hemorrhage. And this presents a profound tension in medicine. The physician's drive for beneficence, the desire to save a life, clashing against the patient's absolute right to bodily autonomy.
How does the medical field respond when the standard protocol is just off the table?
It forced innovation. To respect patient autonomy without giving up on their survival, medicine developed incredible advancements in bloodless medicine.
Bloodless medicine.
Yeah, techniques like cell salvage, where a machine vacuums up the patient's own blood during surgery, washes it, and gives it right back. Or using synthetic erythropoietin to stimulate the patient's bone marrow to rapidly produce their own red cells. Necessity really drove the science forward.
If we look at this whole journey, it's staggering. We started this deep dive picturing physicians haphazardly pumping animal blood into people in candlelit rooms, and we've landed on this incredibly intricate, high-stakes modern science.
It's come a long way.
We've learned that whole blood is mostly a relic, replaced by precise component therapy. We've seen how the terrifying biology of bouncer antibodies means a simple clerical typo by a bedside nurse is the deadliest variable in the hospital. We've unraveled the mechanisms of tri-lie and taco and realized that, counterintuitively, giving less blood is often the safest medical strategy we have.
It is a profound evolution. And considering all those hurdles, the immense immune complexities of matching antigens, the constant threat of human clerical errors, the massive infrastructure required to screen and store human tissue, it really raises a vital question about the future.
Which is?
How close are we to an era where we simply manufacture synthetic, universally compatible oxygen-carrying fluids in a laboratory, bypassing the human donor and all these associated risks entirely?
Now that is a thought to chew on. From 17th century sheep veins to 21st century synthetic labs. Thank you so much for joining us on this deep dive into the source material. If you're lying in a hospital bed anytime soon, hopefully you have a totally new appreciation for the science, the history, and the absolute vigilance flowing through those IV lines. Stay curious, and we'll catch you on the next one. Usually when you set out to learn a new language, you start with the absolute basics, like greetings.
Right, yeah, like asking for directions or ordering a coffee.
Exactly. But what if the language you're trying to learn is written entirely in these jagged, bouncing, squiggly lines?
Oh, man, that is a whole different ballgame.
It really is, because these lines, if you learn to read them accurately, they can literally tell you if someone's heart is about to just stop beating.
Yeah, it is the ultimate high-stakes translation. You're reading the electrical shadow of a human heart, and it's happening in real time.
So, welcome to the Deep Dive. Our mission today is to decode that exact shadow for you.
We are unpacking the science, the, honestly, highly unusual history, and the life-saving mechanics of reading an ECG.
Right, the electrocardiogram. We've gone through this dense stack of clinical notes and historical documents to really distill the absolute core of cardiac tracings.
So whether you are, say, a nursing student prepping for clinicals, or just a curious learner, or even someone who just bought a smartwatch with a heart monitor,
Oh yeah, those are everywhere now.
Right. Understanding these tracings is, well, it's like gaining access to a secret medical code.
Okay, so let's unpack this. Because the history of how we got this technology is, I mean, it's just bizarre.
It really is. We are talking about a journey from a rather strange Victorian experiment to a Nobel-winning medical staple.
The story kicks off in 1887, right? In London, with this British physiologist named Augustus D. Waller. And his primary test subject wasn't even a human patient.
No, it was his bulldog.
A bulldog.
Yeah, the famously patient bulldog named Jimmy. So Waller used this primitive, really highly sensitive device called a capillary electrometer.
Which was what,
It
exactly?
was essentially this tiny glass tube filled with mercury and sulfuric acid. And he noticed that the meniscus, like the surface of the liquid, it would pulse slightly in response to minute electrical changes.
Oh, wow, okay.
So to capture the electrical activity of a beating heart, Jimmy the bulldog had to stand with his paws actually submerged in glass jars of saline solution.
Oh, wait, literally standing in jars of salt water.
Exactly. The salt water acted as the conducting electrodes.
That visual is just a bulldog in jars of salt water in a Victorian lab. I mean, it's hard to shake. But Waller actually totally dismissed his own invention, didn't he?
He did, yeah. He reportedly said he didn't think it would ever find a place in everyday medicine. He just viewed it as a physiological curiosity.
So who actually saw the clinical potential? Who turned that into a real diagnostic tool?
That was a Dutch physiologist named Willem Einthoven. So between 1901 and 1903, Einthoven engineered this thing called the string galvanometer.
Which I imagine was, a pretty massive upgrade from a tiny tube of mercury.
Oh, massive, both in sensitivity and, well, just its physical footprint. Waller's device sat on a little table. Einthoven's machine weighed hundreds of kilograms.
Hundreds. Good grief.
Yeah, it used a microscopic silver-coated quartz wire suspended between the poles of this tremendously powerful electromagnet.
Wow.
And the magnets were so intense that the machine needed constant water cooling. It actually took an entire team of technicians just to operate it in its own dedicated room.
And the patient experience wasn't exactly streamlined yet either. I mean, instead of the bulldog's paws, human patients had to sit in a chair and plunge both hands and one foot into these large buckets of saline.
Right, just to get a reading. And those were basically the first three-limb electrodes.
But Einthoven quickly proved he was a visionary, though. Like in 1906, he realized he didn't even need the patient in the same room as this massive hot machine.
Yeah, he successfully sent an ECG reading from a hospital ward straight to his laboratory over roughly 1.5 kilometers of ordinary telephone wire.
Wait, hold on. They were transmitting live medical data over telephone wires a full century before the smartphone.
They really were. He called it the telecardiogram.
How did they even conceptualize the math for that in 1906? I mean, the signal degradation alone, the interference, that must have been a complete nightmare to account for.
It was an astonishing feat of physics, honestly. Early signal processing. Einthoven didn't just build the machine and the transmission lines. To make sense of the signals coming over that wire, he created the entire mathematical language we still use today.
Which is how he eventually won the 1924 Nobel Prize, right? For mapping all this out.
Exactly. He mapped the mechanism of the ECG.
And that mathematical language, that's what we see on, every modern medical drama. The famous alphabet of the heart. The P, Q, R, S, and T waves.
Yeah, the classic PQRST.
Which I always just assumed those letters stood for some Latin medical terms, like some ancient anatomical reference,
A lot of people assume that. But Waller, with his original bulldog tracings, he had simply used A, B, and C to label the waves.
Okay, so why did it change?
Well, his mercury tube distorted the signal. It was sluggish, so it didn't capture the really sharp spikes. When Einthoven built his string galvanometer, he mathematically corrected that distortion, and the true waveform emerged.
Right.
So to differentiate his highly accurate waves from Waller's old ABC waves, Einthoven just started halfway down the alphabet at P.
Wait, so it was literally just a random bookkeeping choice?
Pure bookkeeping. He deliberately left the first half of the alphabet available, just in case future scientists discovered earlier, smaller electrical deflections that he might have missed.
That is wild.
Yeah, he just went alphabetically from there. P, Q, R, S, T. And that convention has just stuck around for over 120 years.
Unbelievable. Well, to understand what those letters actually represent biologically, we kind of have to look at the heart differently. We tend to think of it as a mechanical pump, right? A piece of muscle.
Right, but underneath that physical pump, it is fundamentally an electrical grid.
So how does the grid actually work?
To interpret the waves, you have to understand two core concepts: depolarization and repolarization.
Okay, break that down for us.
So When cardiac muscle cells are at rest, they maintain a negative internal electrical charge compared to the outside. They're essentially primed, like a drawn bowstring, just waiting.
And then the signal arrives.
Right. When the signal to pump arrives, these tiny microscopic channels in the cell membrane just snap open. Sodium ions, and a bit later calcium ions, rush into the cell.
And that massive influx flips the internal charge from negative to positive. That sudden electrical flip is depolarization, right?
Exactly. And that electrical flip is the exact trigger that tells the physical muscle fibers to actually contract and squeeze.
Got it.
But once the muscle contracts, the cell can't fire again until it completely resets. It has to actively pump all those ions back out to restore its negative resting charge.
And that resetting phase is repolarization.
Yes. So every single squiggle you see on the ECG paper is just tracking millions of these individual cells undergoing this massive ion exchange at the exact same moment.
So let's trace a single normal heartbeat on the ECG paper for you guys listening. It starts with the natural pacemaker of the heart, right? The SA node.
Yeah, the sinoatrial node sitting high up in the right atrium.
So the SA node fires off its electrical spark. And that wave spreads across the top chambers of the heart, the atria, causing them to depolarize and squeeze blood downward.
And that initial, relatively small electrical spread, that creates the very first little bump on our ECG strip, the P wave.
Okay, so P wave equals the top of the heart firing. Then the electrical signal hits a checkpoint before it goes down to the main pumping chambers, the ventricles.
Right, it hits the AV node.
And the electrical signal actually pauses there. On the ECG, this pause looks like a flat, quiet line right after the P wave called the PR segment.
It is a crucial pause.
I always like to think of this pause like holding open the elevator doors, you know? The electricity has to pause so the blood can physically load from the atria into the ventricles before the doors shut and the big contraction happens.
That is a perfect way to look at it.
Because if the electricity didn't pause, the top and bottom of the heart would squeeze at the exact same time and no blood would go anywhere. It would just be a mess.
It would be totally inefficient. That vital pause allows for actual mechanical filling. So once those elevator doors shut, the electrical signal just races down the anatomical superhighway of the heart.
Down into the ventricles.
Right, through structures called the bundle of His, the bundle branches, and the Purkinje fibers. It spreads through those massive, thick, muscular walls of the ventricles almost instantaneously.
And because the ventricles are so big and thick, this electrical burst is huge. I mean, this gives us the QRS complex, which is that really tall, sharp, jagged spike that dominates the paper.
Yep, the QRS is pure ventricular depolarization. Now, interestingly, the atria, the top chambers, they're repolarizing, they're resetting at this exact same moment.
Oh, really? At the exact same time as the big spike?
Yes, but the electrical voltage of those massive ventricles firing is so enormous that it completely buries the atrial reset on the graph. The tracing just hides it.
Wow, okay. So finally, after the ventricles squeeze out the blood to the rest of the body, they have to reset for the next beat.
Right, and that ventricular repolarization gives us the final, slightly wider bump on the strip, the T wave.
Okay, so P, QRS, and T. But you know, a lot of beginners look at this perfectly ordered sequence and form a pretty dangerous assumption.
They really do. They begin to think that every single QRS complex must inherently have a P wave triggering it right in front.
But the electrical grid can break down in ways where they completely separate, right?
Absolutely. In certain pathological conditions, like a complete third-degree heart block, that anatomical superhighway between the top and bottom of the heart gets completely severed electrically.
So no signals get through at all.
None. The SA node in the atria just keeps firing out P waves at its own normal pace, but none of those signals ever reach the ventricles.
So what do the ventricles do? Just stop?
Well, eventually they realize they are starving for a signal, and they start firing completely on their own. They rely on backup pacemaker cells at a much slower, kind of desperate pace, creating their own QRS complexes.
So the top and the bottom of the heart basically just completely divorce each other.
Yes, it's called AV dissociation. On the ECG, you'll actually see P waves marching along completely independently of the QRS complexes. They might even overlap or hide inside each other. The mechanical coordination is just entirely lost.
Which brings up a huge point. Because if the ECG flawlessly tracks this electrical elevator, and we see all the waves in perfect sequential order, P, Q, R, S, T, then a normal-looking rhythm must mean the heart is pumping blood perfectly, right?
See, this raises an important question. If we are only looking at the electrical shadow of the heart, how do we confidently diagnose what's actually happening inside the plumbing?
Right.
Because that assumption you just made, that a perfect electrical rhythm equals perfect mechanical pumping,
Right.
is quite literally the most fatal trap in all of cardiac care.
It seems so intuitive, though. Like, if the electrical trigger fires perfectly, the muscle should squeeze perfectly.
Yeah.
Where does that break down?
The ECG measures electricity, and only electricity, period. It does not measure physical movement. It does not measure blood pressure.
Okay.
There's this terrifying clinical state called pulseless electrical activity, or PEA.
PEA.
Right. In PEA, a patient is in full cardiac arrest. Their heart muscle might be entirely blown out from a massive heart attack, or they might have bled out internally. The muscle is not moving, and they have zero pulse.
But what does the monitor show?
If you look at the ECG monitor, the electrical conduction system is still firing signals into dead or empty tissue. So the screen might show an organized, nearly perfect PQRST rhythm.
That is terrifying. So a nurse or paramedic could look at the monitor, see a great rhythm, and assume the patient is fine while the patient is literally dying right in front of them.
Yes, this is exactly why experienced clinicians constantly drill the phrase, treat the patient, not the monitor. A healthcare provider must physically touch the patient and check for a pulse.
You can't just glance at a screen.
Exactly. You cannot assume blood is flowing just because the electricity is firing. The map is not the territory.
Wow. And that completely shatters that medical TV show trope, right? Where the monitor goes to a flat line, the machine goes beep, and the doctors immediately jump on the patient's chest to do compressions.
Oh, the PV flatline trope is another massive misconception. Yeah. I mean, while a true flatline, a state called asystole, is indeed a fatal cardiac arrest rhythm, a flatline on a monitor is far more frequently just a disconnected sticky pad or a broken wire.
It's just a technical glitch.
Right. Or a dead battery in the patient's telemetry box, which is that little portable monitor pack they wear around their neck on the hospital ward.
So if you just jump on their chest.
If you reflexively start doing aggressive chest compressions just because the screen went flat, you might literally be breaking the ribs of a perfectly healthy patient who just rolled over in bed and pulled a wire loose. So again,
Yeah.
check the patient first.
So if we know the shadow can deceive us, clinicians must have a system to decode the actual truth of the tracing. And it seems like the secret lies in the math of the physical grid paper it's actually printed on.
Yes, the paper grid is highly standardized. It converts physical distance on the page into very precise measurements of time. To read the language, you have to know the speed.
Which is what?
Standard ECG paper moves out of the machine at exactly 25 millimeters per second.
Okay, 25 millimeters a second. And the paper is covered in this tiny grid of boxes. One small box is exactly 1 millimeter wide.
Correct.
So because the paper moves at 25 millimeters a second, that tiny box represents exactly 0.04 seconds of time.
You got it. And those small boxes are then grouped into larger boxes outlined by a thicker line. One large box is 5 millimeters wide, which equals 0.2 seconds.
Okay, so a large box is 0.2 seconds. I feel like a really common beginner mistake would be assuming that one of those big boxes is 1 full second.
It is a very common mistake.
Yeah.
But if one large box is 0.2 seconds, you actually need 5 of those large boxes strung together to make 1 full second.
Oh, right. Basic math. And knowing this grid allows a clinician to just use their eyes and, maybe, a pair of little calipers to measure how fast the heart is beating without pulling out a stopwatch. There's that famous shortcut, the 300 rule.
It is a brilliant bit of mental math.
Yeah.
So if the heart rhythm is regular, you just count the number of large boxes between 2 of those tall R waves, the big spikes. If they are exactly 1 large box apart, the heart rate is 300 beats per minute. 2 boxes apart is 150. 3 boxes is 100. 4 is 75. 5 is 60.
So a clinician can estimate the heart rate from across the room at a single glance just by looking at the gaps.
Exactly.
But what happens when the rhythm is chaotic and totally irregular? Like in atrial fibrillation, where the atria are just quivering, the gaps between the R waves are going to be completely different sizes on every single beat.
The 300 rule instantly breaks down there. You can't use it.
So what do?
Instead, clinicians look at a standard 6-second strip of paper, which is usually marked off by hash marks at the very top of the page. They simply count the total number of QRS spikes in that 6-second window and multiply by 10.
Oh, that makes sense, because 6 times 10 is 60 seconds.
Right. That gives you the 60-second heart rate, even if the beats are wildly irregular.
Okay, so that's rate and rhythm. But a single strip of paper is ultimately just one vantage point. To really see the full 3-dimensional electrical field of the heart, clinicians rely on the famous 12-lead ECG.
The gold standard.
But the math here is initially super confusing for people. because it's called a 12 lead, but the nurse only places 10 physical sticky pads or electrodes on the patient's body. 4 go on the limbs, 6 go across the chest. So where do the 12 views actually come from?
They're generated through vector mathematics.
Oh, math again.
Right. The machine continuously compares the electrical voltage differences between varying combinations of those 10 physical electrodes. It mathematically generates 12 distinct viewpoints, or leads, of the heart.
And Einthoven started this, right?
He did. He started this concept with Einthoven's triangle. He proved that the 3 standard limb, leads lead 1, lead 2, and lead 3, form a perfect equilateral triangle around the heart.
Wow.
The math is so precise that lead 2 always equals the exact electrical voltage of lead I plus lead 3.
That's amazing. You know, I always picture this using a sports broadcast analogy.
Oh, yeah. Let's hear it.
So a 12-lead ECG is essentially the Super Bowl TV broadcast. The heart is the football field. Lead 2 is the camera directly behind the quarterback, giving you the vertical view from head to toe.
Okay, yep. Lead V1 is the camera down on the sideline, giving you the horizontal cross-section. You need multiple camera angles to definitively prove a receiver's feet stayed in bounds, right? In medicine, you need all those angles to prove a heart attack is actually happening.
That is exactly how it works. Because a heart attack, an infarct, where the tissue is actually dying from lack of oxygen, it's localized physical damage.
Right.
So if the bottom wall of the heart is dying, you will only see the electrical warning signs in the specific cameras physically looking at the bottom of the heart, which are leads 2, 3, and AVF.
So a doctor can't just look at one weird squiggle on a single lead and declare a massive heart attack.
Never. Diagnostic criteria for a STEMI, which is a massive acute heart attack, specifically require ST segment elevation in 2 anatomically contiguous leads.
Contiguous meaning next to each other.
Right. You need 2 adjacent camera angles showing the exact same disaster to confirm the tissue death is real and not just, a momentary artifact from the patient coughing or moving around. That makes total sense. Now, if the ECG is this incredibly sensitive grid capturing every tiny electrical shift, I imagine a localized heart attack isn't the only thing that disrupts the signal. What happens if the blood itself is chemically off?
This is what gets fascinating. If we connect this to the bigger picture, the ECG isn't just a cardiac tool, it's a systemic warning system.
Meaning it looks at the whole body.
Exactly. It can act as a real-time bedside blood test. Take hyperkalemia, which is dangerously high potassium in the blood.
And potassium is heavily involved in that repolarization resetting phase we talked about earlier at the cellular level.
It absolutely drives the reset. So when potassium levels get too high in the bloodstream, the concentration gradient outside the cell gets totally ruined. The cells can't reset properly.
So how does that show up on the paper?
The ECG changes in a very predictable staged sequence. First, the T waves, the repolarization waves, they get extremely tall and pointy. They appear peaked.
Okay, picked T waves.
Then, as the potassium level worsens, the QRS complex gets really wide and sluggish. The P waves flatten out entirely and just disappear.
Wow.
And finally, the tracing turns into this terrifying smooth sine wave right before the heart muscle becomes fully paralyzed and stops.
So an emergency room doctor can look at that sine wave and instantly know the patient has a critical chemical imbalance without having to wait like 45 minutes for the laboratory blood results to come back?
Exactly. It's an instant visual lab result. And it also reveals hidden microscopic anatomy.
Like what?
Well, in 1930, a condition called Wolff-Parkinson-White syndrome was described. Some people are just born with a microscopic extra electrical pathway that physically bypasses the AV node.
Oh, so it bypasses the elevator door pause.
Exactly. The electricity takes a shortcut and bleeds into the ventricles too early. The ventricles start depolarizing sluggishly before the main signal even arrives.
And how do they spot that?
On the ECG, this shows up as a shortened PR interval because the pause is missing, and a weird slurred upstroke on the QRS complex called a delta wave.
That is so cool. So clinicians deduce the existence of this tiny anatomical pathway just by looking at the electrical shadow, decades before modern imaging could ever actually visualize the physical tissue.
Isn't that incredible? They just read the shadow.
The sources even mention it can detect environmental factors, too. Like the ECG can literally tell you if someone is freezing to death.
It can. In severe hypothermia, a distinct extra hump actually appears right after the QRS complex. It's called an Osborn wave.
An Osborn wave.
Yeah. It is a stunning visual reminder that the ECG reflects the entire physiological state of the human being, core body temperature included.
But, with all these incredibly specific visual patterns, delta waves for bypass tracks, sine waves for potassium, Osborn humps for hypothermia, why are human eyes still required to read these things?
The automation debate.
Right. I mean, computers can drive cars and write complex software code today. Why is an algorithm so easily fooled by a squiggly line that a tired nurse at 3 a.m. is legally required to double-check its work?
It is a massive debate, and it really revolves around automation bias. Modern ECG machines, they always print a handy computerized interpretation at the very top of the page.
Like normal sinus rhythm or something.
Right, or consider anterior infarct. But studies consistently show that algorithms frequently misread subtle ischemic changes. That's where the heart is starving for oxygen but hasn't fully died yet. Or they misread rare arrhythmias.
But I'd imagine if a clinician is overworked or maybe just lacks confidence in their own interpretation skills, the temptation to just blindly trust the machine's printed label must be overwhelming.
That temptation is highly dangerous. Medical guidelines strictly mandate that a qualified human must overread the machine. You simply cannot surrender clinical judgment to software.
It's just too risky.
Way too risky. And this is especially true because of confounders like LBBB, which stands for left bundle branch block.
Okay, so how does a block on one side trick the computer?
Well, if the left branch of that electrical superhighway is physically blocked, the electrical signal cannot take the fast lane. It has to detour slowly through ordinary, non-specialized muscle tissue just to get to the left side of the heart.
Okay, so it takes a scenic route.
A very sluggish scenic route. And this detour massively distorts the QRS and the ST segment and makes them look wide and bizarre. But more importantly, it completely masks the normal electrical signs of a heart attack.
Oh, wow.
Yeah, the machine gets hopelessly confused by the detour. Human experts actually had to invent an entirely new set of rules in the 1990s called the Scarbosa criteria, just to visually diagnose heart attacks when an LBBB is present.
That's wild. We're just constantly learning how this electrical shadow can trick us. Look at Brugada syndrome, right? Which was only defined in, 1992?
Yes, 1992. And Brugada syndrome completely overturned old assumptions. It is a genetic electrical anomaly.
Meaning?
Patients with Brugada have structurally perfect hearts, no clogged arteries, no dead muscle, but their electrical ion channels are faulty at a microscopic level.
So the hardware is fine, but the software is glitching.
Exactly. It produces a very specific, bizarre ST segment pattern in the chest leads, and it can cause sudden, fatal cardiac arrest. It proved that you don't actually need physical heart damage to have a fatal arrhythmia. A pure software glitch in the ion channels can be just as deadly.
Which I think perfectly dismantles the biggest misconception of all here, the normal ECG trap.
Oh, yes.
Because, say, a patient comes into the emergency room with chest pain. The tracing looks completely normal. They naturally assume they're 100% fine.
But a completely normal ECG does not rule out a heart attack.
Wait, really? How?
Well, if you are having a heart attack on the posterior wall of your heart, the very back, the standard 12-lead placement, doesn't actually have a camera angle pointing directly at it.
Oh, so the front looks totally fine while the back is literally dying?
Exactly. Furthermore, if the heart attack is in its very first hour, the electrical changes might not have even manifested on the skin surface yet. It takes time.
Ah, okay. This explains why ER protocols don't just do one ECG, declare it normal, and send you home.
Right. They do serial ECGs.
Meaning they repeat them every 15 or 30 minutes to catch any delayed changes. And they draw your blood to look for biomarkers like troponin, which is a protein that physically leaks out of dying heart muscle cells.
You have to combine the electrical shadow with the chemical reality. One tool is just never enough.
So bringing this all together, we are talking about a 120-year-old technology, right? Yet its footprint in modern healthcare is absolute.
Oh, it's everywhere.
It's universally used because it's cheap, it's completely painless, and it gives you answers in under 60 seconds. I mean, it dictates how we manage hospital wards, with nurses continuously monitoring telemetry and having to expertly manage alarm fatigue from all those false alerts.
It also directly guides life-saving interventions. Like when someone is in cardiac arrest, the ECG immediately identifies if the rhythm is shockable.
Like ventricular fibrillation, where the heart is just quivering chaotically.
Right. It tells the medical team exactly when to use a defibrillator to reboot the whole system.
And now we have this modern twist. Eindhoven's massive room-sized machine is literally strapped to our wrists right now.
It really is. Millions of consumer smartwatches can now record a single-lead ECG to detect arrhythmias like atrial fibrillation.
We have basically brought the hospital into the living room. but that also means we've brought all the hospital pitfalls, the false positives, the limitations of only having one single camera angle, and the massive automation bias of just trusting a digital alert straight to the average consumer.
And if the ECG has taught us anything over the last century, is that we can look right at a perfect electrical rhythm on a screen while a patient's heart is mechanically standing completely still.
Right.
So we really have to ask ourselves, what other digital metrics in our modern lives are we blindly trusting, simply because we've confused the measurement for the reality itself?
The map is not the territory. The squiggly lines are just the shadow. They're not the beating heart itself. Well, thank you for joining us on this deep dive. Keep questioning the world around you, keep looking past the surface, and we will catch you next time.
When we talk about medical diagnoses, I think there's this expectation of precision,
Oh, absolutely. Like a clear-cut answer.
Right, like if a patient breaks their arm and X-ray shows a jagged white line, the doctor points to it, and the path forward is just obvious.
Yeah, it's visible, it's binary, it's comforting, really.
It is deeply comforting.
Yeah.
But stepping into the world of severe endocrine emergencies, which is exactly what we're unpacking in today's deep dive, it completely shatters that illusion of precision. So, welcome. Today we are diving into thyroid crises. And the absolute most critical realization, like right out of the gate, is that you cannot diagnose these life-threatening extremes with a lab test.
Which is wild, right? It forces clinicians completely out of their comfort zones. I mean, a patient who is actively dying from a thyroid crisis might have the exact same thyroid-stimulating hormone or free T4 levels printed on their chart as a patient who's just sitting comfortably in an outpatient clinic.
Wait, really? The exact same numbers?
Literally the same numbers. The lab values just confirm there is an underlying thyroid disorder, but they are completely incapable of telling you whether that patient's body is compensating for the disorder or actively collapsing from it.
Wow. Which means the clinician standing at the bedside basically has to rely on the actual physical presentation of systemic organ failure.
Exactly. You have to look at the patient, not just the paper.
So our mission today for you, the listener, is to map out the two lethal extremes of this spectrum. So we've got thyroid storm and myxedema coma.
Right.
And to do that, I think we need to bypass the basic intro biology and look at how thyroid hormone operates on a cellular level, specifically regarding the sympathetic nervous system.
Right. Yeah, that's the core first principle here. So the foundational mechanism is that thyroid hormone essentially sets the basal metabolic rate for the entire body, but it does so in this highly synergistic way with your catecholamines.
Meaning like epinephrine and norepinephrine?
Exactly. Adrenaline. Thyroid hormone actually upregulates the expression of beta-adrenergic receptors on the surface of your cells, particularly in the heart and the nervous system.
Okay, so it builds more receptors.
Right. When thyroid hormone levels are normal, this keeps your cardiovascular and nervous systems appropriately responsive.
Got it. So if we think about the overarching analogy for this deep dive, if the human body is a car, thyroid hormone is basically the accelerator pedal.
That is a perfect way to look at it.
Okay, so let's look at the hyper-extreme first, thyroid storm or thyrotoxic crisis.
Yeah.
This isn't just an overactive metabolism. Because of that upregulation of beta receptors you mentioned, the patient's cells become wildly hypersensitive to normal baseline levels of circulating catecholamines.
Yes, the body is essentially flooded with fight or flight signals that it just cannot ignore. It pushes the whole physiological process into absolute overdrive.
Right. So going back to the car analogy, it's like running a car engine at 10,000 RPMs while it's just parked in a hot garage. Eventually, the cooling and fuel systems just fail.
That is exactly what happens. Translating that cellular chaos to the actual bedside, you see a cardiovascular system rapidly exhausting itself. I mean, the heart rate frequently exceeds 140 beats per minute.
Oh, wow.
Yeah, and it commonly devolves into atrial fibrillation. The heart muscle is attempting to meet this impossible metabolic oxygen demand, and it simply cannot sustain that stroke volume.
So it just gives out.
Left unchecked, yeah.
Yeah.
It rapidly progresses into high-output heart failure.
And coupled with that cardiovascular failure is a profound thermoregulatory collapse, right? Because routine hyperthyroidism might make a patient feel uncomfortably warm, but a true thyroid storm frequently produces a raging fever.
A really high one.
Yeah. The source is a core temperatures easily exceeding 104 degrees Fahrenheit or 40 degrees Celsius.
And that hyperthermia is a primary differentiator. When you are trying to determine if a patient has crossed the line from just severe hyperthyroidism into a literal storm, the fever is a massive clue. And parallel to the fever, the central nervous system is equally overstimulated by that beta receptor upregulation. You'll see severe agitation, intense tremors.
Because the brain is just starved for oxygen.
Exactly. As the metabolic demand outstrips oxygen delivery to the brain, that agitation deteriorates into frank psychosis, stupor, and ultimately coma.
The literature also highlights a very specific gastrointestinal presentation that feels like a crucial warning sign to me. Beyond the severe nausea, vomiting, and diarrhea, the appearance of jaundice, the yellowing of the skin and sclera, that is a massive red flag.
Oh, it's ominous. Jaundice in this setting is an indicator of hepatic hypoperfusion.
Meaning the liver isn't getting enough blood.
Right. The liver requires a massive amount of blood flow to function properly. In a thyroid storm, the liver's metabolic demand skyrockets, but that failing tachycardic heart we just talked about cannot deliver adequate oxygenated blood to meet that new baseline.
So the liver tissue begins to essentially suffocate.
Exactly. It leads to acute hepatic injury. When you see jaundice, you know the patient is spiraling toward multi-organ failure.
God, understanding this physiology makes the historical context of this disease incredibly grim. Like, I was looking at the notes, and before the modern era of pharmacology, surgeons were attempting to operate on patients with highly volatile, overactive thyroid glands like those with Graves' disease.
Ooh, it was a nightmare.
Yeah, the surgical mortality rates prior to the 1920s were just catastrophic. A patient would undergo a thyroidectomy, wake up, and immediately crash into a hyperthermic delirious storm, and they'd often die within 48 hours.
Surgeons of that era were essentially operating on a hormonal powder keg. I mean, just the physical manipulation of the gland during surgery would squeeze massive stores of preformed hormone directly into the bloodstream of a patient who was already deeply thyrotoxic.
So just touching the thyroid was killing them.
Literally. But the breakthrough came from the Mayo Clinic in the 1920s. A doctor named Henry Stanley Plummer hypothesized that pre-treating these surgical patients with a high dose of iodine, specifically Lugol solution, would temporarily calm the gland.
Which seems highly counterintuitive, right? Since iodine is the primary building block of thyroid hormone. But Plummer found that delivering it in a massive acute pharmacological dose actually halted the gland's activity long enough to safely perform the surgery.
Yeah, it's a brilliant hack of the body's own regulatory system. We'll explore the specific mechanism behind that shortly because it remains a foundational pillar of how we actually treat these patients today.
Right. But knowing that this is a well-documented, highly lethal emergency, it is deeply unsettling to look at modern diagnostic protocols. Like, if you are an ICU physician looking at a decompensating patient, you are forced to navigate two distinct and sometimes totally conflicting medical scoring systems.
Yeah, it's a huge debate. Clinicians have spent decades trying to quantify this crisis to avoid relying purely on gut instinct.
So wait, if I'm reading this right, if this is a life or death emergency, how can two different medical scoring systems disagree on whether someone actually has it?
Well, because it's a clinical diagnosis, not a binary lab test. The Birch-Wartofsky Point Scale, or BWPS, introduced in 1993, is the most recognized framework. It assigns numerical values to the severity of organ dysfunction.
Like points or symptoms.
Exactly. A fever of 104 degrees earns more points than a fever of 101. Atrial fibrillation earns points, as does the presence of jaundice or severe central nervous system agitation.
Okay, and a cumulative score above 45 strongly suggests a thyroid storm, while a score below 25 suggests an uncomplicated thyrotoxicosis. And this is the crazy part that leaves a massive ambiguous gray zone between 25 and 44.
Right. And to complicate the landscape for the clinician even more, the Japan Thyroid Association, or JTA, published a competing set of diagnostic criteria in 2012.
So you have two rule books.
Yeah, and the clinical reality is that in borderline cases, the BWPS and the JTA criteria do not always align. A patient might meet the threshold for a stone on one scale, but not the other.
Which places the physician in a highly precarious position.
Extremely. Because the pharmacological intervention for a thyroid storm is aggressive, it uses multiple high-risk medications. Administering that cocktail to a patient who doesn't truly need it can cause significant harm.
But withholding it from a patient in a true storm guarantees their death.
Exactly. It requires immense clinical judgment to operate in that diagnostic gray zone.
Wow. Okay, so when you consider how catastrophic that hypermetabolic state is, you might assume the opposite extreme would be less volatile, just a general powering down. But withdrawing that metabolic drive entirely is just as lethal.
Oh, absolutely.
Which brings us to the exact opposite end of the physiological axis, myxedema coma, the decompensated extreme of hypothyroidism. And this is most frequently rooted in neglected Hashimoto's thyroiditis, right?
Correct. If a storm is an engine tearing itself apart at maximum RPMs, myxedema coma is the systemic failure that occurs when the engine is completely starved of fuel. The presentation is virtually a mirror image of the storm.
So everything slows down.
Drastically. Those beta-adrenergic receptors we discussed earlier, they are now profoundly downregulated. The heart becomes highly unresponsive to catecholamines, resulting in severe bradycardia.
So a dangerously slow heart rate. And the respiratory drive is similarly blunted. I was reading that the patient literally loses the neurological impulse to breathe deeply or frequently.
Yeah, they just forget to breathe, essentially. This hypoventilation leads directly to hypercapnia, which is a dangerous retention of carbon dioxide in the blood, and that further depresses their central nervous system.
But the loss of thermoregulation is arguably the most striking clinical feature, I think. Without thyroid hormone driving cellular metabolism, the body just ceases to generate adequate heat. You will frequently see core body temperatures drop below 90 degrees Fahrenheit or 32 degrees Celsius.
It's basically severe spontaneous hypothermia. Accompanying this is severe hyponatremia, low sodium, driven largely by a decrease in the glomerular filtration rate.
The kidneys just stop filtering.
Pretty much. The kidneys simply lack the metabolic pressure required to excrete free water, so they just dilute the sodium concentration in the blood.
Okay, looking at the terminology here, myxedema coma is deeply entrenched in the literature, but it feels like somewhat of a linguistic trap. I mean, the term myxedema literally means mucus swelling, right? Coined back in 1877.
Yes, by a committee chaired by William Miller Ord following observations by William Withy Gull in 1873. They were describing this mucin-infiltrated, non-pitting edema that gives these patients a characteristically puffy appearance.
But I want to clarify a massive misconception here. Does the patient actually have to be in a literal coma? Because the word coma feels highly misleading for modern diagnostic purposes.
It is a dangerous misnomer, a huge historical holdover. By the time late 19th century physicians identified this syndrome, the patients were inevitably in end-stage profound unresponsiveness.
Right, they caught it too late.
Exactly. Waiting for a patient to slip into a literal coma today before initiating aggressive treatment is a near guaranteed way to ensure a fatal outcome.
So what does it actually look like?
The condition represents a spectrum of altered mental status. It starts with lethargy, confusion, or profound psychomotor retardation, well before eventually deteriorating into true unconsciousness.
And the neurological exam for these patients yields a highly specific finding known as hung-up reflexes, which I found fascinating because it provides a brilliant window into the cellular physiology.
Oh, it's a classic sign.
Yeah, so when you strike the patellar tendon, the leg kicks out normally, but the relaxation phase is bizarrely delayed. It's just slow to release.
And the mechanism there directly illustrates the cellular energy deficit. To relax a contracted muscle, the muscle fibers actually have to pump calcium ions back into the sarcoplasmic reticulum,
Which takes energy.
Right. That process requires a constant supply of ATP. Because a myxedema patient lacks the thyroid hormone required to drive ATP production, the muscle simply does not have the cellular energy required to execute that relaxation phase efficiently. The reflex visibly hangs up.
That makes so much sense. To make this memorable for the listener, the classic demographic profile you encounter in the case literature is incredibly consistent. If you're looking out for this presentation, you are generally looking for a textbook example of an elderly female patient with a history of neglected hypothyroidism.
Right.
She's typically found profoundly hypothermic in her home during the winter months. And very often, the precipitating event was the introduction of a new medication, like a sedative or an opioid, which suppressed her already fragile respiratory drive just enough to tip her into respiratory failure.
And that concept of a precipitating event is vital. I mean, neither of these crises typically occur spontaneously in a vacuum. A patient might walk around for years with poorly controlled thyroid disease, just hovering right on the edge of the cliff.
But it requires a distinct physiological stressor to push them over the edge. Which brings us to the sneaky triggers of crisis.
Yeah, the mundane medical events that act as catalysts. In the case of a thyroid storm, that precipitating stressor is usually a massive systemic insult. Severe infection, physical trauma, childbirth, diabetic ketoacidosis, or, as we mentioned earlier, undergoing surgery without appropriate endocrine blockade.
And for myxedema coma, the stressors include prolonged cold exposure, acute myocardial infarction, a stroke, or frequently just an interruption in their thyroid replacement therapy.
Yeah, missed pills are a big one.
Like a patient might be admitted to the hospital for an entirely unrelated orthopedic issue, their levothyroxine gets missed in the shuffle of inpatient orders for a week, and their hormone levels slowly drain away until they decompensate.
It happens more often than you'd think.
But okay, the most fascinating and terrifying trigger detailed in the sources is the Jod-Basedow phenomenon. Are you telling me that a routine CT scan with IV contrast, like for suspected appendicitis, can accidentally trigger a deadly thyroid storm days later?
I mean, yes, absolutely. It perfectly illustrates the danger of treating the body as a collection of isolated systems.
Does that even happen?
To understand why, you have to look at the pharmacology of IV contrast dye. It carries a massive iodine load.
Okay.
If a patient's thyroid is healthy, they process and clear that iodine without issue. However, if a patient unknowingly harbors an autonomously functioning thyroid nodule, like a toxic multinodular goiter or a solitary hot nodule, that tissue is essentially a rogue factory operating entirely outside the control of the pituitary gland.
So it's just making hormone whenever it wants.
Right, but it's usually limited by the natural availability of dietary iodine in the body.
Oh, I see. So when you inject that IV contrast, you're basically dumping a massive shipment of raw material directly onto the factory floor.
Exactly. The autonomous nodule immediately utilizes that iodine load. It rapidly organifies it to synthesize and release a massive surge of thyroid hormone. So days after the patient is discharged with a clear appendix, they are rushed back to the hospital in atrial fibrillation with a 104-degree fever.
That is terrifying. It just underscores why understanding a patient's baseline endocrine history fundamentally alters the risk profile of even seemingly routine radiological procedures.
It's critical.
Okay, moving into the clinical management of these crises, this is where instinct will get you into trouble. Because the intuitive treatments are almost all wrong. The pharmacological protocols are essentially a minefield of physiological paradoxes.
Yes. These scenarios demand a deep comprehension of pharmacokinetics because standard symptomatic treatments often backfire catastrophically. Let's look at the bedside traps.
Let's start with the fever trap. Say you're managing hyperthermia in a thyroid storm. If a patient is burning up with a 104-degree fever, the immediate instinct is to administer a salicylate, like aspirin.
Right, but doing so in a thyrotoxic crisis can be fatal.
Why? Aspirin reduces fever.
It does, but you have to consider how thyroid hormone travels through the vasculature. The vast majority of circulating T4 and T3 is bound to transport proteins, primarily thyroxine-binding globulin, or TBG.
And while it's bound, it's inactive.
Right. Exactly. Only the tiny fraction of unbound, or free hormone, interacts with cellular receptors to drive the hypermetabolic state. Aspirin fundamentally alters this dynamic because it has a high affinity for those same transport proteins.
Oh no, so it aggressively competes for the binding sites.
Yes. It physically displaces the thyroid hormone. If you administer aspirin, you suddenly flood the patient's bloodstream with active free hormone, dramatically worsening the storm.
So it pours fuel on the fire.
Exactly. Acetaminophen must be used instead. It achieves antipyresis without displacing the hormone.
Wow. Okay, and the instinctual trap is equally dangerous on the hypothyroid side. The rewarming trap. If a myxedema coma patient is brought in with a core temperature of 90 degrees Fahrenheit, the intuitive response is to utilize active rewarming techniques, forced air warming blankets, heated 5E fluids, just to raise their temperature as quickly as possible.
Which will reliably trigger cardiovascular collapse.
Wait, why? They're freezing.
They are, but you have to picture the state of their peripheral vasculature. Due to the profound hypothermia, their blood vessels are maximally constricted to shunt blood to the core organs. Their bradycardic, failing heart is barely generating enough cardiac output to maintain blood pressure, even with that intense peripheral resistance.
So if you actively and rapidly heat the skin,
you force widespread peripheral vasodilation, the vascular space suddenly expands massively, vascular resistance plummets, and the weakened heart cannot increase its output to compensate.
the bottom falls out.
The patient will suffer immediate profound hypertension and likely arrest. The standard of care demands passive rewarming, literally just using standard blankets in a warm room, allowing the core temperature to rise slowly as the thyroid replacement therapy begins to take effect.
That is such a crucial trap to avoid. All right, what about the order of operations trap? Earlier, we established that administering a massive dose of iodine like Lugol solution is highly effective at shutting down the overactive gland in a storm. This relies on the Wolff-Chaikoff effect, right?
Yes. The Wolff-Chaikoff effect is a brilliant auto-regulatory defense mechanism. When the thyroid follicle is exposed to acutely elevated levels of inorganic iodine, it transiently inhibits the enzyme thyroid peroxidase.
Which effectively shuts down the synthesis of new thyroid hormone.
Temporarily, yes.
But I want to stress the timing here, because the timing of that iodine dose is everything. You absolutely cannot administer the iodine before you have given an antithyroid drug like a thionamide medication, propylthiouracil or methimazole, to block the gland first.
Never. If you hang the iodine IV bag first, you provide the overactive gland with an abundance of substrate before the inhibitory effect can take hold.
Right. The gland will just use that iodine to manufacture a fresh wave of hormone, fueling the crisis.
Yeah.
So the strict protocol is to administer the blocker, wait at least an hour for the biochemical blockade to establish itself, and only then administer the iodine.
Exactly. And the choice of that blocking agent introduces one of the most difficult ethical and clinical tensions in endocrinology, the PTU paradox.
Okay, break that down for us.
Well, in a severe thyroid storm, propylthiouracil, or PTU, is often favored over methimazole. Both drugs block hormone synthesis within the gland, but PTU has a critical secondary mechanism. It inhibits the enzyme 5-deiodinase in the peripheral tissues.
Meaning it stops the body from converting the relatively inactive T4 prohormone into the highly potent active T3 hormone out in the liver and kidneys.
Right. That dual-action blockade gives PTU a massive mechanistic advantage in quickly bringing the hypermetabolic state under control.
But here's the catch. PTU carries a severe FDA black box warning for fulminant hepatotoxicity. It can cause catastrophic liver failure, sometimes requiring an emergency liver transplant.
It's a huge risk.
Wait, didn't we just establish that a severe thyroid storm causes hepatic hypoperfusion, leading to jaundice and acute liver injury? So we are giving a liver-toxic drug to treat a condition that is already actively destroying the liver.
I know. It's an agonizing paradox at the bedside. It is the ultimate clinical trade-off. There is no perfectly safe option here. The physician must weigh the imminent certainty of death from the unchecked thyroid storm against the secondary pharmacological risk to the hepatic system.
You are forced to accept the risk of hepatotoxicity, because if you fail to break the storm, the patient's liver and every other organ will fail anyway.
Exactly. It's choosing the lesser of two very bad evils.
Now, we see a similarly high-stakes debate in the resuscitation of myxedema coma patients regarding thyroid hormone replacement, the T3 versus T4 debate.
Yeah, whether to administer intravenous levothyroxine, which is T4, or liothyronine, which is T3. Levothyroxine is a prohormone. Under normal conditions, the peripheral tissues convert it into active T3 over several days.
But in a severe myxedema state, the enzymes responsible for that conversion are profoundly suppressed.
Yeah.
So administering standard T4 means you might be waiting days for the patient to actually generate enough active hormone to reverse the coma.
Right. So from a purely mechanistic standpoint, administering intravenous T3 directly bypasses that stalled conversion process. It provides immediately active hormone to the starving cells.
But T3 is incredibly potent. It acts with massive rapidity.
Extremely fast. If you administer a bolus of T3 to an elderly patient with silent underlying ischemic heart disease, you will instantaneously drive up the myocardial oxygen demand. Their coronary arteries may not be able to deliver the necessary blood flow, and you can easily trigger a fatal heart attack or a lethal arrhythmia.
So the medical community is split on this.
Completely divided. Some protocols mandate slower, safer T4, while others advocate for cautious, low-dose T3, or a combination of the two. It is a precise titration of metabolic recovery against cardiovascular tolerance.
Okay, one pharmacological intervention that remains universally consistent across both extremes is the administration of stress-dose corticosteroids, specifically hydrocortisone. Whether the patient is burning up in a storm or freezing in a coma, steroids are administered immediately. Why is that?
This targets a secondary but equally lethal physiological vulnerability. The hypothalamic pituitary adrenal axis is deeply intertwined with thyroid function. In a thyroid storm, the hypermetabolic state rapidly accelerates the clearance and degradation of the body's natural cortisol.
So they burn through their stress hormone.
Fast. The adrenal glands simply cannot synthesize cortisol fast enough to keep up with the metabolic burn rate, leading to a relative adrenal insufficiency.
And in myxedema coma, the severe autoimmune disease that destroyed the thyroid Hashimoto's can often coexist with autoimmune adrenalitis, conditions like Schmidt syndrome or Addison's disease.
Exactly. So if you begin aggressively treating the myxedema by ramping up their cellular metabolism with thyroid hormone, but their adrenal glands are destroyed and incapable of mounting a cortisol stress response, you will precipitate an acute Addisonian crisis.
Right. Without adequate cortisol, the vascular system loses its tone, resulting in refractory shock. Therefore, we never wait for cortisol lab results in these emergencies. We administer empirical stress dose hydrocortisone to safeguard the adrenal axis while we stabilize the thyroid axis.
It's an absolute must in both protocols.
Wow. Okay, so synthesizing this incredibly complex physiological web into a mental toolkit for you, the listener, the vital takeaways are clear? Remember that a lab printout cannot diagnose a thyroid storm or a myxedema coma. You must look past the numbers and evaluate the patient for systemic organ failure.
Look at the whole clinical picture.
Right, and watch out for the deadly traps. No aspirin in storms, no rapid active rewarming in myxedema, and always block the thyroid factory with a thionamide before you flood it with iodine.
It demands a rigorous understanding of the underlying cellular mechanisms, really, because in these extremes, you're not just treating symptoms, you are attempting to manually override a collapsing metabolic engine.
Which leaves us with a final provocative thought to mull over. We are heavily conditioned to view medical emergencies as acute, sudden events. A heart attack, a ruptured aneurysm, a car crash.
Right, things that happen in an instant.
But the pathology of thyroid crises reveals that a life-threatening catastrophe can actually manifest as a slow-motion domino effect. A perfectly benign decision like a missed levothyroxine pill on Tuesday due to an administrative oversight, or a routine CT scan with contrast ordered on a Wednesday that can act as the invisible push that causes a catastrophic multi-organ collapse by Sunday.
It's a profound reminder that the human body is never a static snapshot. It is a highly volatile, deeply interconnected system where every single intervention ripples across multiple physiological axes.
It forces you to question how many other seemingly routine medical decisions are silently initiating biological chain reactions right under our noses. The next time you encounter a clear-cut diagnosis, appreciate its simplicity, because as this deep dive into the endocrine literature demonstrates, the most complex and lethal emergencies require you to look far beyond the obvious answers. Thank you for joining us today. Keep asking questions, and we'll catch you on the next deep dive.
Welcome to this deep dive. You know, usually when we talk about a bodily function, we carry this expectation of simplicity.
Right, like you just do it without thinking.
Exactly. You think about breathing, for instance. Your chest rises, your chest falls.
Or a reflex, like tapping your knee with a little hammer to make your leg kick.
Yeah, we operate under the assumption that these everyday actions are just automatic, mindless processes. But then you look at the act of swallowing, and that illusion of simplicity just completely falls apart.
It really does. I mean, it is not a basic reflex at all.
No, it's a wildly complex, high-stakes mechanical sequence, and that is exactly what we are putting under the microscope today.
Because we perform this sequence, what, hundreds of times a day? And we do it without dedicating a single conscious thought to it?
Yeah, we rarely consider the absolute anatomical precision required to prevent our morning coffee or, our dinner from traveling down the wrong pipe and ending up in our lungs.
And when that precision fails, it goes dangerously wrong. Which brings us to the core of what we're looking at today.
Right. Our mission for this deep dive, we are looking at a massive stack of source material today. We've got medical science notes, clinical guidelines, historical texts, all to unpack a condition called dysphagia.
Which is the medical term for difficulty swallowing.
Yeah, and we're framing this strictly through a clinical and nursing lens for you today. We aren't just talking about a mild inconvenience at the dinner table.
No, not at all. We want to show you how healthcare professionals assess airway risk, how they prevent life-threatening complications, and how they navigate some surprisingly intense medical debates.
Okay, let's unpack this, starting with the word itself. Like if you break it down, dysphagia comes from the Greek roots. You've got meaning difficulty or disorder.
Right.
And phagein, meaning to eat.
But we have to establish a crucial medical distinction for you right at the start here. Dysphagia is a symptom, or I guess you could call it a syndrome. It is not a standalone disease.
Oh, okay. So it's more of a warning sign.
Exactly. Clinicians view it as a giant red flag, signaling that an underlying problem has disrupted the swallowing pathway somewhere. And in the medical field, it's split into two main categories.
Which dictate the entire course of treatment, right?
Yeah, entirely. So first, you have esophageal dysphagia. This is the sensation that food is sticking or, moving too slowly lower down in the chest after it has already left the throat.
And based on the notes, that usually points to a structural issue in the esophagus itself, like a stricture, for example, where the tube physically narrows.
Right. Or a motility problem like achalasia.
Achalasia. That's essentially nerve damage, right?
Yeah.
Where the esophageal sphincter at the very bottom of the tube just refuses to relax.
Refuses to let the food pass into the stomach.
Yeah.
The food just sits there.
Wow. Okay, so that's esophageal. What's the second category?
The second category is oropharyngeal dysphagia. So this is the difficulty of initiating a swallow in the first place, or safely moving the food from the mouth into the throat.
And this specific area, this is the domain of nurses, speech-language pathologists, or SLPs and neurologists.
Yes. And we need to emphasize that oropharyngeal dysphagia carries the absolute highest risk of mortality.
Which makes sense when you look at how the medical understanding of the throat has evolved. I mean, for decades, swallowing was considered just a simple single reflex arc.
But modern clinical science completely reframed it.
Right.
It's actually an incredibly rapid four-phase sequence.
Right, you've got the oral preparatory, oral, pharyngeal, and esophageal phases.
And that sequence requires the coordinated timing of roughly 30 pairs of muscles and 6 different cranial nerves.
30 pairs of muscles just to swallow a bite of food.
Just for one swallow.
So if it's not a single reflex, what is actually happening physically between the moment a bite of food enters your mouth and the moment it hits your esophagus?
Well, the sequence starts with the oral preparatory phase. Your teeth chew the food, and your tongue mixes it with saliva to form a cohesive, wet ball.
Which clinicians call a bolus, right?
Right, a bolus. Then comes the oral phase, where the tongue actively propels that bolus toward the back of the throat.
And up to this point, it's completely voluntary, like you are actively controlling it.
Exactly. You control it. But once that bolus hits the back of the throat, it triggers the pharyngeal phase, which is entirely involuntary.
It's out of your hands at that point.
Completely out of your hands. Within about half a second, the airway must completely seal itself off to let the food pass safely over it.
And this is where the anatomy gets so fascinating. Instead of thinking about it like a simple reflex, it's more like a high-speed biological obstacle course.
A very precise obstacle course.
Yeah, where a series of trapdoors basically have to open and close in the exact right millisecond. Like, the soft palate lifts up to block the nasal cavity so food doesn't go up into your nose.
Nobody wants that.
Right. And then the epiglottis, which is this little flack of cartilage, it tips down like a lid over the airway.
And at the same time, the vocal folds inside the airway snap together like double doors.
And the entire larynx, the voice box, pulls physically up and forward to tuck itself out of the way of the falling food.
So if any one of those 30 muscles fires a fraction of a second too late, or if a cranial nerve fails to send the signal, those trapdoors just don't shut in time.
Which is terrifying. Swallowing is essentially a high-speed relay race where a dropped baton means food goes directly into your airway.
That's a great analogy. And because there are so many moving parts, dysphagia is rarely an all-or-nothing failure.
Right. It depends on exactly which runner drops the baton. Like someone could have the muscle control to swallow thin liquids perfectly, but entirely fail to move solid foods.
Or the reverse. They might handle solids just fine, but thin liquids move way too fast for their delayed trapdoors to catch.
And when those trapdoors fail, we arrive at the most feared concept in this field: aspiration.
Aspiration, yes.
And the source texts are incredibly strict about differentiating between aspiration and penetration. They are not interchangeable terms.
No, they are clinically distinct. That difference was actually formalized back in 1996 by Joanne Robbins and John Rosenbach.
Right. They created the penetration aspiration scale, or the PAS.
Exactly. The PAS is an 8-point grading system used to evaluate swallow studies. So penetration occurs when food or liquid enters the laryngeal vestibule.
Which is a very top opening of the airway, right?
Right. It enters the top opening, but the material stays above the vocal folds.
Okay, so it breaches the outer defenses, but it doesn't drop all the way down into the lungs.
Correct. But aspiration occurs when that material physically passes below the vocal folds and enters the trachea.
And at that point, it is heading straight down into the delicate lung tissue.
Yes, which is where it causes severe problems. The PAS scale allows clinicians to precisely grade how deep the material goes, and crucially, whether the patient makes any physical attempts to cough it out.
Because you can evaluate a patient who experiences frequent penetration but manages to clear it every time, never actually aspirating.
Right, and then you can evaluate a patient who aspirates on a single sip of water without any prior penetration warning signs whatsoever.
And the idea of coughing it out brings up, well, here's where it gets really interesting because it's the most counterintuitive fact in this entire field.
Oh, absolutely.
Coughing is absolutely not a reliable indicator of aspiration.
No, it's not.
The sources show that roughly a third to over half of patients who aspirate show zero visible distress. No coughing, no sputtering.
No throat clearing, no watery eyes.
It is completely silent.
Silent aspiration. It happens because the sensory nerves in the throat and airway have been blunted, usually by a neurological event like a stroke.
So the brain simply doesn't receive the panic signal that food is falling into the lungs.
Right, so it never triggers the reflex to cough and expel it.
But wait, if a patient isn't coughing or choking at all, how on earth is a frontline nurse supposed to know they're aspirating?
That's a huge challenge.
Like, if someone sitting in a hospital bed looks completely fine while drinking a glass of water, how do you catch a silent failure?
Well, we use bedside screening tools. I mean, they are imperfect, but they are the first line of defense. Because silent aspiration exists, a nurse cannot just observe a patient eating a meal and declare their airway safe.
So what does a screening tool look like?
One of the most common is the 3-ounce water swallow test. It was developed in 1992, often called the Burke protocol.
Okay, the Burke protocol, how does it work?
The nurse asks the patient to drink about 90 milliliters of water continuously without stopping.
I mean, 90 milliliters is actually a substantial, challenging volume of liquid.
Yeah, it's meant to stress the swallowing mechanism. If the patient coughs, chokes, or develops a wet, gurgly-sounding voice within 1 minute of finishing, they fail the screen.
Right, a wet voice indicating that water is just sitting on top of their vocal cords.
Exactly. And if they fail, they are immediately flagged for a consult with a speech-language pathologist.
But here is the vital context for this test, according to the sources. It is a screen, not a diagnosis.
That is a very important distinction. A medical screen is designed to be cheap, fast, and highly sensitive in order to cast a wide net and catch potential risks.
Right, but it still relies on observing outward signs like voice changes or delayed coughing, so it will inevitably miss some silent aspirators.
Yeah, the purpose of the 3-ounce test is just to figure out who needs a deeper instrumental look. It is never used to universally clear a high-risk patient for a regular diet.
So to truly catch silent aspiration, clinicians realized they needed a way to literally see inside the throat in real time.
Which sparked a massive revolution in dysphagia care.
Yeah, it's wild to think that before the 1980s, swallowing problems in stroke or cancer patients were usually only diagnosed after the patient developed aspiration pneumonia.
It was treated as a downstream complication. You just waited for the lung infection to appear, and then you treated the lung infection.
But then a speech-language pathologist named Jerry A. Lodgman changed that reactive approach.
She was a true pioneer.
In 1983, she essentially founded dysphagia as a clinical subspecialty by popularizing the modified barium swallow study, or the VFSS.
Right. So in a VFSS, the patient is taken to a radiology suite, and they are fed different consistencies of food and liquid that have been coated in barium.
And barium is a contrast agent that glows dense black on an X-ray.
Exactly. So the clinician watches an X-ray video of the swallow happening live.
So you aren't guessing if the trapdoor closed. You can actually watch the black liquid slip past the epiglottis and drop straight into the trachea.
You see the whole thing.
And then a few years later, in 1988, Susan Langmore developed a rival diagnostic technique called FE.
FEES, which stands for fiber optic endoscopic evaluation of swallowing.
Right, and instead of using X-rays, she passed a tiny flexible camera through the patient's nose and positioned it to look directly down into the throat.
What's fascinating here is that decades later, there's still no single gold standard between these two tests.
Really? They're just used for different things.
Yeah, they are distinct tools that answer different clinical questions. The VFSS gives you the entire trajectory of the swallow. You can see the mouth, the throat, and the esophagus.
But it exposes the patient to radiation, right?
Right, and you have to physically transport a sick patient down to the radiology department, and it only captures a brief snapshot of a few swallows.
Whereas Langmore's FEES avoids radiation entirely.
Exactly. A clinician can roll the camera cart right up to the patient's bedside, making it ideal for critically ill individuals in the ICU.
But FMEAS does have a mechanical catch. The sources describe a phenomenon called the whiteout.
Whiteout, yeah.
At the exact millisecond of the swallow, the muscles of the pharynx forcefully contract and squeeze inward.
And when they do that, the tissue wraps entirely around the camera lens. So the video screen goes completely white for a fraction of a second.
Ah, so you missed the actual event.
Right. The clinician can see everything pooling in the throat right before the swallow, and they can see any food left behind right after the swallow. But the exact instant of aspiration sometimes has to be logically inferred based on what is left in the airway once the muscles relax.
Okay, but Phi does offer one massive advantage over the X-ray study, and it ties into a persistent clinical debate regarding saliva.
Yes, there has long been an argument about whether difficulty managing your own naturally produced secretions, your saliva counts as true dysphagia.
Right, like if you aren't eating or drinking anything, can you still have a swallowing disorder?
The clinical consensus now is yes. Patients who cannot clear their own saliva face an incredibly high risk for aspiration pneumonia.
Because the human mouth is just full of bacteria.
Exactly. If you are constantly microaspirating bacteria-laden saliva into your lungs simply because gravity pulls it down and your trapdoors are weak, you will get sick.
And this happens completely independent of mealtimes.
Completely independent. And FETEs is uniquely positioned to catch this. The camera allows the clinician to see secretions actively bubbling and pooling in the airway before the patient has even taken a bite of the test food.
Wow. Okay, so once a clinician uses these tools and formally diagnoses dysphagia, the immediate question is how to manage it. And for a very long time, the knee-jerk reaction across hospitals was to just thicken the patient's liquids.
Right, and the mechanical logic behind thickening liquids makes intuitive sense. If a patient's airway is closing too slowly, you want to slow down the speed of the liquid dropping toward that airway.
So you make it thicker.
Right. Liquids thickened to the consistency of nectar, honey, or pudding move much slower than regular water.
Which theoretically buys the compromised trapdoors more time to close and protect the lungs.
That concept became so entrenched that the clinical community codified it into the National Dysphagia Diet back in 2002.
But the sources highlight a harsh clinical reality here. Thickened liquids taste terrible.
They are notoriously unpalatable. The texture is awful, and patients simply refuse to drink them.
And when patients refuse to drink, they become severely dehydrated. I mean, if we mandate a diet that directly causes systemic dehydration or leads to severe urinary tract infections because the kidneys just don't have enough water, aren't we just swapping one life-threatening complication for another entirely different set of complications?
That is exactly what started happening. The evidence base proving that thickened liquids consistently reduce pneumonia rates turned out to be much weaker than daily hospital practice implied.
Wow.
So this tension led to a significant shift in intervention strategies, most notably the Fraser-free water protocol, which originated in the 1980s.
Okay, the Fraser protocol. This allows patients to drink unthickened regular water even if they are otherwise prescribed a thickened liquid diet.
Right.
But giving thin water to a known aspirator sounds completely contradictory to everything we just covered about slowing down the liquid.
It sounds wild, but the physiological theory behind the Fraser protocol is actually brilliant.
Yeah.
Pure, clean water is relatively benign if it enters the lungs in small amounts.
Wait, really?
Yes. The lungs can absorb pure H2O into the bloodstream without much issue. Pneumonia isn't caused by the water itself, it's caused by the bacteria carried along with the aspirated material.
Oh, that makes sense.
Right. So if a patient is given rigorous oral care to remove bacteria from their teeth and tongue, and then they're permitted supervised sips of plain water, the aspiration risk is vastly less dangerous than aspirating a food particle or contaminated saliva.
That is fascinating. But moving away from the thickened liquid dogma also exposed how chaotic hospital diets used to be. Like, a liquid labeled nectar thick in a bustling city hospital might have a completely different viscosity than a nectar thick liquid at a suburban nursing home.
And inconsistency in medical terminology is a massive safety hazard. If a patient is transferred between facilities and given the wrong liquid consistency because of a translation error, the resulting aspiration could be fatal.
And that systemic danger is why Julie Cicero helped establish IDDSI in 2013.
Yes, the International Dysphagia Diet Standardization Initiative.
Right. They basically threw out all the old subjective labels and created a unified global 8-level framework.
Ranging from level 0, which is thin water, all the way up to level 7, which is regular unmodified food.
And every level has specific syringe flow tests to objectively measure thickness. It prevents those deadly mix-ups across care transitions.
Standardizing the diet is a vital step, definitely, but we also need to examine who these safety protocols are actually protecting, because there is a pervasive public misconception that swallowing disorders solely afflict the elderly.
Yeah, that is a huge myth. The demographics in the literature are surprisingly broad. Dysphagia affects premature babies in the neonatal intensive care unit whose neurological systems haven't fully developed.
It affects young adults who have suffered traumatic brain injuries in car accidents.
It's a major factor for people of any age living with Parkinson's disease, ALS, or multiple sclerosis.
And we have to mention the COVID-19 pandemic completely dismantled the elderly-only assumption.
Oh, how so?
Intensive care units saw a massive influx of previously healthy patients requiring prolonged intubation and proning, which is lying patients flat on their stomachs to improve oxygenation.
Right.
Historically, many clinicians assumed that once a breathing tube was removed, a patient's swallowing function would naturally bounce back within a few hours.
Yeah, why doesn't it just bounce back? Like, if the tube is out, shouldn't the throat work again?
Think about it mechanically. An endotracheal tube is a piece of plastic wedged directly between the vocal folds. If it stays there for weeks, it physically props the airway open.
Oh, wow.
The delicate muscles of the pharynx undergo severe atrophy from disuse, much like a leg muscle shrinking while inside a cast.
That makes perfect sense.
Plus, the trauma of the tube rubbing against the tissue causes inflammation, and proning causes massive fluid swelling in the face and neck. We now know that post-extubation dysphagia is incredibly common and persistent. Absolutely. Clinicians can no longer pull a breathing tube and immediately hand a recovering patient a glass of ice water. A rigorous swallow screen is mandatory now.
Okay, so as we look at who is at risk, the sources are also very careful to differentiate true dysphagia from a few related conditions that often get lumped together.
That's right. Dysphagia is a mechanical failure of the swallowing process. It is not odonophagia.
Which simply means painful swallowing.
Right. Odonophagia is strictly about the sensation of pain, often caused by severe acid reflux burning the esophageal lining, or maybe inflammation from radiation therapy.
But a patient can have painful swallowing while their mechanical trapdoors work perfectly, or they can occur together.
Exactly. They aren't the same thing.
The sources also detail the globus sensation.
Yes. The globus sensation is the persistent feeling of a lump in the throat. It closely mimics the feeling of food being stuck.
But if you put these patients under a VFSS X-ray, there is no physical obstruction and no mechanical failure, right?
The bolus clears perfectly. Globus is very frequently linked to severe anxiety or stress, which causes the cricopharyngeal muscle at the top of the esophagus to involuntarily spasm or hold tension.
So it creates a very real physical sensation of a lump despite the tube being totally clear.
Yes, exactly. And finally, there is presbyphagia.
Presbyphagia? Wait, what is that one?
This one is crucial for understanding the aging population. It is the normal, expected, age-related decline in swallowing function.
Oh, so just because you're getting older.
Right. As human beings age, we lose muscle mass. Our reflexes slow down. The tissues in the throat lose elasticity.
So it's not a disorder then?
No, presbyphagia is not a clinical disorder. It is just aging. However, it significantly lowers a person's physiological margin of safety.
Meaning an older adult might swallow adequately on a normal day, but they are much more vulnerable to developing true life-threatening dysphagia if they suffer even a minor secondary insult.
Like a small stroke, a bad urinary tract infection, or even generalized weakness from a cold.
That diminished margin of safety really highlights how we need to view swallow studies in general.
Yes. If we connect this to the bigger picture, a diagnostic test, whether it's the X-ray or the camera, is just a snapshot of a single moment in time.
Right. Swallowing function fluctuates wildly. It changes based on a patient's daily fatigue level, the natural progression of a neurological disease, their physical recovery from a stroke,
Or even the side effects of medications they took that morning.
So if a patient is given a strict diet restriction on a Tuesday, it is not necessarily a permanent life sentence.
Not at all. Their ability to swallow has to be continually reevaluated as their overall health shifts.
So what does this all mean? We have explored the intricate mechanical trapdoors of the throat, the silent threat of aspiration, and the fierce clinical debates over thickened liquids.
It's a lot to process.
It is. Why does the intricate science of dysphagia matter to you? It matters because it sits at the intersection of incredibly high everyday stakes. A simple bedside swallow screening by a nurse is one of the highest yield, lowest cost interventions in all of acute care.
It actively prevents aspiration pneumonia, which remains a leading cause of death and hospital readmission worldwide. It is the definition of frontline preventative medicine.
But beyond the mechanics and the pneumonia statistics, dysphagia carries a profound human weight.
It really does. The act of eating is deeply tied to human culture, psychological comfort, and daily autonomy. When a clinician has to write an order for NPO status nil per os, meaning absolutely nothing by mouth, it is a devastating loss for the patient.
And clinicians often have to guide families through the decision of placing a PEG tube.
Right, that is a percutaneous endoscopic gastrostomy, where a surgical feeding tube is placed directly through the abdominal wall into the stomach, bypassing the throat entirely.
Alternatively, families might choose comfort feeding for end-stage dementia patients, where the medical team accepts the high risk of aspiration pneumonia in order to preserve the patient's remaining quality of life.
And those decisions represent some of the most emotionally weighty conversations in modern healthcare.
It is absolutely not just a plumbing problem. It is a fundamental quality of life issue that alters how people interact with the world. I want to leave you with a final thought to ponder. Something derived directly from the source material's notes on saliva management and strict dietary orders.
It's a profound point.
Think about this. If a patient is placed on strict NPO status, meaning they're permitted absolutely zero food or drink by mouth in an effort to prevent aspiration, they are still generating and swallowing their own saliva every single minute of the day.
Right.
If the inability to safely manage your own bacterial secretions is its own standalone risk category, does the simple biological act of existing and producing saliva mean that NPO orders are an incomplete shield? Can we ever truly eliminate the risk of aspiration just by withholding a meal?
That dynamic forces clinicians to constantly weigh the limits of medical intervention against the reality of human physiology.
Thank you for joining us as we unpack this high-stakes mechanical sequence.
Thank you for listening to this deep dive. So in 1997, a computer scientist spent, I think, $20 on public photo records and successfully mailed the sitting governor of Massachusetts his own highly classified medical diagnoses, just to prove a point.
Yeah, and the crazy part is she didn't hack into a secure government server to do it. She just used basic math and some, supposed anonymous data that the state had legally just given away.
Which is wild. So welcome to today's deep dive. We are looking at a massive stack of sources detailing the history, the hidden legal mechanics, and honestly, the spectacular real-world failures of AI and patient privacy.
Right, and it's a huge topic.
It really is. Our mission for today is exploring the line you never cross in healthcare. And we designed this deep dive specifically for you, the curious learner. So whether you are a nursing student prepping to step onto the floor for the first time, a seasoned healthcare professional trying to protect your license, or, just a patient who wants to know who actually has legal access to your medical secrets.
Yeah, and to set the stage for you today, I've actually updated my backdrop. We've got the classic dusty medical records archive, those endless aisles of manila folders. But as you look closely, the paper is sort of dissolving into these glowing digital data streams.
Oh, I love that.
Thanks. Because that intersection, right, where the physical chart meets the digital network, that is where this entire story really begins.
Absolutely. Because when you hear the acronym IAPA, your eyes probably glaze over a bit. It sounds like the most dry, bureaucratic, paper-pushing nonsense imaginable.
It really does.
But the reality in these sources is wild. This law is at the dead center of massive celebrity tabloid scandals, multi-million-dollar international hacks, and intense debates about who actually owns your body's information. Okay, let's unpack this.
Right.
Because before we can talk about how to protect health data, we have to look at what the law actually covers.
Right.
And based on the sources, what the public thinks IP is and what it legally is are just two entirely different universes.
Yeah, they really are. And to understand that disconnect, you have to look at the legislative origin.
Yeah.
Because people think HIPAA was written as this, grand, sweeping privacy manifesto.
Which it totally wasn't.
Not at all. It was passed in 1996 under President Bill Clinton, sponsored by Senators Kennedy and Kassebaum, and its original purpose had almost nothing to do with privacy.
Yeah, the first P in HIPAA doesn't even stand for privacy. It stands for portability.
Exactly. Title I of the law was just designed to help workers keep their health insurance when they lost or changed jobs.
Right.
Then you have Title II, which was really about reducing healthcare fraud and simplifying billing. Because in 1996, hospitals were just drowning in paper. So to fix that, the government wanted to force the healthcare industry to standardize and digitize electronic transactions.
They were trying to drag the medical system into the computer age, basically.
Yeah.
But in doing so, they created this massive vulnerability because before 1996, your medical privacy was mostly protected by physics, right?
That's a great way to put it, yeah.
Your chart lived in a physical manila folder in a physical cabinet in one specific town. It was incredibly hard to steal thousands of records because you'd literally need a moving truck to do it.
Exactly. But once you mandate that every hospital and clinic in America put sensitive patient records onto computers and send them over networks, you massively increase the risk of exposure. So privacy was essentially a necessary patch like an afterthought to protect the new digitization process.
And a heavily delayed patch, according to the timeline. I mean, Congress missed its own deadline to pass the privacy legislation. Because the Department of Health and Human Services, HHS, they eventually had to step in and write the privacy rule administratively.
Right, they had to do it themselves.
Yeah, and wasn't even finalized until 2000 under Secretary Donna Shalala. And they didn't even start enforcing it until 2003.
Right. And that structural history explains why the law has such a frustratingly narrow scope today. Because IPA only covers what's called protected health information, or PHI, and it only applies when that information is held by a covered entity or their business associates.
Let's define those categories, because that's the trap most people fall into, right?
Oh, constantly.
So a covered entity is a hospital, a doctor's office, or a health insurance plan. And a business associate is a company they hire to handle that data, like a medical billing company or a cloud storage vendor.
Right.
Meaning a massive amount of modern health data is simply ignored by the law. Your Fitbit,
Yeah.
not covered. Your 23andMe genetic testing, not covered. The HR files at your corporate job or those health support groups on Facebook,
None of it.
none of that falls under IPAT, even though the data is incredibly sensitive. Is IPAT essentially just a bouncer for a very specific VIP room of data, while letting anyone else in the club trade our health secrets?
What's fascinating here is how that gap has dramatically widened since 2000. When HHS wrote this rule, that VIP room basically contained all the health data that existed in the world.
Oh, wow, right?
Because the drafters never anticipated the smartphone revolution. They couldn't predict we'd be generating terabytes of our own medical data outside the hospital walls through, wearable tech and direct-to-consumer health services.
It's crazy. Well, let's look inside that VIP room. Let's look at the doctors, the nurses, and the insurers who are actually bound by this law. Because even inside the club, it's not a wall of silence. The operational heart of HEPA isn't a mandate to lock everything in a vault. It's a standard called minimum necessary.
Yeah, it's a principle of proportionality. When a covered entity uses or shares your health information, they are legally required to limit it to the minimum amount necessary to accomplish their specific goal.
So like a billing clerk processing a claim for your broken arm needs to see the x-ray results and the orthopedic codes, but they do not need access to the clinical notes from your psychiatric history to process that claim.
Exactly. And that proportionality applies to the primary mechanism of data flow, which is known as TPO.
Right.
That stands for treatment, payment, and operations. Contrary to popular belief, HIPAA actually allows for the free-flowing sharing of your information for those three things without needing your signed authorization.
Wait, so if I'm in the hospital, the nurses can discuss my case at the nurses' station without me signing a form. Isn't that exactly what people are afraid of?
If we connect this to the bigger picture, you'll see why TPO exceptions are absolutely vital and how they actually function. Because modern hospitals use role-based access in their electronic health records. A nurse logs in, and the software only shows them the clinical data for the patients on their specific floor.
Okay, so the system restricts it automatically.
Right, the system restricts their view. If a doctor had to get written authorization from a patient every single time they needed to consult a radiologist or hand off care to an ICU nurse, which falls under treatment, the entire healthcare system would just collapse.
It would completely grind to a halt. And operations is the one that really surprises people. That covers things like quality assessment or training medical students.
Yeah.
A hospital can use your chart to review whether a surgical team followed safety protocols, all without asking your permission first, because that's considered a core operation of running a safe hospital.
Yeah, and that brings us to a crucial distinction. There is a vast difference between informed consent, which is a patient agreeing to undergo a medical procedure, and high-pay authorization.
Which people get mixed up all the time.
Constantly. High-pay authorization is you giving permission to disclose your data outside of that TPO circle, like if you want your records sent to a new employer or maybe a journalist.
And there are also specific times when privacy has to yield to a higher societal duty. The classic legal precedent here in the sources is the Tarasov case from 1976.
Oh, yeah, the duty to warn.
Exactly. Yeah. It established the duty to warn. If a mental health patient makes a credible threat against an identifiable third party, the clinician may, and in some jurisdictions, must breach confidentiality to warn that person. The duty to protect human life just completely overrides the duty to protect data.
Yeah, it is always a balancing act. You have data flowing freely for treatment, restricted by role-based software, and occasionally breached for public safety.
But if data is allowed to flow between hospital staff for treatment purposes, where do things go wrong? Because when you dive into the sources, the most common threats aren't shadowy hoodie-wearing hackers in distant countries. The biggest vulnerabilities are the people already inside the building.
Yeah, insider snooping. It is arguably the most pervasive threat in healthcare privacy.
The 2008 Farrah Fawcett case at UCLA Medical Center is the textbook example here. She was being treated for cancer, and an employee accessed her confidential medical records without any treatment reason, just pure curiosity or, perhaps looking for a payday, and leaked her diagnosis to the National Enquirer.
Which is just awful.
The tabloids knew she had cancer before she'd even told her own family.
Yeah, and UCLA ended up firing over a dozen employees for snooping in celebrity records. They actually had a similar issue with Britney Spears' records around that time.
Right.
The incident was so egregious it drove California to pass a much stricter state law, imposing fines of up to $250,000 for those kinds of violations.
But how does a hospital actually catch an employee doing that?
Hmm.
You mentioned role-based access earlier, but if an ER doctor decides to look up a celebrity who is admitted to the oncology ward, how do they know it was him?
Well, the HIPAA security rule mandates that covered entities maintain strict audit logs. So the computer system tracks exactly which user ID opened which patient file down to the exact second.
Oh, wow.
Yeah, every time you click on a chart, you leave a permanent digital footprint. So when a celebrity is admitted, compliance officers will run reports on that specific chart and cross-reference the user IDs against the actual care team. If you aren't on the care team, you get flagged.
Here's where it gets really interesting, especially for anyone listening who works in a clinical setting. It's not just the blatant selling to tabloid stuff that gets you fired. Around 2010 to 2012, there was this massive wave of nurses across the country getting fired for social media posts. And the wild part, none of them were using the patient's names.
Right, because they assumed they were operating safely within the law. A nurse might post on Facebook like, had a crazy shift, a 25-year-old guy came in with a bizarre leg injury after a motorcycle crash on Highway 9. They felt they were just venting or, seeking community after a hard day.
Yeah, but it becomes a dangerous game of guess who. You don't have to post a person's name for it to be a federal HIPAA violation. The standard is whether the person is reasonably identifiable.
Exactly.
If you provide enough contextual clues to the specific hospital unit, the rare condition, the timing of the accident, that patient becomes instantly identifiable to their family, their friends, or their coworkers who read the local news.
It exposes a massive gray area in human behavior because we tend to think anonymity is just the act of stripping away a formal name. In reality, anonymity is a complete illusion if the surrounding data points are unique enough.
And if it's that easy for one nurse to figure out who a patient is from a Facebook post with just a few context clues, how can hospitals possibly promise that the massive data sets they sell to researchers are actually anonymous?
Well, APA attempts to solve this with something called the safe harbor method. The rule states that if a covered entity strips away 18 specific identifiers from a data set, things like names, exact dates of treatment, full zip codes, the data is legally considered de-identified. And at that point, IPA no longer applies and the data can be shared or sold freely.
But the sources highlight a piece of research from the 1990s that totally shatters that safe harbor logic. Which brings us back to LaTanya Sweeney, the computer scientist we mentioned. She wanted to test how anonymous this data really was, and she discovered that you only need 3 basic data points to uniquely identify roughly 87% of all Americans.
It's staggering.
All you need is a 5-digit zip code, a birth date, and sex.
And when you break down the mechanism of that math, it is both brilliant and terrifying. Because a typical zip code might have, say, 30,000 people. Roughly half are men. Now, how many of those 15,000 men were born on one specific day, like July 4th, 1960?
Right.
Maybe one. Suddenly, a massive pool of 30,000 people filters down to a single identifiable individual.
Which is exactly the stunt we mentioned at the start of the deep dive. In 1997, Massachusetts released gay-identified health records for state employees for researchers. Sweeney bought publicly available voter registration data, which included zip codes and birth dates. She cross-referenced the voter list with the anonymous health records using her 3 data points and successfully re-identified the medical records of Governor William Weld.
Yeah, and that demonstration fundamentally shaped the debates around the HIPAA safe harbor list, because it proved beyond a shadow of a doubt that anonymized is not the same thing as unlinkable.
If 87% of us can be pinpointed with just a zip code, a birthday, and a gender, it feels like.
Yeah.
I mean, if de-identification is that fragile, are these safe harbor rules essentially just a leaky bucket in the digital age?
This raises an important question about the future of medical research. De-identification reduces the risk, certainly, but it cannot entirely eliminate the risk of re-identification, especially today with machine learning and massive commercial data sets tracking our location and, our purchasing habits. The target on healthcare data is only getting bigger.
And when hackers hit that target, the fallout is staggering. Look at the Anthem breach in 2015. Hackers got into Anthem, which is one of the biggest health insurers in the U.S., and accessed 78.8 million records.
Millions, yeah.
Names, Social Security numbers, employment data. It remains the largest healthcare data breach in U.S. history.
And that breach is a perfect example of why the government had to update the law. In 2009, they passed the HITECH Act. It finally gave HIPAA financial teeth.
Because before that, the fines were basically just a slap on the wrist.
Exactly. Penalties were relatively small. But HITECH introduced tiered financial penalties for violations based on the level of negligence. Crucially, it made business associates directly liable for breaches, whereas before, only the hospitals bore the legal brunt.
Right, and because of those HITECH mechanisms, Anthem ended up paying a record-breaking $16 million settlement to HHS's Office for Civil Rights, the OCR, plus a $115 million class action payout to the victims. The financial risk of holding data finally started to match the privacy risk.
But we've spent this entire time exploring how this law penalizes people for sharing your data inappropriately. But there's a whole other paradigm to HIPAA that the public almost entirely ignores. HIPAA actively penalizes providers for withholding your data from you.
Oh yeah. The case that proves this shift is Signet Health in 2011. The government handed down its first ever civil monetary penalty for a HIPAA violation. And it was a massive $4.3 million fine. And it wasn't for a hack. It wasn't for an employee leaking a chart to a tabloid. It was because Signet Health denied 41 patients access to their own medical records.
Yeah, under HIPAA, patients have a fundamental legal right to obtain copies of their own medical records, usually within 30 days. And you have to ask why a doctor's office would refuse that.
Right.
It rarely comes from malice. Often it's a fear of malpractice suits or the sort of paternalism where a doctor thinks the patient won't understand the notes, or simply the administrative burden of using outdated software systems to compile a massive chart.
But the law doesn't care about administrative burden. Since 2019, the OCR has been running the Right of Access initiative. They are actively prosecuting providers who ignore or delay patients trying to get their own charts. Privacy law cuts both ways. It dictates don't leak my data to them, but it also demands give me my data.
Yeah, and while we are untangling these complexities, we should really tackle the rapid-fire misconceptions the sources highlight, because the public understanding of this law is just incredibly distorted. Let's start with a major one from recent years. Asking if I'm vaccinated violates HIPAA.
False. I mean, we saw this everywhere during the pandemic. HIPAA restricts what covered entities like your doctor can disclose. It does absolutely nothing to restrict a private business, an airline, or a restaurant host from asking you a question about your health. It reminds me of the scene in The Office where Michael Scott just shouts, "I declare bankruptcy," as if saying the words out loud magically invokes federal law.
Yes, exactly.
People shouting HIPAA violation at a restaurant bouncer doesn't make it real.
It really doesn't. And here's another pervasive myth. HIPAA means the hospital can't tell my family anything about my condition.
Also false.
Right. Providers are allowed to share relevant information with family involved in your care unless you explicitly object. And if you're incapacitated, they can use their professional judgment. When a family member gets stonewalled at a hospital desk, they're usually hitting an overly cautious institutional policy born out of fear of lawsuits, not the actual text of the HIPAA regulation.
It's also worth noting how isolated HIPAA is globally. International students often get confused by HIPAA because in Europe, they operate under the GDPR, which covers essentially all personal data controllers, regardless of industry. The European model focuses on the data itself, the The American model focuses on who holds the data.
Yeah, and even here in the U.S., if you go to a student health clinic on a college campus, those medical records might not fall under HIPAA at all. They often fall under FERPA, the Educational Privacy Law.
Wow.
So IPA is uniquely, confusingly narrow.
So what does this all mean for you, listening right now?
It means understanding that the boundary of patient privacy is easier to cross than ever before. We are having intimate medical conversations over video calls. Doctors are texting colleagues on their personal phones to consult on cases. We are constantly messaging through patient portals. The digital footprints are everywhere.
And for nurses and healthcare workers, this isn't some abstract regulatory debate. Here, violations are a leading cause of termination. Based on everything in the sources, those lines are almost never crossed out of cartoonish villainy. They are crossed through convenience, like texting a coworker a lab result on an unencrypted phone because it's faster, or through sheer human curiosity, like peeking at a neighbor's chart when they get admitted.
Yeah, and knowing exactly where that legal line sits is a vital career-protecting skill. You have to respect the audit log. The system is always watching. You leave a trail every time you look.
I want to leave you with a final thought to mull over. We've talked extensively about human curiosity and human error today, but consider where healthcare is going right now with the rapid integration of AI scribes in exam rooms. These are tools designed to listen to your appointment and instantly summarize the clinical notes. To do that accurately, an AI algorithm might be tasked with reading your entire medical history in milliseconds to prepare that summary. So how does a non-human entity comply with the minimum necessary standard? Does an AI have a curiosity problem, or does the tech company training the AI have one? If iPow is built as a bouncer for a VIP room of human doctors, what happens when the bouncer is an algorithm? It's a question to keep in the back of your mind the next time you see a microphone sitting on your doctor's desk. The vault has doors, and we're still figuring out who holds the keys.
So picture this. You walk into a hospital room, or, maybe you're just watching a medical drama on TV, and there it is.
Oh, yeah.
Right. The clear plastic bag hanging on that metal pole, just sort of slowly dripping liquid into a tube that disappears into someone's arm. It's like practically the universal symbol of modern medicine.
It really is.
And you look at it and you probably think, hydration. The tank is low, so they're just giving the patient some water.
Yeah, which is, it's the most natural assumption to make, right?
Right.
We all sort of carry this mental model of the human body as like a series of rigid pipes. So if a patient is sick or bleeding, well, the pipes are emptying out.
Exactly.
So you just hook up a bag of water to refill the plumbing. It just feels incredibly straightforward.
It does. But then you actually start digging into the science of those fluid bags, and suddenly that whole simple plumbing analogy just completely falls apart.
Oh, completely.
So welcome to the deep dive. Today, our mission is to unpack the fascinating and honestly highly counterintuitive world of 5V fluids.
Yeah, it's a wild ride.
Because what the sources reveal is that this is so much more complex than just, hydration. We're actually going to explore 3 genuinely surprising realities today for you. First, a fluid bag, clearly labeled isotonic, can actually act as a hypotonic water bomb once it's inside you.
Which is terrifying.
Right. Second, normal saline isn't actually physiologically normal at all. And third, the textbook standard for pediatric IV fluids was quietly harming children for 50 years before the medical community caught on.
Yeah, that one it's a really profound shift in perspective when you realize what is actually happening in that plastic tubing.
So where do we even start?
Well, to understand why those 3 things are true, we need to establish a foundational definition for you. At its core, an IV fluid is a sterile water-based solution infused directly into the bloodstream.
Okay, simple enough.
Right, but the single most important concept here isn't the water itself. It's a property called tonicity.
Tonicity?
Yeah. Tonicity basically describes how that specific fluid forces water to move across human cell membranes.
Okay, I want to spend some time here because, to understand how IV bags work, we really have to visualize this microscopic tug of war. It's happening between the fluid we're pumping into the vein and all the billions of cells lining those veins and making up the surrounding tissues.
Exactly. So there are 3 main classifications of fluids you need to know, and they're all based on this concept of tonicity.
Okay.
And we benchmark this against human blood plasma, which has a very specific, tightly regulated concentration of dissolved particles.
Like salt and stuff.
Yeah, mostly sodium, chloride, glucose, and urea. And that baseline concentration is roughly 275 to 295 milliosmoles per liter.
Okay, so 275 to 295 milliosmoles per liter.
That's the target. So the first type of fluid is isotonic.
ISO meaning same.
Exactly. This fluid has roughly the same effective solute concentration as your blood plasma. When you infuse an isotonic fluid into the bloodstream, the surrounding cells neither gain nor lose water. It creates a state of balance.
Got it.
The second type is hypotonic. This fluid has a lower concentration of solutes than the blood plasma.
Okay, so less stuff, more water.
Right. And because of the laws of physics, water naturally wants to balance things out. So the water actually leaves the bloodstream and forces its way into the more concentrated cells.
Oh, wow.
Yeah, and that causes those cells to physically swell up.
That sounds dangerous.
It can be. And then the third type is hypertonic. This has a higher concentration of particles than plasma.
So super salty or sugary.
Exactly. So in this case, water is violently pulled out of the surrounding cells to dilute the blood, causing those cells to physically shrink.
Okay, so to help you visualize this at home, I was actually thinking about an analogy while I was reading the sources.
Oh, let's hear it.
Okay, so imagine the dissolved solutes, like the salt or the sugar particles. Imagine them as the life of a great party.
Okay, I like this.
And the water. The water is the crowd. And, the crowd always wants to leave the empty, boring room and rush into the room where the party is actually happening.
That's spot on.
So if you inject a hypertonic fluid, you are basically throwing a massive concentrated party right inside the bloodstream.
Right.
So all the water inside the body's tissue says, hey, let's go out there, and rushes out of the cells to join the party, which shrinks the cells.
That paints a very accurate picture of the mechanism.
Hmm.
And, for most of the 20th century, doctors basically operated under the assumption that these properties were simply fixed numbers printed on the bag's label.
Like whatever the label says is what you get.
Exactly. If the label said the party was a certain size, well, that was the end of the story.
Yeah.
But modern physiology makes this really sharp distinction that completely changes how we administer fluids.
Okay.
There is a massive functional difference between osmolarity and tonicity.
Okay, I'm going to need a timeout on this one.
Sure.
Because if the bag is manufactured in this highly controlled, sterile factory, how can the label be wrong? I mean, if it says it has a certain number of particles, aren't particles just particles?
Well, that's the trick. Osmolarity is exactly what you just described. It's the total absolute count of dissolved particles in the bag per liter.
Right.
You measure that in a chemistry lab, and the factory label is 100% accurate about that exact number.
Okay.
But tonicity is the effective osmotic pull that actually drives water movement across a living biological cell membrane.
Oh, I see.
Yeah, and those two concepts are not always synonymous because some particles are sneaky.
Sneaky how?
They can just pass right through a cell membrane without any resistance. Urea and ethanol are like classic examples.
Oh, so they don't trap the water.
Exactly, because they cross freely. They don't force water to move at all. They add to the osmolarity number on the factory label, sure. But inside a human being, they have zero tonicity.
Wow. Which actually brings us directly to that first major revelation from the intro, the D5W paradox.
Yes.
I was reading this section and trying to map it out in my head. So D5W is 5% dextrose in water.
That's right. And if you read the bag, its osmolarity sits perfectly in that 275 to 295 range.
So on paper, it's an isotonic fluid.
Exactly. It looks like it should just sit nicely in the blood vessels and maintain balance.
But dextrose is literally just a form of sugar.
Mm-hmm.
And the cells in our body constantly need sugar for energy. So if we pump this supposedly balanced sugar water into a vein, the patient's cells are going to rapidly consume all that dextrose.
Right.
They basically eat the party.
They devour the solutes entirely. And once the body metabolizes all that dextrose, what is left circulating in the patient's veins?
Just plain water.
Plain free water. So a fluid bag that was clearly labeled and manufactured as isotonic actually behaves as a hypotonic solution once it interacts with human metabolism.
That is wild.
It drops the concentration in the blood and sends all that free water rushing into the patient's cells.
Which, okay, knowing that we can manipulate water like this, forcing it in or out of cells by changing the guest list to this cellular party, it raises a major clinical question for me.
What's that?
Why would a clinician ever want to intentionally force a patient's cells to swell or shrink? I mean, shouldn't the goal always be to maintain that perfect isotonic balance?
Well, maintaining balance is absolutely the goal for basic resuscitation.
Right.
Like if someone is rushed to the ER with severe blood loss from a car accident or massive fluid loss from a gastrointestinal infection, their blood pressure is plummeting.
So you just need to refill the pipes.
Exactly.
Yeah.
You need to refill the pipes just to keep the heart pumping and oxygen flowing. Clinicians use isotonic fluids here because they want that fluid to stay inside the blood vessels. You definitely do not want it shifting into the surrounding tissues and causing complications.
But the sources discuss the use of hypertonic fluids, and I had a really hard time wrapping my head around this.
Yeah, it sounds backward.
Right. Under what circumstances would you ever want to intentionally dehydrate and shrink a patient's cells?
The primary application is for cerebral edema, which is severe swelling of the brain.
Oh, wow.
Because
Okay.
the brain is a really unique organ. It's completely encased in a rigid, unforgiving bone box. The skull,
Right. There's no room.
none.
Hmm.
If brain cells begin to swell due to a traumatic injury or a stroke or a tumor, they have nowhere to expand.
Yeah.
So the physical pressure inside the skull starts building rapidly.
And if that pressure gets too high, it eventually just crushes the brainstem, right? Which controls breathing and heart rate. It's basically fatal.
It is. So to prevent that, a critical care team will push a highly concentrated hypertonic solution, usually like a very strong saline, into the bloodstream.
Ah.
So following your analogy, they throw an aggressive party inside the blood vessels of the brain.
And the water leaves the brain cells.
Exactly. The water that is dangerously trapped inside the swollen brain tissue is drawn across the blood-brain barrier and into the bloodstream to dilute that massive salt load.
That is incredible.
It physically shrinks the brain cells, a cellular process known as crenation, and it relieves that deadly mechanical pressure inside the skull.
The physics of water being used to literally decompress a brain. That is just wild to think about.
It's elegant, honestly.
So, okay, on the flip side, when do we use hypotonic fluids? Like, when do we intentionally swell cells?
Hypertonic fluids come into play when a patient is suffering from profound intracellular dehydration.
Okay.
A prime clinical example of this is diabetic ketoacidosis, or DKA.
Okay, I've heard of that.
Yeah, in severe DKA, the patient's blood becomes so thick with unmetabolized glucose that the blood itself acts like a hypertonic fluid,
Oh. So the blood is sucking the water out of the body.
violently sucking water out of the patient's own tissues. Their cells are effectively shriveling up.
Wow.
So once the medical team stabilizes the patient's blood sugar and initial volume, they will often introduce a hypotonic fluid to gently push free water back into those parched cells to rehydrate them.
But there has to be a dark side to this, right?
What do you mean?
Well, if you are pushing water into a cell with a hypotonic fluid, isn't there a point where the cell just, I don't know, just can't take it anymore, like overfilling a water balloon?
Oh, absolutely. It is a critical risk factor.
Yeah.
If you administer too much hypotonic fluid or if you push it too fast, you can trigger RBC hemolysis.
Hemolysis, meaning what exactly?
It means the red blood cells circulating in the veins swell up with so much free water that their structural membranes simply cannot hold the tension. Yeah, they rupture and burst open directly in the bloodstream, which is a catastrophic event.
Wow. This requires like a surgical level of chemical precision.
It really does.
Which naturally makes me wonder about the history here. I mean, how did humanity figure out this exact benchmark? The 275 to 295 milliosmoles thing. Like, how did we learn to manufacture these safely?
The origin story in the sources is fascinating because it wasn't just a single scientific breakthrough.
Right.
It was a collision of two vastly different worlds over several decades. On one end of the spectrum, you had the 19th century physicists and physical chemists,
Okay.
men like Wilhelm Pfeffer and Jacobus Henricus van Hoff.
Right.
And they operated in these pristine, quiet laboratories, meticulously studying plant cells and deriving the fundamental mathematical equations for osmotic pressure.
Doing the math.
Exactly, mapping out the invisible laws of how water behaves.
But calculating osmotic pressure in a quiet lab is worlds away from, keeping a dying human being alive.
That is exactly where the clinicians enter the picture. And their environment was the exact opposite of pristine.
Yeah, I bet.
In the 1830s, Europe was devastated by horrific cholera pandemics.
The blue terror.
Right, the blue terror.
Yeah.
Cholera causes such violent, relentless diarrhea that patients literally dried out.
Ugh, that's awful.
It is. Their blood would lose so much water, it turned into this dark, thick sludge that the heart could barely even pump.
Wow.
And a Scottish physician named Thomas Latta read theories about injecting water and salts directly into the veins. Driven by just sheer desperation, he began experimenting on dying patients.
So he didn't have all those fancy equations.
He didn't have Van Hoff's equations at all. He was basically just trying to mimic the salty taste of blood.
It was raw trial and error on human physiology.
Entirely. Latta and subsequent pioneers like Sidney Ringer and Alexis Hartman, they would inject various concoctions of boiled water, salt, and eventually sodium lactate, just to see what combinations kept people alive.
Without causing convulsions or that hemolysis we talked about.
Exactly. So over decades, the rigorous, pristine physics of the laboratory finally merged with the messy, desperate clinical survival data from the cholera wards.
And that gave us the formulas.
Yep, eventually yielding the precise IV formulas we rely on today.
But here is where the narrative takes a really sobering turn, I think.
Yeah.
Because we often think of modern medicine as this steady, unimpeachable march of progress. But the sources highlight a terrifying complacency that eventually set in.
He did.
The medical establishment got comfortable, and they got some major things wrong. Which brings us to the holiday cigar failure.
Yeah, this is one of the most sobering case studies in modern pediatric medicine, honestly.
It really is.
In 1957, two well-respected doctors, Holliday and Cigar, developed a formula to calculate the daily maintenance IV fluids required for children who couldn't eat or drink.
Okay.
Their formula was mathematically brilliant for calculating the volume of fluid a child needed based on their weight. But the type of fluid they recommended to fulfill that volume was heavily hypotonic.
Right, because they based their fluid composition on the electrolyte profile of healthy breast milk and cow's milk.
Which sounds logical, right?
It sounds totally logical at first glance.
It sounds logical until you realize that healthy milk is processed slowly by the gastrointestinal tract of a healthy infant.
Oh, right.
It is not injected directly into the systemic circulation of a sick, stressed child lying in a hospital bed.
Yeah, that's a huge difference.
When a child is hospitalized with an illness or undergoing surgery, their body naturally panics. It releases a flood of stress hormones, specifically antidiuretic hormone, which screams at the kidneys to stop producing urine and hold on to every drop of water possible.
So the kid's body is already aggressively hoarding water.
Exactly.
And then the medical team pumps bags of hypotonic fluid, which, as we established earlier, leaves behind a massive load of free water directly into their veins.
The result was severe dilution of the blood. The sodium levels in these children would plummet to dangerously low levels.
Wow.
It's a condition called hospital-acquired hyponatremia.
And if the sodium in the blood drops too low, the blood becomes hypotonic compared to the brain cells.
Yes.
So the water rushes into the brain, causing the exact cerebral edema we talked about earlier.
Exactly. And for over 50 years, the undisputed textbook standard for pediatric maintenance fluids was quietly causing neurological damage, seizures, and in several tragic cases, death.
Just from the routine fluids.
Simply from the routine IV fluids ordered upon admission. It wasn't until 2018 that the American Academy of Pediatrics finally, officially reversed this half-century-old standard.
2018, that was practically yesterday.
I know. They issued strict guidelines that isotonic fluids must be the standard for pediatric maintenance.
50 years of standard practice, it is genuinely unsettling.
It is.
And it underscores just how delicate the body's sodium balance really is. Because the sources point out another complication of fluid mismanagement, and I actually had to read this section twice just to process the severity of it.
Oh, osmotic demyelination syndrome.
Yes.
Yeah, if you zoom out and look at the bigger picture of tonicity, osmotic demyelination syndrome is the devastating consequence of trying to fix a complex problem too quickly.
How so?
Well, if a patient comes into the emergency room with severe chronic hyponatremia, meaning their blood sodium has been dangerously low for days and their brain cells have slowly absorbed water and swollen to adapt to this new environment, a clinician might look at the lab results and think, I need to give them highly concentrated hypertonic saline right now to fix this number.
Right. I mean, the tank is low on salt, so just dump the salt back in.
But if you correct that sodium deficit too rapidly, you radically shift the tonicity in the opposite direction.
Oh.
The hypertonic saline violently sucks the water back out of the adapted brain cells. It shrinks the cells so rapidly and aggressively that it physically tears the myelin sheath.
Which is the insulation, right?
Exactly. It's the protective fatty insulation wrapping around the nerve fibers in the brainstem. You are effectively stripping the insulation off the brain's wiring.
That sounds horrific.
It causes irreversible neurological damage, locked-in syndrome, or even death. It is a permanent reminder that in fluid resuscitation, the velocity of the fluid shift is just as dangerous as the shift itself.
Wow. So with all these historical blind spots and microscopic tightropes that clinicians have to walk, you would think we have it all perfectly mapped out now.
You would think.
But I noticed a huge ongoing conflict in the critical care sources. It seems like a modern group of doctors started demanding massive trials to challenge the fluids we use every single day.
Yeah, the science of critical care fluid therapy is far from settled. If you look at the modern landscape, 2 massive clinical trials have completely disrupted the status quo.
The SAFE trial and the SMART trial.
Exactly.
Okay, let's tackle the SAFE trial first because this gets into the debate between crystalloids and colloids.
Right.
Everything we've discussed so far, saline, dextrose, these cheap bags of dissolved salts and sugars, those are crystalloids.
Correct.
But the sources define colloids as fluids containing massive molecules like human albumin, which is like a large protein derived from blood plasma. But from what I understand, the argument for using these expensive proteins all comes down to the Starling equation.
Yes, it does.
I want to try explaining this actually because it really changed how I view the cardiovascular system.
Oh, go for it.
Okay, so we tend to think of our blood vessels as solid rubber pipes, but the capillaries are actually semi-permeable.
Right.
So they're more like porous soaker hoses in a garden. Water can easily leak out of them to the surrounding tissue, causing severe swelling.
Exactly.
But according to the Starling equation, the giant proteins naturally floating in our blood act like water magnets.
Yes.
They are physically too large to leak out through the pores of the soaker hose, so they stay inside the blood vessel and hold onto the water with a pulling force called oncotic pressure.
That is a phenomenal way to explain oncotic pressure.
Thanks.
And that was the fundamental theory behind using colloids. Clinicians argued that if a patient is critically ill and their blood vessels are leaking, we shouldn't just pump in cheap salt water that will immediately seep right into the tissues.
That makes sense.
They thought we should pump in expensive colloid proteins to act as massive magnets, pulling the water back into the pipes and keeping it there.
Okay.
So the SAFE trial was this massive international effort designed to finally prove that colloids were superior for saving lives in the ICU.
But the results didn't exactly match the theory, did they?
They did not. The SAFE trial demonstrated that, for the vast majority of critically ill patients, resuscitation with cheap, basic crystalloid salt water resulted in the exact same mortality rates as the expensive albumin colloids.
Wow, really?
Yeah. While there are still very specific niche uses for colloids, like in certain liver failure patients, the trial proved that for everyday critical care, the basic physics of salt and water are sufficient.
Which brings us to the SMART trial and our final mind-bending fact from the beginning of the deep dive.
Yes.
The myth of normal saline.
Yes. So 0.9% sodium chloride is universally referred to as normal saline.
Right, you hear it all the time.
It is the most ubiquitous, heavily utilized IV fluid on the planet. But from a purely physiological standpoint, it is incredibly abnormal.
Wait, really?
Yeah. Human blood plasma has a chloride concentration of roughly 100 milliequivalents per liter. Normal saline contains 154 milliequivalents of chloride per liter.
That is over 50% more chloride than the human body is designed to handle.
Exactly. And when a trauma patient or a sepsis patient requires massive volume resuscitation and you pump liters upon liters of normal saline into their veins, that immense unnatural chloride dump wreaks havoc.
I can imagine.
The heavy chloride load constricts the blood vessels inside the kidneys, starving them of oxygen, and it actually induces a state of metabolic acidosis.
Oh, wow.
So the SMART trial was designed to confront this exact blind spot. It compared traditional normal saline against balanced crystalloids.
Balanced meaning what?
Fluids like lactated ringers, which are specifically engineered with buffers to closely mimic the actual electrolyte balance of human blood.
And the results of the SMART trial are actively changing how hospitals operate today, right?
Absolutely. The evidence clearly shows that using balanced fluids instead of normal saline leads to significantly fewer kidney injuries, less need for dialysis, and lower overall mortality in critically ill patients.
That's huge.
We are watching a real-time paradigm shift as modern medicine finally questions the normal saline we've relied on for over a century.
It really emphasizes that no medical intervention, no matter how ubiquitous or seemingly simple, should ever be exempt from rigorous questioning. So let's synthesize everything we've covered today. We have dismantled the plumbing analogy. We've seen that IV fluids are absolutely not just water.
Not at all.
They are highly calculated chemical tools governed by the strict physical laws of tonicity. We explored the d-phi-W paradox, where an isotonic label disguises a hypotonic effect.
Yep.
We talked about the life-saving physics of intentionally shrinking brain cells or swelling dehydrated tissues. And we unpacked the historical tragedies and modern trials, from the 50-year holiday cigar pediatric error to the ongoing movement away from normal saline.
Right.
Which all proves medical science is always, sometimes painfully, evolving.
The main takeaway for you as a listener is that the next time you are in a hospital or you see that clear plastic bag dripping on a medical drama, you're going to look at it with completely new eyes.
Definitely.
It isn't just hydration. It represents a microscopic, calculated manipulation of the physical laws of water inside the human body. Every single drop interacting with millions of cells, governed by equations that took centuries to map out.
I love that. And, I want to leave you with one final thought to mull over. Building on these rules of water movement.
Okay.
We have spent this entire discussion exploring how tonicity and hydrostatic pressure force water to move in a gravity-bound human body.
Right.
But what happens when we leave the planet?
Oh, wow.
Right. In the microgravity of space travel, astronauts lose the normal hydrostatic pressure that pulls blood into their legs. Their bodily fluids naturally shift upward into their chest and head, which is why astronauts often have puffy faces in orbit.
Yeah, I never thought about that.
Yeah, and as we prepare for long-duration missions to Mars, aerospace medicine is having to completely reimagine IV fluid resuscitation.
That is fascinating.
How do you manipulate tonicity, and where does the water decide to go when the fundamental pull of gravity is removed from the equation? It turns out the final frontier medicine might just be relearning how to hydrate a human cell in the stars.
Imagine stepping into a hospital room back in September of 1948. You're looking at a 29-year-old woman, and she is just completely bedridden.
Right, she had severe rheumatoid arthritis.
Yeah, her joints are so destroyed, so inflamed that she can barely even move. Then her doctor walks in with a syringe containing this brand new, highly experimental compound. He gives her an injection, and, well, within days, she is actually walking around the ward.
Which is almost unbelievable when you think about it.
Totally. By her third dose, she has essentially checked herself out and is literally downtown going shopping. I mean, it looks like absolute magic, right? Like a switch was just flipped.
It really was. I mean, the profound dramatic transformation of that single patient, it completely shifted the entire trajectory of modern medicine. It established a whole new baseline for what doctors thought might be possible with autoimmune diseases.
And that transformation is exactly what we're exploring today. Welcome to the Deep Dive. Our mission today is to, well, pull back the curtain on that quote-unquote magic compound, corticosteroids.
It's a massive topic.
It is. We've pulled together a really fascinating stack of sources for you today, ranging from medical history archives detailing that exact 1948 discovery to, modern pharmacology textbooks and even some recent critical care trial data.
Yeah, we're covering a lot of ground.
We are. We're going to look at the massive power these drugs hold, the incredibly dangerous side effects they can unleash, and the absolute golden rule of medicine when it comes to managing them. Basically, why you never, ever stop taking them abruptly.
That is so crucial.
But before we get into the dark side of that miracle, we really need to clear the air. Because when we say the word steroids, we have to erase a very specific pop culture image from our minds. We are not talking about bodybuilding.
Oh, absolutely not.
There's no muscle building, no roid rage happening here at all.
Yeah, and that misconception trips up a lot of people, even nursing and medical students in their very first weeks of training. Anabolic androgenic steroids are synthetic derivatives of testosterone. They are specifically engineered to build muscle mass and, well, enhance physical performance. Corticosteroids, on the other hand, operate in a totally different biological arena. They are anti-inflammatory, immune-modulating hormones that are related to cortisol. They manage the body's stress response, metabolism, the immune system. Basically, they prepare the body to survive severe physiological stress, not to, win a weightlifting competition.
So to understand what these drugs are actually doing in hospitals today, we have to go back to the frantic race to isolate them in the 1930s and 40s. Because scientists knew the adrenal gland, those two little triangular organs sitting on top of your kidneys, they knew it was doing something vital to keep us alive.
Yeah, if they removed the adrenal glands from an animal in the lab, it died. They just didn't know what the chemical was.
Right. It was one of the great medical mysteries of the early 20th century. You had this intense race between two brilliant scientists working mostly independently, Edward Calvin Kendall, who's a biochemist at the Mayo Clinic, and Matthias Reichstein, a chemist at the University of Basel in Switzerland.
And they were painstakingly trying to isolate active compounds from the adrenal glands of oxen and sheep.
Which sounds exhausting.
Oh, it was grueling bench chemistry, just pulling out these distinct microscopic steroid molecules and labeling them alphabetically, compound A, compound B, compound C, and so on.
And Kendall eventually isolates this compound E, which later gets named cortisone. But having the chemical in a vial doesn't cure anyone. The clinical spark, the actual application to human disease, that came from a rheumatologist named Philip Showalter Hensch.
Yes.
And his observation is just brilliant because it's so strange. He noticed that his severe arthritis patients would suddenly go into spontaneous remission if they got pregnant, or, weirdly enough, if they developed jaundice.
Which led to his substance X theory. Hensch theorized that pregnancy and jaundice were causing the body to flood itself with some unknown circulating hormone, likely from the adrenal gland, that was powerfully suppressing the disease.
That makes sense.
Right. The logic being that if the body could naturally turn off the inflammation of arthritis under certain conditions, maybe doctors could induce that state artificially. So he badgered Kendall to synthesize enough of this compound E to test it on a human. And that brings us right back to that 29-year-old bedridden woman in 1948.
She gets up and goes shopping. It makes international headlines. Cortisone is just universally hailed as a miracle cure. And looking at the historical timeline in our sources, they won a Nobel Prize for this almost immediately.
What's fascinating here is the sheer speed of that recognition. In 1950, Hensch, Kendall, and Reichstein jointly won the Nobel Prize in Physiology or Medicine.
Why, 1950?
Yeah, less than 15 years from the early, messy isolation work in the lab to the most prestigious science prize in the world. I mean, a bench-to-bedside timeline that fast is practically unheard of today.
But the euphoria crashed hard. Within just a couple of years, doctors started seeing the horrifying backlash of this supposed miracle. Patients who stayed on high doses of cortisone long-term, they started developing physical deformations.
Yeah, the side effects were severe.
Their faces rounded out into a moon face shape. Their skin thinned like paper, bruising at the slightest touch. Their bones became brittle. They developed severe diabetes, psychiatric disturbances ranging from mania to depression. And most terrifyingly, if they suddenly stopped taking the drug, they would collapse into shock. Some of them died.
The initial rollout of cortisone perfectly illustrates a recurring pattern in medical history. A transformative discovery is completely oversold as a cure-all, and then harsh clinical reality sets in, forcing a recalibration. The central tension of corticosteroids was established right then in those early years. It is an extraordinarily powerful tool that, if mismanaged, is lethal.
Okay, let's get our definition straight. Because diving into the pharmacology textbooks, defining what a corticosteroid actually is depends entirely on who you ask in the hospital. If you ask a bedside nurse versus a pharmacologist, you get two different answers.
You really do. The textbooks use corticosteroid as an umbrella term. It includes two distinct families of hormones produced in the adrenal cortex. First, you have glucocorticoids, which handle glucose regulation, metabolism, and suppressing inflammation.
Okay, that's group one.
Right. And second, you have mineralocorticoids, like the hormone aldosterone. Mineralocorticoids govern sodium and water retention. They are the master regulators of your salt and fluid balance. Because both are manufactured in the adrenal cortex via the same biological pathway, technically they are both corticosteroids.
But when a nurse tells a colleague, like, hey, my patient in bed 4 is on steroids, they're almost never talking about the salt balancing ones.
Exactly. At the bedside, the everyday clinical definition of steroids almost exclusively points to the glucocorticoid family. We're talking about synthetic drugs like prednisone, dexamethasone, and hydrocortisone. These are the heavy hitters prescribed for asthma flares, autoimmune diseases, or severe allergic reactions.
And what about the others?
Mineralocorticoids, like fludrocortisone, are prescribed far less frequently, usually just for specific conditions where the body literally can't retain sodium, like Addison's disease.
Okay, let's unpack this. To really grasp why that one injection in 1948 acted like magic but then turned so dangerous, we have to understand how these drugs fundamentally hijack the body's natural systems. And looking at the physiology guidelines, the easiest way to visualize this is to think of the thermostat in your house.
I love that analogy. The hypothalamic pituitary adrenal axis, the HPA axis, it operates on the exact same principles as a home heating system.
So the HPA axis is your body's built-in corticosteroid factory. The thermostat on the wall is your hypothalamus in the brain. It senses the temperature, or in the body's case, the stress level, and when things get tough, it sends a chemical signal.
Right.
That signal is a hormone called corticotropin-releasing hormone, or CRH. The CRH travels to the furnace controller, which is your pituitary gland. The pituitary receives that signal and sends its own chemical messenger down to the basement.
And that messenger is adrenocorticotropic hormone, or ACTH.
Right, ACTH. And the furnace in the basement is your adrenal glands. The ACTH tells the adrenal glands to turn on and pump out the heat, which is the hormone cortisol. Once the house is warm enough and the stress is managed, the thermostat on the wall senses the heat, stops sending CRH, and shuts the whole system down. It's a classic negative feedback loop.
And your body runs this furnace continuously. Under normal non-stress conditions, a healthy adult's adrenal glands produce roughly the equivalent of 5 to 10 milligrams of synthetic prednisone a day.
Oh, wow. So we always have a baseline.
We do, and this production follows a strict daily rhythm, peaking in the early morning hours to essentially wake your body up and prepare it for the day. Then it drops to its lowest point late at night so you can sleep.
So when we give a patient a synthetic corticosteroid pill, we are basically pumping massive amounts of artificial heat into the house. And the clinical versatility of this artificial heat is staggering. Let's look at how this plays out in modern medicine, starting with the disease that started it all, rheumatoid arthritis. Here, the drug is used as a bridge therapy.
Right. Rheumatoid arthritis is an autoimmune disease where the body's own immune system aggressively attacks the joint linings. When a patient is in agonizing pain, the long-term disease-modifying drugs can take weeks or months to start working.
That's a long time to wait in pain.
Exactly. So corticosteroids serve as the bridge. A doctor gives a dose, and within 24 to 72 hours, it violently suppresses that immune activity. It halts the destruction temporarily, buying time for the slower-acting medications to finally take over.
But you don't always want to flood the whole system. Let's look at asthma. This is where the delivery method completely changes the strategy. You can keep the treatment localized.
Yeah, matching the route of administration to the clinical need is vital. For everyday asthma maintenance, a patient uses an inhaled corticosteroid. The medication goes directly into the airway tissue, suppressing the inflammation right where the problem is occurring.
Which is great because it stays out of the rest of the body.
Right, because it's inhaled, very little of the drug absorbs into the systemic bloodstream, which minimizes side effects. But if a patient comes into the emergency room with a severe acute flare-up of chronic obstructive pulmonary disease, COPD, that localized inhaler is useless.
They need the whole house heated systemically.
Yes. They require a short, powerful burst, usually a 5-day course of oral corticosteroids like prednisone, to systemically crash the inflammation and open those airways up.
Now, here's where my brain starts to struggle with the logic in our sources. Septic shock.
Oh, yes.
We've got a patient in the intensive care unit who is fighting a massive life-threatening bacterial infection. Their blood pressure is crashing. And the protocol suggests giving them an immune-suppressing drug. I mean, that sounds like throwing water on a drowning man. Why would we turn off the immune system when there's a massive infection?
It seems completely counterintuitive, doesn't it? But the key here isn't the immune suppression. It's a concept called adrenal reserve. In severe septic shock, the physiological stress is just off the charts. The patient's blood pressure bottoms out, and their organs are failing.
Right.
In some cases, the sheer magnitude of the illness outstrips the adrenal gland's physical ability to manufacture enough cortisol to keep the cardiovascular system running. The furnace simply can't keep up with the cold. The patient is running on empty.
I see.
So doctors will administer low doses of intravenous hydrocortisone, not to suppress inflammation, but to literally replace the survival hormone the body has run out of.
Okay, so you are just trying to keep the blood pressure up by replacing the baseline cortisol they are missing.
Yeah.
But the critical care data we looked at shows this isn't a universally accepted practice, right?
The practice is heavily debated. Over the last 2 decades, multiple large-scale clinical trials have yielded really conflicting results on whether this low-dose hydrocortisone strategy actually improves overall survival in septic shock.
Really? How so?
Well, some trials show it helps stabilize blood pressure faster, but others show no significant mortality benefit and perhaps even an increased risk of secondary infections. Consequently, the international guidelines remain conditional. It is a highly nuanced decision made at the bedside by the clinician.
That makes sense. It's a desperation move when the body's own factory is failing. But these drugs aren't just for immune suppression or stress response. Our sources highlight a fascinating use in obstetrics. Antenatal steroids for premature labor. We give an injection to a pregnant person, and it fundamentally changes the physical structure of the fetus's lungs.
Yeah, we use specific corticosteroids, usually betamethasone or dexamethasone for this. If a patient is at high risk of delivering prematurely, a single course of corticosteroids is administered to the mother. The drug crosses the placenta and actually accelerates the production of lung surfactant in the fetus.
And surfactant is the stuff that stops the lungs from collapsing, right?
Exactly. It's the slippery substance that keeps the tiny air sacs in the lungs, the alveoli, from collapsing when we exhale. By speeding up that lung maturation, you drastically reduce the risk of respiratory distress syndrome when the premature baby takes its first breaths.
That's incredible.
It proves that glucocorticoids do far more than just quiet immune cells. They can trigger rapid, life-saving developmental changes.
Seeing how powerful this hormone is across all these different scenarios, the logical pushback from a patient, or, you listening to this, would be, if a short 5-day course of prednisone makes my severe COPD feel amazing, why not a 2-month course? Why can't I just take this drug until I am 100% cured and then just toss the bottle?
Answering that brings us to the single most important clinical rule in our entire deep dive today, the tapering rule.
The golden rule.
Yes. If a patient takes exogenous corticosteroids, meaning synthetic hormones from a pill, an IV, or an injection, at doses above that natural 5 milligram physiological baseline for longer than roughly 2 to 3 weeks, they must be tapered off slowly. The dosage has to be gradually reduced over time. They can never, under any circumstances, be stopped cold turkey.
Going back to our thermostat analogy, this makes perfect sense. If you start taking high-dose pills every day, you are flooding the house with artificial heat. You are essentially outsourcing your cortisol factory to a plastic pill bottle.
Right.
The HPA axis, the thermostat on the wall, senses all this synthetic cortisol floating around in the blood and registers that the house is boiling. It completely shuts down. The hypothalamus stops sending CRH. The pituitary stops sending ACTH. And without that chemical signal telling them to work, the adrenal glands down in the basement don't just pause, they physically shrink. They atrophy from disuse.
Yeah, the architecture of the adrenal cortex literally wastes away. The body becomes completely biologically dependent on the pill bottle for its daily cortisol. If a patient suddenly stops taking that medication, they trigger a catastrophic twofold medical emergency.
What happens first?
First, the underlying disease they were suppressing, the crippling arthritis or the inflamed airways, can violently flare back up because the anti-inflammatory shield has been dropped. But the second problem is much more immediate and far deadlier.
The Addisonian crisis.
Yes, an acute adrenal crisis.
Right.
Because the adrenal glands have been dormant and shrinking for weeks or months, they cannot simply be flipped back on like a switch. Full structural and functional recovery of the adrenal glands can take weeks, months, or in severe cases of long-term use, up to a year.
A year?
Yeah.
No.
So stopping the pills abruptly means the body suddenly has absolutely zero cortisol to manage baseline stress or maintain blood pressure.
Without any cortisol, what is actually happening to the patient in that moment?
It is a profound, life-threatening state of shock. The cardiovascular system loses its tone, so blood pressure plummets dangerously low. The patient experiences overwhelming fatigue, severe nausea, vomiting, and acute abdominal pain.
And it messes with their salt balance, too.
Exactly. Because the synthetic drug often has some mineralocorticoid activity as well, stopping it throws the body's salt balance into chaos. The patient's sodium levels crash, and their potassium levels spike to ranges that can cause fatal heart arrhythmias. Left untreated, an adrenal crisis can kill a patient in a matter of hours.
And reading through the nursing pharmacology text, the scariest part is the illusion of health. Feeling fine while on the drug gives you absolutely zero indication of what's happening internally.
None at all.
A patient could feel fantastic, totally symptom-free, but their adrenal glands are completely dormant. You cannot trust how you feel to decide when to stop the medication.
That illusion of health is why prescribing these drugs requires such meticulous management. Short courses, typically under 2 weeks, generally don't require a taper because the adrenal factory hasn't had enough time to completely shut down and physically atrophy.
Right.
But anything beyond that 2 to 3 week window requires a carefully mapped tapering schedule. You have to slowly lower the artificial heat to coax the thermostat into turning the body's natural furnace back on.
Because the stakes are a matter of life and death, precision timing dictates everything. And here's where it gets really interesting, especially when we look at recent medical history. Let's talk about the COVID-19 pandemic, specifically the recovery trial out of the UK. This was a massive, highly publicized moment for corticosteroids.
It was huge. The recovery trial provided one of the most consequential therapeutic breakthroughs of the entire pandemic regarding the steroid dexamethasone. Researchers discovered that administering low-dose dexamethasone significantly reduced mortality, it saved lives, in hospitalized COVID-19 patients who were so sick they required supplemental oxygen or mechanical ventilation.
But the nuance in that trial data is crucial. Didn't it also show that if you gave dexamethasone to mild cases, like people early in the infection who didn't need oxygen, it offered no benefit? And the data suggested it might actually harm them.
Yes. The paradox of the recovery trial is a masterclass in understanding how immune suppression works. In severe late-stage COVID-19, the virus itself is often no longer the primary threat.
Right, it's the body's reaction.
Exactly. The danger is the body's own immune system overreacting and destroying the lung tissue, the infamous cytokine storm. Dexamethasone damped down that fatal late-stage inflammation.
Early on.
Early on in the mild phases of the disease, the virus is actively replicating. You desperately need your immune system awake, aggressive, and fighting to clear the virus. If you introduce a powerful immunosuppressant like a corticosteroid too early, you disarm the body's natural defenses, allowing the virus to replicate unchecked.
Context is everything. The benefit of the drug depends entirely on the exact phase of the disease, not just the name of the disease itself. Giving it on day 2 is dangerous, but giving it on day 10 is life-saving.
Timing and disease pathophysiology dictate the outcome entirely.
Let's clarify one more thing, because if I'm a nursing student reading a chart, I might see a patient taking ibuprofen, which is an NSAID, and another taking prednisone, a corticosteroid. Both are classed as anti-inflammatories. Both bring down swelling. How do we distinguish how these neighbors operate?
Mechanistically, they operate in completely different biological universes.
Oh.
Oh, yeah. NSAIDs, like ibuprofen or naproxen, work near the surface level of the inflammatory cascade. They act by blocking specific enzymes called COX enzymes. By inhibiting COX, they stop the body from producing prostaglandins, which are the chemicals that cause localized pain and swelling. It's a very targeted, localized blockade.
Okay, so how do corticosteroids do it?
Corticosteroids go infinitely deeper. They are lipid-soluble, meaning they pass right through the outer membrane of a cell. Once inside, they bind to specific glucocorticoid receptors in the cytoplasm, and then that entire complex travels straight into the nucleus of the cell to physically alter gene transcription.
I love visualizing it this way. NSAIDs are like putting up a physical roadblock on a street to stop traffic. Corticosteroids bypass the street entirely, walk into City Hall, sit down at the mayor's desk, and completely rewrite the city's zoning laws.
That's a perfect way to look at it. By altering gene transcription in the nucleus, corticosteroids are literally commanding the cell's DNA to stop manufacturing inflammatory proteins while simultaneously turning on the genes that produce powerful anti-inflammatory proteins.
Wow.
It is a profound systemic cellular override. It dictates cellular behavior from the genetic code upward.
Which brings us to a huge misconception that we really need to stamp out before we wrap up. We've talked about how powerful the cellular override is. Does a corticosteroid actually cure an autoimmune disease?
No, it does not. And it is vital for clinicians to communicate this clearly to patients. Corticosteroids do not cure the underlying pathology of diseases like rheumatoid arthritis, lupus, or severe asthma.
They just mask it.
They merely suppress the symptomatic expression of the disease. They hold the monster in a cage. If you taper off the steroid without introducing another medication that actually modifies the disease process, the monster's still there and the symptoms will return.
So to bring all of our sources together for you listening, we've covered a massive amount of ground today. We learned that these synthetic marvels don't invent a new biological function. They hijack, amplify, and prolong the stress response your adrenal cortex already manages.
Right.
We saw their origin in the desperate bench chemistry of the 1940s. We explored their staggering versatility, from acting as a bridge in arthritis to rescuing failing blood pressure and septic shock to rapidly maturing fetal lungs. And we hammered home the absolute non-negotiable necessity of the tapering rule to avoid a fatal adrenal crisis.
And the reason this information is so critical, whether you are a medical professional managing a ward or just a curious learner, is that corticosteroids remain one of the most widely prescribed drug classes on the planet.
They're everywhere.
From treating eczema and severe allergies, to preventing organ transplant rejection, to managing viral pneumonia, their footprint in medicine is inescapable. But that power requires vigilance. Managing a patient on long-term steroids means meticulously monitoring blood glucose because these drugs spike sugar levels.
Right, diabetes risk.
It means protecting bone health to prevent osteoporosis. It means looking out for those Cushingoid physical changes, the redistribution of fat to the face and the center of the body. Ensuring patient safety with corticosteroids is one of the highest stakes responsibilities in everyday clinical practice.
So what does this all mean? It means we are wielding a double-edged sword that interacts intimately with our most ancient biological rhythms. And I want to leave you with one final thought to mull over, something that builds on exactly how these drugs work. We learned earlier that corticosteroids operate by going deep into the cell's nucleus and altering gene transcription. We also learned that our body's natural HPA axis, our internal thermostat, has a strict circadian rhythm, peaking our natural cortisol early in the morning and dropping it at night.
Yes, our natural biological responses are heavily dictated by the clock.
It makes you wonder, if our natural hormones are tied so strictly to the time of day, could the exact hour you swallow a synthetic corticosteroid pill fundamentally alter which immune genes are turned on or off?
That is a great question.
By choosing to fight against or align with that natural morning peak, can a drug's effectiveness, or even its side effects, be manipulated simply by looking at a watch before taking the dose?
The intersection of circadian rhythms and drug timing is called chronopharmacology, and it is honestly one of the most fascinating frontiers in medicine today. It is a perfect question to keep exploring.
Think back to that 29-year-old woman in 1948, walking out of the hospital to go shopping. It looked like magic.
Yeah.
But as we now know, in medicine, there is no magic, only incredibly powerful mechanisms that demand our deepest respect, careful timing, and relentless understanding. Thank you for joining us on this deep dive into corticosteroids.
Keep questioning the mechanisms, and goodbye until next time.
You know, usually when we talk about medical diagnosis, there's this expectation of precision.
Right, like a clear-cut answer.
Exactly. I mean, you break your arm, the x-ray shows a jagged white line, and the clinical path is just binary. It's broken or it's not broken.
Yeah, there's no real debate there.
But you step into an obstetric emergency, and that x-ray machine is, well, it's essentially useless. You're suddenly operating in these diagnostic muddy waters, where the clinical picture is just shifting by the second.
It's incredibly volatile.
Yeah, and the stakes literally could not be higher, especially considering that roughly a quarter of all maternal deaths globally are tied to one very specific complication: postpartum hemorrhage, or, PPH.
It is arguably the most urgent diagnostic puzzle in modern obstetrics. And what makes it so critical for us to analyze in this deep dive is that mastering PPH, it goes way beyond just memorizing vascular anatomy.
Right, it's bigger than that.
Oh, absolutely. We are really looking at a masterclass in how clinical systems and definitions and simple cognitive checklists can actually intercept human error in the middle of a totally chaotic high adrenaline crisis.
Okay, let's unpack this, because our mission today for you, the listener, is to really demystify how modern medicine tackles this ancient threat. We're going to explore the actual physiological causes of why a patient hemorrhages after birth, and we'll decode this framework known as the 4 T's.
Which is a brilliant life-saving checklist.
Totally. But we also need to examine the controversies in the sources, like the fierce debates over how to even measure blood loss in real time, and why this entire standard of care is actively evolving right now.
Yeah, and to really grasp that evolution, you have to look at how the target itself has moved over time. Because before a clinical team can, fix a hemorrhage, the system has to agree on what actually qualifies as one.
Which sounds like it should be obvious, but it's really not.
No, not at all. For decades, the traditional baseline, which the World Health Organization still references, by the way, defined PPH strictly by volume.
Okay, so just a strict number.
Right. It was 500 milliliters for a vaginal delivery and 1,000 milliliters for a C-section, all within 24 hours.
Which, I mean, on the surface, that feels like that clean binary X-ray we mentioned. But the sources highlight a pretty major pivot that happened in 2017.
Yes, a massive shift.
Right, because the American College of Obstetricians and Gynecologists, ACOG, they basically threw out those separate thresholds. They bumped the vaginal baseline up to 1,000 milliliters, regardless of how the baby was delivered. And more importantly, they layered on this clinical criterion:
If we connect this to the bigger picture, the problem with a fixed numeric threshold is that it completely ignores the actual physiological reality of the specific patient in the bed.
Right, because everybody's different.
Exactly. By requiring either 1,000 milliliters of loss or blood loss accompanied by signs of hypovolemia like a rapid heart rate or low blood pressure, ACOG, shifted the focus from just the fluid volume to the patient's actual hemodynamics.
Okay, I think I get it. So a small-framed woman, for example, she might have a severely constricted vascular space if she has preeclampsia, right?
Precisely. She might start crashing at just 700 milliliters.
But then another patient who maybe has robust pregnancy-induced hypervolemia, like she has extra blood volume just from being pregnant, she could potentially lose 1,200 milliliters and still have perfectly stable vital signs.
Spot on. So a medical field that's usually defined by extreme precision realized that a static number just wasn't capturing the real clinical danger.
But looking at the measurement history in these sources, the actual methodology for tracking that blood volume is just staggering to me.
It's definitely a contentious topic.
Wait, so for decades, doctors and nurses were just visually eyeballing how much blood was lost on pads and sheets, just looking at it and guessing.
Yeah. Visual estimation was the undisputed standard of care for generations. And it was fundamentally flawed.
I mean, it's like trying to guess the weight of a packed suitcase just by looking at it from across the room. The human eye might process the dimensions, but you cannot possibly account for the density.
That is a perfect analogy. And when you factor in that you're dealing with blood mixing with amniotic fluid and soaking into heavy hospital fabrics, visual estimation isn't just difficult, it's basically mathematically impossible.
And the data backs that up, right?
Entirely. Multiple systematic reviews show that visual estimation underestimates true blood loss by a third to a half.
Oh, wow. A half.
Yeah, and the psychological component is what makes it so terrifying. Paradoxically, the larger the hemorrhage, the worse the human brain is at estimating it.
Wait, really? So when it's worse, we are worse at seeing how bad it is?
Exactly. When a patient is losing massive, catastrophic volumes of blood, the clinical team's visual estimate becomes increasingly conservative. The human brain just sort of goes into denial.
That cognitive blind spot that just totally explains the massive push in the last decade toward QBL, quantitative blood loss, meaning they literally have to weigh the suitcase now.
Right, you have to put the blood-soaked materials on a scale. QBL requires the team to weigh the lap pads, the under-buttocks drapes, subtract the known dry weights of those textiles, and then meticulously measure the fluid in suction canisters.
Which ACOG and AATHON now demand as standard practice, but implementing that on the hospital floor must have been incredibly disruptive.
Oh, it caused a massive uproar.
I can imagine. I mean, stopping to calibrate a scale and weigh bloody gauze while a patient is crashing. It feels totally counterintuitive to the urgency of an emergency.
It really was met with tremendous resistance. It's a hugely disruptive workflow when every single second counts. But the patient safety movement pushed it through because the alternative, just relying on a flawed visual estimate, was leading to delayed recognition.
And delayed recognition costs lives.
Exactly. That's exactly what drives the mortality rate.
So if visual estimates were just systematically failing for decades, it completely contextualizes why the medical field had to restructure its entire behavioral response.
Which brings us to the real core of this deep dive, the 4 Ts.
Yeah, and the architecture of the 4 Ts is fascinating, mostly because it was born out of a very dark reality.
What do you mean?
Well, in the late 90s and 2000s, state-level maternal mortality review committees, particularly the California Maternal Quality Care Collaborative, the CMQCC, they began aggressively auditing these deaths.
Okay.
And the hard data they published revealed that a significant portion of hemorrhage deaths were not caused by untreatable exotic diseases. They were preventable.
Preventable. So why were they dying?
Patients were dying because the clinical response was disorganized, people were panicking, or they were waiting for an attending physician to arrive to sort of divine the source of the bleeding.
They essentially took the ABCs of trauma resuscitation, airway, breathing, circulation, and they just built a trauma bay checklist for obstetrics. That is the exact mechanism of action, yes. Through programs like the ASO course and those early CMQCC toolkits around 2009 and 2010, the 4 Ts were formalized.
Because it bypasses the cognitive overload.
Exactly. During a crash, clinicians can freeze or develop tunnel vision. The 4 Ts turns this open-ended panicked mystery of why is she still bleeding into a lightning-fast differential diagnosis.
Let's break down the physiology behind that differential then, starting with the overwhelming majority of cases. The first T is tone. specifically uterodenectomy.
Right, which accounts for roughly 70 to 80% of all PPH cases.
With a failure rate that high, why isn't the standard of care to just intervene surgically right away, instead of relying on a bedside checklist?
Because the natural physiological mechanism of childbirth is incredibly robust when it works, and invasive surgery carries severe morbidity risks.
Okay, fair enough.
To understand adeny, we have to look at how the body naturally stops bleeding after the placenta detaches. Most people assume it's about clotting, but it's not driven by the coagulation cascade. It is entirely mechanical.
The spiral arteries.
Yes. The uterine muscle, the myometrium, is this dense, interlacing network of fibers. When the placenta separates, those torn spiral arteries are just exposed and bleeding. The only way to stop that high-pressure flow is for the uterus to contract violently, clamping down like a fist to physically strangulate those blood vessels.
So if the muscle stays soft or boggy, those arteries just bleed freely into the cavity.
Exactly.
Here's where it gets really interesting. The sources mention that carrying twins or having excess amniotic fluid polyhydramnios are major risk factors for this.
Right, because of the physical stretch.
Yeah, if you think about the interlacing fibers of the uterus, like a rubber band or maybe a woven Chinese finger trap, normally the harder it pulls together, the tighter it grips the vessels.
Right.
But if that trap is distended way beyond its structural limit by twins, the muscle fibers stretch out. They get fatigued and they lose their snapback force.
That is an excellent way to visualize the structural failure. Prolonged labor induces a very similar kind of muscle fatigue. And that mechanical failure is what we call tone.
Okay, so let's create a clinical dilemma for you. The nurse pushes on the patient's abdomen. The uterus is clamped down tight as a rock. The tone is perfect, but the blood is still pooling. The mechanical fix worked, but the patient is still bleeding out.
That immediately forces the clinician to move down the checklist and look for the second T trauma.
Which accounts for about 20% of cases.
Yes. When tone is resolved, the bleeding is almost certainly a structural injury somewhere along the birth canal. We are looking for lacerations, concealed hematomas, or, in catastrophic cases, uterine immersion.
That's where the uterus actually turns inside out, right? Often from excessive pulling on the umbilical cord before the placenta has fully detached.
Exactly. It's often an iatrogenic injury, meaning it's caused by the clinical management itself.
This specific T trauma was actually central to Serena Williams' highly publicized postpartum crisis back in 2017.
Oh, yes. That case was a major cultural touchstone.
Yeah, she had a hematoma at her C-section site, combined with a pulmonary embolism. Well, it wasn't textbook adeny. It falls squarely into trauma. And it catalyzed this huge national conversation about maternal morbidity and specifically racial disparities in having your symptoms actually believed by medical staff.
Her experience forced a really critical structural review within health systems. It highlighted that even with all these checklists in place, the speed at which a patient's self-reported symptoms are evaluated is still a variable that hospitals have to rigorously monitor.
But going back to the bedside assessment of trauma and tone, there's a massive misconception here. I want to ask you about this. If a nurse feels the patient's stomach and the uterus is firm, they are safe, right?
Absolutely not, and that assumption has tragically cost lives.
Wait, really?
Yes, a firm fundus is not a free pass. You could have a patient with a perfectly contracted, rock-hard uterus, but if they have a severe undiagnosed cervical laceration, which is trauma, they will continue to hemorrhage briskly. Yeah, the firm uterus only clears the very first box on the checklist. The clinician is still obligated to visually inspect the entire anatomical tract.
Which brings us to the third scenario. The uterus is firm, the clinician does the visual inspection, and there are no lacerations, no structural trauma at all. But they are still leaking blood. What else could possibly be leaking?
That points directly to the third T tissue.
Retained placenta.
Yes, retained placental fragments or blood clots, which make up about 10% of these emergencies.
But if even a tiny fragment, like a millimeter of the placenta, is left behind, how does that cause a massive hemorrhage?
Because it disrupts that Chinese finger trap mechanism you mentioned earlier.
Okay, how so?
The uterus cannot contract uniformly if there is a foreign mass occupying space inside it. The muscle fibers around that retained tissue stay stretched out, which leaves a localized area of spiral arteries completely uncompressed and bleeding.
Got it. And the most aggressive pathology in this category from the sources is the placenta accreta spectrum, right?
Yes, where the placenta essentially invades the uterine wall.
And this was my biggest aha moment from the reading. The data is chilling. The massive rise in placenta accreta tracks almost exactly with the rising global C-section rate.
The pathophysiology behind that link is entirely rooted in how scar tissue alters the uterus.
Right, because a prior C-section leaves a physical scar on the uterine wall. And when the patient gets pregnant again, the new placenta often implants over that compromised scar tissue.
Exactly. And in an attempt to find adequate blood supply, the placental cells dig deeper. They invade the muscle wall because the normal physiological barrier was structurally damaged by the previous surgery.
So a surgery that was designed to make childbirth safer today is essentially planting the seed for a severe hemorrhage risk years down the line.
It's a downstream cascade of interventions,
Yeah,
yes.
that is just wild to think about. Okay, so that leaves the final, and I think most complex, T thrombin.
Thrombin is very rare, about 1% of cases, but it is disproportionately lethal. This is coagulopathy.
So the plumbing is fine, the structure is fine, the cavity is clear, but the blood simply won't clot.
Right. Conditions like severe preeclampsia or an amniotic fluid embolism can trigger DIC, disseminated intravascular coagulation. The body forms microclots everywhere, which rapidly consumes the entire reserve of clotting factors.
What's fascinating here is that thrombin is the only category where mechanical fixes are completely useless. Right?
Exactly. You cannot massage a clotting disorder. If you put in a uterine balloon, it won't help. You must replace the blood products via a massive transfusion protocol. You have to rebuild their capacity to clot.
Okay, so knowing the 4 Ts tells clinicians why it's happening, but how do they proactively stop it? This brings us to the fierce debates over intervention, like active versus expectant management.
Right. Intuition suggests that for a low-risk patient, you just practice expectant management, let nature take its course, and withhold drugs.
But the sources say that's totally wrong now.
It is. Large trials prove that a massive portion of atony cases happen to women with absolutely zero identifiable risk factors.
So you can't predict it.
You can't, which is why active management is the standard. Giving a uterotonic drug like oxytocin to every single woman immediately after birth. It chemically forces the uterus to contract.
And when that fails, we look at the woman trial from 2017, tested on 20,000 women across 21 countries. It proved that tranexamic acid, or TXA, drastically reduced bleeding deaths.
Yes. It's a cheap, decades-old generic drug that stops the body from breaking down its own early clots.
But there's a dramatic catch here. TXA only works if given within 3 hours of delivery, right?
Timing is literally everything. If given after 3 hours, the patient's coagulopathy has shifted phases, and TXA offers absolutely no survival benefit. In fact, it could cause dangerous blood clots.
Wow. Okay, as we wrap up this deep dive, I want to address you, the listener, directly. Because there is one last dangerous misconception about timelines that you need to know. A lot of people assume the danger window closes when the mother leaves the delivery room.
Oh, that is a huge mistake. We have to talk about secondary PPH.
Right, the 12-week danger zone.
Exactly. A patient could be home weeks into recovery and suddenly experience a massive hemorrhage, often from a tiny retained placental fragment that causes an infection. It can strike completely out of nowhere.
So what does this all mean? When you look at everything, the 4 Ts essentially compress a life or death mystery into a seconds-long bedside checklist. It empowers nurses and midwives to act instantly without waiting for a specialist.
It's the ultimate example of clinical systems overcoming human error.
It really is. But I want to leave you with a final thought to mull over. Since rising C-section rates globally are quietly driving up the rates of placenta accreta, are we currently manufacturing a future epidemiological crisis? In our modern quest to medically manage childbirth for immediate safety today, are we unknowingly engineering the very hemorrhage crises that the next generation of nurses and doctors will have to fight? Definitely something to think about. It's 2 in the morning, right? And your toddler wakes up, but instead of a normal cry, they make this harsh, just terrifying sound.
Oh, yeah, like a barking seal echoing down the hallway.
Exactly. And your immediate primal instinct as a parent, or, even as a newly minted doctor, is to just look down their throat to see what's blocking their air.
Which makes total sense. I mean, you want to see the problem.
Right. But depending on what is actually causing that sound, the sources say simply opening their mouth and looking inside could trigger a reaction that, stops their breathing entirely.
Yeah, it literally stops it. That split-second decision in the dark is the harsh reality of pediatric emergency medicine.
It's just terrifying to even think about.
It is, because a child struggling to breathe isn't just a stressful scenario. It is a highly precarious physics problem. And for centuries, we just didn't fully understand the physics or, the biology of what was happening inside those tiny airways.
So today, our mission is to decode 2 classic, really nerve-wracking airway emergencies: croup and epiglottitis.
Two very distinct, very dangerous conditions.
Right. And we are pulling from clinical nursing guidelines, pediatric triage protocols, and some historical medical texts for this deep dive to figure out basically how to tell these two apart.
And why getting it wrong can be catastrophic.
Exactly. We're going to explore how one of these diseases forces you to just abandon your most basic medical instincts, and then how the other was practically erased from pediatric wards by a single scientific breakthrough.
It really is a fascinating journey.
It is. Ultimately, this deep dive is going to completely change how you view a simple sore throat. So, where do we start?
Well, to understand the danger, you really have to visualize the anatomy first. Both of these conditions share a fundamental vulnerability, which is the sheer physics of a child's airway.
Because it's so small, right?
Right. A smaller tube naturally moves less air, but the relationship is governed by Poiseuille's law for laminar flow.
Okay, Poiseuille's law. What does that actually mean for the kid?
It means airway resistance doesn't just increase proportionally as a tube gets smaller. It rises with the fourth power of the radius.
Wait, the fourth power. So if the airway radius gets just a tiny bit smaller, the resistance doesn't go up a little, it just skyrockets.
Exactly. It skyrockets. If you cut the radius of a breathing tube in half, the resistance to airflow doesn't double. It increases 16-fold.
Oh, wow. 16 times harder to breathe.
Yeah. Now apply that math to a toddler. Their baseline airway is roughly the width of a pencil.
Just a pencil. That's so tiny to begin with.
Right. So a mere 1 millimeter reduction from inflammatory swelling causes a catastrophic drop in airflow. I mean, an adult wouldn't even register a single millimeter of swelling in their throat.
They just think, oh, I have a slightly scratchy throat.
Exactly.
Yeah.
But for an infant, it brings them to the brink of total obstruction.
I was picturing it kind of like city infrastructure while reading the sources. Like, if you have a massive underground water main, a 1 millimeter buildup of rust on the inside isn't going to change the water pressure for the neighborhood at all.
No, not even slightly.
But if you have that exact same 1 millimeter buildup of rust inside a tiny garden hose, the water just stops flowing completely.
That's a perfect analogy. The scale of the anatomy completely dictates the danger here.
So since both diseases deal with this, garden hose physics problem, the difference must come down to where that 1 millimeter of swelling actually is.
Precisely. Location changes absolutely everything. So croup, which is formally called laryngotracheobronchitis.
There's a mouthful.
It is, yeah. But croup is a viral inflammation, and the swelling happens just below the vocal cords, so in the subglottic space.
Okay, below the cord.
Right. Now, epiglottitis is anatomically distinct. The texts sometimes call it supraglottitis because the swelling sits directly above the airway opening.
Ah, okay, so above versus below.
Yes. And historically, epiglottitis was almost always a bacterial infection targeting the epiglottis, which is that tiny leaf-shaped flap of cartilage that, folds down to protect your windpipe when you swallow.
So below the cords for croup, above the cords for epiglottitis, that tiny anatomical shift, like literally just a few millimeters of difference in the throat, creates wildly different sounds when a child actually arrives in an emergency room.
Right, it really does. Croup has that distinct auditory signature we mentioned at the start.
The harsh, barking cough. The sources universally compare it to a barking seal.
Yeah, the seal bark is classic. But the real hallmark sound of croup is stridor.
Stridor, that's the high-pitched one, right?
Right. It's a high-pitched crowing noise that you hear when the child breathes in. You are literally hearing turbulent airflow violently struggling to pull through that narrowed subglottic passage.
It sounds exhausting for the kid.
It is. And fun fact, the word croup actually derives from an old Scottish dialect verb, roop.
Roop. What does that mean?
It means to shout or cry out hoarsely.
Oh, wow. So it's a disease literally named after the forceful sound it produces. But epiglottitis doesn't have that loud, chaotic bark, does it?
No, it doesn't. And honestly, it is often eerily quiet, which is much, much more alarming to clinicians.
Quiet is bad.
Very bad. Clinicians are taught to look for the 3Ds when it comes to epiglottitis: drooling, dysphagia, and distress.
Dysphagia, meaning difficulty swallowing.
Exactly. The child isn't barking because they are dedicating every single ounce of their energy just to pull oxygen past that swollen flap of cartilage.
And the drooling happens because the airway is so swollen and it hurts so much to swallow that they can't even clear their own saliva.
Right. They just let it spill out.
While reading the clinical sources for this deep dive, I noticed a very specific physical posture these kids adopt too. It's called the tripod position.
Oh, yes, the tripod position is a huge red flag.
Yeah, they sit up, lean forward, put their hands on their knees, jut their chin out, and just open their mouth. And I was thinking, no one teaches a 2-year-old to do this.
No, it's entirely instinctive.
Wow.
It is an unconscious biological drive to manually align their internal anatomy. They are trying to force open whatever tiny airway diameter they have left.
It's like a primal survival reflex.
Exactly. And recognizing that tripod posture brings us to really a foundational rule in nursing and medical education.
A golden rule.
Yes, if you see a child in that posture, drooling, visibly working for air, you must never attempt to visualize the throat with a tongue depressor.
See, I had to read that line in the guidelines twice. Because if someone says their throat hurts and they can't breathe, the most universal medical instinct is to say, open your mouth, let me look.
Of course it is.
But the guidelines treat a tongue depressor like it's a loaded weapon. How does just looking at a throat kill a patient?
It comes down to the evolutionary purpose of the larynx. I mean, its primary job isn't actually speech. It's to act as a security door, preventing food or water from getting into the lungs.
Okay, so a biological bouncer.
Exactly. And when the epiglottis is massively infected and inflamed, that biological tripwire is hypersensitive.
So any touch sets it off.
Any mechanical stimulation, just the physical touch of a wooden stick, or even the child panicking because you're forcing them onto their back to look in their mouth, it makes the brain think it's choking.
Oh, I see.
So it triggers a laryngospasm. The muscles violently slam the security door shut, and because the airway is already critically narrowed by the disease, that spasm just seals it off entirely.
Wow.
Yeah, in seconds, a child who is struggling to breathe becomes a child who cannot breathe at all.
So you literally have a patient suffocating in front of you, and your medical protocol is to touch absolutely nothing.
Nothing. You keep the child calm. You let them sit right in their parent's lap in whatever posture they choose.
No IVs or anything.
No 5E lines, no blood draws, absolutely no laying them flat. Simultaneously, you are urgently calling for anesthesia and an ear, nose, and throat specialist to secure the airway in the operating room.
Why the operating room specifically?
Because they need an environment where they have specialized surgical tools to bypass the throat entirely if that airway completely closes. They might need to do an emergency tracheotomy.
It's wild that we know to do this now. I mean, the precision we have today, knowing exactly when to intervene and when to keep our hands in our pockets, it's built on a long foundation of historical trial and error.
Oh, absolutely. A lot of tragic error, unfortunately.
Yeah. I mean, if we go back to 1765 in the texts, Francis Home, a physician in Edinburgh, published an inquiry trying to define croup. But doctors back then were basically treating all childhood throat illnesses as one giant, undifferentiated soup of respiratory deaths.
Right. And the devastating failure of that era was lumping viral croup together with diphtheria.
Diphtheria, which is totally a different.
Completely different pathogen. Diphtheria is a highly lethal bacterium that creates this thick, grayish, leathery pseudomembrane in the throat.
A membrane that physically grows across the airway.
Yes. It physically grows and literally chokes the patient from the inside.
So a bacterial membrane essentially acting as a cork.
Precisely. And because physicians couldn't easily differentiate the two, they treated the viral, usually self-limiting croup with the exact same aggressive panic as diphtheria.
Which meant what, practically?
It meant they subjected children with viral croup to futile, agonizing remedies. Leeching, harsh emetics to induce vomiting, even early tracheotomies in unsterile conditions.
All because they believed a fatal membrane was forming when it wasn't.
Right. It wasn't until the 1880s, when the diphtheria bacterium was actually isolated under a microscope, that pediatricians could confidently separate the viral illness we call croup from the bacterial nightmare of diphtheria.
And untangling those diseases allowed doctors to finally figure out what actually works for croup.
Yes, finally.
And the modern treatment involves a massive contradiction to typical medical advice, which I found fascinating. Usually, if you have a sick child with a fever and a terrible cough, the absolute last thing you do is take them out into the freezing winter air.
Right, you want to keep them warm.
Yeah. But parents historically would bundle up their barking toddler, run out to the car on a cold November night, and by the time they actually reached the ER triage desk, the kid was breathing easier.
Because the cold air wasn't just a placebo, it acts on the fundamental biology of the subglottic tissue.
How so?
The cold night air triggers reflex vasoconstriction. So, the blood vessels in the inflamed mucosa rapidly shrank in response to the temperature drop.
And shrinking blood vessels means less swelling.
Exactly. When the blood vessels shrink, the physical swelling in the tissue goes down, which pulls a child away from that catastrophic 16-fold increase in airway resistance we talked about.
That's incredible. So it's one of the rare instances where stepping outside into the cold is a scientifically sound first aid measure.
It really is. It works.
But if cold air actively constricts the blood vessels, what about the other classic home remedy? The cool mist humidifier. I mean, it feels like every nursery has one of those elephant-shaped humidifiers pumping mist into the room.
Oh, the cool mist humidifiers. They've reached a near universal folk status. But they're a perfect example of a treatment persisting simply because it feels intuitively helpful.
Wait, they don't work.
When subjected to controlled clinical trials, the evidence for mist therapy altering the course of croup is remarkably weak.
Really? So people are just filling their rooms with steam for no reason?
Well, it might soothe the dry throat, sure, but it does not effectively shrink subglottic edema. The swelling stays the same.
Okay, so if mist doesn't shrink the swelling, what does? I mean, we obviously can't just leave a toddler out in the winter air all night long.
No, definitely not. The paradigm shifted significantly following a 2004 study published in the New England Journal of Medicine by Bjornson and colleagues.
What did they find?
They demonstrated that children with even mild croup benefited from a single dose of oral dexamethasone.
Dexamethasone, that's a corticosteroid, right? To forcefully shut down the inflammation?
Exactly, and just one dose. It drastically reduced return visits to the emergency room and severely shortened the duration of symptoms.
Just one dose did all that.
Just one. The data was so conclusive that dexamethasone became the absolute standard of care across the board. You no longer just tell parents to take the kid home and wait it out.
And what if it's really bad? Like a severe case?
For moderate to severe cases, clinicians use the Wesley Croup score to assess the patient, and they might add nebulized racemic epinephrine.
Epinephrine. That's essentially adrenaline, right?
It is, yeah. Inhaling it acts almost like a chemical version of the freezing night air. It causes rapid, intense vasoconstriction of the airway tissue.
Okay, so it shrinks everything down quickly.
Very quickly. It buys hours of immediate improvement. Though the child does require careful observation because, well, the swelling can rebound once the medication wears off.
So science-isolated croup figured out the cold air mechanics and standardized the steroid treatment. But epiglottitis didn't just get a better treatment protocol, did it? The entire disease was practically erased from childhood.
It was. The modern history of epiglottitis is honestly one of the most stunning victories in public health.
How bad was it before?
Before the mid-1980s, epiglottitis was a constant, terrifying staple of pediatric emergency training. The primary culprit was a specific bacterium, Haemophilus influenza type B.
Commonly known as Hib.
Yes, Hib.
And the sources detail how this specific bacteria wasn't just causing airway swelling either. It was invading the bloodstream and causing devastating meningitis in young children.
It was awful. It was a leading cause of acquired mental disability and pediatric mortality. But then, in 1987, the Hib conjugate vaccine was licensed and added to the routine childhood immunization schedule in the U.S.
And what happened?
What followed was just a breathtaking natural experiment. Within a decade, invasive Hib disease, including the classic pediatric epiglottitis, plummeted by over 99% in vaccinated populations.
A 99% drop. I mean, we aren't talking about a gradual decline over a century due to, like, better hand washing or sanitation.
No, not at all.
A common, highly lethal disease basically fell off a cliff the exact moment a targeted vaccine was introduced.
The pediatric wards emptied of these specific cases almost overnight. The clinical texts frame this as an irrefutable case study of vaccine success.
It's an amazing medical triumph. But here's where it gets really interesting, based on the texts. Because the incredible efficacy of the Hib vaccine created a profound, totally unexpected shift in demographics.
Yes, it did. Epiglottitis didn't vanish from the planet entirely. It just shifted populations.
The adults, right?
Exactly.
Yeah.
Today, epiglottitis is proportionally more common in adults than it is in children.
I guess because adults' airways are so much wider, the swelling isn't as immediately catastrophic, but they are still actually getting the infection.
They are getting it, yes. But it is usually driven by entirely different organisms now, like Streptococcus species. And the onset in adults is often slower, more insidious.
Which creates a new problem.
A huge problem. This demographic flip creates a massive cognitive trap in modern medicine.
How so?
Well, you have a whole generation of pediatric trainees who might complete their entire residency without ever seeing a true case of Hib epiglottitis. Concurrently, you have adult ER physicians who might evaluate a 40-year-old patient presenting with a fever, severe sore throat, and difficulty swallowing.
And they don't even think of epiglottitis.
Exactly. The doctor might completely dismiss the possibility because medical folklore has firmly anchored it in their mind as a childhood disease.
That is a very dangerous blind spot.
Mhm.
If a doctor assumes a disease only exists in textbooks or pediatric wards, they just won't look for it in the adult sitting right in front of them.
Which delays treatment and increases risk.
That makes me wonder about the flip side of that triage coin, too.
Yeah.
Like, if you are an ER nurse or doctor today, and a child comes in with that high-pitched stridor, is there a risk of just anchoring on croup?
Oh, absolutely.
Like, if you hear the seal bark, do you just hand them a dose of dexamethasone and assume they're fine?
Anchoring on croup is one of the most perilous mistakes a clinician can make, actually. There is a very pervasive misconception that stridor in a child equates exclusively to croup.
But it doesn't.
No. Stridor is just a physical symptom of turbulent air passing through a narrowed tube. It is a sign of obstruction.
Right, the physics problem again.
Exactly. That obstruction could be viral croup, but it could also be a swallowed coin lodged in the upper airway, a deep retropharyngeal abscess, or, most alarmingly, bacterial tracheitis.
Bacterial tracheitis. The medical texts refer to this as the great mimicker.
It is the ultimate diagnostic camellia. It occupies this really dangerous gray zone between viral croup and bacterial epiglottitis.
Why is it so tricky to spot?
Because initially, bacterial tracheitis presents exactly like a severe case of croup. The child has the bark, the stridor, the struggle for air. Everything looks like croup.
Okay, so you treat it like croup.
Right. You administer the racemic epinephrine, you give the dexamethasone, but then the trajectory diverges. The child continues to deteriorate.
I noticed the sources use terms like toxic appearing for these kids.
Yes, they aren't just dealing with the swollen throat anymore. They are dealing with a severe systemic infection.
So they look much sicker.
Much sicker. They will spike high fevers. They might exhibit cyanosis, meaning they are actually turning blue around the lips from a lack of oxygen. You'll see severe retractions, which is when the child is pulling in their chest muscles between their ribs just to forcefully vacuum air into their lungs.
So the steroids aren't working because it's not just regular swelling.
Correct. The obstruction in tracheitis isn't just inflamed tissue. The trachea becomes physically blocked by thick, purulent secretions, so heavy, pus-filled mucus that steroids simply cannot dissolve.
Wow. So if you hit that clinical wall where the standard croup treatments are just failing, you have to immediately widen your differential diagnosis. You can't just keep giving them epinephrine and hoping the physics improve.
You can't. And historically, before we had advanced imaging and rapid lab tests, X-rays were a crucial tool for cutting through this diagnostic fog, assuming the patient was even stable enough to be imaged.
What were they looking for on the X-rays?
Clinicians learned to read specific shadows on lateral neck X-rays. For croup, they look for the steeple sign.
The steeple sign, like a church.
Exactly like a church steeple. The narrowing of the subglottic space physically tapers on the film, looking exactly like a pointed tip.
Okay, and for epiglottitis?
They look for the thumbprint sign.
Thumbprint.
Yeah, the epiglottis is so massively engorged and rounded that the shadow on the X-ray looks like someone firmly pressed their thumb right into the middle of the airway.
The steeple and the thumbprint. I mean, those radiographic markers provide such clear visual anchors.
They do, but even with imaging, bacterial tracheitis confounds the picture.
Really? Even with X-rays?
Yes. An X-ray might show a steeple sign, misleading you into thinking it's just simple croup, while a lethal bacterial infection is brewing in the trachea.
So you can't just rely on the picture?
Never. The physical presentation of the patient must always override the assumptions of the initial triage or the X-ray.
It is such a dynamic, high-stakes environment. You really cannot practice emergency pediatrics by following a flowchart blindfolded. You have to treat the physics in front of you.
Absolutely.
Well, we've covered a lot of ground today. We started this deep dive exploring the unforgiving math of a child's tiny airway, where a single millimeter of swelling dictates whether oxygen reaches the lungs.
And we uncovered the evolutionary tripwire behind the strict do not look rule of epiglottitis, where a single wooden tongue depressor can trigger a fatal laryngospasm.
Right. We also mapped the historical struggle. I mean, differentiating viral croup from the suffocating pseudomembrane of diphtheria literally changed the trajectory of pediatric care.
It allowed us to finally abandon invasive, futile treatments in favor of scientifically validated interventions, like the cold air effect and targeted
And
corticosteroids.
we explored the absolute undisputed triumph of the Hib conjugate vaccine. It didn't just mitigate a disease, it virtually eliminated a terrifying pediatric airway emergency, proving that human intervention can fundamentally alter the landscape of infectious disease.
The practical application of this knowledge is immense, rapidly distinguishing a manageable barking cough from a true life-threatening airway obstruction is a vital skill for anyone involved in pediatric care.
Absolutely.
But beyond the clinical mechanics, epiglottitis serves as a definitive case study. As the texts point out, in an era grappling with resurgent vaccine hesitancy, this is not theoretical data. We are talking about a deadly pathogen that used to regularly fill hospital wards and is now a clinical rarity purely because of widespread immunization.
Which leaves a lingering question for you to consider long after this deep dive ends. We saw how the success of the Hib vaccine essentially evicted epiglottitis from the pediatric population. It forced the disease profile to shift into adults, now driven by entirely different bacterial organisms like Streptococcus.
A total ecological shift.
Right. So as we continue to develop new vaccines and alter the baseline immunity of global populations, what other supposedly classic childhood diseases are quietly mutating or shifting right now?
It's a sobering thought.
It is. What other pathogens are finding new footholds in adult populations simply because we have permanently disrupted their original pediatric ecology? The human body and the microbes that attack it are always adapting.
And the diagnostic waters are never perfectly clear. We have to adapt right along with them.
Picture this. An 84-year-old woman goes into the hospital for just a routine hip surgery. She's totally sharp. She lives independently and does the Sunday crossword every single week.
Right, a very familiar baseline for a lot of patients.
Exactly. But then 2 days after her surgery, she completely doesn't know her own name. She's frantically picking at her bed sheets and she's terrified, like insisting she's trapped in a strange house.
And her family is standing right there at the foot of the bed, absolutely panicking.
Yeah. Their immediate thought is always, this is it, we lost her, it's Alzheimer's. But guess the question for today's deep dive is, what if it's not?
What if her brain isn't experiencing this permanent, irreversible decline, but it's actually just in the middle of a totally reversible acute metabolic crash?
Welcome to today's deep dive. We are tackling a massive, incredibly common mix-up in medicine, which is untangling delirium from dementia.
Yeah, and that panic from the family in your example, healthcare providers see that constantly. It stems from this really dangerous habit we have of taking two completely different neurological conditions and, well, just throwing them into the same bucket called confusion.
Which is such a disservice to the patient.
Yeah.
I mean, mixing these two up isn't just some vocabulary error. It leads to massive diagnostic blunders that cause real harm.
It absolutely does every single day.
So knowing the difference here is literally a life-saving skill. Whether you are a nursing student doing rounds or a caregiver looking after an aging parent, or you just want to understand how the brain works under stress, this is incredibly high yield for you.
It really is. And to start, we should probably lay down some foundational mechanics, right?
Yeah, let's use the smartphone analogy from the sources because I think that works perfectly.
Yeah.
How do we categorize dementia versus delirium using a phone?
Well, I love that analogy. If we use the smartphone model, dementia is basically a hardware issue.
Okay, so the physical parts of the phone.
Right. The battery is permanently degrading, the microchips are corroding over months and years. The physical structure of the brain itself is slowly failing.
And just to clarify, the sources note that the term dementia was actually retired from the psychiatric manual, the DSM-5, back in 2013, right?
Yeah, that's spot on. It was retired to reduce stigma. It's technically called major neurocognitive disorder now. But honestly, at the bedside, dementia is still the word everyone uses to describe that chronic hardware degradation.
Got it. So if dementia is the physical phone breaking down, where does delirium fit into that?
Delirium is a software crash. The hardware might be, somewhat weathered from age, but suddenly a rogue app starts taking up 100% of the RAM.
Oh, like a bad medication or an infection.
Exactly, or even severe dehydration. The operating system just totally freezes. Delirium is a flashing red alarm indicating a medical emergency.
So the brain is effectively screaming that it does not have the resources to function in that exact moment.
Yeah, it doesn't have the metabolic or physiological fuel, and it manifests as this acute, wildly fluctuating disturbance in thinking.
It's so fascinating. And history actually gives us a really great window into how long we've been trying to articulate this software crash. The etymology in the sources paints such a vivid picture.
It really does, especially when you look at the sheer age of the word delirium. I mean, it is older than dementia by nearly 2,000 years.
2,000 years, that's wild.
Yeah, it comes from the Latin word delirare, and literally translated, that means to go off the furrow or off the plowed track.
Oh, I love that. So the prefix de means away, and lyra means furrow. It's an agricultural metaphor.
Exactly, it's an ancient farming reference.
So if delirium is the mind wandering off the plowed track because of a temporary storm, like that infection or a new drug, then dementia, which comes from the Latin dement, meaning out of one's mind, is the track itself slowly fading away.
That is a beautiful way to visualize it. And that agricultural visual holds up really well for centuries. Starting with the Roman Encyclopedia Celsus in the 1st century AD, delirium was just a descriptive word.
Like it wasn't an official diagnosis yet.
Right, not at all. It was merely a way to describe at the bedside the feverish ravings of someone who was dying or just severely ill.
So it was just viewed as a symptom of being really sick. And for a long time, the medical community didn't view senile dementia as a specific disease either, did
Yeah, they didn't. They just assumed if you got old, your brain naturally weathered away. That was the prevailing assumption for most of the 20th century. Old age just equaled cognitive decline.
Until 1906, right, when Alois Alzheimer completely shattered that belief.
Yes. He was a German psychiatrist, and he presented this incredible case of a woman named Auguste de Terre. She was only 51 years old.
Wait, 51? That completely rules out the normal aging hypothesis right out of the gate.
Completely. She suffered from progressive memory loss, intense paranoia, and eventually her language just totally disintegrated.
Wow. And when she passed away, he actually examined her brain tissue, right?
He did during an autopsy, and he found these abnormal clumps of protein, which we now know as amyloid plaques, and tangled bundles of fibers called neurofibrillary tangles.
So he essentially proved that her cognitive decline wasn't just the natural passage of time.
Right. It was a discrete neurodegenerative disease that was actively destroying the brain's tissue.
Okay, so that perfectly establishes the hardware failure. The physical track is literally being destroyed by plaques and tangles.
Yeah.
But how did we finally get a biological grasp on the software crash, on delirium?
Well, that shift didn't actually happen until 1959. Two psychiatrists, George Engel and John Romano, published a paper that completely reframed it.
What did they do differently?
They called delirium a measurable state of acute brain failure. They actually hooked delirious patients up to an EEG, which measures the electrical activity of the brain.
Oh, so they could physically see it happening.
Yeah, exactly. They could literally watch the brainwaves slow down in real time. It showed the brain's metabolism was failing, like it just didn't have the energy to fire its neurons properly.
And the most important part, according to the sources, is that they proved this generalized disturbance was reversible, provided you found and treated the underlying cause.
Yes, the reversibility was the key finding there.
Which is great historical context. But if I'm a nurse on a busy ward today, I don't exactly have time to look at brain tissue under a microscope, and I definitely might not have an EEG machine handy.
No, you definitely won't in most standard rooms.
So how do you actually tell the difference between a fading track and a temporary storm just by talking to the patient?
Well, you rely on the 4 bedside axes of distinction: onset speed, the course over a day, attention, and reversibility. Let's look at onset first.
Okay, onset. Delirium happens fast, right? Like hours to a few days, whereas dementia takes months to years.
Spot on. So if a family brings someone into the ER and says, Grandpa was completely fine at breakfast, playing Sudoku, but by dinner he didn't know his own name, that speed is your biggest red flag.
That speed screams software crash.
Exactly. The trajectory tells the whole story. The second axis is the course within a single day. Delirium fluctuates wildly.
Meaning they could seem fine 1 minute and totally out of it the next.
Yeah. A patient might be totally lucid, holding a perfectly normal conversation with you at 10 a.m., but by 4 p.m., they are profoundly disoriented, maybe hallucinating or severely agitated.
And dementia doesn't do that.
No, dementia is relatively stable hour to hour. A person with Alzheimer's is going to struggle to remember their granddaughter's name just as much in the morning as they do at night.
Okay, let's dig into the third axis, because the sources call attention the single best bedside discriminator. And I want to make sure I really understand the mechanics of this.
Sure, it's crucial to grasp.
So if I ask an elderly patient to spell the word world backward, they don't know what day of the week it is, but they can sit there and focus their mind to spell DLROW for me. That points to dementia.
Yes, that's exactly right.
But if they get distracted halfway through because, I don't know, a nurse walks by in the hallway, that points to delirium.
You've hit on the absolute crux of it. In early to moderate dementia, the brain's underlying energy supply is actually still somewhat intact.
So they have the power to focus.
Right, attention is relatively preserved. The patient can sustain focus on your request. They just might not remember the conversation 5 minutes later because the memory storage hardware is broken.
But in delirium, the attention mechanism itself is what's shattered.
Exactly. The brain is in a metabolic crisis, so it literally cannot hold a thought or filter out background noise.
So if you ask them to recite the month of the year backward, they start, get distracted by a beep from a heart monitor, and just lose the thread entirely.
Yeah, it's a mechanical inability to maintain focus. Which leads us to the fourth axis, which is reversibility and cause.
Right. We know dementia is caused by things like those Alzheimer's plaques you mentioned.
Yes, or vascular infarcts, which are basically microscopic strokes that cut off blood supply to tiny regions of the brain over time.
Oh, so that creates like a stepwise decline.
Right. And another common cause is Lewy body dementia, where abnormal protein clumps disrupt neurotransmitters. That causes cognitive decline paired with Parkinson's-like physical tremors.
And all of these are ongoing neurodegenerations. Medicine can maybe slow them down, but we can't reverse them currently.
Exactly. Now contrast that with delirium, which is driven by a fixable precipitant.
This is the part I really want to understand the how on. How does a simple urinary tract infection, a UTI, cause acute brain failure? It sounds crazy.
It is a fascinating and honestly terrifying cascade. When a younger, healthy person gets a UTI, their immune system handles it locally in the bladder.
Just a localized battle.
Right. But in a frail older adult, that local infection triggers a massive systemic alarm. The immune system just floods the body with inflammatory proteins called cytokines.
And those cytokines travel up to the brain.
They circulate in the blood, yes. And because an older brain's defenses, like the blood-brain barrier, are often weakened, those inflammatory markers actually breach the barrier.
Oh, wow. So the infection literally invades the brain's environment.
It does. And once inside, those cytokines trigger the brain's own immune defenders, the microglial cells, to just go into absolute overdrive.
So you get severe neuroinflammation.
Exactly. And that inflammation throws off the synthesis of key neurotransmitters, especially acetylcholine, which is vital for attention and awareness.
So a simple bladder infection launches a chemical attack that unplugs the brain's communication network.
That is exactly what happens. But if you give antibiotics and clear the UTI, the cytokine storm stops and the delirium usually resolves.
Applying this to the hip fracture case from the beginning, it makes total sense now. An 84-year-old has major surgery. The physical trauma, the anesthesia, the painkillers, it's a massive storm.
Right. All of those things launch a huge inflammatory and chemical storm in her body.
So 2 days later, her attention is broken. She's picking at the sheets. That is textbook delirium.
And it is incredibly common in frail, elderly patients after surgery or in the ICU.
But, you know, the hip fracture example sounds sort of obvious because the patient is visibly agitated. She's vocal. She's moving.
Yeah, that's what people expect to see.
Right. When we hear delirium, we immediately picture someone thrashing around, pulling out their 5E lines, shouting, kind of like delirium tremens from severe alcohol withdrawal.
You're describing the hyperactive subtype of delirium. It's the dramatic, cinematic version everyone pictures in their head.
But the sources say the reality on the ground is very different.
Very different. The most common presentation in older hospitalized patients is actually the hypoactive subtype, and it is the most frequently missed by doctors and nurses.
Hypoactive meaning underactive. What did that actually look like for the person just sitting in the hospital bed?
Well, these patients are quiet, withdrawn, lethargic, and apathetic. They might just sleep all day or stare blankly at the wall.
And if you talk to them?
They might just answer questions with single syllables. The danger is that a quiet patient doesn't demand attention the way a shouting, agitated patient does.
The squeaky wheel gets the grease, especially in a busy hospital.
Exactly. Studies repeatedly show the vast majority of hypoactive delirium cases go completely unrecognized at the bedside.
That is just a silent catastrophe. Inside that quiet patient, the brain is still in a state of acute failure, right? The cytokine storm is still raging.
It's still a medical emergency, but nobody is noticing.
Which raises a really tricky scenario for you if you're working in a clinic. What happens when a patient has both?
Ah, yeah.
Let's say someone who already has Alzheimer's comes into the hospital for a minor procedure and develops hypoactive delirium on top of it.
You're touching on delirium superimposed on dementia, or DSD. This is a massive trap for healthcare providers.
That's so.
When a patient with pre-existing dementia has an acute worsening of their mental state, maybe they stop talking entirely. Families and clinicians alike often throw up their hands and assume, well, the dementia's just progressing.
They see the cognitive decline and just blame the chronic disease they already know is there.
Exactly. It's a huge blind spot.
And if you are listening to this, you can immediately see the danger. Because someone already has an Alzheimer's diagnosis, a totally curable urinary tract infection gets ignored.
Or a toxic reaction to a new sleeping pill gets missed.
Right. It just gets written off as inevitable decline.
Failure to catch DSD means a treatable, life-threatening insult goes entirely unaddressed. It is one of the most consequential diagnostic errors in geriatric medicine.
Before we move on to how we actually fix this, the sources mention a couple of neighboring terms that I want to clear up for anyone navigating this space. We hear the term sundowning a lot.
Right, sundowning is very common to hear.
And also something called pseudodementia. Let's start with sundowning. What is that exactly?
Well, sundowning is just a descriptive term for patients who become more confused, anxious, or agitated in the late afternoon and evening as the sun goes down.
So is it its own specific disease?
No, clinically, what gets casually labeled as sundowning is very often just undetected delirium layered on top of dementia. It's usually triggered by fatigue or poor lighting in the evening. It's not a distinct disease.
Okay, that makes sense. What about pseudodementia? Because that sounds like a fake hardware crash.
In a way, it kind of is. Pseudodementia refers to severe depression that basically mimics cognitive decline.
Oh, really? Depression can do that?
Yeah. The patient has slowed thinking, poor concentration, they complain about their memory. It looks remarkably like dementia.
Yeah.
But the mechanism is mood-based, not structural.
So if you treat the depression, does their memory come back?
Yes. Once you treat the underlying depression with therapy or medication, the cognitive issues clear up completely.
Wow. It's staggering how many things wear the disguise of dementia. So realizing that a quiet, withdrawn patient might actually be in a state of acute brain failure is sobering.
It definitely shifts your perspective.
But if there is neuroinflammation happening, how do we stop it? Historically, medicine took a pretty aggressive approach to the agitated, hyperactive patients.
Right. Yeah, for decades, the standard hospital practice was straightforward. If a patient was delirious and pulling out their tubes, you just gave them an antipsychotic or a heavy sedative, typically a drug called haloperidol.
Which, on the surface feels sort of logical to a stressed out medical team. The brain is hyperactive, the patient is a danger to themselves, so you give them a drug to calm the brain down.
But did it actually calm the brain down or just the body?
Oh, right. The sources highlight this massive 2018 trial that finally answered that.
Yes. The MIND USA trial, published in the New England Journal of Medicine, they tested haloperidol and another antipsychotic, ziprasidone, against a placebo in ICU patients suffering from delirium.
And the results were a genuine bombshell, right?
Absolutely. The antipsychotics did absolutely nothing to reduce the number of days patients spent delirious. They didn't shorten the ICU stay, and they didn't improve mortality.
So if you're listening to this and you've ever had a relative given sedatives in the ICU to calm them down, this has to be a terrifying revelation. We weren't treating the brain at all.
No, we were just treating the symptom, the agitation, to make the patient manageable for the staff.
Because haloperidol just blocks dopamine receptors.
Exactly. That stops the thrashing around. But it does absolutely zero to stop the inflammatory cytokines from a UTI or to reverse the metabolic starvation of the brain.
So the biological fire of the delirium just continued to rage on underneath the chemical restraint.
It did. It was just masking the failure.
That is a colossal medical failure. But it leads into an even bigger bombshell from the sources, one that completely reverses a long-held 20th century belief.
This is probably the most important shift in how we view delirium today.
Yeah, because we've been talking about delirium as a reversible state. The old logic was, fix the UTI, the delirium goes away, the software reboots, and the phone works perfectly again.
Right. No lasting harm. That was the old teaching. That delirium was a temporary detour with no lasting cognitive cost.
But that's not true anymore.
Not at all. Longitudinal research following patients after they leave the ICU or cardiac surgery has completely overturned that. Studies show that patients who experience a severe episode of delirium have a significantly higher risk of accelerated cognitive decline and subsequent dementia in the years following.
Wait, so it's not harmless once it clears. It doesn't just reveal a vulnerable brain. An episode of delirium actively injures the brain.
It does. It leaves a scar. Severe neuroinflammation causes collateral damage to neurons. It really blurs that once tidy line between acute and reversible on one side and chronic and progressive on the other.
So delirium might actually be a catalyst that accelerates long-term hardware degradation,
Exactly. It actively damages the hardware.
which makes the stakes astronomically higher for you and your loved ones. If drugs don't fix it, and merely having an episode of delirium causes permanent brain injury, how do we stop it?
The ultimate solution is prevention, and this is where the pioneering work of geriatrician Dr. Sharon Inouye completely changed the landscape.
What did she do?
Well, in 1990, she recognized that you can't prevent what you can't measure, so she invented a screening tool called the CAM, the Confusion Assessment Method.
Okay, how does that actually work at the bedside? What are the nurses actually measuring?
It's a quick algorithm that takes under 5 minutes. A nurse evaluates 4 features. First, is there an acute onset or fluctuating course?
Basically checking the timeline.
Right. Second, is there inattention? Like, can the patient squeeze your hand every time they hear the letter A in a sequence of letters?
Testing that mechanical focus.
Exactly. Third, is their thinking disorganized? Are their answers rambling or illogical? And fourth, is their level of consciousness altered? Are they hyper alert or lethargic?
And how many of those do they need to flag for delirium?
If a patient has the first 2 plus either of the last 2, they are flagged.
So it forces the medical team to actively check for that broken attention mechanism, catching even the quiet, hypoactive patients.
Exactly. And once you can measure it reliably, you can test ways to stop it, which Dr. Inouye did in 1999 with a landmark trial also published in the New England Journal of Medicine.
Did she test a new drug?
No, she didn't test cutting-edge pharmaceuticals at all. She tested a multi-component intervention that targeted basic environmental and physiological risk factors.
That makes sense. If the brain is starving for metabolic resources, you have to support its baseline needs. So what did this intervention actually look like in practice?
It was fundamental, rigorous nursing care. They put up large orientation boards so patients always knew the date and where they were.
Okay, keeping them grounded in reality.
Right. They aggressively minimized nighttime disruptions, clustering blood draws and turning down alarms to ensure uninterrupted sleep. They got patients out of bed and walking to promote blood flow.
And pushing fluids to prevent dehydration, I imagine.
Yes. And crucially, they gave patients back their reading glasses and hearing aids.
Let's pause on that last one. Why would not having reading glasses trigger acute brain failure?
Think about the mechanism of sensory deprivation. If an older patient is lying in a hospital bed without their glasses or hearing aids, the world is a blurry, muffled, terrifying place.
Oh, I hadn't thought of it like that.
The brain has to work overtime, exhausting its limited metabolic reserves just to interpret shadows and mumbles. By giving them their glasses, you instantly reduce the cognitive load.
You remove that stress on the operating system. Did it work? Did delirium rates actually drop?
Dramatically. The intervention group had a substantially reduced incidence of delirium. Dr. Inouye proved that this acute, life-threatening brain failure is highly preventable.
Not with drugs, but just by engineering an environment that supports the brain's fundamental needs.
Exactly. Basic human needs.
That is profound. And it brings us right back to you, the listener, and why untangling these terms empowers you. Let's rapidly synthesize what we've covered today.
Sounds good.
Delirium is a fast-acting software crash. It fluctuates wildly, it breaks a person's mechanical ability to pay attention, and it is always driven by an underlying medical cause, like an infection triggering neuroinflammation.
Right, whereas dementia is a slow hardware degradation. It takes months to years to develop. It remains relatively stable within a single day. It spares a person's attention in the early stages, and sadly, it has no cure.
We also learned that hypoactive delirium, the quiet, withdrawn patient, is the silent killer because it is so easy to ignore.
And if we lazily assume that a sudden cognitive decline in someone with Alzheimer's is just the dementia getting worse, we might be masking a life-threatening but completely treatable emergency.
The boundaries between these two conditions are porous. Delirium causes lasting damage, meaning preventing that acute brain failure is one of the most critical things a healthcare team or an advocating family member can do.
Absolutely.
Whether you are charting notes on a geriatric ward or advocating for your own parent in an overcrowded, chaotic ER, knowing the difference between a chronic brain disease and a reversible check engine light changes everything.
It changes the questions you ask the doctor. It changes how you observe your loved one.
It shifts you from a place of panic to a place of action.
It really equips you with the vocabulary to intervene when the medical system might be missing the subtle signs.
And I want to leave you with a final thought to mull over today. We learned that Dr. Inouye proved a state of acute brain-injuring delirium can often be prevented simply by giving a patient uninterrupted sleep, hydration, mobility, and their reading glasses.
Yeah, basic physiological support.
So if the lack of those basic fundamental human needs causes the brain to rapidly fail, are modern hospitals themselves fundamentally toxic to the aging brain?
That is a very heavy question.
Think about it. The constant beeping of monitors at 3 a.m., the sensory deprivation, the windowless rooms. If the very places we go to heal are actively inducing cognitive trauma, what would it look like to design a hospital that actually healed the mind instead of just the body?
It's a design challenge we desperately need to solve.
Something to think about. We'll catch you on the next deep dive.
It is completely wild to think about, but just a century ago, gardening was essentially an extreme sport.
It really was. I mean, a simple scratch from a rose bush or, a blister from a stiff new pair of shoes
Could literally be a death sentence. You get a little dirt in a cut, the area gets red, streaks start traveling up your arm, and, well, that was it. Game over. You just hope your affairs are in order.
Right. There was absolutely no safety net. Human beings lived entirely at the mercy of microscopic organisms. We were losing a massive invisible war that we didn't even fully understand yet.
But then we found the ultimate safety net, right? Antibiotics. And because they worked so miraculously well, we basically immediately started taking them for granted. Which brings us to our mission today. We are taking a deep dive into the fascinating high-stakes world of these life-saving drugs.
Yeah, and we're going to look at them specifically through the lens of the people on the front lines of healthcare. So, nurses, clinical pharmacists, the people actually administering these medications to you.
Exactly. We need to understand how these drugs actually hunt down bacteria, why the safety net is suddenly fraying, and why that golden rule you grew up with, always finish your prescription, is suddenly at the center of a massive medical debate.
Yeah, because the era of just casually throwing a Z-Pack at every sniffle, that era is rapidly closing.
Okay, let's unpack this. Before we get into the looming crisis, we really need to figure out what an antibiotic actually is. And from what I understand from our sources, the definition itself is a bit of a moving target.
It has shifted quite a bit, actually. Originally, an antibiotic was strictly defined as a weapon used in microbial warfare.
Microbial warfare?
So it had to be a natural compound made by one living microbe to kill another living microbe. Think of a mold in the soil fighting off a nearby bacterium for resources.
Right. So under that strict old-school definition, if a scientist creates a germ-killing drug entirely from scratch in a chemistry lab, it's not technically an antibiotic.
Precisely. Historically, strict pharmacology textbooks would insist that fully synthetic drugs were antimicrobials or antibacterials, but not antibiotics. But in modern clinical and nursing fields, the term has completely broadened.
Oh, okay.
Today, it essentially means any drug used to treat a bacterial infection inside the body, whether it was found in a damp forest or, built molecule by molecule in a lab.
Good to know. So we don't get tripped up by old textbook definitions if we're reading the literature. Now, the story of how we actually found these things, it is full of drama. When you read the history, it's not just neat scientists in pristine white coats having quiet eureka moments. It's a lot of dirty petri dishes, massive egos, and stolen credit.
The ego and sheer stubbornness that drove these early discoveries is incredible. Take Paul Ehrlich in the early 1900s. He established this revolutionary concept of the magic bullet.
Magic bullets.
Right, the idea that you could find a chemical to selectively kill a pathogen without killing the patient. He's trying to cure syphilis, and he systematically screened hundreds of toxic arsenic-based compounds.
With arsenic, the thing famous for, poisoning people.
Exactly. And it wasn't until the 606th compound that his team found one that worked without immediately killing the host.
Wow.
It was marketed as Salvarsan in 1910. He actually coined the word chemotherapy for this, though back then it just meant the chemical treatment of any infection long before it became synonymous with cancer.
606 tries. That is a level of persistence I just cannot fathom. But then there's the story that sounds like it was written for a Hollywood movie, Gerhard Domack, in 1932.
Yes, Domack. He was a German pathologist working for a chemical company, and he discovers that a synthetic red dye called Prontosil protected lab mice from lethal streptococcal infections.
A red dye.
Yeah, but the real drama happened when his own daughter, Hildegard, developed a life-threatening infection.
From a sewing needle prick, right. Just like the rosebush scratch. And he's a scientist watching his daughter actively dying, and he takes this massive gamble to give her this experimental industrial red dye.
And it saves her life.
Unbelievable.
The human body actually metabolizes pontosil into a compound called sulfanilamide, making it the ancestor of all the sulfa drugs we use today. Domak won the Nobel Prize in 1939 for this, but the story takes a really dark turn. Nazi Germany actually forced him to decline it.
Wait, really?
Yeah, he was arrested by the Gestapo for a week just for being awarded the prize. He didn't receive his actual medal until 1947, long after the war.
That is wild. A literal miracle cure wrapped up in global fascism. But when most people think antibiotic origin story, they immediately think of a very messy desk in London.
Right, Alexander Fleming in 1928. He goes on a summer holiday, leaves his laboratory petri dishes out, and comes back to find a mold. Penicillium notatum had contaminated a dish of Staphylococcus bacteria.
Just left it out.
Yep. But what he noticed was a clear halo, a ring around the mold where the bacteria had been completely wiped out.
The ultimate task failed successfully moment in human history.
It really was. Though it's worth noting, Fleming couldn't actually purify it into a usable drug himself. It took a brilliant team at Oxford, Howard Florey, Ernst Boris Chain, and Norman Heatley to figure out the incredibly fragile chemistry and scale up penicillin to make it a functional medicine during World War II.
And then we have Salman Waxman, who actually coined the modern word antibiotic in 1941. He was systematically screening soil bacteria looking for these chemical weapons.
Yes, and this is where the dark side of academic credit really rears its head. Waxman's graduate student, a man named Albert Schatz, was the one who actually isolated streptomycin in a basement lab in 1943.
Which was a big deal.
A huge deal. It was the first drug that could cure tuberculosis, a massive world-changing discovery. But Waxman took all the credit and eventually the Nobel Prize, entirely alone.
Ouch. I mean, as a grad student, doing the literal dirty work in a basement to watch your boss take the Nobel for your discovery, that is brutal.
Schatz actually did the unthinkable for the time. He sued his mentor.
Oh, wow.
He sued Waxman in Rutgers University. He won formal recognition as a co-discoverer and a share of the patent royalties, but he was essentially blacklisted in the academic community for speaking up. It remains a classic cautionary tale that historians point to about power dynamics in science.
So we have this arsenal of miracle compounds born from arsenic, red dye, moldy dishes, and bitter lawsuits. But here is the fundamental question. You mentioned Ehrlich's magic bullet. If these drugs are essentially microscopic poisons designed to violently kill living cells, why don't they kill our cells when we swallow them?
That is the absolute cornerstone of pharmacology. It's a concept called selective toxicity.
Selective toxicity, meaning it's toxic, but only to a select target.
Exactly. To work safely, the drug has to exploit a specific structural or biochemical difference between a bacterial cell, which is a simple organism called a prokaryote, and a human cell, which is a more complex eukaryote.
Right.
If the drug can find a biological target that the bacteria absolutely relies on, but that human cells don't even possess, it can slaughter the invader while leaving the human host completely unharmed.
So it's like targeting the exhaust port on the Death Star. You are finding the one architectural flaw the enemy has that we don't, and dropping the torpedo right there.
That is a brilliant analogy. And for nursing education and clinical practice, organizing these drugs by which specific exhaust port they target is the fastest way to understand how they work, predict their side effects, and manage drug interactions.
Instead of just memorizing a list.
Exactly. Instead of just memorizing complicated names, you look at the spatial journey into the bacterial cell.
Yeah.
There are 5 major mechanisms or buckets we need to explore.
Okay, let's take that journey. If I'm an antibiotic attacking a bacteria, the first thing I hit is the outer defenses, the deflector shield.
Precisely. That's our first bucket cell wall synthesis inhibitors. Bacteria have a rigid outer wall made of a highly cross-linked substance called peptidoglycan. It's like a heavy suit of armor.
And human cells don't have that.
Nope. Human cells do not have this wall at all. We just have a soft membrane.
So how do the drugs break the armor?
They don't just break it. They stop the bacteria from maintaining it. Penicillins, for example, have a specific chemical structure called a beta-lactam ring. This ring perfectly mimics the natural building blocks the bacteria uses to build its wall.
Oh, sneaky.
Very. When the bacteria's enzymes grab the drug thinking it's a brick, the drug jams the enzyme permanently.
Wow. So the bacteria is trying to build its wall with fake bricks, the machinery jams, and then what? Does it just sit there?
No, it dies violently.
Yeah.
Bacterial cells are highly pressurized on the inside. Without that rigid wall holding everything together, the bacterial cell literally bursts open under its own internal osmotic pressure.
It just pops like an overinflated balloon.
Exactly. This is the largest, most clinically important group of drugs. It includes the penicillins, it includes cephalosporins, which are organized into generations.
Wait, generations? Like an older and newer version?
Yes. As you move from first to second to third generation, the drugs trade their ability to kill gram-positive bacteria, which have very thick outer walls, for the ability to kill gram-negative bacteria.
What's the difference?
Gram-negative bacteria have a thinner wall, but they have an extra sneaky outer lipid membrane that makes them incredibly hard to penetrate. The newer generations were designed to slip past that extra membrane.
Ah, so it's upgrading the torpedo to pierce different types of shielding. What else is in this first bucket?
You have carbapenems, which are incredibly broad-spectrum, heavy hitters.
Yeah.
These are often locked away in the pharmacy, reserved as the absolute last-line therapy for severe hospital infections to prevent resistance.
The big guns.
Right. Then you have monobactams, which are crucial because their chemical ring doesn't trigger allergic cross-reactions, making them safe for patients with a true severe penicillin allergy. And finally, glycopeptides, like vancomycin, which is chemically different but attacks the same wall. Historically, that's our last resort against superbugs like MRSA.
Okay, so bucket one pops the deflector shield. Let's say the bacteria doesn't have a thick wall or we need to attack it differently. We breach the perimeter and go for the inner lining.
That brings us to bucket two cell membrane disruptors. Instead of stopping a wall from being built, these drugs, like the polymyxins, act almost like detergents. They punch physical holes directly into the existing bacterial cell membrane. The cell leaks its vital contents and dies.
I have to stop you there. If human cells also have membranes, you said earlier we have soft membranes instead of walls, wouldn't a drug that punches holes in membranes punch holes in our cells too? Isn't that friendly fire?
You've hit the nail on the head. That is exactly why selective toxicity isn't always perfect. Polymyxins are older drugs, and they are quite toxic to human kidneys and the nervous system.
So why on earth do we still use them?
Because they've been revived recently out of sheer desperation. For some superbugs that resist every single wall-destroying drug we have, especially those carbapenem-resistant organisms, these highly toxic hole punchers are literally the only things left that work.
That is terrifying. Okay, moving deeper into the cell. We've bypassed the wall and the membrane. Now we're inside the bacteria. What's the next target? Bucket three.
The internal droid factories, protein synthesis inhibitors. Bacteria need to constantly manufacture proteins to survive, just like we do. They use cellular assembly lines called ribosomes. But bacterial ribosomes, called the 7DS ribosome, are structurally different from human ribosomes, which are ADS.
Hold on, 70S, 80S, you lost me. What does that actually mean and why should I care?
Oh, the S just stands for Svedberg units. It's a matter of how heavy and dense the molecule is. All you really need to know is that the bacterial factory is physically a different shape and size than the human factory.
Okay, that makes sense.
Because of that structural difference, these drugs can slip inside the bacteria and throw a wrench directly into the gears of the 7DS ribosome, completely halting bacterial protein production, while our ADS human factories keep chugging along right next door.
That is incredibly elegant. So what drugs are we talking about here?
Several major ones. Aminoglycosides are here. They are powerful against gram-negative bacteria, but require nurses to monitor drug levels in the blood closely because they can cause severe kidney and ear toxicity. You also have tetracyclines. These are fascinating mechanically because they strongly chelate or bind to calcium.
Calcium, like in our bones.
Exactly.
Yeah.
That's the primary reason we avoid giving tetracyclines to children or pregnant women. The drug binds to the calcium in developing teeth and can permanently stain them gray or brown, and it can even temporarily stunt bone growth.
That is a side effect you definitely want to remember if you're a nurse handing out pills.
Yeah.
What else jams the ribosomes?
It's macrolides. If you've ever had a respiratory infection and been handed a Z-Pack that's azithromycin, it has a long half-life in the body, which is why you only need a short 5-day course. This group also includes lincosamides like clindamycin, which has a notorious reputation we'll get to in a minute, and oxazolidinones, which are newer drugs used for deeply resistant superbugs like MRSA and VRE.
All right, so we've jammed the factories. What if we want to go straight for the central computer, the blueprints?
That's bucket 4. Nucleic acid synthesis inhibitors. These target the enzymes bacteria use to uncoil and copy their DNA and RNA. If they can't copy their DNA, they can't multiply. Fluoroquinolones, like Cipro, live here. They are highly effective, but they carry heavy FDA-boxed warnings.
Warnings for what?
They can cause spontaneous tendon rupture, like your Achilles tendon just snapping, and even aortic aneurysms in rare cases.
Tendon rupture from taking an antibiotic for a UTI, that is completely wild.
Yeah, it's a stark reminder that these are potent systemic chemicals, not candy. Another fascinating drug in this DNA blocking group are the rifamycins, used heavily for tuberculosis. And here's a critical clinical pearl. They block bacterial RNA polymerase, but a hallmark side effect is that they turn bodily fluids, urine, sweat, and even tears a bright orange-red color.
Oh my God. Nurse, why am I crying orange tears? Yeah, a heads up would be nice there.
Exactly. Nurses have to proactively educate patients about this, or the patient will think they are sweating blood and go into sheer panic.
Okay, that brings us to the final mechanism. Bucket 5. We've hit the wall, the membrane, the factories, and the blueprints. What's left?
The supply lines. Metabolic pathway inhibitors. These drugs block specific steps in how bacteria process essential nutrients. The classic example is folic acid. Bacteria need folic acid to synthesize their DNA. Sulfonamides and trimethoprim block the specific enzymes bacteria use to manufacture folic acid from scratch.
But wait, human cells need folic acid too, right? My pregnant sister takes a folic acid supplement every day.
We absolutely need it. But human cells don't have the metabolic machinery to synthesize it. We have to get it externally from our diet or vitamins. Since we don't have the factory to make it, targeting that factory in bacteria is a textbook example of selective toxicity. They often combine two of these drugs, like in the medication Bactrim, to block two different steps in the bacteria's supply line at the exact same time. It's incredibly effective.
Okay, so we have these incredibly precise tools. We've got torpedoes for the wall, the protein factories, the DNA, the membrane, and the metabolism. But I have to push back here, or at least play devil's advocate for you listening.
Go for it.
If I'm really, really sick, I have a high fever, I feel terrible, why wouldn't I just want the doctor to prescribe the absolute strongest broad-spectrum antibiotic they have in the pharmacy? Just wipe everything out. Nuke it from orbit.
That is a very common and very dangerous misconception. People hear the term broad spectrum and think it means more potent or stronger. It doesn't. A broad spectrum drug doesn't kill a specific bacterium any harder. It simply means the drug is chemically capable of attacking many different types of organisms at once.
And why is that a bad thing? If I don't know exactly what's making me sick, shouldn't I just cover all my bases?
Because of the friendly fire you mentioned earlier, your body is home to trillions of protective normal flora. The good bacteria living on your skin, in your mouth, and especially in your gut. They take up space and resources so harmful, invading pathogens can't move in and set up shop.
Ah, I see where this is going. If I use a broad-spectrum drug unnecessarily, I'm basically carpet bombing my own internal defenses.
Exactly. You are wiping out the peacekeepers.
Oh.
And that collateral damage leaves you wide open for what we call superinfections. The most classic terrifying example in healthcare is Clostridioides difficile or C. diff colitis.
Which you mentioned earlier is heavily associated with clindamycin.
Yes, as well as fluoroquinolones and broad-spectrum cephalosporins. When you wipe out the normal, healthy gut bacteria, this one toxin-producing, highly antibiotic-resistant organism, C. diff, survives the blast. With no competition left, it rapidly takes over the entire colon. It causes severe, sometimes fatal diarrhea that is incredibly difficult to cure. So a narrower targeted therapy, a sniper rifle instead of a grenade, is always preferred the moment you know exactly what specific pathogen you're fighting.
You want the sniper rifle. And while we're talking about massive misconceptions, let's clear up the biggest one. Viruses. If I have a terrible viral flu or the common cold, why won't a doctor give me a Z-Pack?
Because antibiotics do not work on viruses, period. Look at the mechanisms we just discussed. Viruses do not have a peptidoglycan cell wall. They do not have bacterial 70S ribosomes.
You can't target an exhaust port that isn't there.
Exactly. Taking an antibiotic for a viral infection does absolutely nothing to the virus, but it still detonates that grenade in your gut. It wipes out your good flora, exposes the surviving bacteria to selective pressure, and contributes to global drug resistance for zero benefit to you.
Which actually brings us to a massive contradiction. We just talked about minimizing collateral damage, minimizing exposure. Yet for my entire life, every doctor and nurse told me the golden rule. Never, ever stop taking your antibiotics until the bottle is completely empty, even if you feel 100% better on day 3. Doesn't taking them for 14 days cause more collateral damage than taking them for 5?
Here's where it gets really interesting. That dogma, the absolute holy grail of 20th century medicine, is being actively dismantled.
Wait, really? So stopping early doesn't create superbugs?
It's much more nuanced than we were taught. In 2017, a group of infectious disease experts, led by Martin Llewellyn, published a highly provocative paper in the BMJ arguing that the finish the course dogma was never actually supported by rigorous scientific evidence.
Yeah.
We literally just made up the durations, like 10 or 14 days,
Yeah.
because they were nice round numbers.
So what does cause the resistance, if not stopping early?
Their central point is that resistance is driven by total drug exposure. Think about it. When you take a long 14-day course, by day 12 or 13, the drug levels in your body are tapering off. You are exposing the surviving bacteria to low, sublethal concentrations of the drug for an extended period.
Oh, wow. So by taking more of the drug longer than I actually need to cure the infection, I'm essentially giving the surviving bacteria a low-stress training camp to figure out how to beat the drug.
Exactly. The longer the exposure, the higher the chance of selecting for resistant strains. Now, to be incredibly clear, the takeaway from modern research is not just stop taking your medicine whenever you feel like it.
All right, we don't want anyone listening to just start freestyling their medical care based on a vibe. I feel great today. Into the trash they go.
Please do not do that. Critics of the BMJ paper rightly pointed out that for serious, deep-seated infections like tuberculosis or endocarditis, which is an infection of the heart valve stopping early, is well documented to cause a deadly relapse. The expert consensus today is about precision. Course lengths need to be entirely evidence-based for the specific infection.
So why finishing the course still matters is because the course itself is changing.
Precisely. We now have clinical trials proving a 3-day course works reliably for an uncomplicated UTI, and 5 days is often plenty for community-acquired pneumonia. If your doctor prescribes 5 days based on the latest evidence, you absolutely must finish those 5 days. But we no longer need to blindly prescribe a 14-day supply for everything just because a textbook from 1980 said so.
But getting this right, matching the exact drug and the exact duration to the exact bug, it feels so urgent because this resistance crisis isn't some abstract sci-fi problem for the year 2100. It's happening terrifyingly fast.
It is immediate, and it's been happening since the beginning. Let's look at methicillin. It was a synthesized penicillin introduced in 1959, specifically because staph bacteria had already figured out how to chew up regular penicillin. Just 2 years later, in 1961, doctors in the UK identified the very first strain of MRSA, methicillin-resistant Staphylococcus aureus.
2 years. It took humanity thousands of years to find the drug, and it took a microscopic blob 2 years to completely outsmart it.
2 years. It is the clearest possible demonstration that resistance isn't a mistake. It is the built-in evolutionary consequence of using antibiotics at all. Alexander Fleming himself anticipated this. In his 1945 Nobel lecture, he explicitly warned that underdosing penicillin would cause resistant bacteria to survive and multiply. He predicted the crisis before resistance was even a widespread clinical problem.
And now, because we didn't listen, we have things like NDM1.
Yes, New Delhi metallobeta-lactamase 1.
Sure.
First described in 2008. It is a resistance enzyme that completely destroys carbapenems.
Wait, carbapenems, the ones you said were locked in the pharmacy as our absolute last resort. Bucket one.
Exactly. NDM1 neutralizes our last line of defense. But the true nightmare scenario isn't just that a single strain of bacteria mutated to have this enzyme. It's how they spread it.
What do you mean spread it? They don't just divide and pass it to their offspring.
That's vertical transmission. But bacteria can also do something called horizontal gene transfer. The genetic code for NDM1 sits on something called a plasmid. A plasmid is a small, mobile, circular piece of DNA that exists completely separate from the bacteria's main chromosome.
Like a little USB drive of genetic code.
That is exactly what it is. And bacteria can literally trade these USB drives with each other across totally different species. Resistance doesn't just spread when a bacterium reproduces. A completely unrelated bacterial species, say an E. coli in your gut, can bump into a Klebsiella bacteria and just hand over the plasmid.
Like swapping trading cards. Here, take this gene that makes you invincible to the strongest drug humanity has. Thanks, here's one for surviving tetracycline.
Exactly. They build multi-drug resistance shields in real time across species lines.
So what does this all mean for you, for the people listening? We are looking at a landscape where the World Health Organization has repeatedly warned that we are heading toward a post-antibiotic era. An era where common infections, routine surgeries, chemotherapy, even premature birth become deadly again, simply because the base assumption of modern medicine that there will be a drug that works is gone.
That is what makes antimicrobial stewardship the single most critical frontline job in healthcare today. Choosing the right drug, the sniper rifle at the right dose, for the exact evidence-based duration. It isn't just hospital paperwork. It is the only thing keeping modern medicine viable. Every time a nurse pushes for a culture before starting broad-spectrum therapy, or questions an unnecessarily long prescription, or educates a patient on why they aren't getting a Z-Pack for a cold, well, they are actively defending the safety net of humanity.
It really puts the responsibility on all of us, doctors, nurses, and patients, to respect these molecular tools. We can't just demand pills for a runny nose.
We can't. But I want to leave you with one final thought today, something to really explore on your own that builds on everything we've just discussed about how resistance forms. We've spent this entire deep dive talking about human medicine. Hospitals, prescriptions, nursing, fighting over a 5-day versus a 14-day course. But historically, a massive share of all antibiotics manufactured globally hasn't gone to sick humans at all. They are fed, by the ton, to completely healthy livestock.
Wait, healthy animals? Why would they give expensive drugs to animals that aren't even sick?
Because the agricultural industry realized decades ago that continuous low doses of antibiotics make animals gain weight faster, likely by altering their gut microbiomes to absorb more calories. Now think about what we just discussed. If the major driver of antibiotic resistance isn't stopping early, but rather total drug exposure at long sublethal concentrations, think about the implication.
Oh my God, the training camps.
Exactly. We have an invisible, massive pipeline of resistance genes and plasmids brewing in agricultural feedlots around the world. These invincible bugs are quietly multiplying in the soil, the water runoff, and entering the human food chain, long before a patient ever even sets foot in a hospital to ask for a prescription.
That is profoundly chilling. Suddenly, the idea of a simple scratch from a rosebush being a death sentence doesn't just feel like a quaint history lesson from 100 years ago. It feels like a very real reality we could be facing again tomorrow if we're not incredibly careful about how we use these tools. Thank you for joining us on this deep dive. Respect your microbes, think twice about that Z-Pack, and we'll see you next time.
You know, when we look at how modern medicine tracks a patient's stability, there's just this immense reliance on the intake and output chart.
Oh, absolutely. The classic I&O.
Right. And it looks like this perfectly balanced accounting ledger, at the end of a nursing shift. You have this meticulous log of every single milliliter of IV fluid or water the patient consumed, measured right up against every milliliter of urine or drainage that left the body.
Yeah, it's very neat, very tidy.
Exactly. And the fundamental assumption here is that if those two columns match, well, the patient is perfectly hydrated and physiologically stable.
Which is, it provides a really comforting illusion of control, right? We basically try to map complex human physiology onto this super basic thermodynamic principle of, input equaling output.
But I'm guessing the clinical reality is a bit more deceptive than that.
Far more deceptive, yeah. A patient can have a flawlessly matched chart on paper where the total volume of water in their body is technically totally normal, but they are simultaneously experiencing a lethal fluid crisis.
Wow, wait, so how does that happen?
Well, the critical factor we constantly misinterpret isn't the total volume of water, it's the geographic location of that water within the microscopic compartments of the body.
Okay, and that spatial distribution is exactly our target for this deep dive. We are unpacking the true architecture of fluid balance today.
Right. It's fascinating stuff.
We're going to examine the biological mechanisms that drive water into hidden tissue compartments, which is often called third spacing. And we'll also look at why the reflexive medical instinct to just give IV fluids to a shock patient can sometimes trigger catastrophic organ failure.
Yeah, which goes against decades of medical training, by the way.
Right. And we'll also talk about how the biological mechanisms governing a trauma patient in the ICU are actually identical to the ones causing marathon runners to inadvertently drown their own brain cells.
It is all connected. So to really dismantle that reliance on the intake and output ledger, we basically have to start by mapping where the fluid actually lives.
Okay, let's map it.
So we frequently hear this baseline statistic that the average adult body is roughly 60% water.
Right, yeah, the classic science class trivia fact.
Exactly. Clinically, though, that total percentage is almost irrelevant. It really comes down to how that volume is partitioned.
Because we tend to visualize the body as a single vessel, just as giant water balloon of sloshing fluid. But the partitioning is actually highly segregated.
Very much so.
Like, of that total body water, 2/3 is entirely locked away inside the intracellular fluid compartment. It's just spoken for, just maintaining the function of your individual cells.
Right, which leaves only 1/3 of your total water in the extracellular fluid compartment. And this right here is the pivot point where our intuitive understanding usually just completely fails.
Also,
Well, of that extracellular fluid, the water outside the cells, only about 1/4 is actually circulating inside your blood vessels as plasma.
boy, only a quarter.
It's just a quarter. The remaining 3/4 is what we call interstitial fluid, which is basically the water bathing the tissues and filling all those microscopic gaps between the cells.
Okay, so if we map this onto a visual analogy for you listening, imagine your body is a house.
I love this analogy.
Right. So the plasma, the fluid inside the blood vessels, is the plumbing system. But the vast majority of the water in this house isn't in the pipes at all.
Not at all.
It's sitting locked inside the individual rooms, which are the cells,
Yeah.
or it is literally soaking into the drywall and the insulation, which represents that interstitial fluid you just mentioned.
And the massive clinical challenge here is that doctors and nurses can only easily access and measure the plumbing. When you take a blood pressure or draw labs or, measure urine output, you are only interacting with the plasma. You're staring at the pipes, completely blind to what is happening inside the walls.
That's wild. And the recognition of these distinct environments actually dates back to Claude Bernard in the 19th century, right? With his concept of the milieu intérieur.
Yes, the internal environment.
He proposed that our cells don't actually interact with the external world. They survive in this highly defended sort of primordial internal ocean.
But translating that concept into actual bedside medicine didn't really happen until James L. Gamble's work in the mid-20th century.
Right. Gamble.
Yeah, he was a Harvard pediatrician, and he was confronting this massive pediatric mortality rate from diarrheal dehydration. Prior to his work, the standard of care was basically just pouring uncalibrated saline solutions into these kids.
We were just topping off the tank.
Exactly. They assumed fluid was just fluid. But Gamble recognized that the body's compartments rely on highly specific electrical and chemical gradients.
So he mapped out the precise concentrations of like sodium, potassium, and chloride in the different fluid compartments.
Right, and he created these visual bar charts called Gamblegrams.
I love that name.
It's great, right? And it shifted medicine from blindly topping off the tank to precisely replacing the specific electrolytes a patient lost. So if a child lost bicarbonate and potassium, Gamble's charts allowed doctors to formulate a fluid that replaced those exact molecules.
Just to restore the osmotic pressure.
Exactly. And those osmotic pressures are what keep the water in the correct compartments.
But Gamble's work mostly addressed fluid that actually leaves the body, like through diarrhea. The map gets terrifyingly complicated when the fluid doesn't leave the body, but it just escapes the plumbing.
Yes. Welcome to the third space.
The phantom zone.
Basically, yeah. So Francis D. Moore, a surgeon who was analyzing trauma patients from World War II and the Korean War, he noticed this massive discrepancy.
What were the soldiers showing up with?
Well, they were arriving with severe injuries, their blood pressure was crashing, and their urine output had just completely stopped. They looked profoundly dehydrated.
But let me guess, the visible blood loss didn't match the severity of the shock.
Exactly. The surgeons would calculate the blood loss, and it just didn't add up. The soldiers were missing massive volumes of fluid that couldn't be accounted for on any external chart.
So where was it going?
Moore figured out that the trauma had triggered a systemic inflammatory response. The capillaries, the tiny porous pipes of the circulatory system, had become hyperpermeable.
They got leaky.
Super leaky. The fluid was leaking out of the intravascular space and pooling into the injured soft tissues, the bowel walls, the abdominal cavity.
Wow. So the water hadn't actually left the soldier's body?
Right. It was still inside them, but it was entirely lost to the circulation. It was sequestered in this non-functional third space.
Which just completely invalidates the standard intake and output chart. The nursing ledger can't measure fluid that's hiding in the body's drywall.
It absolutely cannot. And to make it worse, standard charts routinely ignore insensible losses.
Like breathing and sweating.
Yeah. An average resting adult breathes out and sweats roughly 800 to 1,000 milliliters of water vapor a day.
That's a whole liter.
Right. And if you have a patient on a ventilator or someone with a high fever, those unmeasured losses just skyrocket.
Which is why the daily weight of a patient is such a far more rigorous proxy for fluid balance than any written ledger.
Yes. The physics are absolute. 1 liter of retained fluid has a mass of exactly 1 kilogram.
So if a patient's intake and output chart claims they're perfectly balanced, but the scale shows they gained, say, 3 kilograms overnight.
You know, with absolute certainty that 3 liters of fluid have leaked out of their plumbing and are actively third spacing into their tissues.
That is just wild. And to visualize the sheer scale of this third spacing, we really should look at the protocols for severe burn victims.
Oh, yeah. The fluid shifts there are unimaginable.
Right, because when a patient suffers a major thermal injury, the capillary leak is catastrophic. So to prevent the plumbing from running completely dry, burn units use the Parkland formula to calculate resuscitation fluids.
And it is a lot of fluid.
The math is 4 milliliters of fluid multiplied by the patient's weight in kilograms, multiplied by the percentage of their body surface area that's burned.
So if we run those numbers for a standard 70-kilogram adult with a 40% total body surface area burn, which, to be clear, is an incredibly severe, life-threatening injury.
The result is staggering. 4 times 70 times 40. That is 11,200 milliliters.
Yeah.
11.2 liters of 5E fluid required in just the first 24 hours, with half of that volume mandated in just the first 8 hours.
It's massive. The clinical team is effectively forced to flood the patient's circulatory system just to maintain enough pressure to perfuse the brain and the kidneys.
Even though they fully know that a massive percentage of that 11 liters is going to leak straight out of the damaged capillaries.
Oh, completely. It's going to cause the patient's entire body to swell to almost unrecognizable proportions.
Okay, I have to challenge the mechanics of that treatment protocol for a second.
Go for it.
If I'm the attending physician, and I see a patient whose tissues are actively ballooning with liters of trapped third space fluid, my mechanical instinct is to just drain the system.
Sure, that makes intuitive sense.
Right. I'd want to give them a powerful loop diuretic like furosemide to force the body to excrete that excess water and relieve the swelling.
And administering a diuretic in the acute phase of a third space crisis is actually one of the most lethal conceptual errors a clinician can make.
Wait, really? Why?
It comes back to our map of the fluid compartments. Diuretics act specifically on the kidneys, and the kidneys are just a filter attached to the plumbing.
Ah, so they only have access to the intravascular volume.
Exactly. The fluid currently circulating inside the blood vessels. The kidneys have no physical mechanism to reach into the interstitial tissue and pull water out of the walls.
So if you push a diuretic.
The kidneys will aggressively filter and excrete whatever volume is currently in the plasma. But in a burn or trauma patient, the plasma volume is already dangerously depleted. It's all leaking into the tissues.
So the diuretic would just instantly drain the last remaining fluid from the pipes.
Yes, causing a catastrophic drop in blood pressure and inducing multi-organ failure. And the massive tissue swelling won't even go down because that fluid is sequestered away from the kidney's reach anyway.
Wow. So the only viable mechanism for removing that fluid is just time.
Basically, time and healing. The underlying inflammation has to resolve. Once the capillary leak seals, which is usually around day 3 to 5, the hydrostatic and osmotic pressures naturally pull that trapped fluid back into the blood vessels.
And only then can the kidneys filter it out.
Precisely. And waiting for the capillaries to seal brings us to probably the most contentious debate in modern critical care right now, the liberal versus restrictive fluid strategy.
Because for nearly a century, medical dogma basically dictated that if a patient had low blood pressure from sepsis or trauma, the immediate reflex was to administer a huge IV fluid bolus.
Right. Fill the pipes. Increase cardiac output.
And this was heavily based on the Starling equation from 1896, right, which modeled capillary exchange purely as a balance of physical hydrostatic pressure pushing fluid out and the oncotic pressure of plasma proteins pulling it back in.
Yeah, it treated the blood vessel like it was just a passive, semi-permeable membrane, like a coffee filter.
But modern vascular physiology has identified a microscopic structure that completely breaks that old Starling model.
The endothelial glycocalyx.
The what?
Glycocalyx. It is this microscopic, gel-like meshwork of glycoproteins and proteoglycans that coats the inner lining of every single blood vessel in your body.
Oh, wow. So it functions like a biological Teflon coating.
Exactly like Teflon. It isn't just a passive barrier. It actively repels red blood cells, it houses regulatory enzymes, and most importantly, it traps plasma proteins to maintain the osmotic gradient that keeps water inside the vessel.
So what happens to this Teflon coating when a patient develops sepsis?
Well, the immune system releases this massive storm of inflammatory cytokines and enzymes. And these enzymes literally chew up and degrade that delicate sugar protein layer.
Just destroys it.
Yeah, and the body actually does this intentionally to allow white blood cells to slip out of the bloodstream and attack the infection in the tissues.
Right, but the biological cost of stripping that Teflon coating is that the plumbing completely loses its structural integrity.
Once the glycocalyx is degraded, the capillaries aren't just leaky, they are functionally shattered.
Which completely reframes our approach to resuscitation.
Completely. Because if the vessel lining is destroyed, pushing a rapid bolus of IV fluid doesn't meaningfully increase blood pressure. The fluid simply bypasses that degraded barrier and floods straight into the interstitial space.
And we actually have massive clinical data proving how lethal this traditional fluid reflex can be, like the FEAST trial.
Oh, yes, fluid expansion as supportive therapy, published in 2011.
Right, where researchers studied over 3,000 critically ill children with severe febrile illnesses across sub-Saharan Africa. And the absolute gold standard protocol for a child in shock was to administer a rapid fluid bolus.
Because the underlying assumption was that the bolus would restore the volume in the pipes and improve tissue oxygenation.
But the trial was halted early, wasn't it?
It was, because the results were absolutely devastating. The children randomized to receive the standard fluid boluses had a 3.3% higher absolute mortality rate compared to the control group that received no bolus at all.
Wait, really? Giving the standard, trusted treatment actually pushed fluid through those damaged glycocalyx barriers into their lungs, causing pulmonary edema, and into their brains, causing cerebral edema.
Yes, the textbook intervention accelerated their death. It was a massive, paradigm-shifting realization for the medical community.
That is deeply unsettling. But it also echoes the findings of the 2004 SAFE study, right?
Right, in Australia and New Zealand. For decades, ICUs spent insane amounts of money administering albumin, which is this large, expensive human protein, instead of just cheap saline.
Because the theory was that the massive albumin molecules wouldn't be able to leak out of the capillary.
Exactly. They thought it would hold the water in the pipes via oncotic pressure.
But the SAFE study proved there was zero overall mortality benefit to albumin over standard saline.
None at all. Because if the glycocalyx is destroyed, even massive proteins will hemorrhage out into the third space and they drag the water right along with them. The barrier itself is the critical failure point.
But here's the thing, the degradation of those vascular walls and the shifting of fluid compartments, that's not just a phenomenon restricted to trauma bays and ICUs, right?
Oh, not at all. The exact same hormonal triggers that mismanage fluid distribution during a severe infection, they can be hijacked during everyday activities.
Which bridges the gap to sports physiology. Because we see catastrophic fluid shifts occurring in amateur athletes who are literally just adhering to what they think are healthy hydration guidelines.
Yes. And the primary culprit here is antidiuretic hormone, or ADH.
Okay, so ADH is secreted by the pituitary gland, and its primary function is to instruct the kidneys to conserve water.
Right. It does that by inserting water channels, called aquaporins, into the kidney ducts. And your body naturally releases massive surges of ADH when you are under physical stress, when you are experiencing pain, or when your blood volume slightly drops from sweating.
Which perfectly describes the physiological state of a person running a marathon.
Perfectly.
So during the 2002 Boston Marathon, there was this study by Dr. Christopher Almond. His team drew blood from nearly 500 runners at the finish line. And he discovered that 13% of them were suffering from hyponatremia.
Which is dangerously low concentrations of sodium in the blood.
But crucially, they didn't develop hyponatremia because they sweat out all their body salt.
No, they developed it because they drank too much plain water. They basically followed the pervasive advice to drink at every single hydration station.
And because their systems were flooded with that stress hormone, ADH, their kidneys were chemically blocked from excreting that heavy water load.
Exactly. So the plain water had nowhere to go except into the bloodstream, where it massively diluted the existing sodium.
And this is where the physics of osmosis become incredibly deadly, because the blood plasma becomes hypotonic, meaning it's extremely watered down compared to the fluid inside the body's cells.
Right. And to equalize that pressure, that excess water is forcefully driven out of the plumbing and across the cell membranes,
rushing into the intracellular compartment, so the cells physically swell up.
And while a swollen muscle cell is painful, a swollen brain cell is life-threatening.
Because the skull is a rigid, fixed vault. It can't expand.
Right. So as the brain cells absorb this hypotonic water, they expand, increasing intracranial pressure. This is early hyponatremic encephalopathy.
And the external symptoms of this brain swelling, nausea, extreme fatigue, confusion, collapsing. The tragic overlap here is that these symptoms flawlessly mimic the signs of severe dehydration.
It looks exactly the same.
Huh.
So when a runner collapses at the finish line exhibiting confusion and cramping, the immediate instinct of a well-meaning bystander or a medical volunteer is to assume, oh, they're dehydrated.
So they hand them a bottle of water. Or worse, a medic hooks them up to an IV bag of hypotonic fluid.
Which instantly exacerbates the osmotic gradient. It pushes even more water into the brain, herniating the brainstem and literally killing the athlete.
It's terrifying. Fatalities at major marathons have been directly caused by this precise sequence of well-intentioned but physiologically backward medical care.
It really emphasizes why understanding these mechanisms is so crucial. But on the flip side, mastering these fluid shifts has actively engineered some of the most profound medical advancements in history.
Like oral rehydration therapy, or ORT.
Yes. Back in the 1970s, researchers investigating cholera and severe diarrheal diseases, they mapped out this specific protein embedded in the intestinal lining.
The sodium glucose cotransporter, right? SGLT1.
Right. And this transporter acts as a molecular pump. It couples the transport of one glucose molecule with two sodium ions.
So if a patient just drinks plain water, it moves sluggishly across the inflamed intestinal wall.
And if they drink purely salty water, the sodium remains in the gut and actually draws more water out of the body, worsening the diarrhea.
But if you create a solution with a highly specific molar ratio of sodium and glucose,
the SGLT1 transporter engages. It actively pulls the salt and sugar across the intestinal epithelium.
and that localized movement creates a powerful osmotic gradient that physically drags massive amounts of water along with it straight into the bloodstream.
It's brilliant. This simple, hyper-calibrated mixture of sugar, salt, and water bypasses the need for intravenous fluids entirely. It has saved tens of millions of lives globally.
Which is amazing. Yet we see this massive disconnect in the modern commercialization of hydration today.
Oh, don't even get me started on the IV drip bars.
Right. We have these wellness clinics and strip malls heavily marketing intravenous fluid bags to the general public for like hangovers or general fatigue.
People are paying out of pocket to bypass their perfectly functioning, highly evolved GI tracts and SGLT1 transporters. They're forcing uncalibrated fluids directly into their intravascular plumbing, completely ignoring the complex hydrostatic pressures and glycocalyx barriers we've just spent all this time talking about.
It trivializes a really fragile medical intervention.
Yeah.
And honestly, it assumes an infinite abundance of supplies, which we know is a deeply flawed premise.
No, definitely.
I mean, the fragility of our reliance on manufactured fluid compartments became terrifyingly clear in late 2024.
With Hurricane Helene.
Yeah. Hurricane Helene caused catastrophic flooding in North Carolina, directly incapacitating a massive manufacturing plant that produced a huge percentage of the nation's IV fluids.
Literally overnight, the abstract physiology of fluid balance became a brutal supply chain crisis.
Hospitals nationwide were forced to instantly ration IV fluids.
Yeah.
Bedside clinicians had to delay elective surgeries and rethink every single milliliter of fluid they administered.
It was a very stark reminder that a bag of normal saline isn't just a commodity. It is a meticulously engineered medical tool designed to manipulate the internal ocean of the human body.
And when you lose access to it, you realize how delicate the physiological architecture truly is.
Exactly.
So bringing it all together, the ultimate takeaway from this deep dive is that fluid balance defies simplification. It is not an accounting ledger.
Not even close.
It's this highly dynamic, actively negotiated distribution of water across selectively permeable membranes, protected by microscopic gel barriers and governed by stress hormones.
Whether we are looking at burn resuscitation, the feast trial, or runners crossing a finish line, the evidence is absolute. Blindly pushing more fluid is rarely the panacea we want it to be.
We really have to move past treating the body like an inert container.
Yeah. The human organism is constantly adapting to preserve its core functions, and our interventions just have to respect the complexity of those biological defenses.
Absolutely. So I want to leave you with a final mechanical reality to consider as we wrap up.
Sure.
Right now, without any conscious input from you, your body is managing a microscopic internal ocean. Your pituitary gland is titrating antidiuretic hormone, your endothelial glycocalyx is actively trapping plasma proteins, and your cell membranes are utilizing ion pumps to keep from drying out or rupturing.
It's constantly working.
You are quite literally a walking, self-regulating bag of seawater. And if the brightest minds in critical care have spent the last century repeatedly realizing how dangerously wrong their assumptions were about something as seemingly simple as water and salt, what other fundamental everyday functions of our own anatomy are we currently entirely misunderstanding?
So welcome back to the deep dive. And, we know you're here because you want that really rigorous, aha-filled